Good morning, everybody, and it is my proud privilege to welcome you all to the first session of the 30th RIO Foundation Day celebrations. This is the session on approach to a pediatric case, and it is an honor to call up
an infant and pediatric eye. Sorry for the interruption. I'll be discussing my talk under this following head, which is the current SOP guidelines we follow in our department. So few tips: make child comfortable on parent's lap or ask them to stand nearby. Introduce the child with toys and the instruments available in the OPD. Keep room child friendly. You can even give a fixation target like this in our OPD. So few visual milestones which must be known to the ophthalmologist while examining child. At 29 week of gestation, pupillary reaction is present. Soon after the birth, blink reflex is present. At 2 months, fixation gets developed, and by 5 months, Manax reflex, that is the reflex, blink reflex to visual threat is present. The American Academy has classified vision assessment as per child age group in infant 1 to 2 years, 2 to 3 years, and 3 to 5 years. I will be discussing few of the clinical aspects of it. So first is how to occlude the child. Any of the occluder present in the OPD can be used. Even the occlusion can be held with the help of hand. Never hesitate to patch a child if you feel the child is peeping through the other eye. So CSM method is not only helpful in assessing vision in infants, but it also helps in assessing vision in preverbal children also. So central, either the fixation is either foveal or eccentric. STD means it is either stable or the child has nystagmus, and maintained is orthophoria, and unmaintained is any kind of a squint. So Bruckner reflex helps in measuring a small angle deviation or amblyopia in cases where the children does not cooperate for cover test. Here the simultaneous illumination of both the eyes is done with the help of direct ophthalmoscope by projecting light from a distance. In myopia, if the child has myopia, we can see an inferior crescent. In cases of hyperopia, there might be a superior crescent, and there is a difference in the reflex of both the eyes in cases of amblyopia or any kind of other pathology. So optokinetic drum helps in initiating optokinetic nystagmus. There is a succession of black and white strips are passed through the patient's visual field. Catford drum test also based on similar kind of OKN. Here the size of the dot is reduced until the smallest dot is found that can no longer induce OKN. Preferential looking tests are Teller acuity card and the Lea grating. Lea gratings have paddles of stripes arranged, while the Teller acuity card and center there is peephole through which the observer stands behind and observes the movement of the child eye. Visual acuity potential is the measure of cortical activity generated in response to the patterned stimulus or the checkerboard stimulus. Cardiac acuity test is based on vanishing optotypes, and I prefer using Lea symbol. I don't hesitate to give a printout of Lea symbol to the children, so they help. It helps in the assessment in the next visit at least. So apart from this miniature toy test, HOTV test, Jogren hand test, tumbling E-chart, and the Landon broken ring, and Snellen charts helps in identify vision assessment in children of more than 5 years of age. Look for alignment. This child has right eye esotropia, hypotropia, and also had some kind of dystropia also. This child who presented to our OPD with normal alignment but had an AHP, and when we correct the AHP, we can see there is a left exotropia. Sometimes we are the first point of contact for the child caregiver. So any kind of facial dysmorphism which feels abnormal to us should be addressed for syndromic assessment. Like this first child has a right eye proptosis, but actually it was not proptosis. There was some amount of frontal bone dysplasia. The other child has a frontonasal dysplasia who complained watering of eyes. So in these patients, syndromic assessment is required. Any kind of abnormal position like right face turn or any head tilt. This is a patient with both eye nystagmus. See how he is adjusting head posture to see clearly. Extraocular movements must be checked in all 9 gazes. Ductions and versions to be addressed separately. This child was orthophoric, but when we see in 9 gaze there is right eye abduction limitation. In left eye there is PF change. This child seems to have right exotropia, but when we see in 9 cases there is inferior oblique overaction. That was a case of V pattern exotropia. In preverbal children also, assessing vision with either toys or you have to be patient to assess the ocular movements in the preverbal children. This was a case of traumatic sixth nerve palsy. So later I used a doll's eye maneuver, explained the caregiver that it is not going to harm the baby. Squint assessment, Hirschberg reflex gives us idea of the type of a squint. Here the child has left esotropia, pseudostrabismus, that is the epicanthal fold or broad nasal bridge needs to be addressed. In the cover test, we cover one eye and observe the movement of the other eye, while helps in identifying tropias. Uncover test helps in identifying phorias. Here we cover the one eye and observe the movement of the same eye. Alternate cover test helps in assessing whether the squint is alternating or is it comitant or paralytic. In prism bar cover test to be checked separately for near and distance and give the fixation target. Cover one eye. And place prism on the other eye and we can elicit it. Coming to the refraction, I follow guidelines of my alma mater, ROP drops for less than 1 year, home atropine till 18 years of age, and cyclopentolate in cases of AS and spasm of accommodation. Further we perform wet retinoscopy, dilated autorefractometer wherever required. The prescription of glasses based on cycloplegic acceptance, post-mediatic test or the objectively. 4 prism base out test is important for assessing any kind of microtropia. Here the abnormal eye, when we give 4 prism, there is no refixation moment. But when in the normal eye we are giving, you can see the refixation moment. So in the case of nystagmus, sorry for this interruption. We need sphincter occluder or high plus lens to occlude one eye to surpass the latent component of latent component. Binocular vision assessments must be done in patients with nystagmus, and crowding phenomena to be avoided by using tumbling E-chart. It's not moving. Okay. So anterior segment and posterior segment examination to be done thoroughly. Thank you for giving this opportunity. Any queries are welcome.
Call the patient multiple times to familiarize them with the environment in the clinic or make them more comfortable. So what is the attitude that we should have if we have patients or kids of autism and they are quite frequently coming? So how do you assess? Do you have?
See, evaluating them will be a main challenge, but slowly main thing we have to focus is on fixation, whether it is maintained or unmaintained, because otherwise you will not be able to do a very thorough motor evaluation, cover test, they will not cooperate.
They never fix it, they don't look at you in the eye only.
But which eye is not fixating, which is the weak eye, that with experience you will be able to make, and then you can start patching those eyes. And subsequent visits, it's difficult. Problem with them is, again, they don't use spectacles. Even if it is required, they will resist it, not use it. But we have to keep counseling the parents that it is important.
Do you call them frequently? Or
Yes.
multiple visits and all?
Every 3 months, 3 to 4 months we call.
And any particular, in the school-going children, so-called school-going children, do you have any particular vision chart that you use specifically for them? Because alphabets are the making sense. It's not.
See, Lee symbol we can use, but
Since 45 for near, but the EOM is full, there is no limitation. So we do cyclo, there's plus 4.5 in right eye, plus 5 in left eye. So here we prescribe full correction, full glass correction, and we review with glasses to reassess the squint. So here the glasses fully correct squint. So this is a case of refractive accommodative esotropia. So a similar case, little bit different, 6-year-old girl complaining of squinting since 1 year. There's no history of glasses or patching. Ocular examination, there is a left convergent squint going into alternate. And for PVCT, distance is 15, prism diopter near 25. So the vision is 6/9. On cyclorefraction, it's plus 2.5 diopters, fair in both the eyes. So we do a cover test with the glasses. Still, there is some 18 prism diopter of deviation for near with the glasses. So this is a case of accommodative ET with high AC by A ratio. Here we prescribe bifocals because we want to eliminate some. We give near power for near because we want to decrease the accommodative demand, and this will improve the esotropia for near. So these are the guidelines for esotropia. If there is no deviation more than equal to 4 diopters, we prescribe. If there is esotropia more than equal to 1.5, and in anisometropia, same, more than equal to 1.5. Now, a 4-year-old girl complaining of defective vision and occasional squinting, no history of use of glasses. So on cover test, there is IDS, but there is good control for near and distance. Vision is 6/9, left eye is a little bit worse than the right eye. So cyclorefraction, there is minus power in both eyes. So we give glasses. I have 1 minute. Okay, so we give glasses and review 3 monthly. The minus power will also improve the alignment for distance. So 6-month-old baby, status post lensectomy, both eyes quiet. So these are the value we get, 23 diopters fair with -2 cylinder. So here the important thing is we have to give single vision glasses with a +3 add. We will not give just 23, we will add +3 because the child is less than 1 year. So what are the guidelines? Till 1 year we give +3 add, 2 year 2 add, and 3 year 1 add, and later we will give bifocals. So case 8 is a similar scenario, status post lensectomy, but this is a unilateral case. So here contact lenses is better. Yes, children do accept aphakia better than adults, but we also want some amount of stereopsis and fusion to develop, so we give contact lenses with patching. In bilateral cases, a 5-year-old boy, there was a right eye esotropia on examination. The cataract surgery was done for both eyes. So this is the vision, right eye esotropia, and there's lesser vision in the right eye. So these are the cyclo values we get. So we give full correction for distance and bifocal glasses. Here we will patch the better eye, that is the left eye. So tips for spectacle correction, counseling of parents is very, very important. Proper fit and comfortable, it should not be like this. The centration of the pupil should be there. And to conclude, the cycloplegic refraction is essential. Prescribe only when indicated. Regular follow-up is key. And early detection and correction to prevent amblyopia and support optimal visual development. Thank you.
Dr. Bhadra, generally which cycloplegic agent you prefer to use?
Yes, sir.
Which cycloplegic agent you prefer?
Sir, in smaller children less than 2 years, we use atropine 1%. So if in age group of 2 to 5, if there is no esotropia, the CTC guidelines can be used. That is, we give cyclopentolate, 2 drops cyclopentolate, then 1 tropicamide, and the retinoscopy is done 1 hour later. And if there is no esotropia, then this. If there is esotropia, then atropine 1% eye ointment. And in older children, if those with myopia, astigmatism, like 7-8-year-old child, it can be done with tropicamide also.
Thank you.
To proceed with the program, Dr. Sujit Mishra sir and Dr. Vishal Kishore sir kindly join the panel. And now we move on to our third talk of the day. Dr. Amit Kumar, who is a postgraduate of the prestigious RP Center of Ophthalmic Sciences in AIIMS New Delhi and currently working as assistant professor at AIIMS Patna, is going to speak on amblyopia diagnosis and management. Over to you, sir.
Good morning, everyone. I am going to talk on amblyopia diagnosis and management. Amblyopia is defined as reduction of visual acuity in one or both eyes due to vision deprivation or abnormal binocular interaction during critical period of visual development with no obvious organic cause. In unilateral amblyopia, there is difference in visual acuity of 2 or more lines. In bilateral, visual acuity is less than 612. Now coming to etiological classification, there are different etiology for amblyopia such as strabismus and isometropia, combined isometric or deprivation. I will not go into details of this. Up to 7 years of age, it is a sensitive period for visual development, and it is most important for amblyopia development if not addressed properly. Grading of amblyopia as per amblyopia treatment studies: mild amblyopia up to vision up to 20/40, moderate 20/40 to 20/100, and severe amblyopia best corrected visual acuity 20/100 to 20/400. Now, how to diagnose amblyopia? Crowding phenomenon is seen in amblyopia, in which increased vision is when the visual acuity is tested with isolated letters compared to that of lines because of the lateral inhibition which is hampered in amblyopia. Also, there is decreased sensitivity of foveal cones in amblyopia. That's why visual acuity is better under mesopic conditions than under photopic conditions. Also, as we introduce neutral density filters, it creates a mesopic condition, so vision in amblyopic eye improves with that. Also, we see decreased contrast sensitivity, especially high frequency spatial contrast. Contrast sensitivity is less affected in strabismic amblyopia compared to that of anisometropic or deprivational. Accommodative is defective. There is high accommodative lag, which we can check with NRA or PRA. Eccentric cases are present in some cases. Retinoscopy, difference in axial length, difference in keratometry value help diagnose anisometropic amblyopia. Now, treatment modalities: all patients must undergo cycloplegic refraction, and accordingly glasses to be prescribed. The gold standard till today is patching of sound eye. It causes active inhibition of the dominant eye and reinforces connection between brain and weaker eye. So also, what does ATS2A says about patching? In a case of severe amblyopia, full-time patching has similar result to 6 hours of patching. So in severe amblyopia, we should go for 6 hours of patching per day. What about moderate amblyopia? In moderate amblyopia, 6 hours per day patching has similar effect to that of 2 hours per day of treatment. So in moderate amblyopia, ATS also supports 2 hours of patching. Should we do near work during patching? ATS 6 has told that there is no extra benefit in doing near work, but as vision is severely affected in severe amblyopia, greater improvement in visual acuity will be seen when patient is doing near work, because he is not able to see distant object, and alertness will decrease. So we should give near work along with patching when treating severe amblyopia. What are drawbacks of patching? Occlusion amblyopia. It is not seen after 6 hours or 2 hours of patching. It was usually seen after full-time patching. Cosmetic issues, allergic skin reaction. Patching affects binocularity, causing resistance from children. Recurrence is a big issue after any amblyopia therapy. What is recurrence? Recurrence of amblyopia is defined as 2 or more logmark level reduction of visual acuity after cessation of patching. It has been seen to up to 24%. Patient treated with 6 hours of patching has 4-fold greater odds of recurrence compared to 2 hours of patching. The risk of recurrence is higher if patching is stopped at earlier age. So, when should patching be stopped or when to wean? Patching should not be stopped abruptly. Weaning to be considered if there is no further improvement in visual acuity after 3 to 6 months of patching, or if child's vision has reached normal value. Maintenance therapy may be needed until they cross the amblyopic age, that is 7 years of age. Now coming to different other modalities, atropine penalization. It is effective alternative therapy in moderate amblyopia. The advantage is that it has chances of binocular stimulation. Patching has monocular suppression. There is active use of the amblyopic eyes, but in this there is binocular stimulation and no risk of occlusion amblyopia, and it is useful in children sensitive to eye patch. The drawback is that active inhibition is not eliminated. So comparing 6 hours of daily patching and 1% atropine, no difference is seen in either groups according to ATS1 study. And ATS4 study has told that whether you give daily atropine or weekly atropine, results in visual outcome is the same. Now, what about combined patching with atropine? ATS has shown that there is no minimal visual improvement of 0.5 lines in both groups after 10 weeks of therapy with patching or with daily atropine. But as one has binocular stimulation and one inhibits actively involves the suppressed eye, so combined patching and atropine must be given in cases resistant to either of the other therapies or with severe residual amblyopia. Perceptual learning. What is this? Repeated practice influencing neural plasticity by improving performance on visual tasks. Use of video game or PL training helps children to maintain attention and improve compliance. A PL learning software coming to different softwares useful in perceptual learning. Amblyopia iNet software. This is installed in the personal computer of patient for home training. Training consists of 30-minute session duration performed 5 days per week with dominant eye occluded. Sessions are controlled online by optometrists, confirming compliance and customizing session among different games available. Patient performs letter recognition, identification, tracking in crowded environment. A specific sound for right or wrong answer provide a feedback to patient, maintaining attention. Coming to other thing, this is a Luminopia virtual reality headset. It is having dioptic stimulation. That means binocularity is preserved in this. It is contrast-based. The sound is presented a reduced contrast image and higher contrast image is presented to amblyopic eye until image of same contrast are seen by both the eyes. The prerequisite is that it is used in anisometropic amblyopia but not in strabismic amblyopia because it has binocular function. So in strabismic amblyopia it is used only up to 5 prism diopters of squint. Similar, Digras is also contrast based. It is also binocular stimulation and is not used in strabismic amblyopia more than 5 diopters. Binox has color, it is based on anaglyphic principle of color saturation. It is also effective in patients with anisometropic amblyo and strabismus with less than 5 diopters. It has inbuilt prism system. It is also contrast based, but it is as it is has inbuilt prism system, it is useful in both anisometropic as well as strabismic amblyopia. Gabber patch, the patch matches image of the receptive field of neurons in the visual cortex and induces high level stimulation. It has both monocular as well as dioptic visual conditions. However, PEDIC have conducted a study between binocular game to patching and has found no statistically significant difference. Orthoptic magnocellular stimulator has based on principle that repeated stimulation of magnocellular cells of peripheral retina during saccadic movement causes stimulation of V1 area of occipital cortex. It has top to down impulse mechanism. It has also found a pilot study conducted by Santhan Gopal sir has found better result in stropsis, visual acuity and squint after orthopic treatment. There are different pharmacological therapy available such as levodopa, carbidopa, SSRI, citicoline, all have promising result, but many studies are giving suboptimal results also. So patching is still the gold standard with promising result. Look for other available options if patching is not working like penalization and perceptual learning. Weaning should also always be considered and child should always be closely followed post stopping patching or any treatment. Atropine has been found. Low dose atropine, no sir. It must cause blurring, sir. Atropine 0.01% doesn't cause blurring or has any cycloplegic action, so it has no role in amblyopia therapy as per now.
As it is suggested that it is going to release neurotransmitter and it is inducing the visual pathway.
Sir, it has.
Nowadays it is very frequently used in myopia.
Yes, sir.
So, if a patient having myopia of -3 diopter in one eye and -5 diopter in other is supposed to be, and he is amblyopic for the other eye, -5 diopter with weak exo, does atropine help?
As of now, atropine 0.01% will definitely help in checking progression of myopia. But apart from that, we have to do therapy for amblyopia also. It will not control amblyopia or reverse amblyopia. It will just halt the progression of myopia. But we have to add some amblyopia therapy apart from that halting that progression. Sir, previously it was thought that in the critical period amblyopia therapy works up to 7 years. But now as we are getting that brain plasticity can be recovered at later age also we give a trial of amblyopia therapy in older children also. Also there is one case of a truck driver in America losing vision in his better eye, other eye was amblyopic, and he regained 6 vision after that. Sir, at least we should try for 3 to 6 months in older also.
The studies show that if it has not been patched earlier, then it can be effective at an older age also. But if amblyopia therapy has been done earlier, then probably at older age the patients may not respond. That is for binocular. What is the example he is telling for truck driver, that is there, that if one eye is totally blind, then other eye may improve. But if it is a binocular good vision, and if patching has not been done earlier, then in older age also it is effective. Any age, you should try. But problem is in anyone who is working in a high school or college, compliance will not be there. That is the problem.
Even in older children also, they
Yes.
are very resistant to
Yes.
How do you improve that adherence to patching therapy in those
Sir, if they are not adherents, non-compliant to patching, we can do pharmacological penalization, or we can go for dioptic treatment, because compliance is very good in dioptics, binocs and all.
Just a comment, since Kunal is here, I think Kunal is here? Yeah, okay. Since he has orthoptic and we've been sending a lot of children for orthoptic therapy, so can we have some real world feedback from him regarding
Vision
orthoptic?
therapy is quite good even in older patients, even in adults, I will say. It's quite good, but it's not 100%, but vision do improve.
So there is a
There
chance?
is a remarkable change. Sensory function definitely improves. If visual acuity doesn't improve, but binocularity and sensory
What
does
would be the
improve. In all
oldest
patients.
patient that has improved under your care?
I have tried 35 years old patient also.
That's great.
I have seen improving 2 lines, 3 lines, not 100%,
Well,
but definitely.
Still, that's a big.
Even in severe
Yeah, you have to do that treatment for 20 days at a stretch. Then depending on the amblyopia and the extent of improvement, you can. About 1 to 1.5 hours.
So,
Yeah, 45
I
minutes.
think I have always
But
given
it's
my
not
adults a
100%.
chance.
It's not at all 100%.
That's not expected.
It depends
but
on
so
patient
keeping
to
track
patient.
of the time, I think we should
But
move on
if
with our minutes.
there is some hope for somebody, so you should definitely try vision therapy. If nothing works, you have to give some option to the patient and guardian.
Dr. Love, are you doing orthoptic?
Kindly proceed.
What is the effect of amblyopia on visual field as such? As sports person, one eye amblyopic, he is playing cricket.
Yeah, definitely.
We are doing patching therapy. Is he suitable guy to pursue his career in cricket?
Patching we do in the home. Why can't he do? But
Why-
yeah,
he's asking for binocular
visual
vision.
field, there will be a problem. There will be definitely a
Stereoscopy will
problem.
also be a
Stereopsis will be problem.
And stereoscopy will also
What
be a
happens in the
problem.
amblyopia? We have a reduced BSV and stereopsis. So if stereopsis is less, definitely he will have problem in playing ball game and anything.
That is for average. That
is
rule for
individual
average
skill.
players.
That is individual skill.
That is when he fell from horseback
is individual.
and lost his eye. That was later. He had already adjusted to cricket.
Patching is going to broaden the visual field if we do it properly.
Yeah, definitely.
Regarding vision therapy, your question, in our practice we reserve it for older children who are not responding to patching.
Correct.
So you find it useful in the cases where, because there is a contention few says that no, it is not worth.
One thing I've noticed is reversal after
reversal is
stopping.
there. Reversal is there.
But as far as the aim is to convey to the house that we cannot discard
It is not
saying
a
that
substitute for patching.
it is not
100%.
What about few cases who have history of long patching and
Then
up
you
to
can try.
certain
See,
extent
after patching it has
worked.
stopped. It is not working after some
and
level.
then it
then
has
you can try
orthoptic
this.
because
Yes.
that is what, because I have tried it. See, first of all, let me tell you, you try it yourself and then you will come to know how it works,
So let us
whether
kindly
it
move
works
forward.
or not. So
Let us
before
kindly
first
move
you
forward,
use
sir.
it and then see. Okay.
Till the age of 5-6 years, children are
Let us kindly move forward, sir.
the
So we can discuss over high T. So Dr. Kunal sir, kindly proceed with planning squint surgery in
So
children.
planning squint surgery, as all surgeries like retinal surgery and cataract surgery, we remove cataract. So in the squint also, we have 12 muscles in both the eyes. So planning surgery, we have, what we require is a correct position of the eye in the primary gaze, if possible in the all gaze, with improvement in abnormal head posture, and if there is a mechanical restriction, to improve that restriction. So what is the optimal time of the squint? It depends on the type of the squint, age, and the various sensory adaptation. In comitant non-paralytic squint, we have to do a refraction, patching, make the eye alternating freely, then operate, and operate before 8 years of age, because visual maturity develops by that time. Intermittent exotropia or intermittent squint is quite tricky, and planning surgery at the right time depends on the how many hours the squint is present, by asking the parents whether it is present 50% of the waking hours, and then confirming on the clinic with a cover test, cover the eye, and if the eye comes back to primary position when the cover is removed before the blink, then that means you have to wait for the surgery. If it comes after the blink, that means the control is poor, you can straight away plan surgery. And planning surgery, bilateral surgeries are always better. Recession is always better than the resection, which causes narrowing of the palpebral fissure. Coming to more important, paralytic, which is very tricky, and when to plan, not too early before 6 months, and not too late when the secondary fibrosis and all take place. So in the squint, we have 4 group of procedures, weakening procedures, like recession, myectomy, tenotomy, Fedens, which changes the posterior fixation. With the posterior fixation, we change the arch of contact of the muscle, and the muscle lengthening, which I will be dealing in subsequent slides. Strengthening procedures like resection, advancement, tucking, plication. These are all strengthening procedures. And in procedures which change the direction of the muscle, that is the transposition surgeries are required in AV pattern. If there is no oblique overaction, we can plan the transposition surgery on the horizontal muscle. In A pattern, we move medial rectus towards the apex and lateral rectus down, and the V pattern, medial rectus down and lateral rectus up. Depending on the ESO and EXO, we plan the recession accordingly. Transposition surgeries are the surgeries which we do in the paralytic squints. General consideration for surgeries, surgeon factor is very important. The amount of squint he is correcting in his hand is very important for planning the amount of dose you have to give. The globe fixation is also required, proper, and the fornix based conjunctival flap is nowadays preferred because limbal is preserved, and cosmetically it is better. These are the flow chart for recession. I'll skip this because of the time recession video. This is the recession, what is done. The dose depends on the amount of the squint you have, and you can hang it. Even you can transplant muscle. If there is a large angle, you can take the resected muscle, attach it here, and do a large recession with the transplanted muscle. This is done in the heavy eye or high myopic with exotropia. One special case is Duhan's retraction syndrome. As you all know, Duhan's retraction is ESO-EXO, but the most important thing is the upshoot and downshoot which occurs in the adduction position. So what we do, as you know, that it's because of the co-contraction of medial and lateral rectus when the eye is adducted. So you do a Y splitting of the lateral rectus to decrease the co-contraction effect on the globe, because of the hammock effect, eyeball throws up or down. So you split the muscle vertically about 10 to 12 mm behind in the fornix, and with the V shaped and Y shaped, you attach it, both the arm 10 to 12 mm apart. So I'll just move this video. This is how you attach it, and the end you measure the amount of the Y arm should be around 10 to 12 mm to decrease the tone of lateral rectus on the globe. So marginal myectomy and the fade-ins are the other weakening procedure. Inferior oblique overaction occurs in the V pattern, as inferior oblique has a abduction, extorsion, and the elevation effect. So eye with the inferior oblique overaction, you have to plan inferior oblique recession, otherwise the V pattern will not be corrected. As you know, the inferior oblique arises from the floor, goes behind the lateral rectus. It's a very thick muscle. Once you isolate the muscle, it will not slip. So you have to isolate, tie it, and then recess it near the inferior rectus. This is inferior rectus. And depending on the overaction, you can recess it at the level or 2 mm by 2 mm from the inferior rectus, which is called the Park recession. This will correct the V pattern. And next comes the superior oblique muscles. There are various surgeries on superior oblique muscles. I'll just skip the video because of the time. This diagram will clear all the surgeries on superior oblique. The action of superior oblique is intorsion, abduction, and depression. So this is the muscle which is required in the reading. So superior oblique palsy patient will have difficulty in reading. So this muscle starts from the sphenoid apex, from the apex of the orbit, goes through a trochlea, and then fans out under the superior rectus and get attached on the sclera. It has two fibers, the anterior 1/3 and the posterior 2/3. This is a posterior 2/3. Posterior 2/3 is the muscle, is the part which causes the abduction and the depression, and the anterior 1/3 causes intorsion. So in a A pattern in which eye in down gaze deviates out, so to correct it, we have to remove this part, which is called the posterior tenectomy of superior oblique, PTSO. So this whole part is removed to correct the A pattern. And in the superior oblique palsy, what we do, since the anterior fiber is the problematic part, so we tuck it. Tucking it like you isolate the superior rectus muscle and fold it like something like sandwich like this. And the tone and the amount of folding or the plication depends on the FDT. The eye should be freely moving up and down in the adduction. Otherwise, you will be making the eye brown. You will creating a heterogenic Brown syndrome. So what is Brown syndrome? Brown syndrome is also treated by this muscle, superior oblique, in which there is a thick, tight superior oblique. So we have to lengthen it, take the retinal band, you isolate the muscle near the inner canthus and superior rectus, isolate this tendon, cut it, and then place a retinal band and extend the tendon so that the eye freely elevates in adduction. The problem with Brown is that eye will not elevate in adduction position. So Ito Harada is same thing, the tucking superior oblique palsy patients. Coming to other transposition which changes the original place of the muscle is Knapp's procedure. What is Knapp's procedure? Knapp's procedure is used when there is a double elevator palsy. The eye is not elevating. For that, you have to do a FDT, check whether inferior rectus is not a problem. If there is an inferior rectus problem, that restriction, you have to do an inferior rectus recession to align the eye in the primary gaze. Otherwise, if FDT is free, then you can plan Knapp's procedure. Knapp's is quite simple. You have to isolate medial and lateral rectus. This is a medial rectus. I'll just move the videos a little fast. And then attach near this is the superior rectus muscle. You have to attach at the side of the superior rectus. In both the side, medial and lateral is pulled up and attached near the superior rectus. This way you can correct the hypotropia. Then comes the sixth nerve palsy. There are 3 surgeries for sixth nerve palsy. There will be an abduction restriction, so Hamilton, Jensen and Nishida. These are the procedures which are done for sixth nerve palsy. In this, you have to do a translocation process in which in the Hamilton, the superior rectus and the inferior rectus is isolated, dissected from the globe and attached adjacent to the lateral rectus to start eye abducting. And this way the whole muscle is translocated. Improvement of this is Jensen, in which the half tendon is attached. All three muscles half tendon is attached near the rectus, about 10 to 12 mm behind the limbus, in between superior and lateral and inferior and superior. This way you are preserving the anterior ciliary artery, and the risk of ASI, that is anterior segment ischemia, is less. The improvement over this is Nisida procedure. In Nisida procedure, there is no risk of ASI, and you have one more rectus muscle to operate. If there is a esotropia in the primary gaze, you can operate MR, you can use a medial rectus recession, since in Nisida you are not dissecting or you are not touching the tendons. You are simply pulling the whole muscle with a non-absorbable suture, superior rectus, inferior rectus, and then attaching on the sclera around 10 to 12 millimeter behind the limbus. This way Nisida is quite superior, and nowadays all vertical VRT, that is vertical rectus transposition surgery in sixth nerve, is done through Nisida procedure. With you can add medial rectus recession if you find a esotropia in the primary gaze. So we have finished fourth, sixth, and the third is left. Before I go for complication, third is quite tricky because you have a ptosis along with exotropia. So exotropia hues, the eye will be quite far away from the primary gaze. So you have to deactivate lateral rectus. How to deactivate? Isolate it and then attach to the periostome of the orbit. Whole tone of the lateral rectus is removed. This way you can bring the eye in the primary gaze, but movement will not be there. So our goal is what I said in the first slide, that our goal is to correct the eye in the primary gaze if we cannot correct in all the gazes. So by this way, after frontalis sling, the eye will be in primary gaze with and the third nerve can be taken care. Complication: as you drive a car, you have an accident, so squint surgeries are not without accidents. So most important is oculocardiac reflex, which you should know, and then I will just skip. ASI, you have to remember anterior segment ischemia. Don't touch more than 2 rectus muscle. Preserve the anterior ciliary circulation as, and this slide you can, for weakening, strengthening, this is a schematic diagram showing all the squint surgeries. And thank you. Any questions are welcome. नहीं, याद रखना है कि सिक्स्थ नवी में नाम है और किसी में नाम नहीं है. सिक्स्थ में नाम. हाँ. Surgical dose, actually it's a surgeon dependent. It depends on your hand. There is a standard dose by Arvind, which I am using for last 18 years.
So have you modified it according to?
Yeah. Depends on the case to case and amount. What I am getting, I am using.
We are really running short of time, sir. Thank you so much. And now we would like to call upon Dr. Anita Ambasht ma'am to speak on pediatric optic neuritis. Dr. Anita Ambasht ma'am is additional professor at RIO IJMS Patna.
Good morning, everyone. I will be talking on pediatric optic neuritis. We see very few cases of pediatric optic neuritis, and it's very different from adult optic neuritis. And just to remind us of the old age, child is not a young adult. They are different. Here I'll be dealing mostly with the demyelinating optic neuritis, because otherwise there are so many causes. So pediatric optic neuritis is an enigma. Why is it an enigma? Because we have very few case series being reported, and most of what is there is on adolescents and young adults, rarely on children younger than 12 years. And there's no comparable trial like ONTT. Mostly what we're doing is extrapolating the results of ONTT onto the pediatric population. And another important factor is that 25% of all acute demyelinating syndromes in children will be presenting with optic neuritis, and these conditions are sight-threatening and life-threatening, and also they can lead to lifelong disability if not detected and treated properly. The urgency on us ophthalmologists is that a lot of good neuroimaging techniques are there. We know more about this, and some new serological tests have come up, so the urgency is there on us to diagnose these correctly and refer. So the epidemiology, pediatric optic neuritis is an inflammatory disorder, rare, with limited data, more in adolescents, female predilection in children near puberty, after puberty, and there's a higher incidence in non-white children. Mostly it's idiopathic, isolated, following a viral infection or vaccination. This is a presentation which we usually see. So how is the pediatric optic neuritis different from the adult optic neuritis? Adult is mostly in female, unilateral, painful, mostly retrobulbar optic neuritis, and it may be associated with MS or go on to have MS. Pediatric optic neuritis, prepubertal, male slightly more than female. The vision loss at presentation is more severe. It is usually a disc edema which we see, bilateral, and these patients rarely develop multiple sclerosis. So we all know that idiopathic optic neuritis, post-viral, post-vaccine, like we see, recover vision on their own. So why do we treat these patients? From the ONTT trial, we saw that it speeds up the recovery and it reduces the risk of future episodes. Plus, it addresses any underlying conditions that may be causing optic neuritis. There might be some inflammatory condition leading to optic neuritis, so it's treating that also. Another thing is that there is risk of developing neuroinflammatory or demyelinating diseases with risk of very severe vision loss. At least we are going to minimize this vision loss. So not many studies, as I said before. There was just one pediatric optic neuritis prospective outcome study, 2-year results. And this study was done by PEDIC and the Nordic groups, and they planned to recruit 100 children and follow them up for 2 years with optic neuritis. But only 28 children completed the study. However, the outcome is that majority had marked improvement in visual acuity by 6 months. But the important part is that associated neurologic autoimmune conditions were seen in 61% of the participants, where acute demyelinating encephalomyelitis patients, MOG was positive in 7%. MS was seen, multiple sclerosis was seen in 14%, neuromyelitis optica spectrum disorder in 11%, and MOG antibody associated disorder in 29%. So you can see the amount of associated autoimmune conditions which were seen in these patients, but we can be a bit skeptical about this study because only 28 patients had completed it. Now this was again our study where we checked serostatus of seroaquaporin 4 in optic neuritis patients. We had 4 patients with NMO positive. Now this is one of the child. This girl we saw in 2017, she presented to us with atypical optic neuritis, severe vision loss. We treated her with IVMP. The vision improved, but not that much. Again, she came back to us after a month or so with recurrent attack, and this time the disc became pale. Soon thereafter, she developed features of transverse myelitis, the MRI showing long, extensive transverse myelitis lesion, and that is the time this was ordered. The serum aquaporin 4 antibody was ordered, and it came positive. The child was diagnosed as having NMO spectrum disorder, and treatment started with rituximab. Again, now this was 2019, 2 years later. Now this is a 14-year-old child with again atypical optic neuritis. And because it was atypical optic neuritis and we knew better, we started IVMP immediately, after ordering the MRI, of course. The MRI showed very characteristically optic nerve enhancement involving also the posterior part of the optic nerve. This goes in favor of NMO spectrum disorder, and on the basis of this, we ordered a MRI spine also. And here we were very agile. We went for IVMP, and then we started her on immunosuppressants, and we had a better outcome in this child. In 22, we had this 15-year-old female with atypical optic neuritis, severe vision loss. Because it was atypical optic neuritis, we got the NMO and the MOG test done. This MOG was positive. the MRI showed anterior optic nerve and sheath involvement in both the eye. Now this is important because sheath involvement is usually seen in MOG associated disorders. And although the disc became pale, but vision was retained, and she is on chronic immunosuppression for azathioprine. We followed her for 2 years and she was doing well. This was our first case of MOG optic neuritis. In 2022, again we had this female of 16 years, presenting visual acuity less than 660. And again, we tested her because it was atypical optic neuritis. She was MOG positive. You can see the disc is looking so pale, but the vision was retained. OCTR and showed optic atrophy. So how do we work up a case of pediatric optic neuritis? How do we manage, and does ONTT provide the answers? So whenever we are seeing a patient with optic neuropathy, child with optic neuropathy, it's imperative that we rule out, we have a look at the differentials, rule out all other causes of optic neuropathy before coming to the diagnosis of optic neuritis. So you have to rule out hereditary, infectious causes, very important. Neoplastic, there might be optic nerve glioma sitting on the optic nerve, or there might be a leukemia. So you also do a peripheral blood smear in these children. You rule out papilledema, see for signs of raised ICP. The MRI will also provide a clearer picture. Take history of trauma, maybe it's a traumatic optic neuropathy. Take history of medications, toxic. Yesterday I had a 15-year-old child, alcoholic toxic optic neuropathy. So don't be shy of asking this history also, or it can be nutritional. So after we have ruled out all the differentials, we come to the diagnosis of clinically isolated optic neuritis, which could be due to an underlying inflammatory condition or could be a harbinger of a demyelinating condition in future. So we evaluate these patients by doing a thorough systemic and neurological examination. We take the help of a neurologist if needed. We check the pupillary reaction, do the CBC autoimmune workup, rule out tuberculosis, do the imaging, do the fields, whatever you feel is necessary to come to a diagnosis. So after we have come to we have taken care of the differentials and we have come to the diagnosis of clinically isolated pediatric optic neuritis. And if we have a case with atypical optic neuritis, we check for the serostatus, and you can have a neuromyelitis optica spectrum disorder patient or a MOG associated disorder, or acute demyelinating encephalomyelitis neuritis patients presenting to you. These usually come from the neurologist. They have a patient with a non-febrile encephalomyelitis syndrome, and they send them to us to have a look at the disc. If it's typical, then it just might be idiopathic. In that case, you may not do anything. If your MRI is clear, you may not do anything. And if, or the child may be having some white matter lesion or a multiple sclerosis. So we have to know the difference between typical and atypical optic neuritis to proceed further, to know which patients to order for serological testing. This is the difference. And then we have to differentiate, of course, between the MOG antibody diseases, the aquaporine, and the MS. MOG optic neuritis and aquaporine 4 optic neuritis is usually, the difference is that MOG is more common in children. And otherwise, the presentation of the optic neuritis is bilateral, severe vision loss, recurrent in both MOG and aquaporine, more recurrent in MOG. And MRI involvement, what we see in the MRI is long lesions in optic nerve in aquaporine involving the chiasma. And in MOG, we see sheath enhancement also. And in MS is like a typical case with typical optic neuritis. So the treatment, I'll just skip over. So the treatment, it's important to differentiate between these three conditions because the treatment differs. In an NMOSD, it is very necessary that we start treatment timely. Otherwise, we are going to lose the eye. So acute attacks, after we have done the imaging, we don't wait for the serology test. If we see the imaging, if it looks atypical, we presume that it's NMO, and we start off with IV corticosteroids. Or we can also, if the serostatus comes positive, we can do a plasma exchange. And maintenance is with rituximab or azathioprine. In MS attacks, if we are diagnosing the patient as MS, we start with disease-modifying agents immediately to prevent further demyelinating lesions. And MOG, again, we do with IVMP, IVIG, and plasma exchange. The important thing is, why we have to differentiate is because the disease-modifying agents to prevent further attack and demyelinating lesions, disease-modifying agents are given in MS and not in others. Just a few queries. Is imaging necessary? Yes, because you want to rule out a SOL. You want to see if there is a demyelinating lesion sitting there. That will decide your treatment. Is IVMP needed? If your MRI is clean and it looks idiopathic, you may not give. A child above 5 years can do fields. CSF, even the neurologists don't do CSF much because they say that by the time you get an oligoclonal band, you're going to get an MRI finding, and that will help in the diagnosis. To conclude, optic neuritis in children is rarer. It has different presentations. It might be associated with underlying neuroinflammatory diseases, which is going to be different from adults. And pediatric optic neuritis is more likely to be an initial manifestation of ADEM. Steroids may hasten visual recovery, but they do not change the final visual outcome except in NMO. Visual outcomes are good. Treatment is extrapolated from ONTT, so maybe we need another pediatric ONTT. Thank you.
Just wanted to know that in case of like a 7-year-old girl presented with clinical suspicion of optic neuritis post-viral fever, do I wait for any ancillary investigation reports or start on IVMP immediately?
If you want to start with IVMP, I always take a MRI. You never know. You are thinking it's post-viral or post-vaccine, and you never know what you're going to see there. Once in a poor lady, with the optic neuritis, I thought, okay, she's poor, let me not get an MRI. Gave one dose, and then on better thought, sent her to PMC, got one, and there was a tuberculoma sitting there. So you want to be very sure before starting IVMP. And even a patient post-vaccine or post-viral, might have a white matter lesion and may need a regular follow-up and some kind of other management. That helps you in the diagnosis. You see a prolongation in the P100 because of the conduction delay. So that helps you in the diagnosis.
You don't think it is mandatory if we want to start anybody on IVMP or
If you have VP, you very well do it.
Why it should not be done?
What? VP is not going to just rule out any other lesion in the brain. So you need that to rule out other conditions. There might be something else out there. As I said before, and of course, if you have a BP, definitely it's going to help you. That is a protocol we follow. We order it in all the cases of optic neuropathies. Okay, so if you have a prolongation of P100, you think it's an optic neuritis?
To see the first time, it is mandatory to go for MRI. If the patient comes to you after some time, then it is better to use methylprednisolone.
We are discussing whether VP, I think for optic neuritis we should go with VP and MRI.
Yeah, exactly. But I will not exclude MRI because suppose you have a prolonged P100 and you have a MS lesion here, then how will you know that the child is having a... Yes, of course. That is going to add to your this thing. VP itself rules out many things.
Ma'am, do you follow ONTT protocol of tapering in steroid or do you customize in cases of...
We do both depending upon. Sometimes we don't taper and give for 10 days and finish off, or we taper over 2 weeks. We do both, and if we think, okay, we'll give some more, then we taper. This is not particular any one thing that we follow.
And what is duration of rituximab in cases of...
See, this is given by the neurologist, and it is their take, the rituximab. We think that our job is to diagnose these conditions, and then we send them. So they are giving IV immunoglobulins, rituximab, they are giving.
And how do you monitor these patients apart from visual acuity, because after some time they will develop partial optic atrophy also?
So we are following with fields, color vision of course. Color vision is another thing, and the fields we are monitoring that, how it's going.
Thank you for your comments, and now we move on to our next talk.
Recurrence is there in optic neuritis, that is why the role of these, especially in MOG and NMO, there's recurrence. So you give chronic immunosuppression in these patients. In other cases, you have ruled out the other causes of the optic neuropathy, and then you come to this diagnosis. there is a chronic relapsing inflammatory optic neuropathy. The moment you stop it, it again recurs. So you have to be on some kind of a maintenance for a long time. And then, of course, the steroid sparing agents are used.
So we move on to our next very interesting talk, leveraging ultra-wide field imaging to uncover hidden threats in retinal periphery, by Dr. Sat Prakash Tiwari, sir.
Thank you so much. At the outset, I would like to thank the organizing committee, Dr. Abhishek Anand and team of RIO for having me here for this talk. This is actually industry-sponsored talk by JAIS. They are into the business of making very good ultra-wide field fundus cameras. So one thing I would like to make clear, as far as the uncovering the lesions of periphery is concerned, till date there is no ideal fundus camera available, although most companies are claiming that I'm having 200 degree, 160 degree, 130 degree, but none of them images properly the regions, the ora serrata or vitreous base region where we get most of the lesions, peripheral lesions, that atrophic whole operculated tears or horse tear. But still we do need some kind of fundus camera. Nowadays the best tool to see peripheral lesion is still the indirect ophthalmoscope. None is going to change that procedure or doing a good indirect ophthalmoscopy. But nowadays, as the medical profession and the practice of medical science has become that you don't only have to diagnose a disease, but you have to prove with some evidence to the patient, to the courts or to the society that you have diagnosed, and that is there inside the eye. And here the fundus camera helps, and to convince the patient also, because many times we do get a patient with having a very serious lesion in the peripheral retina, which if left untreated might lead to serious complications. But at present patient is not having any issues, so they are very reluctant to opt for any treatment. So in those cases fundus camera does help a lot, and it is very easy to convince them that, see, this is having in your eyes and you need to undergo a prophylactic treatment to save your eyes. So what is ultra wide field imaging? As we all know that retinal imaging is divided into three parts: posterior pole imaging, wide field imaging, and ultra wide field imaging. So posterior pole imaging essentially includes optic nerve head, macula, and adjoining these vessels is there in the posterior pole. Wide field imaging includes imaging till the vortex vein ampulla, and ultra wide field imaging includes any image which covers at least some anterior part beyond the vortex vein ampulla. So at present we are having a lot of fundus camera available. Spectralis originally takes only up to 60 degree, but there is additional attachment, and with that of that wide field attachment we can image up to 105 degree. Clarus is excellent fundus camera, and it images 133 degree in single image and 200 degree or in montage to 67 degree. If we take multiple pictures and put into a montage. Optos ultra wide field also takes up to 200 degrees. Mirante takes 163 degree in single image, and I am having both these Clarus ultra wide field and Mirante ultra wide field cameras, and these are supposed to be the two best wide field camera fundus camera available in the market at present. And Clarus is actually takes true color picture, that is what we see with our eyes with the help of direct or indirect ophthalmoscope. Exactly same colors we are getting in a fundus picture, and rest of the camera mostly takes pseudo color. Mirante is near to a true color. It is also a pseudo color, but it uses 4 laser rays, and that extrapolates the pseudo color almost nearer to the true color images. Mirante, if we take multiple picture, what I have personally felt that it takes much more wider area. In most of the cases I am imaging ora serrata or beyond ora serrata also, if we take properly 2-3 images. While Clarus, it also does take, but it takes very difficulty, and many a times we may not take all the ora serrata. But what advantage Clarus gives to me is that even in relatively hazy media or vitreous haze or a significant cataract, nuclear sclerosis, the images of Claris are much more clearer and visible. While this Mirante, it takes images up to far periphery, but the images gets blurred very, very easily if there is slightest of the media opacity in cases of any patient of cataract or vitreous hemorrhage or whatever. So as I said, that there is inability to capture aura to aura in single phase. That is, even at present it is beyond the capacity of any instrument available at present, and media opacity degrades the quality, but I would give upper hand to Claris that it takes very good images even in significant media opacity cases. Peripheral distortions are actually a problem, but again here whatever area captures that Claris, it takes very good images, and peripheral distortion is also list in cases of Claris as far as peripheral imaging is concerned. So this is the flow chart of development of fundus imaging, and what the problem we see, especially in optos, that eyelashes making the peripheral imaging hazy, and optos is having extremely pseudo color images that doesn't have any true color image, and the color that is being given by that fundus camera many a time masks the many retinal pathologies. And if we rely on the imaging by the optos, we do get very poor diagnosis of multiple retinal pathologies in cases of this optos. These are the some of the photographs taken by Claris, and color clarity and complete comprehensive examination is actually being given by Claris, and usable ultra wide field is very good in cases of Claris. Peripheral distortion is very less, and field of view is, as compared to other ultra wide field camera, is actually very good. This image shows the that definition of posterior pole wide field, ETDRS7 field, and ultra wide field imaging actually. So this is actually the principle of operation is broad line fundus camera with these red, green and blue LED emitting light emitting diodes, and that makes and scans and gives a true color imaging. And by using a slit to only illuminate a portion of retina at a time to obliterate the reflections of peripheral rays, and then that takes a very good, and there are a lot of functions in that fundus camera to take precision focus, auto bright and gaze point to give images very crisp and clear to actually interpret the images. And another good thing is that if we connect with Forum in our desktop where we are sitting in our OPD, we get actual images in which we can enlarge, we can zoom, or we can improve the view and see the periphery, and then we can find without going to the imaging. This is fluorescein angiography done by a choroidal melanoma and excellently shows a double circulation in cases of melanoma. And I would just show some of the images which is being clinical cases. This is we can see a small NV and being clinched very easily with the help of this Claris imaging. Then AMD, we would skip these images. See, we can compare head to head that image of Claris and optos. What we see in Claris, that image of the optic nerve and macula is very well seen clearly, and equally good is the peripheral imaging. While in optos, peripheral images are still better, but the optic nerve and macula images are blurred and they are far away from the natural looks or images, and finding the disc and macular pathologies is not that good in cases of optos. Yes. I would, in the last, I would just show few images of ROP taken by flying baby position, and we can see that how good this is See, this is such a crisp image taken by aggressive ROP baby, just by using flying baby position with the clarus, and it shows such a wonderful images without any blurring or masking. Again, this is image taken by a flying baby position of ROP, and this camera actually gives a wonderful images. So to conclude that all ultra wide field fundus camera are very good, and nowadays available camera are at very low cost also. We do need something to diagnose and evaluate our cases, and we are still very far away from developing an ideal ultra wide field camera which can ideally replace indirect ophthalmoscopy. Till date we are having the best ultra wide field camera is indirect ophthalmoscope. Thank you so much.
Thank you so much, sir. And now we come to the highlight of the session, which is a keynote address by Dr. Laj Kochgave, sir, on management of congenital cataract. Sir is senior consultant and director at Netralayam, Kolkata.
Thank you, Dr. Vibhuti, for inviting me to the new RIO building. It's wonderful, and in this talk I would be briefly covering the various surgeries that we do in children for cataract or subluxated lens. One or two varieties of subluxated lens surgery and PHPV is missing in this, but broadly it covers all the common surgeries that we do in pediatric cataract. So first is if you go by age group, if the infant is representing to us, we generally tend to avoid intraocular lens implantation, and in that we undergo lensectomy. And in this there are two ways it can be done. One is by limbal route and second is by pars plana route. It depends on your training. The posterior segment surgeons generally advise to go more by pars plana route, but what I have seen and when we have trained, the head of retina of Shankar Netralaya was doing by limbal route. So that is why we adopted the limbal route for lensectomy, and the care has to be taken that the rim of anterior capsule cannot be too large or too thin, because if you make it a thick anterior capsular rim, capsular phimosis will occur and leading to obliteration of the visual axis. And if you make it too thin, then chances of implanting IOL at a future date becomes much more difficult. So this is the first variety what we do. Second is the routine, the most common procedure that we do in pediatric cataracts, which is anterior capsular excess, cortical aspiration, IOL implantation, primary posterior capsular excess, and anterior vitrectomy. So in this case also you can see probably the posterior, it is a posterior subcapsular, but if you see with the structure of the cataract, probably the posterior capsule is deficient there. So we have to be very careful when doing cortical aspiration. Don't do any hydro procedure and do only the cortical aspiration. Then we may be able to preserve the posterior capsule till the IOL implantation, and after that anyway we have to do a posterior capsular excess. So as you can see here, the cortical aspiration has been done, and nowadays we have given up manual posterior capsular excess. So generally we implant a hydrophobic lens in the bag, and then with the same 23 gauge cutter we go back and do a posterior capsular excess and anterior vitrectomy. Sutures have to be applied to at least till 7 years of age. After that, case to case basis, we can decide on not putting sutures, but till 7 years of age, the main port should always be sutured because children have low scleral rigidity. And nowadays, one more variation I've done is started in this, that when doing anterior vitrectomy, in the last moment, I remove the irrigation and do a 2-3 second anterior vitrectomy and come out. Then the AC becomes very well formed in those cases. This, if you are having a unilateral pediatric cataract, please, and if the child is not cooperating for slit lamp examination, presume that the posterior capsule is deficient. And this is a typical case of posterior lenticonus. in which you see a spindle-shaped defect as soon as you put the child under microscope. Again, the hydro procedures have to be avoided, and in children mostly we avoid hydro procedures. After capsulorhexis we do the cortical aspiration. Care has to be taken that till the cortical aspiration vitreous loss should not be there, and after that anyway we have to do the anterior vitrectomy. So here you can see that more or less we have been able to avoid vitreous loss, and there is a large pre-existing posterior capsular defect, so posterior capsulorhexis is not required in these cases. Anterior vitrectomy has to be done neatly so that the bag is totally free of vitreous and it forms with it in the bag, inflates well so that we are able to implant the IOL in the bag and when doing pediatric cataract surgery. In pediatric cataract surgeries, IOL implantation in the bag becomes much more important than in adult patients. And finally, the next case, this is again a significant portion of pediatric cataract patients, and especially when you are catering to patients with semi-urban and rural background, and there they tend to have eye injuries more. So it is very important to actually do it in the golden period. And in this case, as you can see, initially this patient had reported to us late. Primary wound repair was not done. And then since the patient reported it late, the wound had sealed by itself, so we went ahead with a cataract surgery. The cortical aspiration was done through the opening in the due to the trauma in the anterior capsule, and then the capsular rim was enlarged using a cutter, and then finally the IOL is implanted in the bag. Whatever bag remnant is there, it is better to implant the IOL and place the haptic on the 90-degree opposite the long axis of the anterior capsular tear, so that future decentration of the IOL is less. While doing this, the wound had given way, so we put one suture to the wound, and then it became a self-sealing wound again. And traumatic cataract, every case will present in a different way. This is just one of the scenarios what I have shown. And finally, the posterior capsulorhexis and anterior vitrectomy is done. Next is another thing which is very this is the common thing what we do after lensectomy and around 2 years of age. I generally, as soon as the child reaches around 2 years of age, I go for a secondary IOL implantation, and invariably you will get some synechia from the remnant of anterior capsule and iris, so that has to be released. The spatula has to be swept 360 degree to see if there are any adhesions or not, and once this is released, the IOL can be placed in the sulcus and sometimes with optic capture or without optic capture. But with a proper rim, it doesn't cause any difficulty, though 2-3 cases I have had 10 years after the surgery, the IOL went dropped in the bag, in the vitreous cavity. But that could be due to a very thin rim that was left during lensectomy. So this has to be done in almost all cases after lensectomy. Only thing we have to see that axial length has to be more than 17 and corneal diameter has to be 9 millimeter at least. Then IOL implantation is safe in children. Next comes, which is quite challenging, and I've done all variety of procedures for subluxated lens in children, and finally you have to come to a conclusion that what suits best in your hand. So this is one of the variety what I am showing, in which capsulorhexis is done, CTR is placed, and we were hoping that this will lead to centration of the bag. But unfortunately the bag didn't get centered even after CTR implantation, so IOL was implanted. And generally subluxated lenses are older age group if it is not traumatic, so we can skip the posterior capsulorhexis in these cases, but in this case it was done. And then since the lens was still not centered, we went through and pierced the bag with a ninoprolene. The CTR was used as the anchor, and the CTR was fixed to the sclera, bringing the bag to the center. So this is one of the ways what we deal with subluxated lenses, and I will just demonstrate one more in which, as you can see, this is more than 270-degree subluxation. So it is better not to preserve the bag in such cases, because even if you fix it on one side, the other side it will give way, and the procedure also becomes very difficult. So in this case, we decided to do a lensectomy, and care has to be taken that no cortical fibers fall in the vitreous cavity, and very small fibers generally get absorbed, but if it is a significant chunk, then that will lead to inflammation, and it's ideal to remove it in the same sitting itself by a VR surgeon. But generally it doesn't fall, and we start on the anterior surface, then go to the equatorial portion, keep cutting it and remove the whole of the lens. And even the attached portion, we have to be careful that none of it is left on that side also. So here you have chance of some of it falling in the vitreous cavity, and as you can see here, it's been done neatly without any fall, and in older children we can even do a scleral fixated lens. Just one more video is remaining, and slowly this is becoming my treatment of choice for a subluxated lens in children. I think this is the last slide, and if another option for gross subluxation is just do a lensectomy and leave the child like that for a few, and especially when you are operating it before 8 years of age. In those cases, scleral fixation should not be done, so it is better to leave the child aphakic and plan for a secondary IOL, secondary scleral fixated IOL at a later date. So with all these varieties, and the only thing I think significant missing type of surgery in this collection is PHPV, which we get in children. And in those cases, one important thing is that we should be ready to cauterize the stump of the PHPV, otherwise that causes bleeding. And mostly if it is a large PHPV, the results are not that good, but it's worth giving a try. So thank you so much, and thank you for this opportunity.
That was a very nice bouquet of cases that you presented, Dr. Love. Do you ever do a PI in these patients?
No, PI we don't.
Even aphakia, none of them?
No. But if you do a good vitrectomy, it's not required.
In any of these cases in pediatric? Okay, secondly, what is the cut rate that you're using, and what is the bottle height when you're doing the anterior vitrectomy?
See, bottle height nowadays we use the IOP based one, so bottle height factor is not there. But cut rate, if you are cutting the capsule, if it is a fibrosed capsule, the cut rate has to be lesser, maybe 1000, 1500, and vacuum has to be more. But as if it is a normal capsule, it has to be a high cut rate, because that gives a very good rim of without much serrations.
Just want you to know that in the secondary IOL group, you must be having a considerable number of cases. So over those children who attain adulthood, what has been your share of refractive surprises, and how many cases you've used additional procedures?
But I have not done additional procedures, but unilateral, if it is a unilateral cataract, myopic shift is much faster, and my cases have come to -10, 12 also after 10 to 12 years of age. If it is a bilateral cataract, generally the myopic shift is less. And why we don't do a secondary procedure, see, is the more you operate on these eyes, the chances of complications, and in children fibrosis is much more. And if the IOL no. We leave a hyperopic. We leave it +1, +2 generally. Yeah, yes. But you see, if you leave a higher hyperopia, suppose, and if the child is not using spectacles, then you are inducing amblyopia. So it is better to deal with a myopic shift later than inducing amblyopia in the first phase.
Sir, what is the lowest stage of implantation of IOL in the bag in pediatric cases?
I've done post ROP needle touch 3 months.
3 months.
And that
in
child
unilateral,
is
we are little bit aggressive. In
that child is having 6/9 vision now. Now almost 10 years. 2-3 cases I've done at 3 months, but one I remember because that case earned me a grand prize at APCRS. And that child now 10 years later is still having 6/9.
In SFIL also, sir, I have done many cases in 3-4 years. Although scleral rigidity is less, but if we use sharper instruments and we are a little bit careful in dissection, I haven't seen any complications so far.
What suture do you use?
No suture, sutureless.
Oh, achha, you do the
sutureless. Suture I am not doing.
Yeah.
I am using sutureless, so it's a bit easier to do, even if scleral rigidity is less. And I have done, I think, more than 40-50 cases at 3-4 years ages of Marfan's or traumatic subluxation and all, and they are doing good. But yes, we have to be very careful while dissecting, because the sclera is so that rigidity is so less that even with little bit of pressure, the flaps can cut out and we may get complications.
Just one input, sir, regarding, sir, very important point that you brought up, that if you are doing an anterior, like if an anterior segment is doing
limbal root,
lensectomy, so it's very important to not allow the cortical matter or the knee fragments to fall into because it will lead to a second procedure itself. So how to avoid that? Just emphasizing, sir was doing it perfectly, but just to make the picture more clear, you enter the capsule and you try to do everything removed inside the capsule. So try to remove it maximum inside the capsule, because you make a small puncture, put your vitrectomy probe inside the capsule, and then you try to remove it. And then after you maximum removal of the nuclear matter and then you go for the removal of the capsule, and that will ensure the minimum fall of any inadvertent fall of cortex into the posterior matter. Anyway, the GLC is very well formed, and it gives you the liver.
And cutting on the top of the lens rather than cutting from behind.
That is it. And regarding the SFI, just will require one input from you. That I have found almost in my experience, I have also done a lot of pediatric SFIs, but then 30 to 40% of case I find pigment deposition over a time, like some amount of pigment deposition over the SFIs.
Yes, even so that I have also seen that
so
pigment.
So how to, do we think that this gives, does this gives a flip side that you should go for preservation of the capsule, because the long-term quality of the vision, that those deposition can affect sometimes.
If capsule is preserved, that is the best. There is no that substitute to natural capsule of the patient. But if we don't have capsule, I think rather than leaving aphakic, we should try 3 years and above. We can try at least sutureless SFIL in such cases.
Love, that was excellent video, all cases. Just wanted to know about your opinion of using this low dose myopin, low concentration atropine drops in patients whom you think that there is myopic shift. Say that you have operated patient and after 3-4 years of age you see that the patient has started having shift in
we should use, though there are no studies about it, but the pathway in which it works, it should work for a sort of phakic myopic shift also.
Because I have started using that.
Yes, we should use. Regarding bag preservation, 10-12 years later, it doesn't give a very good picture. Now I am seeing, though all of them are maintaining good vision, but some of them I am surprised why they are maintaining, because slowly it starts contracting and coming towards the center.
And I have seen lots of cases that CTR, CTS placed subluxated lens and vision was recorded 600, and after 3-4 years down the line, the whole CTR, CTS lens drops into the vitreous cavity, and GRT developed, and then we have to manage by doing vitrectomy, explanting everything. So these kind of challenges are there. Anyway, these are not simple and straightforward cases. So we do expect such kind of complications, but there are various methods to tackle.
Thank you so much, sir, and we are very thankful to all the speakers and chairpersons. Now we call upon, please wait for 1 minute. We would like to call upon senior ophthalmologist Dr. Arvind Jaiswal, sir, our chief, and Dr. J.J. Agarwal, sir, president of Bihar Ophthalmological, former president of Bihar Ophthalmological Society, to felicitate Dr. Love Kochgave, sir, who would be leaving soon. We are also very thankful for to Dr. J.J. Agarwal sir. Despite having a health issue, he managed to come and bless us at this occasion. May we have a standing ovation for sir. And we request Chief and Arvind Jaiswal sir to kindly felicitate Dr. J.J. Agarwal sir, who would also be leaving soon. All the speakers kindly come forward to receive their mementos, and in the meantime we will have the quiz. Speakers please. Dr. Pragya, Dr. Bhadra, Gyan Bhaskar sir, Dr. Soni Sinha ma'am, SP Tiwari sir, kindly wait. Dr. Bhadra, are you here? Dr. Amit Kumar sir. Dr. Kunal Kishore sir. Dr. Kunal Kishore sir. SPT sir. Dr. Anita Ambasht ma'am. Dr. Tiwari sir.
Pratik, yourself for moderating.
And Dr. Pratik for moderating the session. नहीं कोई नहीं डिस्पर्स होगा कोई डिस्पर्स नहीं होगा खड़ा रहो यहीं से करो अरे नहीं जल्दी जल्दी स्टार्ट करा क्विज रेडी भाई हां क्विज है सब रेडी है चलो चलो चलो
starting with the quiz okay
एंजाइटी मत हम कर देते हैं एंजाइटी
just followed by prize हम लोग
हाँ
lucrative prizes
नहीं अभी
We will have a very short quiz with prizes, with exciting prizes, so kindly participate. It is open to everyone. Dr. Isha, please take over.
thank you sir
Slides please.
Okay, starting with the quiz. The first question is, identify the syndrome which is a triad of the following: unilateral high myopia, amblyopia, myelinated nerve fibers. Yes, please.
Correct.
That is correct. No. The promised gift. Strassler syndrome.
Next question.
Question number 2. Who is this personality that was credited for the introduction of occlusion therapy for amblyopia in children? Option A, David Hubel. B, Hermann von Helmholtz. Johann Jawal. Johann Friedrich Diefenbach. Please. Hubel is not the right answer, please. Option D. Option D is the right answer.
No one gets this prize.
No, she guessed it. नहीं वो ह्यूबल उधर से आया था. उसने बोला है. सुरभि ने बोला है.
चलो सुरभि तिवारी gets the prize.
Question number 3. What type of deviation is greater when fixing with the paretic eye? Primary deviation, secondary deviation, concomitant. Please raise your hands.
You're not allowed, sir.
The prize would go to
Vishal Kishore sir is included. Correct.
That would be all. Thank you.
We move on to the next session.
So after this Power Packed quiz, we are moving on to the next session, which is the Retina Pearls. May I call upon chairpersons Dr. Arvind Jaiswal sir, Dr. Salab Sinha sir.
Meanwhile, Chief sir,
Dr. Deepak Agarwal
Chief
sir,
Dr. Subhash Prasad sir, kindly hand over the memento to Dr. Isha.
and Dr. Abhishek Kedia sir. For the panelists, I call upon Dr. Vivek sir, Dr. Satyaprakash Tiwari sir, Dr. Abhishek sir, please be seated in the panelist. Dr. Bhulesh sir, Dr. Bhulesh, can I request Dr. Lalit Agrawal sir and Amitabh sir to join the panelist, to join the panel. Dr. Santosh, please join the chairperson. Yes. So to start with, we start with the talk of Dr. Amitabh sir on pediatric uveitis treatment algorithm simplified. So Dr. Amitabh sir hails from Bihar and he has completed his MBBS from NMCH and is currently working as senior consultant in the Department of Uvea in the Shankara Netralaya, Kolkata, and he has to his credit various papers in national and international journals and has delivered various talks in national as well as international conferences. Over to you, sir.
Good morning, and thank you so much for this invite. It's always a pleasure to come to my hometown. I have no financial disclosures in my talk. So uveitis remains an enigma and pediatric uveitis is a bigger challenge. And why do I say that? Because it has an asymptomatic onset, a late detection, persistent chronic inflammation, difficulties in diagnosis, the hesitancy to start children on potentially toxic medications, and amblyopia. So overall, the visual outcome in children is less favorable as compared to adults. So whenever a child walks into your office after a complete examination, you would want to come to a working clinical diagnosis and then try and figure out whether it's an infectious etiology or a non-infectious etiology, because the treatments would vary. Non-infectious, you would bank mainly on steroids, immunosuppressives, and biologics. And for infectious etiologies, specific anti-infectives and anti-inflammatory. So there are a whole gamut of uveitic entities that can affect children. And the common immune-mediated ones are JIA-associated uveitis, intermediate uveitis, the infectious ones being toxoplasmosis tuberculosis, toxocariasis, and not to forget the masquerades. We did a study at our center on 389 pediatric uveitis patients at Kolkata, and we found the non-infectious etiologies to be more common than infectious. And amongst the non-infectious etiologies, the commonest systemic association was juvenile idiopathic arthritis. Toxoplasmosis was the commonest infection, followed by tuberculosis. What would be the goals of our treatment? Number one, to control the active disease as early as possible and try to achieve a remission, minimizing complications from the disease to treat the side effects and visual rehabilitation. We know that JIA-associated uveitis is a pretty common cause of uveitis, and pauci-articular type is the most common. And if uveitis precedes arthritis, it has got a very aggressive course. So how would we treat them? Of course, topical steroids in the form of prednisolone acetate 1% eye drops, along with cycloplegic mydriatics in the form of homotropin or atropin. It's best to avoid cyclopentalate because this itself is uvitogenic. Parenteral steroids, either intravenous or oral, and systemic immunosuppressive therapy with methotrexate and anti-TNF alpha. And what is the evidence that we have for treatment with childhood chronic uveitis? So this study suggested that almost 3/4 of the patients on methotrexate had an improvement in the intraocular inflammation. The caveat being there has to be a longer period of inactivity before we withdraw the medication because the chances of relapses after withdrawal are high. This study suggests the use of methotrexate and anti-TNF in the treatment of onset of to prevent the onset of uveitis in juvenile idiopathic arthritis. The Sycamore trial also suggested the use of adalimumab for along with methotrexate for childhood uveitis, which was pretty well tolerated. Amongst adalimumab and infliximab, adalimumab fared better as compared to infliximab. And when the disease is recalcitrant and non-responsive to all the other treatments, rituximab is a kind of a rescue therapy and intravenous daclizumab, but these are very toxic medications and you would need to follow these patients very closely for their side effects. A very common complication is band-shaped keratopathy, which can very well be taken care of with EDTA chelation. Cataract is another very common complication, and the choices which we have are lensectomy, vitrectomy, vis-a-vis phacoemulsification with intraocular lens implantation in the back. The evidence which we have for cataract surgery is before you put the patient under the knife, the uveitis should be absolutely under control, as well as the systemic disease, and then we can use a foldable intraocular lens, which should only be a single or a 3-piece acrylic hydrophobic intraocular lens along with posterior capsulorhexis and anterior vitrectomy. So with adequate immunosuppression, a very meticulous choice of surgery, though the secondary procedures could be more, but then there's still a gain in the visual acuity with intraocular lens implantation in children. And this is our experience of phaco-IOL and JIA, and the keys to success are age of the child, absence of amblyopia, and needless to say, a very strict preoperative and postoperative control of inflammation. Intermediate uveitis is not all that uncommon in children. It's pretty severe. It mimics JIA. You may have a pars planitis where there is no etiology or may be associated with tuberculosis sarcoidosis. And again, you would bank on steroids, immunosuppressives, and biologics. Dexamethasone implant has been tried in pediatric patients, which does control the inflammation, but a red flag is a rise in the intraocular pressure, which needs to be monitored very closely. Pars plana vitrectomy is one of the treatment modalities which is effective and safe in chronic uveitis, and this would reduce the dependence on systemic medications. So this was a 13-year-old girl who presented to me with complaints of decreased vision in both the eyes. She had a history of an open globe injury and a corneal tear suturing done in the left eye a month back. And she came back with a cellularity in the interior and the vitreous chambers, disc hyperemia, edema, exudate retinal detachment, multiple pockets of SRF, which we can see on the OCT. So this was a sympathetic ophthalmia, and this was she was treated with intravenous methylprednisolone, oral steroids, and azathioprine, and topical steroids, of course, to take care of the anterior segment inflammation. And this is the resolution of the subretinal fluid which you see post-IVMP. This was a 14-year-old boy with a vision of 660 and 36 in the right eye and 624 and 18 in the left eye. A VKH where you can see the disc involvement, multiple pockets of SRF, and the OCT showing multiple SRF pockets with fibrin septae. He was treated with intravenous methylprednisolone, oral steroids, and azathioprine. He's still on azathioprine. His vision has improved to 6, 9, and 8, and this is almost 9 months post his presentation to us. You may not be lucky all the time, and this patient kept having recurrences despite steroid and immunosuppressive therapy, so we had to resort to a triple agent immunosuppression and top him up with cyclosporin. Though we could not prevent the disease into going into a stage of sunset glow, but at least the vision was maintained and the inflammation could be brought under control. So again, VKH, we have to rely on steroids along with immunosuppressives and probably biologics. So VKH and SO, these are two conditions where you would start immunosuppressives not as a steroid sparing agent, but as a steroid equivalent. So you start them at the same time along with the steroids. When it is recalcitrant, again, infliximab is a good option. If we see the infective spectrum, toxoplasmosis, a pretty common condition with an active lesion next to a heel lesion or an active retinitis with chirales, arteriolitis, and it has to be treated with trimethoprim, sulfamethoxazole, clindamycin, and 3 days later with low-dose oral steroids. This was a 15-year-old girl who had choroidal tubercles in both the eyes. She had tested positive for a TST and IGRA, so she was treated with oral steroids and a full 9-month course of antitubercular treatment, and this is how the lesions resolved. Toxocariasis is not all that uncommon, and the most common presentation is a significant vitritis, which can be taken care of with systemic steroids. You may have a disc drag or a macular drag and a granuloma sitting in the periphery, and many a times you have to resort to a VR surgery. So a word of caution, any uveitis at the extremes of age should ring an alarm bell, and you must rule out a masquerade. So to wrap up, if there's an anterior segment inflammation, of course you would need to put the patients on topical steroids, and once the acute condition ebbs away, probably you can use non-steroidal anti-inflammatory. Parenteral steroids will have to be used, but the dictum is to try and wean them off as early as possible, and that is another indication of an early institution of immunosuppressives and biologics in an adequate dose for an adequate period of time. We need to tackle the complications very deftly. The surgery is indicated only when the uveitis is very well controlled, along with the steroid and immunosuppressive cover. Amblyopia therapy with glasses or occlusion. And treatment of childhood uveitis is a team effort, and you will have to liaison with your pediatrician, a rheumatologist, and an immunologist. And I thank you for a patient hearing.
Sir, do you think switching IMT non-biologic IMTs, it is better to use non-biologic along with biologic combinations in those cases where we don't see optimum response with non-biologic single agent?
Yeah, so the basic way you approach a patient is you take care of the acute crisis with steroids. And we would want steroids not to go on for a very long time in children. So we would start either antimetabolites. Though cyclosporin is a pretty toxic medication, but I have had the opportunity to use cyclosporin in children. Methotrexate is the best immunosuppressive, which is tolerated very well by children. And I think the threshold for use of adalimumab has gone down. So the next step would be probably adalimumab. But for childhood uveitis, you may have to use antimetabolites along with adalimumab. Also, in our part of the world, since cost is a factor and insurance is a factor, so many patients cannot afford adalimumab. So what you would do is probably stop them on adalimumab and tweak the dose of the antimetabolites to take control of the inflammation.
So you prefer to use a combination of non-biologics over combination of biologics?
No, so if the disease is under control with the non-biologics like antimetabolites, probably you may not need to step up your treatment to go to the biologics. But if it is not controlled, then I think biologics is the next option. And now, off late, we have also been using a lot of JAK kinase inhibitors. So Janus kinase inhibitors is like, and the commonest ones being used is tofacitinib.
Have you ever seen any theoretical neoplastic risk factors in your
No.
practical
So there have been lots of studies, especially from US, where they have found that with the antimetabolites or any immunosuppressives, in a trade-off between the risk for cancer and control of the inflammation, I think you would always err on the side of treating the patients, and the overall incidence of cancer from these immunosuppressive therapy is very, very low.
So you have not?
No, we haven't. And in fact, worldwide data suggests that there's no increase in the frequency of cancer with the use of antimetabolites.
Seen TINU, tubulointerstitial nephritis-induced uveitis before?
Yes, so I think out of the 390 patients we studied the pediatric uveitis, I think I just had around 2 patients who had a microglobulinemia, and beta 2 microglobulin, which was present. But I don't think TNO is all that common in our part of the world.
And Blau syndrome?
Yeah, Blau is pretty common because it's a kind of a pediatric sarcoid. So Blau is pretty common in the pediatric age group.
Blau is in your series of cases also?
Yes.
Okay. Thank you.
Usually, this BSK, which we chelate with EDTA, they recur after 5-6 months. Then
Yes.
what we should do, sir? In
Well, I think for if you have a BSK which is obstructing the visual axis, I think the only option will be to do a EDTA chelation, nothing else that you can do about it. The only word of caution is if you are planning to do a cataract surgery, I think it is best to do it in 2 steps. So don't do a chelation and cataract surgery at the same time, because you may have perioperative problem with visualization, and also post-operative use of topical steroids. That might be a problem if you have a corneal epithelial discontinuity. So I think it's always good. You may have to induce the patient twice under anesthesia, but I think it's always a good option to do BSK first and wait for some time, let the give the cornea some time to heal, and then go ahead with the secondary procedure.
Thank you, sir.
Thank you.
Thank you, sir, for the insight on pediatric uveitis. Next, we move on to the talk by Dr. Neha Goyal, ma'am, on inherited retinal disorders, ERG, electrophysiology as a guide. Neha ma'am has worked as vitreoretina and uvea consultant and was in charge of electrophysiology services at Eye Care Hospital and Postgraduate Institute for 7 years. Currently, she is working as assistant professor at Army College of Medical Sciences, New Delhi, and senior consultant in the vitreoretina and uvea at the Synergy Eye Care, New Delhi. Over to you, ma'am. She would be on Zoom. Ma'am, can you hear us, ma'am? Ma'am, I think. Unmute. Ma'am, please unmute yourself, ma'am. Ma'am, can we? Ma'am, am I audible to you, ma'am? She is not audible. वो unmuted ही है वैसे. Ma'am, your slides are visible, but there is no audio.
I'm unmuted actually.
But can you move the slide? Slide भी तो move नहीं कर रहा. Slide लगाओ. Slide up. Ma'am, we are putting the phone on the mic. Okay. There's a problem in audio at our end. ऑडियो पर लगा रहा हूं मैं.
अच्छा ठीक है. So I'll keep the phone on.
Yes, ma'am.
Okay.
So your slides are visible.
Yeah. Shall I start?
Yes, ma'am.
Yes, ma'am. Okay. So good morning, everyone, and big Congratulations to RIO on achieving this landmark, and a big thank you to the organizing committee, especially Dr. Abhishek, for including me in this excellent program. I'll be talking about inherited retinal disorders and electrophysiology as a guide. So as we know, IRDs, as they are commonly called, are a diverse group of disorders with retinal degeneration. And this is caused by pathogenic variation in proteins critical to retinal structure and function, resulting in vision impairment. So because of overlapping clinical presentations and variable inheritance, this group of disorders presents a diagnostic challenge.
While genotyping through sophisticated tests such as NGS are available, but these are limited by their cost and also the patient willingness in some cases. So advances in imaging like fundus autofluorescence and OCT have allowed for accurate phenotypic characterization, but electrophysiology remains a valuable tool as it identifies the site of damage and the cell type involved. So there is basically a vertical pathway of neural information flow in the vision pathway, and electrophysiology isolates each of the cells which are responsible for this. For instance, the RPE can be tested by the EOG, the photoreceptors up to the amacrine cells by the full field ERG, the ganglion cells by the pattern ERG, and then further the connections to the visual cortex by the VEP. So the origin of these signals can be altered by altering the visual stimulation characteristics, the electrode placement, and the state of visual adaptation, whether it is light adapted or dark adapted. So this is, it's a busy slide, but it summarizes all the tests, what should be the state of adaptation, where the electrodes are placed, and what the stimulus is. So as we know, we have to follow the ICEF standards for all these 5 major tests, which includes the state of adaptation, the stimulus, and the potential recording. And whenever any institute or any facility gets a new machine, it is encouraged that they should produce their own age and sex matched normative data. So this is something to remember. So with the help of few cases, I'm going to discuss electrophysiology in IRDs, which tests to order, how to interpret them, and most importantly, what are the caveats. So this is the first case, a young male presented with decreased vision. The fundus looks almost normal. There are few subfoveal photoreceptor defects. So a full field ERG was done to study the state of the rods and cones. As you can see, the scotopic or the dark adapted responses are normal, whereas the photopic responses or the primarily cone driven responses are flat. So this was a case of achromatopsia or rod monochromatism, and retrospectively checking the color vision, the child was only able to read the demo plate. Now this disorder is inherited in an autosomal recessive manner. And if you look back at the fundus photo, you can see the child was also photophobic because of the flash of the camera. So a similar patient who also had high myopia, decreased vision, and defective color vision, again full field ERG.
Was done, and here you can see that there's a small B wave coming. I think the voice is echoing. So there is a B wave coming on the blue flash ERG. So this is a case of blue cone monochromatism, which is on the other hand X-linked recessive. So cone dystrophy, as we know, can present clinically with decreased vision, abnormal color vision, and in some cases nystagmus along with photophobia. The stationary variety presents earlier. The rods here are normal, whereas the progressive variety, which we commonly associate with the bullseye maculopathy, sets in later, and it also progresses to involve the rods. So although rare, we have reported the Mizuo-Nakamura phenomena in the case of cone rod dystrophy. Here you can see the typical bullseye maculopathy and the golden metallic sheen of the fundus. And after prolonged dark adaptation, we can see some recovery in the scotopic function. So, if I were to summarize, one major use of ERG is in isolating the rods and cones and identifying which of the photoreceptors are involved earlier or are involved primarily. So, we've looked at the cone dystrophies. Next, we go to the rods, and the commonest disorder here we encounter is retinitis pigmentosa. Now, in a typical case or an advanced case of RP, we feel that full field ERG has a limited role. The diagnosis is quite obvious clinically, and all you will get on a full field ERG are these extinguished responses, rods as well as the cones. But then ERG, especially multifocal ERG, can be used to assess the residual central cone function. The 30 Hz flicker can also be used to prognosticate for how long the patient can retain useful vision or what can be the rate of deterioration. Similarly, ERG is valuable in patients who have atypical findings or in early cases who present with nyctalopia without the typical fundus changes.
In children especially, a common question is of parents, before you do genetic testing or along with it, is the child going to develop RP? So if the ERG is normal more than 6 years of age, then the likelihood is much less. And full field ERG can also identify the carriers of X-linked RP on the 30 Hz flicker ERG. Now, just another 2 cases of night blindness I'll show you. This was a young male who had normal vision, normal fundus, and decreased vision only at night. Now, if you look at the full field ERG, the combined rod cone response shows what we call a negative ERG. The B/A ratio is reversed here, and the remaining responses are within normal limits. So, this is a case of CSNB or congenital stationary night blindness. It's important to identify because it is non-progressive, the prognosis is good, and all the patient needs is some lifestyle modification. CSNB with abnormal fundus are easy to recognize by the Musuo-Nakamura or this flex, the fundus albipunctatus. But for the normal fundus, we need the full field ERG. So continuing with night blindness, though this was an older patient with night blindness, normal fundus, here again you see the negative ERG, but then when you do the pattern ERG, you see the responses are depressed over here as well, and so are they in the multifocal ERG. So this, and if you see the cones are also depressed. So this points to an acquired cause rather than CSNB, in this case a vitamin A deficiency. Though this was an older patient and had liver cirrhosis, but this is very common in children as well, and it can be identified by electrophysiology. You don't need to go in for genetic testing. This is easily reversible by vitamin A therapy. So negative ERG can be seen in many conditions. Among the inherited ones, the commonest are CSNB and X-linked retinoschisis, and others are all acquired like venous occlusions and toxic retinopathies. So this is again coming back to the summary of ERG. We've looked at the photoreceptor dysfunction, the negative ERG. Now sometimes we get extinguished ERGs in children, and these can be easily differentiated based on clinical examination. So there are only a handful of conditions which lead to extinguished ERG, and they will all have different striking fundus features, so there will be no confusion in this. Among the pathognomonic ERG, it is the Goldman-Favre syndrome, which now we know is the NR2E3 gene mutation and so called, and this leads to progressive night blindness along with cataract. On OCT, you will see macular schisis. Sometimes these cases can be confused with RP or with X-linked retinoschisis. Now, ERG remains the key diagnostic test, even if you don't do the S-cone ERG separately, which are enhanced. On full field ERG, you can see absent rod responses, and you will get similar waveforms in the rod cone response as well as the single light flash ERG. So there that clinches the diagnosis. Now coming to the caveats, remember that though ERG, full field ERG is the only test that will isolate and test the rod separately, at least 1/3 of the retina needs to be affected before you can see a change in the full field ERG. So if there is an isolated macular lesion or a macular dystrophy, the full field ERG will be normal. Hence, in all cases, a pattern ERG and or a multifocal ERG should be done as well. So this is a device which is available for use in children. This is a handheld ERG. It is quite quick, doesn't need mydriasis. Of course, it is not in accordance with the ICEF protocols, but it comes with skin electrodes and it can be used as a screening device in children. Now, next, coming on to the macular dystrophies, this is quite a clear-cut case. You see this scrambled appearance at the macula and you see a vitelliform lesion. The patient complained of metamorphopsia, relatively good vision in both eyes. So the full field ERG in this case was normal. Based on the clinical picture, we would also advise a EOG. And here we see that the Arden ratio is decreased in both eyes. This was a case of best vitelliform dystrophy. So please remember that EOG will always be abnormal whenever the ERG is abnormal. The classic use is in the diagnosis of best macular dystrophy, where there will be a reduced or absent EOG rise accompanied by a normal ERG. Hence, these two tests should always be ordered together, even if you suspect a best dystrophy. So another case, this was a young male complained of metamorphopsia and was diagnosed as X-linked retinoschisis based on this OCT which showed chytic cavities. But if you also see, there are also vitelliform lesions and these which would be hyper autofluorescent. And here let's see what the electrophysiology says. So the ERG is again normal and the EOG is abnormal. So this rules out X-linked retinoschisis, and this is in fact a case of autosomal recessive bestrophinopathy. Now, this is important to recognize because almost 50%, half of these patients go on to develop angle closure glaucoma, and a prophylactic PI is recommended in these cases. And some of them may be associated with, for instance, we've reported this case of focal choroidal excavation in ARB. Now, coming to other macular dystrophies, here you can see the beaten metal appearance and macular scarring, disorganization of the retinal layers. So here again, the full field ERG is normal. This does not has shown that in and just the
anatomically non-specific, which means even if there is a macular problem, something simple like a CNVM or a macular hole, that can also lead to a VEP delay. Also, it's important to remember when you're ruling out malingering or cortical disease that flash and pattern VEP, the two channel, they only detect pre-chiasmal disease. For post-chiasmal disease, you need a multi-channel VEP. Wherever possible, it's better to do a pattern VP unless it's a child or uncooperative patient. Now, this is the last case. This was a young male who was referred only for the VP test to me. And he had history of high fever and he was being followed up as a post-viral optic atrophy. So, vision was decreased in both eyes, fundus appeared normal, and you can see that the VP, the waveform was ill-formed in both the eyes and there were P100 delays as well. However, when I clinically examined the patient, I suspected that there could be schisis. So I did a ERG and you can see here there is a negative ERG. So this actually makes the diagnosis X-linked retinoschisis, and the OCT did show the chytic cavities as well. So to conclude, electrophysiological assessment remains a specialized part of ophthalmic practice, and despite advances in imaging, electrophysiology does provide unique information which is functional and objective, and this can lead to a definitive diagnosis in certain cases. So electrophysiology is invaluable in not just diagnosing but also monitoring inherited retinal diseases, and clinical trials of new drugs or even gene therapy use electrophysiology to ensure the absence of toxicity and to see the improvement. So thank you for your patient hearing, and once again I thank everyone for including me in this program.
Thank you, ma'am.
Thank you, ma'am, for the wonderful talk on ARG. Ma'am, when a patient
So we have lost the Zoom connection. So for the next session, for the next talk, I would like to invite Dr. Subhadra Jalali ma'am for a talk on how to evaluate nyctalopia in clinic. So ma'am needs no introduction. She's always full of energy and radiates so much of energy. She is the Network Director Quality at LVPI, and she is best known for her work in area of ROP. And she's also the director of the Newborn Eye Health Alliance, NEHA, at LVPI, that provides neonatal care. And she's also on the National Task Force on ROP, Government of India, and she's an expert advisor on ROP to the Government of Bangladesh and Philippines. Over to you, ma'am.
Thank you, and good morning, aap sabko mera namaskar. So I think this is the talk which just follows ERG, that many times ERG is not available. और आप अपने क्लिनिक में बैठे हैं और वहाँ पे कोई पेशेंट आता है जो बोलता है कि मुझे रात को नहीं दिखता है या कम दिखता है. So how should a general ophthalmologist try to understand what the patient has? They may or may not be able to refer the patient for more sophisticated tests, but at least a basic understanding of how to look at the patient just by the fundus photo history, few tests, so that you can come to some idea that what this patient has. And I am thankful to Dr. Deepika, who is now at Narayan Netralaya and Sarang, for helping me with this study. I am a paid person from Optos for some of the lectures. Otherwise, I don't have any financial disclosure. So the purpose of my talk is to help the eye specialist diagnose possible etiology in a patient with nyctalopia who may have some pigmentary retinopathy, just using the history and fundus examination, because I think these two tests are available to everybody. History is lacking more than the fundus photos. So I'll just be going through an atlas of 20 cases which we have collected. All of them were bilateral cases, and rarely they were unilateral or asymmetric. So I think very important, the way we go about in the clinic before we order tests is the careful history, laterality, attention to all the retinal findings, taking a fundus photograph and then looking at that photograph and reporting it, and then counseling the patient what can be done further. Confirmation, of course, might need some other investigations, but this is what we can understand clinically. So I think this is something very common. If we see bony pigment spicules, we might think this is RP. But one important finding which we should always look for in a generalized retinal dystrophy like RP is the arterial narrowing. So pigments may or may not be present, disc pallor may or may not be present, pupillary reactions may be almost similar in two eyes, but it's the arterial narrowing. And how to look for arterial narrowing is move your light across the retina and try, or even on the fundus photograph, try to look for two vessels. So always the arteries and veins are paired, but here you will find that there is only one vessel which looks like an artery, but actually it's the vein which has become narrow and the artery is absent or very attenuated. So always look for paired vessels. If you see only one vessel and no other pair, then that is how we detect that this is arterial narrowing. So there can be macula involved, or macula may not be involved, and mostly there will be some peripheral flex, and there could be a macular involvement. So Western literature says there is no macular involvement till very late, and we had really difficulty in publishing some of our data from India saying that there is a foveal atrophy in very early RP. But I think it's because they see mostly autosomal dominant and we see autosomal recessive, and there could be differences in diet and light. So here's a collage of various types of fundus appearances, and they're all RP. They're all rod cone dystrophies with proven genetically. So you can see that the RP is not one fundus photo. It can be variable, and if you see the last one, that almost somebody might think that this is a macular dystrophy, but again look at the vessels. There are no two vessels, there's only one vessel. So then you know that there is an arterial narrowing, which is a hallmark of all RP. Then congenital stationary night blindness. So this is a good diagnosis for the patient that they will not progress. So here, they will have either some flecks in the retina or it can be completely normal. And the more important thing is that you will see the two vessels and you will see the thickness of the retina, the succulent fleshy retina and not the atrophic thin retina, and all the vessels will be normal. And then of course you can have some changes like the mesophenomenon in some of them, but you won't see any atrophy or pigments in these cases. Sometimes in children we are not sure, but you can do confrontation fields. So fields is something which is almost normal in all the CSNB patients. Now Leber's congenital hemorrhages, again the Leber's congenital hemorrhages can range, fundus can range from normal to very severely abnormal. Sometimes they can have macular lesions which can look like toxo, and have seen publication in IGO of saying this is toxo in LCNO. These are colobomas of the macula which are common in LCA patients. But the history is that the patient has been detected to have loss of vision by 6 months of age. That's very important as a diagnostic criteria. So actually they have since birth, but since parents don't understand, but usually by 6 months they know that child was not seeing and has nystagmus. Now nystagmus is not a feature of RP or of most of the CSNB. Of course incomplete CSNB can have nystagmus. So if you have nystagmus, then you can look for LCA, and of course ocular albinism or incomplete CSNB, achromatopsia. So if you have nystagmus, then you can see whether it is they have problem in bright light or they have problem in dim light. If it is dim light, then most of them will be LCA and sometimes they will be CSNB. So sometimes you can have a patient who has absolutely no symptoms, but the retina looks awful because of lot of dots, but you can see the vessels are normal, disc is normal, there are no vitreous cells or anything, and there is no nyctalopia, and these are just benign flecks and nothing more needs to be done. They don't need to be referred anywhere. If you are keen, you may do a field test just to confirm, but otherwise you don't even need to do an ERG or autofluorescence or OCT and anything. They are just incidental and they are normal. You can see that. Now enhanced Escon syndrome, this is a subset which we are just publishing all the data from India from various centers. There is something we should all recognize. Here the lesions are around the arcades. That is one very important clue. The other important clue is the vessels are totally normal. If you do OCT, you might feel some schisis in the center. But they have nyctalopia. It's very slowly progressive. Usually this is a good diagnosis as compared to RP. And here you will see you may have nummular pigments of bright color just around the arcade. And rest of the retina is normal and vessels and disc are normal. Whereas in the congenital X-linked retinoschisis, you can see some mesophenomenon in some patients, usually diagnosed in very early childhood. And of course, you can see the cartwheel appearance on your good 90D examination of the fovea. So this is, again, I'm showing a picture of enhanced Escon syndrome. They can have various, colors, various sizes of these lesions, and many of them will have schisis in the macula. Some of them may already have got atrophy, but this is so characteristic that you see it and you can diagnose enhanced Escon syndrome. Now vitamin D deficiency, again, this is something that we have to look for when an adult patient comes and says recent onset of night blindness, and they will usually have a normal retina, normal fundus, but in very late stage, if it has been for a long time, then they may develop some arterial narrowing, but they won't have pigmentary changes. So here your history is very important. Did you have bariatric surgery? Are you an alcoholic? Did you have some malabsorption syndrome? Is the patient looking malnourished, sick, or having jaundice? So that history will help you to know that this is a vitamin D deficiency. In children, of course, we can see white spots and post measles and others. Now we don't see that much of vitamin D deficiency, but still in malnourished communities you will still find children with vitamin D deficiency. Now ocular sidrosis is something that we should not miss out. Again, here the patient may come with night vision problem. It will be unilateral almost always, and it will look like RP. But the giveaway would be a good slit lamp examination, and you will see that sidrotic changes on the lens or on the corneal endothelium. And sometimes you may not find the front body, it may be in the angle. An X-ray, a simple X-ray will help you to come and make the diagnosis. And of course, the history may or may not be there. Now, this is something that we saw this patient from Uttar Pradesh, a very interesting young lady, 29 years old, came to us and was referred to me as RP because she had been seen by multiple people and seen that she has recent onset night blindness, and her fields were very bad. She just had a ring scotoma, as you can see here. But her ERG showed a negative ERG. Now in RP, almost you will see flat ERG. But also the late onset was a giveaway. So whenever there is a history like that, I asked her, do you have any swellings in the body? And she said that I'm getting married and I'm going to gym, and because of that I got a big swelling in my axilla. And when I touched it, it was a large secondary, and then at her finger we found this melanoma. So this is actually a melanoma associated retinopathy. Now we may miss this because, but you can see the fundus except for arterial narrowing has no other sign of RP. So some of the clues could be there, but a thorough history and how it started and what they noticed would help. Now you can have various types of uveitis which can present with nyctalopia, and here you will look for signs of uveitis in the eye. Now sometimes the lasered ROP can also present. I'll just stop because I think dignitaries here, welcome, all of you. Welcome, sir. So sometimes we've had patients who are coming from the orphanages or abandoned children, and then they come with, nyctalopia, and we see that actually they had lasered ROP and they may not have that history, and somebody diagnoses them as RP or as choroiditis. So that's another history that we may not have. Now, various types of retinal exudative RDs can, present as pigmentary changes, and again they may look like RP, but the history may help. And rubella retinopathy, again here you can see the vessels are normal. So if you have normal vessels, then you will think of things like, early vitamin D deficiency or CSNB, or maybe it's Stargardt's, or maybe it's a non-RP like condition. High myopia itself can present as night blindness, as can nuclear cataract in high myopes. So I want to conclude by saying that a careful history of the onset, course, gender, what is the difficulty you face, what are the visual tasks you are having difficulty in, laterality, antecedent events of the onset of night blindness, and attention to details on comprehensive examination including slit lamp and detailed fundus photography itself can give you a lot of clues of where you are heading for. So inherited, nutritional, inflammatory, trauma, malignancy, parasites, iatrogenic, and miscellaneous like CSCR can all present as nyctalopia. And in your clinic, I think you can make a good diagnosis where we are heading for. Thank you.
Thank you, ma'am, for simplifying nyctalopia in such an interesting way. We welcome our guest of honor, Dr. Rajvardhan Azad sir and Lalit Verma sir and Radhika ma'am. So, any question from the panel? So, ma'am, how frequent do you see night blindness and lasered ROPs?
Complain of nyctalopia?
Yes, the older children, if I hope that in future we won't see, because now we are not doing so much of laser for zone 1, but yes, many children who've had extensive laser, whether it is diabetic patient or ROP patient, we know that they will have some difficulty in dim light. Yeah, they are complaining when they have to drive or when they are older. But if we don't tell them, then it's not all that common. But yeah, once they get to know, then they are very disturbed. This happens in diabetics also.
Yeah, thank you very much, ma'am, for such a nice review of this night blindness. How we should approach to CME in RP patients?
So the CME in retinal dystrophies, I will say, not only in RP patients, is a degenerative condition. It's not inflammatory. So most of the times the anti-inflammatory may not work. It's been shown that initially people used to use Dimox to dehydrate that cavity and it used to work, but now of course topical droselamide is my preferred treatment 2 or 3 times a day. I usually give it at least for 4-5 years and follow them. We have patients where at least 2-line improvement has occurred in some patients, in some it has not, in some it has shown a deterioration which may be in the natural course of the disease. But I think in patients with foveal schisis, enhanced Escon syndrome, RP with CME, which is usually autosomal dominant, we can give a trial of topical rosulamide.
So we move ahead with the next talk on basics of pediatric retinal surgery by our own very dynamic Dr. Abhishek Anand sir, who is Associate Professor at RIO IJMS.
Thank you, Shivani. So my talk would be basically trying to emphasize how we transit from regular adult surgeries to pediatric surgeries, and in this case, pediatric retinal surgeries. So my slides are not moving. And we have the doyens of pediatric retina surgery with us, Dr. Subhadra Jalali ma'am and Dr. Rajvardhan Ajad sir. So thank you, sir. And pediatric eyes are not small eye adult eyes. Same, but different. They have narrow palpebral procedure. They have smaller orbit. So I wait for. The surgical anatomy of pediatric eyes is different. They have narrow palpebral feature, they have a small orbit, and we have a relatively large lens. So lens to globe ratio is higher. Lens is also thicker and more spherical. And it is to be considered during lens sparing vitrectomy because you can't cross the midline without inadvertently touching the lens. The axial eye length is also less. So adult sized trocar cannula instrumentation can cause trauma if caution is not exercised. The sclera is thin. The risk of intraoperative cannula dislodgement, sutured, you go for sometimes for sutured infusion cannula. The null valve, because of the thin sclera, the valve effect is less, so requiring suture more frequently than adult. And suturing and dissection during sclera becomes very careful because we have very thin sclera, and heavy cryo to be avoided because it will come very fast. Extraocular muscles are very thin and fragile, so if we are going for buccal surgery, then while tying the and rotating the globe, it might cause avulsion. The past planar development has to be taken into consideration. It generally at 3 to 4 years of age, you can go at the adult. Otherwise, there is a normative database where we can plan for. Generally, in premature infants, instruments or injections should enter the pars plicator, not more than pars plana, not more than 0.5 to 1 mm posterior to the limbus. So now this is a stage 4A ROP in which we are planning for a buccal surgery, and look at very thin and fragile muscles. Also look at that we are planning, since we are wanting for we don't want to suture, so we have made a scale pocket, and we have to be very careful and while we are trying to achieve this, because we are accustomed to dissecting it for very thick sclera. Now another important is to look for the densely adherent cortical matter. So we are not just talking about ROP here, we are talking about the pediatric spectrum. So always stain, there is no harm if you double stain and look out for the hyaloid. Use DDMS, venous loop or island forceps to dissect the posterior cortical hyaloid whenever it is necessary. Don't be over aggressive or jealous. And we have to also look for the intraoperative pressure control during pediatric vitrectomy. Children have a lower systolic blood pressure, and they can predispose to iatrogenic CRO and avoid excessive explained depression or elevated intraocular pressure. Now this is a case of a BLEV ROP. Now look at the change in the perfusion of the central retina at 10 centimeter of bottle versus 40 centimeters. So once we lower the bottle, you see the whole of the BLEV is perfused. So it's so common that if we just suturise the bottle to a height of 40 centimeter, the whole of the retina will be blanched. So this might lead to to a CRO. Now another case is you will need to, because we are a retina surgeon, we are accustomed to the non-contact visualization system, and they keep to hang and they are very close to the eye. Now once you go for a GA, then there are pipes which are coming in and out of the baby, and they will inadvertently hinder your movement. So you have to look for that GA pipes before you talk to your anesthetist. What is your comfortable time? How do you talk? How do you want to approach the surgery? And this will give you a very good time during the surgery. If you don't plan it beforehand, then it might lead to hindrance of visualization. Now use of small lenses, there are non-contact lenses with smaller corneal diameter for a smaller diameter, but then you need to talk to your suppliers regarding this. consider using a high magnet. Now another thing that I find very useful is a high magnification lens, that is the green 60D lens in the ReSight system. So because of the focal point is further from the eye, making the lens bump less than to avoid, and this will help you to more dissection of the without inadvertent touch of the pipes that are coming in. Now another is the ocular pediatric Landau's vitrectomy set that is available. However, I am not accustomed to it. That is what I found in the literature. Sclerotomy is using a normal adult trocar can lead to increased risk of lens trauma and iatrogenic retinal breaks. So shorter 25 gauge vitrectomy packs are available. However, a very useful development was done by Babu et al., in which what they did was they placed a spacer by using a 240 band, and this is how we prepare a spacer so that the eventual length of the trocar in the cannula system is decreased. So we cut it, fashion it, and this leads to further. Now what I think is more important is that it gives a platform on which it rests on the sclera, and it leads to less movement of the trocar inside the eye, and this leads to decrease the iatrogenic trauma to the lens itself. Closure of the sclera and the conjunctiva may be done with an absorbable vicryl. For limbal or corneal wounds, you can go for a teno vicryl, which is extremely fine, and it will self-absorb itself, and then the need for further anesthesia is decreased. What we have also trying is the conjunctival closure with using using the fibrin glue, and what we have found that it gives a very good post-operative result, especially because if you try to form any type of suture-related irritation to the babies, so it avoids it, and it gives a very good result on the table itself. And we have a very successful outcome with this. Now, very important is the informed consent that you discuss with the parents. On many occasions, the finding of the examination and anesthesia can alter the surgical plan itself. So you have to, once you find that you are deviating from your surgical plan, stop, go and discuss with your parents. Many a times you would be the person who knows the best, so it's rather better to talk yourself rather than to depute any junior or a junior colleague to do that. Pre-operative visual prediction, avoid any visual prediction, which is the best. Extremely distorted retinas can have a pretty good visual outcome, and apparently good anatomic outcome can have pretty bad visual outcome. Aggressive refractive and amblyopia care should be pursued, and good post-operative visual rehabilitation in conjunction with a pediatric ophthalmologist should be a good. So it's not a single man, it's a complete team that works with it. You should have an access to imaging equipment, including ultrasonography, Bolosian angiography, OCT, and color fundus photography. Access to UVM can give vital information to peripheral pathology and past-planar relationship. Always examine both eyes, always. Many pediatric pathologies are bilateral in nature, and the clues can be hidden in the other apparently looking normal eye. Examine family members. It's a very good and effective way of taking genetic testing. This is a case of an apparently normal looking retina, and when we do an FFA, we do have access to the Claris Whitefield angiography, and we see a large area of avascularity, which we suspected beforehand on, and the patient is around 16 years of age, and we also see a neovascularization which is present. Very good, important is the examination and the anesthesia. A great supplement in pediatric clinical examination should include dilated anterior segment examination, fundus photography, and handheld OCT if available. Use should always be done in OT, where intervention can be carried out if parents give consent. If bilateral surgery is performed, each eye should be treated as if it were completely fresh surgery. Fresh cleaning, draping, instrumentation, and fluid to avoid cross-contamination. Proper head positioning is critical for successful vitrectomy in a pediatric eye. Conjunctival period for maximal control of 180-degree conjunctival period extending from the plant infratemporal to superior nasal trocars, and pre-placing the sutures for the infusion line. Another element is tunneled or beveled cannula may limit rotational freedom and while doing a trocar, and a straight-in trocar approach is better. Just to emphasize, when you are going for, you look for a sclera, do an sclera indentation. So we are trying to look to find out the exact site where we want to insert the trocar. So because the retina is folded, so we want to look where should be the ideal trocar placement so that we don't avoid the subretinal placement of the trocar and avoid minimal pathology. Now, in this diagram, you are sitting on the right hand side. So once if we are done a we are doing a if we are doing trying to enter through the 23 gauge this system. So our right hand side on the right on the red side is vertical to the limbus.
on our, if you are a right-hander, and in the left side, it is, the blue is the parallel to the limbus. So, and in the gray, we have placed a pre-placed suture 8 of fissure. Now what it helps is when you will try to suture it, it is easier to grasp and suture it. So we, in this case, you can see that pre-place and anchor suture infusion. Use a fresh valved cannula, which is very important because the risk of hypopnea, intraoperative bleeding is increased, and use infusion cannula tracker set with lock mechanisms to prevent slippage during eye manipulation. I'll just rush through my slide because it's a pretty long surgery, presentation. So also another aspect is if you go, you can go for a Sandler assisted illumination also if you require dissection. So not only on the three, we do need to, if we need to dissect, it's always wise to use the Sandler dissection so that you can hold the membrane from the one side, and then you can use the scissors to dissect the posterior apex of the fold and to dissect it. Always avoid entering young eyes if possible. PVR in pediatric eyes that have not been previously vitrectomized tends to be subretinal, and subretinal bands often do not eject substantial traction. To drain or not to drain, I would always err on the side of not to drain as much as I believe in the RPE pump. Subretinal fluid may take months to dissolve. Tame the urge to jump into recommending vitrectomy. They have thinner sclera. Relative size of the buccal to the eye is much larger to minimize the risk of exposure, strabismus, and postoperative discomfort. Eyes continues to grow over time while the buccal remains fixed. Younger children under 3 years at the time of buccal placement may require a buccal revision. Buccal cut down or removal may require approximately 3 to 6 months after the buckling surgery when the retina appears stable. And anisometropia result from an encircling procedure may be greater in pediatric population. So I would conclude my talk because taking up. So to conclude, bilateral eye examination under anesthesia, examination of the family members, ultrasound and ultra-wide field imaging go in a long way in managing pediatric retinal disorders. Give parents realistic visual expectations, risk of anesthesia and long-term rehabilitation with a pediatric ophthalmologist. Tame the temptation to jump in pediatric rheumatogenic retinal detachments. If buccable, do give a shot. Meticulous
thesis, retina was attached, retina was on after 1 year of SOR.
We have to see why it developed that. We have to find out why they developed all things like something was missed there, or they were having an underlying inflammatory disorder like a vasculitis or something which we have missed. Or, many of these children, they have hypofocal behavior and self-injury behavior, these syndromic cases. So is that the reason? So we need to try to see, why it happened. So just because it happens in one case doesn't mean we go ahead and do everything in next couple of cases without understanding. But if we go into the depth, try to see back our videos, we might get a clue what is happening to them.
Thank you, ma'am, for your expert opinion. I also welcome our guest of honor, Professor Dr. Bindi Kumar Sir, who is the Director cum VC of IJIMS and also Bihar University of Health Sciences, and also our Dean Academic, Professor Dr. Om Kumar Sir, who is Dean Academic of IJIMS. Next, we move on to the next talk by Dr. Lalit Agarwal Sir, who will be talking on ROP in Eastern Nepal. He is the VR surgeon and ROP specialist, also medical superintendent of Viratnagar Eye Hospital, Nepal. So he has come all over from Nepal to deliver his talk. Thank you so much, sir.
Thank you. Once again, good morning to everyone. And I would like to thank the organizing committee for giving me this opportunity to talk on a topic which is very close to my heart. As I have been practicing ROP since 2017, long back in 2019, I came across this flyer. I got here early, where we use this flyer to raise awareness, as these babies are at a high risk of developing visual impairment and blindness due to ROP. More than 30,000 preterm babies were found to be visually impaired due to ROP worldwide in 2010. In the last 30 years, the prevalence of moderate and severe visual loss and blindness due to neonatal disorders has increased by 13% and 33% respectively. In 2019, ROP caused 1,000 cases of visual impairment, out of which 25,000 were blind. And by 2050, it is expected that the prevalence of visual loss due to ROP will be as high as 43 blind per 100,000 population, which is very, very high. What is the burden of ROP in India? The exact number is not known. However, it is seen that the prevalence ranges from around 25 to 30% in the preterm babies. In a study conducted in one of the tertiary eye cancer centers in India, which showed that lack of screening was the major cause of stage 5 ROP detection, which was around 25% of the babies screened for ROP at that time. In another study conducted in twin city, that is Hyderabad and Secunderabad, which clearly showed that the concept of 30-day screening helped in early diagnosis and treatment of these babies with ROP to prevent blindness. Talking about the burden of ROP in Bihar, this is just an extrapolated result from a study of impact of expansion of telemedicine screening for ROP in India, which has estimated the burden of treatment requiring ROP in 2017 as 112 babies. That is, these 112 babies, if not treated, would likely cause bilateral lifelong blindness. Also, with the development of NICUs, the likely rise was expected, that is, it must be around 335 per year of treatment requiring ROP, or maybe more. The literature of ROP in Nepal is scarce. The prevalence in various studies have been found to range from 7 to 27.4%, an unpublished study conducted by our team, in which we took a survey to find out the treatment, the doctors providing screening and treatment of ROP, and the babies they have been screening and treated, and the likelihood of preterm babies in Nepal who need to be screened. And it showed that around 39,000 babies require screening, out of which 35,000 are not being screened. Around 9,000 babies per year are at a risk of developing ROP, and around 1,400 babies need ROP treatment. However, in 2023, only 125 babies were treated for ROP in Nepal. That is, maybe around 1,276 missed this treatment. This is just an extrapolated data, not the exact data. So after that, we conducted a retrospective study in a Biratnagar Eye Telemedicine ROP project. Just a small video in which these NICU babies or preterm babies who need ROP screening. For this, we have had a MOU in all the NICUs of Biratnagar, Nepal, wherein our team goes to these NICUs to screen these babies on every Wednesday and follow up these babies after they are discharged on every Thursday. We do the screening program either using indirect ophthalmoscopy or using the fundus imaging cameras. And as per the diagnosis, we either follow up or treat them as per the need. So we conducted this retrospective study in 2023 to assess the demographic pattern of these preterm babies, the incidence and severity of ROP, and to report the outcome of treatment in these ROP babies. These are the parameters, the variables which were studied. 200 babies were screened, out of which 69% were female. Most of them had an equal distribution of presentation based on the gestational age, except for only 8 babies who were born less than 28 weeks. ROP was seen in 31.5% of babies, out of which 29% had type 1 or aggressive ROP and 71% had type 2 ROP. As expected, the smaller babies had ROP more common and also at a severe stage. Treatment was offered, that is to 13.5% of babies screened and 43% of babies with ROP. Final outcome, 71% had a regressed ROP without sequelae, 2% had regressed with sequelae. However, we lost 27% of babies due to lost follow-up. Some of them were referred for surgery due to advancing stage of ROP, and many of them did not follow up. So the incidence of ROP was 31.5%, severity was seen in 29% requiring treatment. However, based on the clinical judgment, 43% of them received treatment, and the final outcome was 73% had regressed ROP following treatment. Treatment is offered either in the form of laser or intravitreal injection, but over last 1.5 years, we have been seeing that we are getting more of referral at a stage, maybe stage 4 and even stage 5. So a more need of surgical treatment of ROP is seen in our center in eastern Nepal, as the catchment area is quite big. So we have the opportunity to start ROP surgeries, and maybe in 2026 we will be starting ROP surgery there. The particular challenges which we have is the facilities are limited to few big cities only. Facilities are there in some hospitals and NICUs, but the referral is not that great. There are no facilities of ROP screening and treatment in several medical colleges and majority of government hospitals. Overall, before concluding, managing ROP care pathway is often complicated. We have tried to adhere to some extent to this pathway, wherein the first thing is a proper implementation of protocols in NICUs, which can decrease the incidence of ROP. To identify the babies at risk by the NICU nurses, to undertake screening by the ophthalmologist, and as per need to provide treatment, to coordinate about the rescreening and treatment by the NICU nurses or the ROP coordinator, to communicate with the parents regarding the need of screening, rescreening and treatment and follow-up, and to manage the data to see how effective is our ROP screening practice. Thank you.
Thank you, sir, for sharing the data on ROP in eastern Nepal.
So indeed, we are all facing this situation where the NICUs are able to save the preemies, but it's our duty along with the obstetricians and the pediatrician to refer us at the right time. So next, I will be talking on, this is an industry talk, and this is simplifying anti-VEGF therapy, the role of pre-filled syringes. So basically, we have more than 1 crore patients who need anti-VEGF treatment for retinal diseases. So FDA has approved many molecules, and this constitutes ranibizumab, aflibercept, which are also come in a high dose, brolucizumab, and faricimab. So this is a timeline depicting the uses of various anti-VEGF in neovascular AMD and DME. Coming to the mechanism, we all know the mechanism of anti-VEGF and anti-angiogen 2 mechanisms. So the selection of anti-VEGF agent is important because the number of injections will depend upon it, and most important is the financial burden which is going to be incurred to the patient. Also, we have biosimilars which have brought a change in the market. So why is biologic important? Because it is to develop an alternative affordable therapy option with the same efficacy and safety. So why it is important? Because we have a huge cost of treatment compared to the patented molecule. And we are a developing country, and our GDP is way much lower than the developed countries, so we need a cheaper option. So there are many studies which have shown the efficacy of Razumab, and currently we have also got the DCGI approval for PDR and ROP. Contact with the atmosphere, there is reduction in the intraocular air bubbles and the silicone oil droplets. There is improved precision in the volume and the doses of it is a time saving, and there are safety benefits of pre-filled syringes. So this is the overall proposed advantages of the PFS in our clinical administration. So we have already gone through it. Induces reduced injection time and also reduces the possible risk of endophthalmitis, and also there is a reduction in the air bubbles and the silicone oil droplets. So this is a very easy to administer pre-filled syringes of Razumab. So as to conclude, the Razumab pre-filled syringes, they represent a novel method of administering intravitreal anti-VEGF therapy for the treatment of retinal diseases. And the PFS is a very small syringe, glass syringe, which is minimally siliconized, and also latex-free, non-retractable plunger is there. So the ease of administration is very easy. And it also has, as we have seen, reduced injection time, and because of the decreased number of intraocular air bubbles and the silicone oil droplets, there is increased patient comfort also. So the ranibizumab pre-filled syringes have improved the ease of administration to physician, while we are using the intravitreal injection in and out in our OPD practice, in and out or for OT procedures. Thank you. So next, we move on to our keynote address by Dr. Subhadra ma'am. On the retinal diseases in newborn, diagnosis and management approach. Over to you, ma'am.
Thanks again, and it's always a pleasure to be here in Patna. For those of you who don't know, अगर आज मैं आपके सामने यहाँ खड़ी हूँ वो इसलिए क्योंकि पटना में मेरे पिताजी ने इंजीनियरिंग की थी। डॉक्टर बलदेव साहब के घर में एक छोटी सी खोली में रहते थे। In those days, of course, Patna was the mecca of education. There was no engineering college in J&K state, and he was, brought here and he stayed here. Sasa is here. इनके दादी के घर में वो रहते थे एक छोटे से कमरे में, और वहाँ से उनकी जर्नी शुरू हुई और आज मैं यहाँ पे खड़ी हूँ क्योंकि उनको ये अपॉर्चुनिटी मिला था. So it's always, pleasure to be here. I'm not going to talk of ROP because we've heard about that, but while my journey with ROP started about 30 years ago, what I found was that there were many other disorders in the newborns which I was not aware of, and I want to share them with you. In the newborn babies, when we screen, we can see a whole lot of pathology, right from congenital anomalies to, high refractive error, even in the newborn, and I'll just share some pictures of that. I think uveal coloboma are very common in our country, microphthalmos, which we don't see in the Western world. We still have not solved the issue why this is so common, and we don't have a good epidemiological study of what are the communities where it happens, what are the risk factors, but all of us in our clinic will see newborns with. And often we just look at these patients and say that nothing is. The important thing is that these patients can be there. For example, you can see here this patient had a lot of exudates in the eye and we lasered, and then there can be sometimes an aborted coloboma, sometimes there may be need for patching. Even if one eye has more involvement than the other, patching really helps to maintain that vision. So there are various things like cataract, glaucoma, strabismus, retinal detachment which these eyes develop, and so we need to periodically follow. So my practice is to do frequent ultrasound in these eyes because in the clinic you may not be able to pick up shallow detachments very early. So whenever they come to the OPD, every 4 to 6 months we do ultrasound. That's the best way to pick up detachments. And now in older children, more than 2 or 3 years old, we are able to do the fundus photography, and that's how we follow them up, besides the refraction. So sometimes you can have other anomalies with these eyes which you should be aware of, like persistent fetal vasculature, which may require surgery or may require follow-up because that can worsen. Now here's a patient where this is the right eye and this is the left eye. You can see the fundus looks so much myopic right at birth, and this case has -8 D sphere at birth, and this is +3.5, which is normal for the age. This was picked up during ROP screening, and this was actually a combined hamartoma. Sometimes you can have a falciform fold. This is a post-op picture. Again, it's unilateral pathology. The other eye is normal, and you can do the surgery and save that eye from going into phthisis. So Coats disease, normally we say that these eyes present at 2 to 4 years of age, but actually it is a congenital disorder. And you can see here how the disease worsens. So this is at 12 weeks. So had we seen this baby at 4 weeks, then obviously there would have been no macular involvement and we could just have treated that. And you can see here when they come at 1.5 years, this whole exudation incisipates and becomes a nodule, and then their vision is not going to improve. So a uniform screening, if we had universalized screening, then we would never ever see advanced Coats disease. We would be treating them just like we treat ROP. And this is a premature baby, and my fellow saw this patient and called me. I was on leave and said, madam, you're always teaching us that ROP always manifests in the posterior pole. I have now this one case who has no ROP in the posterior pole and only unilateral peripheral ROP. I said, no, it's not ROP, let us see. So it was unilateral Coats disease. You can see here macula completely normal, no hard exudates. This is what we should be picking up. And the interesting thing in this patient was that I had done the laser, and then in the follow-up within 4 to 5 weeks, actually that patient presented new lesions, maybe because of the high VEGF in those eyes. Now this is another case, we see it very commonly. Previously these used to be undiagnosed and labeled as ROP or ROP in big babies. So you can see here patients presenting with vitreous hemorrhage, tractional folds within few days of birth. So this is congenital FEVR, don't get bogged down. Don't wait. I have seen people just waiting and telling nothing can be done. So here we give anti-VEGF and do lens sparing vitrectomy within 24 to 48 hours because these really progress very fast, these FEVR cases. And you can see here, you can stop the tempo of the disease. And even if there's a small area of dysplastic retina, the child can see, but at least you have prevented something from developing further. These children can present as leukocoria, and they are referred as retinoblastoma, but when you look inside you can see the hemorrhage and you can see that these lesions are behind the eye. Now here I'm just showing that what we need to do for FEVR patients is this mother, one-eyed, blind almost. I have told her your children are going to get this problem even without genetics if it is not available. And you can see this son within 7 days of birth, you can see has come, there's no plus disease, nothing, but you can see the avascular retina and the new vessels, and you treat them. And then the other son also born with avascular retina. So you can treat them and they will not have the life that their mother had. There will not be any exudation. So this entity now called ROPER is when we see a preterm babies but actually has an FEVR, that is a genetic disease. Here the retinal vessels have an arrested angiogenesis, that is the vessels are just there in zone 1 or zone 2 and they never move forward. So if you see after 1 week, 2 weeks, the vessels will not grow, which does not happen in ROP. And there could be significant asymmetry in the two eyes. So whenever you have this type of, something unusual type of ROP, then always examine the parents, ask history of squint or small eye in other family members, do a systemic examination because it could be incontinentia pigmenti or muscular dystrophy or any of the other LRP5 mutations. And you can, if you have the facility, you can do FFA. Nowadays we are doing oral FFA in all these babies, and that's very easy to do on your normal adult Claris camera or your normal Optos. In a normal Topcon camera, you can do oral FFA in these babies. The doses are out there in the literature. If you see white deposits here, I'm showing, especially they have a wreath pattern, or even if you have 1 or 2 white deposits, this is FEVR. It could be syndromic. Now this is something new that we found, this LRP5 mutations. This is normally called as a pseudoglioma osteopenia syndrome, which means that children come with leukocoria. But what we found is that they come with leukocoria because they were not screened at birth. Actually, if you screen them at birth, you can pick up this problem and they won't have pseudoglioma. So actually it's a syndromic FEVR. So you can see here this boy is blind, and we have told the family your next child needs to be screened within 24 hours of birth. Here we don't say 30 days. We screen within 24 hours, and this child born on 15th August few years ago, on 16th we saw her. You can see completely dysplastic retina. These yellow dots which are on the posterior highlight give you a clue that this is FEVR. We were able to laser and then do surgeries. So far we have multiple patients now of this LRP5 genetic mutation. They start with eye problem at birth, and you can treat them, and then they will not develop pseudoglioma, but they will start developing bone problems. And within few years, they start developing fractures and become completely handicapped, and they are in the wheelchair. So in addition to low vision or blindness, they also have a lot of osteogenic problems. So when we diagnose these patients, we ask them to start oral calcium along with whatever vitamin D, and they need to be under care of orthopedic surgeons right from birth. And then we might be postponing, though not stopping their bone fractures. So incontinentia pigmenti, again, all patients of IP must have a screening done. It is not being done, and they can worsen very fast. So they need oral angio and laser periodically, and if they develop traction, then we should operate them early. So here we have a patient which we thought has tuberous sclerosis. We could not prove it, but you can see these mulberry-like lesions, which will be a differential diagnosis for retinoblastoma. So this slide by Dr. Carol Shields has given us a clue of if you have bilateral coats like retinopathy, don't consider it coats. Coats is usually unilateral. So there could be other conditions, systemic, which we need to look for. And if you have exudative detachments, then in addition to ROP, there's a whole list of other conditions. And these are my additions here. Viral retinitis, we see it very common in our country. It's not given much importance in the Western literature. They will have choroidal scars or vasculitis, and then of course endogenous endophthalmitis, not uncommon in our country. This Dr. Santosh has given me the slides that retinoblastoma in newborns will almost always be at peripheral, at the posterior pole, or very small lesions. So they will not usually present with total leukocoria in the pupillary area. So mostly it will be like a retinal lesion rather than a retrolenticular lesion. Of course, we do see other conditions like metabolic disorders. As I said, viral retinitis, very common in our situation. It is usually misdiagnosed as conjunctivitis or as retinoblastoma or leukocoria. And we see a whole plethora of chorioretinitis. Whenever you see scarring, think of viral retinitis. And you can have various presentations of endophthalmitis. And then, of course, we already talked about the other retinal dystrophy conditions. One thing I wanted to highlight is that foveal schisis is normal in newborn babies preterms. So this is not congenital retinoschisis, which is what I thought it was. But foveal schisis is common, it goes away. Anand Vinekar has a huge series follow-ups of these patients. They may have little less vision, but if they have foveal schisis with ROP, they have usually very good prognosis as compared to eyes which don't have foveal schisis. So I want to conclude by saying that neonatal retinal pathologies are an area that is less well recognized. There's immense scope for clinical study, natural history and outcome information, and potential for using newer diagnostic tools like oral FFA we are using. We have not tried oral ICGA, but oral FFA is quite easy to use. And OCT on the normal machine in flying baby position, you can get beautiful OCTs. That OCT was on the normal adult camera. Thank you.
Thank you, ma'am, for the wonderful insight on retinal diseases. Ma'am, we have got a lot of fundal colobomas. So do we keep on lasering all the colobomas? Like we have a mixture of ophthalmologists here. So what should be the guideline in that?
So first of all, there is no consensus guideline so far. So what I'm saying is from our data, so we have published data of eyes where we lasered and those we didn't laser at first 15 years of life, and we found that there was a definitive advantage of lasering the colobomas. So the rate of detachment was hugely decreased in eyes which had received the laser versus those who came to us with detachment and never had laser. Now when should we do and how should we do? So we don't do laser in the disc macular area, we do only in the pillars because that is where the lesions are, that's where the breaks occur, Dr. Lingam Gopal has shown. So don't laser the disc macular area. What's the earliest we laser? So since we don't know what is the guideline, so my practice usually is to wait for me to have at least some visual acuity.
In which scenario you will not treat a case of ROP? The options are stage 3 zone 1 without plus, a stage 3 zone 2 with plus, stage 2 zone 2 with plus, and a stage 2 zone 2 without plus.
What is the right answer?
The answer is 4.
Persons above 50 are also not allowed. Go away, jaldi do. Sir, go. Right.
Our next question is, identify the pathology.
Bolo na, jaldi bolo.
Yeah, a spoke wheel appearance, juvenile electrichisis. The next question is, identify the disease. What disease? Okay. Sir. Thank you, sir.
Thank you. Now you can conclude and
So we conclude the Retina Pearl session and we'll move ahead with the felicitation of the chairman and the panelist. So, Dr. Subhadra ma'am, kindly come on the stage to felicitate. So, Dr. Amitabh sir. Sir. So we will felicitate them in the inauguration as well. We are just giving away the certificate right now. Dr. Lalit Agarwal sir. So Abhishek Anand sir.
May I request Dr. Sivani to collect the certificate from Subhadra Jalal ma'am. My request, Arvind Jaiswal sir, please come to give the certificate of presentation to Subhadra Jalal ma'am. Thank you, ma'am.
Who is moderator? Dr. Manish. Ma'am, please stay.
Dr. Manish.
Good afternoon, everyone. So here we come to the very important session of this Foundation Day celebration. That is the fourth RIO Foundation Day oration. Now there are two orations, fourth and fifth, being held today. Last year actually we couldn't organize this. Satyajit, बैठ जाओ. So last year we couldn't organize the fourth oration because we were in transit. We were shifting from the old building to new building and lot of things were happening. So this year we are organizing the fourth and fifth oration. Now this oration has been, the fund for this oration has been donated by the alumni of RIO. So that a wonderful kind of. So may I request the chairpersons to come in the front. First of all, I like to invite Dr. Professor Binde Kumar. I would like to invite one of the legendary ophthalmologists of not only of Bihar but India, Dr. Professor R.V. Azad sir, who has been the guiding force for everyone in ophthalmology, at least in Bihar. We all are like his sister, so we are growing under him. I like to invite Dr. Subhas Prasad, a very prolific surgeon, ex-Ophthalmological Society and Bihar Ophthalmological Society, and also now President-elect of Bihar Ophthalmological Society. And he has throughout his career guided all the juniors for future endeavors. I would also like to invite Dr. Gyan Bhaskar to join the chair. बात हुई है क्या? Dr. So today's oration is being delivered by none other than one of the legendary ophthalmologists, a person whose kind of persona is like impeccable. One has to emulate him to be like a little bit of a person who like Dr. Lalit Verma. He was a Congress president of APAO AIUS 2025, which was one of the biggest Congress in history of India, I think. So wonderfully organized, sir. I was there. Secretary General of South Asian Academy of Ophthalmology, President of All India Ophthalmological Society, AIUS 2022-23, and Director Vitreoretina Services, Center for Sight for New Delhi. He was also Honorary General Secretary of All India Ophthalmological Society 2008-14. These all introductions are for younger generations. We all have come across his all the credentials many times, and we are all versed with him. Chairman Scientific Committee of All India Ophthalmological Society 2015-20, Chief Organizing Secretary of SAO Conference. He did his MBBS and MD from All India Institute of Medical Sciences, Vitreoretina Fellow from LSI, USA, and spent 21 years at RP Center teaching, much like what we are doing right now here. He was also invited as speaker in 646 conferences, workshops, CMAs, 206 publications. May I request our director, Dr. Professor Binde Kumar, to join the chair, and also Dean of Academics, Dr. Om Kumar, to join the chair. He has also authored a manual of fluorescein angiography and book on intravitreal injections and CME series on AIUS, multiple chapters. Then his articles are well read, and there are hundreds of citations to that. He was also office bearer of DOS and AIUS in various capacities from 1999, and till now he is trying to serve and he is giving his best to the society. He was also organizing secretary of 61st Annual Conference of AIUS, New Delhi, APAO, and DOS conferences. With these words, I would like to invite Dr. Professor Lalit Verma, sir, to deliver his oration. Beyond that, I want to say, his friend of Bihar. When he was chairman scientific committee, Bihar got maximum representation or as in the what is called on the forums, and then also in the instruction courses and at the various podium. So that gave us impetus that we can also perform at national level. So that is how Bihar started growing at national platform. He was the person who was behind the organization of midterm conference of AIUS, and he was the person who gave this to Bihar. So full credit to Bihar, so sir. So with these words, I want to invite you, sir, to deliver this oration.
Thank you, Vibhuti, for this long and unnecessary introduction. But I don't think so I did any favor to Bihar. I think Bihar deserved that. It was long pending for a long time. You see, I have seen Bihar, Jharkhand in various times. But the amount of progress this young brigade of, I call them young brigade of Bihar, has made, has changed the entire scenario. And buoyed by all these things, we started this at national level, the competition amongst various states, and very happy that Bihar, Kerala, they did so well. In fact, my mother society, DOS, also they superseded. So that is what Bihar was, and midterm concept was going around for a long time. And I was talking to the chief RP Center, Radhika, on my way, that you see, AIUS can't go anywhere, everywhere, annual conference can't go. So it was my job as president of AIOS to see to it that AIOS serves all the states of the country, and that was the genesis of midterm AIOS. So thank you very much, Vibhuti, for having me here, and very happy to be participating in this celebration of 30th Foundation Day celebration, which is being done along with Bihar, and thanks to all the office bearers of BOS as well as of RIO, notably Nilesh and Vibhuti are two pillars of RIO which have taken a very big shape, and very happy to be, they deserve a very big applause also. Very happy to join this long list of national faculty which we have gathered on this occasion. So RIO, although founded nearly 3 decades back, but now you see this building, and I did go around and I'm in fact very happy that I came couple of times before also, and consulted, was instrumental in giving some ideas. But this new RIO, hats off to the hard work. I know a lot of people are involved because doing at a government job such kind of building is, I jokingly told Vibhuti, अगर महिपाल ऐसा सेंटर बनाए तो बहुत बड़ी बात नहीं है, but सरकार में ऐसा सेंटर बने तो बहुत बड़ी बात है. So it's a challenge to get all these posts sanctioned, have ocular pathology, ocular microbiology, things which were done by LP Agarwal in RP Center. Now what Vibhuti and Nilesh and his team are doing is wonderful, wonderful. And I just hope that they carry on and maintain this level. And not only this, not only service to the people, but also research and some international collaboration they should be doing. And this should become the best RIO of the country. So I have chosen this topic, VR interface disorders, which is one of the commonest surgeries which we do in our practice. And I know it's a mixed audience. I'll try to make it as simple as possible. And I always begin with a very basic slide of OCT, which I'm very fond of asking all the residents and fellows. Sari layer ginao retina ki, so a lot of people fumble there also. But you see, suffice to say that retina, this is just a histopathological slide or mimicry that we divide into inner retina and outer retina. Inner retina is from this green colored membrane, which is ELM and RPE. This is outer retina. This is outer retina. And diseases here are ARMD and CSR and such things. Inner retina is from ILM to ELM. So दोनों ELM, ILM, यहाँ से ILM है, ये ELM है. This is inner retina. So diseases of inner retina include diabetic retinopathy, vascular blocks. But we will not talk of any of these pathologies. What we will talk of where vitreous meets the retina. Vitreous यहाँ retina को चिपकता है यहाँ पे. This is the area. This is the junction, and we will talk of junctional pathologies, or also known as interface pathologies. Remember, all of us are born with a gel vitreous, a 100% gel vitreous. Gel means the consistency of a white of an egg, is a lacy substance, and this is optically clear vitreous at birth, but variable adhesions in various different people. What happens with age and diseases like diabetes, trauma, and so many other things? Two things occur. This gel becomes sol, that is, it becomes liquid, and there is a weakening of adhesion. That means the adhesion between the vitreous and retina, they weaken with time. So if both the things happen together and concurrently and together completely, then what we get is a total PVD. At this time, flashes and floaters may occur, and there may be horseshoe tear formation also, if they occur totally and completely. But what happens if vitreous gets liquefied, but some adhesions are still there? So this will allow the liquefied vitreous to seek into the retrohyaloid place, and this initiates the process of total PVD. And this process can be modified by this breakdown of barrier, and cells may proliferate. This may be compounded by breakdown of blood-retinal barrier also, or by disease like diabetes, trauma, and so many things. And this leads to membrane formation. So we should know what is total PVD, what is partial kind of or anomalous kind of PVD. And this explains all these interface pathologies, and this is the best way to explain all these interface disorders. So this was the latest classification. This was given IVTS. I have compared with GAS classification also, because GAS propounded classification when OCT was not available. And here we have VMA, vitreomacular adhesion and vitreomacular traction, and also the full thickness macular hole and lamellar macular hole. The only point to be noted here is what they proposed, the small, medium, large macular hole is 250 microns and 400, but believe me, in practice we get holes of 1000 and more than 1400 microns. And what you see on label on t-shirts, XL kind of t-shirt, but we get XL macular holes and XXL macular holes also. So VMA is a pathology, or it's I think a normal occurrence also, where vitreous is separated from the retina, but it remains adherent, often in a dumbbell shape, but it's not pulling the retina. There's no pull on the retina. So if there's no pull, the photoreceptors don't get distorted, and there's no distortion there, and therefore mostly it is asymptomatic. In contrast, VMT, remember, is again a complication of this anomalous PVD, but there's an element of retinal pull. If you see this picture here, the retina is getting tented up or pulled. Remember, if his retina is getting pulled up, there will be some traction on the receptors also, rods and cones. So patient may complain of metamorphopsia, teda meda dikhta hai. And later on you may have decreased vision and CME also. So the difference between A and T is the pull on the retina. So VMT is generally symptoms are mild and they develop very slowly. And there's always a discrepancy between the OCT picture and what patient complains of. Like this OCT picture is alarming, but vision is 6/6, patient not complaining anything. Sometimes you may have acute visual loss in such patients, and this is primarily because of this sensory neural detachment which may occur in such patients. So there's always a discrepancy. And various classifications have been given of VMT, J shape, V shape, focal, broad, but all of this are only academic importance and not much clinical relevance. The key question in the minds of specialists is, do all this OCT diagnosed VMT require intervention? Because people scare them, bhai aapko khich raha hai, aap operation kara lijiye. The answer is a very big no, that these don't require. Reason is that a lot of these patients of VMT have mild or what we call tolerable metamorphopsia, kabhi kabhi teda dikhta hai, and they don't require intervention. And sometimes this, you may have relief also, and complete PVD can occur spontaneously. So I'll just show examples of both. This lady, right eye, we operated macular surgery, and fortunate to have good recovery. Left eye, we made her aware that you have a traction. Patient was not aware also. So obviously no intervention required. This was a patient who had progressive VMT, you see, from February to June, and we counseled her for surgery. But before surgery, she had resolution of metamorphopsia, increase in near vision also, and patient developed a spontaneous PVD. This is another patient, right eye macular surgery done, and we had a type 1 closure. And you see this spontaneous PVD occurring in this patient also. You see there's a VMT here, but the foveal contour restored. So therefore, management of VMT is only if the patient is symptomatic, only if the patient has disturbing metamorphopsia in his day-to-day life, only if the patient virtually begs you for surgery, but doctor sahab bahut teda meda to aap kariye. In those scenarios, we may operate VMT even in 6/9 vision because patient day-to-day work is being hampered. So believe me, we do not, even this alarming kind of OCTs, no need to treat them. So basic aim in management is to remove this, vitreous, which is adherent here, or this greenish color or pseudo color image, and aim is to remove this traction. So all of us have been doing MIVS surgery for a pretty long time, and in came Jetria suddenly out of the blue, ochriplasmin for enzymatic kind of vitreolysis, and this was more than a decade back by thrombogenetics, and it came with a very big bang, but believe me, went away with a bigger bang than that. Primary reason was that it's not only expensive of one injection of 4,000 USD, but more, this thing success rate was dismissally low, to the tune of around 27%, compared to what we have been seeing success rate of over 90-95% in this patient. So this was a comparative study between Jetria and vitrectomy. In patients undergoing vitrectomy, VMT resolved in 100%, but in eyes receiving Jetria, 50% only. So all in favor of definitively MIVS only. And the key step, after you do a core vitrectomy is induction of PVD. And various ways, various difficulties you may encounter. But the best is after you do a core vitrectomy, you introduce this tricot, which has the ability to adsorb, get adsorbed onto the surface of the vitreous and make it more visible. and then with the help of suction function of the cutter itself, you engage this and try to pull gently, increase from 200 to 300 to sometimes 600 also, depending on the stickiness you encounter. And once this is done, this comes off and you eat it up with the help of cutter. And this virtually, after you do, then you do some kind of base dissection, and the results are pretty good. This OCT picture may take weeks or months to come. This may not come, but the relief on symptoms come pretty fast. So this is one such OCT showing the relief of VMT. Sometimes you may have picture like this, like on the upper right side, where the tenting is so much that you are afraid that if you pull too much, you may create iatrogenic macular hole. In scenarios like this, you see what is advocated is a foveal sparing kind of job, that you go round and round and leave a small stump here. Do not try to be very aggressive in pulling this, lest you can cause an iatrogenic macular hole. So this is what the same patient, we had this very severe tenting here, but you see after this surgery, when the air is still inside, there is no need to have expansile gases in such patients, only air may suffice in this. So as far as ILM is concerned, ILM we all try to peel, but don't be very aggressive in peeling ILM, because that may not be required. The second pathology in interface disorders is epiretinal membrane. Epi means upon, and upon the retinal surface this membrane forms. Whereas in VMT, PHF hyaloid is the culprit. In epiretinal membrane, this membrane which forms over the retina is the culprit. So again, all ERMs don't require surgery. Even this OCT, shows patient having 6/6 vision. There is this globally adherent kind of ERM here, but since patient does not have any visual complaint, no surgery. So if at all surgery is required, surgery again after you take care of the hyaloid, I like to stain this membranes with some staining agent like trypan blue. The reason for staining is because the job becomes very precise and visibility is pretty good. So key step after you have taken care of the hyaloid is to identify the edge. Once you get the edge of the membrane, I think then the surgery becomes reasonably simple, and you can peel off this edge with the help of this micro pick forceps, which is being shown here. Most of the time this ERMs will generally come in single membrane, in contrast to PHF, where you may have sometimes chysis encountered, you may have the last layer of cortical vitreous, but ERM generally come in a single membrane like this. This is another patient who had concurrent dry ERMD along with the symptomatic ERM. So we did this first job of core vitrectomy, then put in tricot and pull off the hyaloid face. Then under the air, I normally inject trypan blue. This is the posterior pole being dried up. Once the posterior pole is dry, put 1 or 2 drops like this. Wait for a couple of minutes, and under air itself, remove this excess of trypan blue from there. And once this trypan blue comes out with the help of backflash needle, you get a nicely stained epiretinal membrane. And again, this most friendly instrument to me is an old 25 gauge MVR MVR blade, with which you make a nick, and then with the help of Acard forceps peel this membrane. Generally this membrane, whatsoever is visible, is a huge membrane encompassing the entire posterior pole, and this membrane generally, as I said, comes off in a single sheet, as is being shown here. And after that, after this entire sheet of membrane comes out, you do an air fluid exchange, and this is the result of this membrane. A lot of times this macular surgery is done along with cataract surgery so as to maximize the visual results. This is one of the recent patients who had this ERM. This is the pre-op picture and the post-op picture. As I said, foveal contour takes months and months to come. Again, the role of ILM peel in a pure ERM, you do try, but do not persist, lest you cause iatrogenic damage to the papillomacular bundle. Even global trends in retina surveys say that ILM peel is not necessarily to be done, is not advantageous in all patients of ERM. Coming to the last pathology, which is the macular hole in this interface disorders. Here, as I said, ILM is the culprit. We discussed PHF, we discussed epiretinal membrane. Here ILM, and for ILM the specific dye is BBG, or also known as blue ICG. After you have taken care of the PHF and the ERM, then you put in this BBG, and have a fresh diamond dusted in case you want it, because this is not good. Then old diamond dusted not creating an edge in the ILM. So best is to do a pinch and peel, direct pinch and peel. Sometimes you may have this particular hemorrhage on the surface of retina, which practically are of no consequence. And in the first surgery itself, try to peel away this ILM from arcade to arcade, because that is the best time you can peel off the entire ILM, and nicely stained ILM, and then do an airflow exchange and inject gas here. So this is the result when with the gas still inside. A lot of these patients have closure of the macular hole. Another patient who had a large macular hole with PVD pre-op, but with the gas itself. See, closure of the macular hole, OCT has taught us, generally occurs in 1 to 3 days. This is another patient, recent macular hole with traction here and excellent closure. So a lot of things have changed in macular surgery, because initially we used to position the patient too much, but today, believe me, no one should deny macular surgery to anybody. No one should deny macular surgery even to large macular holes or extra large macular holes. Just for the want of position, patients may be obese or unable to position, but it's possible to close all these macular holes also. A lot of new equipment has come, small gauge vitrectomy has come, and a lot of new procedures in the form of ILM flaps or even lens capsular remnant can be used, or retinal autologous transplant can be done. So this was a game changer for me when I attended this ARS meeting, when I for the first time learnt a procedure of flap, and because of this pioneering work done by Maculeska. This was a patient whom I was following up since my RPC days, more than 15 years. So I offered this lady this surgery, and this was the first flap surgery which I did after coming back from ASRS in 2016. So more or less similar procedure that you take care of. Here you just direct pinch and peel we are doing, but instead of taking this ILM across the macular hole, just leave it at the edge. Leave it there at the edge, so this flap of macular hole remains, ILM remains here. So there are various ways which people have described: temporal flap, mini flap, small flaps, but I normally do a multi-layered ILM flap from all around the macula, and a cauliflower like flap has been created here. Then you peel the rest of the membranes here, and after you have done that, take the cutter at the lowest possible suction and the highest possible cut rate so as to trim this, and then do an airflow exchange. So this is the result of this patient. You see some ILM remnants here, but a nice closure of the this large macular hole. The height of the macular hole is less, even then the macula closes. So biggest, most useful parameter, although a lot of indices have been given, if the height is less, then the possibility of type 2 closure is much less. If the height is more, this patient will do fantastically well. Sometimes you may have a double trouble. Double trouble means a reg RD we were operating and you encounter a macular hole. So this was the patient, this was my first patient where you see we had a reg RD. Because of the bullous nature of the RD, we could not diagnose macular hole before, but as soon as we started vitrectomy, the macular hole was staring at you at the visualization. So the technique here again is more or less similar principles, that you take care of the hyaloid, and this is the peripheral break which was causing reg RD. So you do maximal vitrectomy. After that, put a PFCL bubble to iron out the fluid from the peripheral break. And once that has been done, after that, once you are taking out the PFCL, this bulle may start coming back. Inject this BBG dye to stain the ILM. This can be injected with the PFCL there or without the PFCL there. And once this has stained the ILM, then I would like to do direct pinch and peel technique under the PFCL, because we do not want the retinal bulle to be coming in between once you are doing the ILM job. And here again, with direct pinch and peel technique, you are peeling this ILM, but the behavior of the ILM is slightly different. Because of the weight of the PFCL, this ILM will tend to scroll down rather than moving as a flap. So this ILM is getting scrolled down because of the weight of the PFCL, but we have done a reasonably good maculorhexis. This is similar to what you people do, capsulorhexis. A maculorhexis has been done at the posterior pole, and this scroll down ILM will take it out. And after that you complete the surgery as usual. So this is the post-op result. You see the how this OCT is and how after the successful surgery. The success rate of macular surgery nowadays is pretty high, more than 90-95%, but off and on you may get a failed macular surgery either from your own this thing or from referred patient. So what do you do in such patients is that if it is a patient which has been referred from outside, we do stain the ILM and see, often you see the lot of ILM still there. But in this patient, we knew that we had taken out the ILM. So here what you do is you prepare an ILM graft which is prepared in the extramacular area. So after you have prepared this graft with the help of diamond duster, you inject PFCL, because this graft has to be maneuvered onto the macular hole. If you do it in a fluid-filled eye, this will move. So under the weight of PFCL, you maneuver this graft. This is under the PFCL. You move this graft with the help of diamond dusted or a soft tip needle and try to position it over the macular hole. So once this graft is positioned, after that you do air fluid exchange. You can sometimes inject a small drop of visco or a heel-on over so as to stabilize this graft. So the world today, believe me, is divided between peelers and non-peelers in macular surgery, and the flap surgery generally preferred in patients who have very large macular hole or XXL kind of macular hole or a myopic macular hole or a failed macular hole. So despite the flap or a peel being there are still unmet needs of macular, especially in patients who have MLD of more than 650 or so. So in these eyes, what is recommended is either a HAM, that is human amniotic membrane graft, or a ART or autologous retinal transplant, or a macular hydrodissection. So these are gaining importance. So this is the latest closed study group which has come up, which has analyzed this data, and what they reported was that if you do HAM kind of procedure, you have a nearly 100% closure, and 190 and 80 depending on HAM, ART and macular hydrodissection. So the preferred surgical technique in patients who have very large refractory macular hole is this. So this closed classification is the latest. I gave the initial classification of international study group. This is small macular hole, medium, large. Then what I was telling you about this size of XXL and giant kind of macular hole. So giant macular hole is one which has more than 1000 of MLD. And the preferred surgical technique, as I said, in a large, till the large is ILM peel or flap, but once you are dealing with XL or XXL or giant, the preferred technique are human amniotic membrane and ART. So these are the preferred techniques in summary, which has been summarized in slide. As far as lamellar holes are concerned, people have burnt their fingers by unnecessarily trying to close them. Only if in your vertical follow-up they become symptomatic or become full thickness, or the patient has issues, then you should operate. So this was one such example where patient has all the membranes, like we has VMT also in lamellar macular hole. So we took him up for surgery because this patient became symptomatic, and did this 4-in-1 kind of surgery where cataract and all the 3 membranes also were taken out. So this is a tricot assisted PHF removal, as was shown before. Then you do an air flow exchange, put in this trypan blue dye. This is the few drops of trypan blue staining the epiretinal membrane, and this is the epiretinal membrane being nicked with the help of 25 gauge MVR blade, and with the help of forceps. Then you remove this epiretinal membrane. After removal of this epiretinal membrane, the surface of the retina is still wrinkled. So we injected the 3rd dye now, that was the BBG. This is the BBG coming in, nicely staining the entire epiretinal ILM here. And this direct pinch and peel technique, this after the epiretinal membrane is the ILM membrane. The behavior is different, and this is then taken care of. So all the 3 membranes along with the cataract surgery done in this patient, and fortunately, thanks to the integrity of these 3 lines here, outer retina, that RPE, the rods and cones and ELM, they are good, and hence the patient recovered excellent vision in this patient. So thus to conclude, all of us do this surgeries very commonly, whether it is VMT, macular hole or ERM, and OCT and these newer theories of PFD have helped us in better understanding. And with these staining agents and smaller gauge vitrectomy, it is today possible to take care of all these pathologies in a very nice, not only anatomically but functionally also. So these 3 membranes, 3 staining agents, we should all remember. Thank you so much for your kind attention.
So wonderful oration on different vitreomacular junctions disorders and the modalities which we have been utilizing. I like to have two concluding remarks. Two concluding remarks from the chairpersons. With us, we have our director, who's not only administrator, but an avid researcher who has, to his credit, starting MCH courses at two places, AIMS Patna and IGMS. So he was the person who ran these two courses at two different institutes. He has, to his credit, many international work also and national work also. He is also a prolific pediatric surgeon. So we are fortunate that today we have dedicated our this whole 30th Foundation Day to pediatric eye disorders, and fortunately you are among us. So I invite you for giving a small concluding remark on the oration given by Dr. Lalit Verma sir.
Very good afternoon, and it is very heartening to see the Sunday morning the hall full of the delegates, and it is the only, I have seen many conferences and meetings of the Ophthalmic Society, and the way the enthusiasm is very infectious and very encouraging. Delegates from whole country, experts and faculties, I would like to go in the memory lane, down the memory lane, and I think one of two people are sitting there at that time. It was 1996. Nagendarji is there, Dr. Sudhir is there, and Dr. Minal, my colleague at PGI Chandigarh, was also there. He came to me, Bindeji, we have to do something for the retinopathy of prematurity, and will not believe, to get the patient where we have to go. We went to Kurji Hospital. There was 800, Maruti 800 that Minalji was carrying on, and we all three sat together and went there. Madam V. Kapoor was there, and he sat there and discussed. She was very much surprised. People are taking care, and from government hospital they are going to the missionary hospital for getting the patients. And the first meeting of retinopathy of prematurity started, and that was the start of the RIO. RIO has always done a wonderful job, and that is the one thing they have started in 1996 itself, when they were in infancy, because it was started now see the 30th year, so it was 1995. So people were there, and the people are there who shaped the RIO in such a beautiful form. Whether it's Dr. Minal, whether it's Dr. Nagendar, whether it's Dr. Subhas, whether it's Dr. Sudhir. I can name the persons, and they are virtually not a person, they become institution in themselves. So this is the way I want to tell you, the way they have carried it, and the reputation of RIO, what we are sitting there and meeting at this place, is not only the work done by the Vibhutiji, it was all the epitome of all the predecessors who have led the foundation stone. So from bottom of my heart, being a director of the institute, I just only want to say that one should, if you cannot do the thing, they should emulate you to do it themselves. And regarding the prematurity of retinopathy, I have seen the plights, being a pediatric surgeon at different places, and they are coming with some surgical problems, and the retinal problem is there. And they are always suffering a lot, and this is something, this is a scar, as a blot on the humanity. And I congratulate to bring the pediatric retinopathy in the fourth stage and forefront into this meeting. And I congratulate the whole team, whole organizing team, and all of the experts who have spared their only one Sunday in a week, and they have come to here to share the knowledge and share their view. Thank you very much.
I invite Professor R.V. Ajad sir for his concluding remark on the oration delivered by Lalit Verma sir. Aage.
Concluding remarks. It was a wonderful presentation, and Lalit is what I can say. We have been together for a very long time, whether it is AIS or it is South Asian or it is the Vitreoretinal Society of India. In so many places we have been together, and this guy has got a lot of capabilities, not only academic, but this guy has got organizational capacity. The way he organizes, the way he talks to people, the way he makes presentation. If you people were sitting here, if you would have seen, I always appreciate it. You see, I told this fellow, Abhishek, you should learn from his presentation today. See, the verbosity should be less. You should be as much as the pictures, and you should be able to make a comment on those pictures. So that will make an impact over the audience. And I always, I always learn from him. Today I was sitting there and I was thinking that if we have different diseases, we don't talk too much, we just show. So that makes a very permanent impression on the audience. So what should I say? It's a wonderful presentation, and thank you for coming here. And because I don't only belong to India, but I belong to Bihar first. Thank you very much.
May I request now the chairpersons to join. Please come forward for felicitating the orator. Sir, please, sir. Yeah. Standing ovation for friend of Bihar. So we'll be giving a plaque, a scroll of certificate and medal from Ajad sir and director sir and the dean sir for felicitating Dr. Lalit Verma sir. Now the next oration, I'll request Ajad sir to please be on chair. Binde sir also and Om sir also to be on chair. And Dr. Nilesh Mohan sir will be taking over from here for the next oration to be delivered by none other than Dr. Professor Radhika Tandon, Chief of RP Center. Thank you.
नहीं ससुर लगा लो पहले ऑफ क्यों हो गया तुम चेक कर दो चेयरपर्सन को खाली बुला लेता हूँ पहले वो मैम का वो डिस्प्ले करो ना आगे बस 2 मिनट्स मैम वो कहाँ गया हाँ
Good afternoon, everyone. Now we are continuing with the 5th oration. May I now call upon Dr. Nagendra Prasad to join as a chairperson, Dr. Sudhir Kumar and Dr. Rakhi Kushumesh. She's here. As we all know, this year we had 2 orations, and the 5th oration is going to be delivered by none other than the first woman chief of Dr. RP Center AIMS, Professor Radhika Tandon. She is a very approachable personality, and these are the list of achievements again for the youngsters to know what she is. She is a core student from AIMS, Delhi, did a graduation, post-graduation, senior residency, then joined there as a faculty, And you can see the list of academic achievements of ma'am, which has been there on the since last 20 years. Regarding research activities, she has n number of publications, and she has also been an examiner for FRC Oft and FRC Edinburgh examinations, and still probably she's there. And she had been always to help our institute. She had been here earlier when we had held the iBank Association of India conference at Patna, and that was the first one, and that had given a breakthrough to this institution in establishment of the iBank. So we would like to welcome you, ma'am, and would like that this helping hand should always be there for RIO in future. So welcome, all yours, ma'am.
Respected dignitaries on the dais, and thank you, Dr. Nilesh, for that nice introduction. Hello, everybody. It's a very special occasion for me to be here. I'm very honored that Dr. Azad is in the chair and Dr. Lalit is also here. It feels nice to have one's teachers because we imbibe a lot from our teachers. So it is a rare occasion that in a place like this, they're both here, and also nice to have so many students here as well. The other thing is that this is my third visit to Patna. You can say that in this millennium, there's been literally one every decade. So first, early 2000s had come with Dr. Dada. There was a training of the trainers program. And if I recall correctly, I did a keratoplasty at that time. And then there was another visit, as Nilesh said, in the next decade, that's around 2017-ish. And then we had the EBAI CME, and after that workshop, and then now. So for this oration, and I must say it's so heartening to see that these young boys, they started the eye banking and corneal transplantation in this city, in this state, which for a long time was shown in every forum as, you know, nothing can be done and it will never work. So I think a big hand of applause for this entire team led by the whole team at RIO, because it was a tough journey. And then they also took the approach of encouraging other institutes. They didn't have this thing that only we will do, nobody else will do. So they had the sort of facilitatory approach. If you go only rigidly that this is the rule and you cannot go here or there, then things cannot work. So they were very facilitatory in that approach, and if I'm not mistaken, other corneal transplant centers are also functioning, which is a good thing. And then of course, having come up with this wonderful institute, this multi-speciality, beautiful building, that also we realize what is the hard work and personal planning. We ourselves have seen it, how RP Center came up, and we know that it is not an easy thing. So many congratulations, that is RIO for its 30th Foundation Day, and then this award. So for me, I just took a little different approach to this oration. I wanted to just open your minds to some of the ideas or thoughts that I've over the years realized as a teacher and as a clinician. So expanding horizons in eye care, training and research in India, technology-driven paradigm shift. So often we are always, you know, complaining that the students are not there in the class, and, you know, they're busy somewhere or the other, and many things like that, like why are they not in the class? Like, it's different from when we were students, things were different, and, you know, nowadays things are different, and there's no point forcing them, and there's something going on, obviously. So you have to realize from their perspective. One is that they're too busy, clinics have increased a lot, the workload has increased a lot. Ophthalmology long ago was simple. There was cataract surgery, retinal surgery also. There were few procedures which were done. Now the quantum of diseases, the quantum of care that you can give, the quantum of investigations, and the range of treatments that you can give, even daycare surgeries and intravitreal injections. So the load has increased tremendously, and it's of course true that the youngsters are very busy and they also need some time. So we have to think that how are we going to modify this training thing? You cannot use the old-fashioned methods. So you have to keep thinking, and also the demand from the patients, because whatever we do for that patient, that is the surgery. So you have to deliver the best results right at the first go. So that is what I'm saying. I just want to share. So this is the introduction. I'll just give you little snapshots and insights and a futuristic view. So we have a legacy. After all, with an institute like us, we've had stalwarts and huge doyens of ophthalmology, and we are running in their footsteps. And sometimes you feel very small because you really looked up to them, and now you're right there in their shoes. So there is a legacy that you have to live up to. And there are current trends, there are dreams that you have, and there are goals and timelines. So for other people who are starting their institutes, you can look at the other, backstories, and you can learn some things and you can do some things different. And the other thing is that people may forget what you said, but they will never forget how you made them feel. And this is something very conscious that it matters a lot. It's not only, you may be very busy, you may be having a lot of pressures, but for that particular person who's come to see you, whether it's as a patient, whether it's as a student, whether it's any staff member who's coming with a problem, you have to give time, and you have to at least give a few words of encouragement, and be very conscious about what you see. So you're on duty all the time. So that's a very hard thing when you're an administrator, that you have to be fair, you have to make sure that it may be some small issue also, so you have to be very careful. So the key elements, now let's come back to the forum over here, that there have to be key elements of a memorable learning experience. So one has to have an engaging approach, and there has to be active participation. So this requires time, and you require the young people to be engaged, and they have their own way of thinking. There is some new app which I forget the name of, which they prefer to look at that app rather. There's some, I forget the name, there is some app that they're using. They use it for PG, NEET, PG entrance, and they prefer to look at that app and see the answers written there rather than listen to us. Marrow, yes. I just heard about it recently. So there's this app called Marrow. So now I'm thinking I better read it because obviously it's giving more information in a better way. So I'm thinking now that I will also read Marrow. So you have to keep changing. And I just recently came to know about it. I honestly wasn't aware of it. So you have to keep them engaged. You have to tell a story to connect with, like Dr. Lalit nicely told the story about how, his thought process when he started the, so you have to keep connected and, link things up to tell them that it's not only about what's written in the book. You have to have that personal interaction, but there is a difference in the mindset of the youngsters today. And you have to therefore keep the sessions interactive. So this is, of course, many such already known things are there that you can access and take the benefit of these insights and deliver with impact. So effective patient care is ultimate. So that's the important thing to get through to the students, that effectively you've come here to become a doctor. A lot of them are having pressure issues, they have issues. So you have to tell them, forget about your own issues. You've become a doctor to help people. So you have to, you've taken this decision, you've come down this journey, you've studied so hard and reached this step with the support of your parents, and you just forget about your issues and you just focus on the patient, and automatically things will fall into place. And that largely works unless somebody has a very pathological illness which requires a lot of intervention. But largely if you give them this kind of a approach, then just forget about your own small little issues and you'll handle life as it comes, and you concentrate on that and the efficiency and professionalism. So, you have to have eye contact, purposeful gestures. These are the things that even the senior residents need to live, because not everybody has natural communication skills or natural tendency to be able to, engage with people. Different people have different personalities. So, whatever teaching program you do, you plan with a clear purpose, engage with the learners and direct involvement using rapport, storytelling and questions, and you have to adjust. And you also have to try to fit it into your busy schedule. So when somebody is assisting you, you can just spend a few seconds at the end of the surgery, telling them, rather than during the surgery speaking continuously, because the patient is under local anesthesia, and patient doesn't like it that you're doing his surgery and you're focusing on something else. So try not to keep speaking when doing the surgery, but take a few seconds either before or after to talk, to teach whatever you want to teach. So this is what I want to say, that integrating patient care and teaching, and my concept is actually there is no scope for a learning curve. So how do we do that? So you have to be well prepared for everything. We have to do a transfer of knowledge and skills to the younger people. There has to be competency, efficiency and ethics, but you cannot compromise on clinical outcomes and patient safety. So over the from the past, it's not that things were not done properly, but because we have newer technology and newer access, we can improve that much even in this journey. So as far as RP Center is concerned, as you know, there's a lot of expectation. So people coming to AIMS itself have heard so much about it, and they expect that, you know, a very high level of standard of the teaching and the quality of the of what they're going to gain to learn. And the patients coming there have high expectation. Everything has to be amalgamated with your clinical responsibilities. So one great thing is, of course, the surgical skills transfer concept. So we have the surgical lab, and we have a very structured way of a stepwise approach with the simulator, and a huge credit to everybody who was involved in the journey of creating the surgical skills center. And then whatever surgery you take, retinal surgery, corneal surgery, my only impression is that, my only message is that the patient has to get the result right from the beginning. So you use whatever is available in your armamentarium, whichever kind of hand-holding technique you do, so that the outcome for the patient is not compromised. Now coming to that, so that was keratoplasty, and now coming to refractive surgery. Now refractive surgery is again a higher level, and a lot of people consider it cosmetic. Now the question is it really cosmetic? And my argument is that you should not consider refractive surgery as a cosmetic surgery. It is a very healthy eye, and some people say that, you know, glasses are fine, why do you need the refractive surgery? But look at it from the other point of view. We are a tertiary surgery for official purposes. They're coming because they're going for a job, and the very fact that there are a lot of jobs which require you to have spectacle free vision to do a certain task, so that means it's not cosmetic, it's a professional requirement. And so some of them will have the requirement even for refractive errors as low as 3, that they want them to have 6/6 vision unaided. So that completely removes the argument that refractive surgery is cosmetic. It isn't. So if you look at it from that point of view, now the patient has come for refractive surgery. Now you yourself are a refractive surgeon, but you have to have a generation of refractive surgeons who are going to do the surgery onwards. There's a limit to how much you can do in the surgical skill lab. You can, of course, take care of a lot of steps, but ultimately when you're operating on that first patient, that patient has to be given the perfect result. So it is again the trainer's huge responsibility and the learner's responsibility that you prepare in advance for that particular surgery. This is just a snapshot of the kind of cases we get, and we have a huge number of patients who come. This is just a few examples to make sure that we don't compromise on safety. And here again I will stress, sometimes people do come saying that we are going for this job and we want the refractive surgery, but either the age is less or there is some sort of a parameter which is not safe, and there again we don't compromise, because we say, look, the surgery should not be done. I understand that you want the job, but we will not compromise on safety just for that. And usually when you counsel them, they do understand. So no compromise on the basic steps, irrespective about the amount of pressure the patient puts. We follow the general contraindications and do a very thorough preoperative checkup. But one additional point I would add, which we do for patients coming for professional reasons, is the color vision test. Now it's a different argument whether color vision is essential or not for many jobs. However, whatever the job requirement is, it is better to do the color vision beforehand, because in many cases that parameter may make them ineligible. So it's better to be upfront right from the beginning. However, some of the patients, even supposing they're going for railways, they turn out to have a color vision deficiency, but then after going through the thing and after interacting with the other patients in the clinic and seeing the profile, sometimes they still want to go for the surgery anyway. The only thing I would say is that when they have a red-green deficiency and they're going for the surgery, to be a little careful at the instructions you give the patient when you're doing the actual firing of the laser, because there's a red light and there's a green light. So not sure where the patient is looking, so you have to specify that look at the blinking light, you know, so that they can make out that much of a difference. So the blinking light is the green target that they should be looking at. Then of course the contrast sensitivity we will do, and these are the common scenarios. We have defense, security, railways and other government jobs, and here again it varies from one job to the other. My only purpose of showing this is that they keep changing their guidelines. So whenever a person comes for refractive surgery for professional indicator, always tell them that you please check what are the criteria. because some of them want that the surgery should have been done 1 year before. Some of them have a specific axial length. Some of them have a particular refractive error. Some of them have a specific residual corneal thickness. So since the criteria keep changing, it's always good to check that beforehand itself. So just to show you, so many various criteria are there, but again, if you see what are the criteria, many people have this kind of a refractive error. Even if they're not going for professional reasons, it means there is some impairment of their day-to-day activity because of the glasses. So we should not consider it as a cosmetic surgery. So now coming to the actual surgery. Here again, even for me, I'm like a very experienced corneal surgeon and a refractive surgeon. But when SMILE came, I was very hesitant, because the surgery involves a lot of manual manipulation within the eye, and initially when the surgery was described, it did say that it did not have the wow effect of LASIK on the first post-operative day. And there's a bit of biology involved, that, you know, how is the patient's cornea going to react to all that manipulation? With LASIK, it's the laser doing it, so there's not that variation in human touch. But with SMILE, there is that variation in human touch. So you're worried. So initially, when people would come, firstly, I was very hesitant to do SMILE straight away. However, with time, when I interacted with Rupal Shah in one of the conference like this, and I just said, you know, I'm very hesitant to do it. She said, no, you get 6/6 vision on the first day. So hearing that from a person who was very casual about it, she was very confident that she gets 6/6 vision on the first day. Then I said, okay, I'll do it. And then again went through at this stage again, you go through the whole learning process, and and for me it was even worse, because I was the senior most in my unit. I'm doing a new surgery. I cannot afford to not do it well. So the whole thing was, quite stressful, but I did exactly what I'm trying to say, that you read up about it, you be familiar with the case, be very, and have a good trainer with you at that time. And the trainer, sometimes even the company assistant can be a good person, because they actually have to only make you confident about the machine aspect, the surgery you have to do. So therefore, initially, if patients would come for refractive surgery, I would say that, we'll do LASIK, because I can give you more guarantee of that 6/6 vision on the first post-op day. But gradually, as you found to yourself, even though it's written in the books, even though Rupal Shah said it, but in my hands can I give it? So only when I was confident of that, then, very seamlessly now I have no hesitation in giving them the option, SMILE versus LASIK. And so you have this incision, and I'm sure people are already familiar with the surgery, but those who aren't, you can understand when you look at the images that, how much manipulation is involved. But the other important thing I want to enhance is, you need to get the patient on board, because a lot of the initial steps, you require the patient's full cooperation. And you can understand what is clear to you, it may not be clear to the patient, and he may make an inadvertent mistake, which if you haven't prepared the patient properly, you may just end up with a mess, because the patient has moved at the last moment and you have suction loss, etc. So you have to internalize every step and then plan and break it down in steps, so that the patient also is very engaged and knows what's happening and doesn't panic during the surgery. So this is what I wanted to say, that the surgery actually does involve a lot of manipulation, but if you're very clear what is required, you don't have all the problems and complications which are reported. Similarly, for LASIK also, you have to have a senior resident who is beginning. They have to do the first case. So we encourage them that you watch every step carefully in the assistant phase, and then you also keep asking them, what are you going to do before they do their first case? You make them walk through the whole process, so that when they're actually doing the case, still you have to be right on their shoulder and, whisper in their ear. Don't give instructions loudly. And then, you have a seamless surgery for the patient. So how do we connect the dots? So this is our thing. I would say that SMILE is way above in skill and tension for the surgeon compared to everything else we do. I'm sure phaco also would be for a beginner. So phaco, I would say, is one such, and SMILE. I know vitrectomy surgery is also very complicated, but often the patient has poor vision, you know, whereas in here, the thing is the patient has very good vision and a healthy cornea. That's the only thing which adds an extra element of this thing. So we have no financial interest. So again, the first step is to be convinced that the surgery is better. So talking about myself, I wasn't convinced that smile was better, because initially there was always this thing that you don't get the Y effect, that you may not get 6/6 vision on the first post-op day, required a lot of manipulation. So only when I myself was convinced that it is better, similarly the person has to be convinced, because only then you're motivated to do it well. And it is no doubt better. It is a cutting edge keyhole refractive surgery. There's a more stable cornea and there's less corneal anesthesia after it. And then you can also check up what does the rest of the world say about it. And then the stakes and expectations are very high. A whole list of complications have been described. And you have to know the complications to know that, okay, I'm not going to cause these complications, but you read the complications very carefully so you understand which step it happens. And you just develop your database that if I do this step properly, I'm going to avoid this complication. So it is really good to review the literature and being fully aware of the potential complications. So the surgeon is anxious, there's lack of familiarity, there's a difficulty in identifying the planes, low confidence in dissection, and there's a fear of incomplete lenticule removal, all of this leading to the fear that the patient's eye is going to be messed up after the surgery. So we have our interaction with the trainee surgeons. They're motivated to learn it and then be well versed with the technology. So what they do is they start in there generally after 1.5 years senior residency in cornea. Now this is how we tend to do it, but this may not be everywhere, because some places you have to learn early. I'm not saying you have to go through this journey, but it's kind of a, given the kind of pressures we have, this is our protocol. After 1.5 years, and then they first spend 2 to 3 months in the refractive clinic. So they're working up the cases and they're seeing the patients post-op. So it's gone into their DNA that yes, 6/6 vision first post-op day, etc. So they again further convinced that it's a good, so they've seen the patients with, you know, their smile on their face after the surgery. Then 3 months after this, they independently perform LASIK, around 2 cases per week, followed by 4 cases per week. This is when I was in Unit 6, and in Unit 3 also it's similar, but they have a larger number of cases. And then 3 months smile under supervision, 1 case per week, and then followed by 2 cases per week, because this person has to be confident enough leaving RP center to be able to deliver and to train others. And the guide to the beginner, this is it. When I was saying technology driven, so you have so much access. You have the video there, they can watch it, they can record it, they can see it later. So but you tell them that just don't be like passive in the OT. You have to be actually engaged. You have to actually feel a virtual experience, which everybody understands now. So you have to feel as if you're doing the surgery, watch every step extremely carefully, and take enough time to talk to the patient before, let them know their role for the best outcome, and the use of the patient interface. So these are the normal protocols and the precautions you take. The other thing is, then you keep thinking to yourself that how can I improve it? So there are certain steps where it might help that don't start in a hurry. Make sure it's sharply focused, make sure there's high magnification, and take a few seconds at the initial steps where you know people make mistakes. If uncertain, don't proceed, because the tendency is, you know, let's get on with it and we'll figure it out later. But once you end up with a mess, it's very difficult to clear it. So take a few steps, and then you have all the list of all the signs. The silver sign, the ring sign, the meniscus sign. So each and every sign you try, but you may not see that sign in every case, because that's what happens. You heard about the meniscus sign, but you may not see it in every case. So you have to, your brain has to put everything together on the spot and put it together. So identify the lenticule edge, gently elevate, anterior dissection, etc. And then you can proceed. So then you shift to low magnification when you're sure you're in the right place, and this is how we guide them and how to dissect it, and then completely dissect it peripherally, and then get them to be very familiar throughout the side, and then, you know, and then you can progress. So this is an example of a senior resident doing her very first case. So here again, as I said, initially you need to have the patient engaged so that they do not move during the step. There is no suction loss, no movement. And then as you can, and initially what I would do is I would do the right eye and let the trainee do the left eye. Then I changed because the right eye is actually easier to do. So I tell them, start, if you're a right-handed surgeon, so I say do the right eye, and if the right eye goes well, you can go ahead with the left eye, and you're right there scrubbed and willing to take over whenever required. The other thing is you also have to have your sign language, and without speaking a word, you have to shift. If in case a surgeon has to take over, you have to beforehand know that this is what I'm going to indicate. And then they do have a tendency to say ma'am. You know, they say, is it okay, ma'am? So then, you know, the person knows that the person operating is a junior. So that's the other thing we have decided, that don't say ma'am or sir during the surgery, because it's for the mindset of the patient. It's a very simple thing. They're doing it out of respect for me or the surgeon, but you know, for the patient, मन में आ जाता है ना कि junior कर रहा है. Lot of patients, they don't understand it, even though sometimes the junior may be better than the ma'am or the sir, but you know, as a surgeon, but it's a question of the mindset. So with that, I just wanted to say, similarly for ICL, again a highly difficult surgery. So here this was a unique experience with SMILE that I had to learn, and then my other faculty, all of them were very hesitant to do SMILE. But now I'm so pleased that all of them are very confident, and now I've shifted from one unit to the other, and they're going ahead and continuing to train more senior residents for the procedure. So with that, I'll stop here. And I just say that, you know, this kind of a concept can be extended to anything we do, knowing that the people learning are the future of ophthalmology in our country. Thank you very much.
Thank you so much, ma'am, and I think she deserves a standing ovation. I mean, such a wonderful and simplified talk, and how we have to move ahead in ophthalmology. Thank you so much, ma'am. And concluding remark by Dr. Professor Azad, sir. Mike.
मैं क्या बोलूँगा? She made a wonderful presentation, and I was just sitting thinking here that she little bit departed from the you know, the core of the ophthalmology, and I am also interested in that. By this I mean that how the people can be trained, what should be the training criteria, how much they should be trained, how we should evaluate, and all these things are very important. So now that she is a planner and a policy maker, so from that point of view, it was a wonderful presentation. I am not a cornea expert, but I can definitely say that a lot of good things were made public to you. I feel that you learned a lot from this, and thank you, Radhika. Thank you very much.
Dr. Om, sir, just a concluding remark from your side.
I am odd man out in this meeting.
Though, definitely, but father-in-law of an ophthalmologist,
yeah,
yes.
My son-in-law is ophthalmologist, but what I have learned from madam, that she emphasized that how the transfer of knowledge from the trainer to the trainee, and it should be in a structured way, and it is outcome based. So this is the message she has given, and I am very much proud that RIO has arranged her arrival in this meeting, and I am thank you, and I appreciate her gesture that she has agreed to come to RIO Patna and deliver it. Thank you, ma'am.
May I now request the chairpersons to please come forward to felicitate our orator, Professor Radhika, ma'am.
May I request Vibhuti, please?
With this, I request all the chairpersons to just... Neeraj ma'am ka sara sign. I request the chairpersons just to take their seats. By the time we arrange in 5 minutes for the inaugural program. Sir, सामने बैठ जाइए. लो प्रतीक.
तौलिया सब फटाफट तौलिया सब करो. हाँ.
Hello. So, requested to gather for the inaugural program. May I call on the dignitaries on the dais, Professor Azad, to take his seat. Jabula bula. Sir ko. May I request our today's guest of honor, Professor Binde Kumar sir, to come on the dais. Our today's orator, Dr. Lalit Verma and Professor Radhika Tandon, to take their respective chairs on the dais. Dr. Om Kumar, Dean Academics, IGMS, to please come up on the dais. Chief RIO and Deputy Director IGMS, Vibhuti Sinha, to come up on the dais. Secretary Bihar Ophthalmological Society, Dr. Satyajit Sinha, please come up on the dais. Sir, Lalit sir, please. Radhika ma'am, aa gayi, haan. Dr. Gyan Bhaskar, Chairman Scientific Committee, Bihar Ophthalmic Society and Professor at RIO. Dr. Ranjana, Honorary Treasurer of Bihar Ophthalmic Society, please come up on the dais. Ranjana. वो सीट किसकी? Dr. Ranjana, please. नहीं है, ओके, छोड़ दो, नहीं छोड़ो। May I now request Surbhi to felicitate our guest with flower pot, Professor Dr. Azad. Jao fatafat, one by one. Professor Azad, sir. To welcome our director, Dr. Binde Kumar, sir. Quick, Shivani, facilitate it fast. Jao, director. To felicitate our today's orator, Dr. Lalit Verma, sir, with a flower pot. Jao, Lalit Verma. Felicitate Professor Radhika Tandon, ma'am. Lalit Verma. You are late. Fast, jao. Felicitate, welcome Dr. Om Kumar, sir, Dean Academic IGMS. Welcome our Chief RIO and DD IGMS, Dr. Vibhuti Sinha. Welcome our Secretary, Dr. Satyajit Sinha. Welcome our Chairman Scientific Committee and Professor of Ophthalmology, Dr. Gyan Bhaskar. And Dr. Ranjana is not here, na? Dr. Ranjana is not here. We would also like to welcome Honorary Secretary AIOS, Dr. Santosh Honavar, also with the welcome him with a flower pot. We welcome Dr. Rajesh Sinha, who is President at DOS and a faculty in Cornea and RP Center. We welcome Dr. Kirti Singh, ex-director GNSC and honorary treasurer of DOS. We welcome Dr. Subhadra Jalali, ma'am, who has taken so pains to come up here. Welcome, ma'am. And welcome our student and a faculty at IMS BHU, Dr. Deepak Mishra, who is always omnipresent at his parent institute in whichever program being held over here. Now we call upon all the dignitaries to come forward for the lighting of the lamp.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं
May I request Dr.
कल्याणम्
Subhash sir and Dr. Nagendra sir to please.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
Now we begin this inaugural program by the welcome address by the Chief RIO and the Deputy Director of IJMS, Dr. Vibhuti Sinha.
So we are running late by around 30 minutes. Out of those 30 years, I have spent around 25 years at this place, the 30th year which we are celebrating. So I started jotting down the memory of around 4 pages at least. Couldn't jot down everything, try to summarize, but I'll have to cut little more if I want to give a welcome address. So on behalf of Regional Institute of Ophthalmology family, I really welcome Chief Guest Dr. Professor R.V. Azad sir, who has been the guiding light for us, who is also Emeritus Professor for Regional Institute of Ophthalmology and guiding us in our various projects. Guest of Honor, Director cum Vice Chancellor of not one university. He has the opportunity of becoming Vice Chancellor for 2 universities, leading not only IJMS but also Bihar University of Health Sciences. So all the medical colleges are right now working under the guidance of Professor Dr. Binday Kumar sir. Our Dean Academics, who is a great sports person also, and a great nephrologist, running a very successful kidney transplant program at IGMS, Dr. Professor Om Kumar. A special invitee, Dr. Lalit Verma sir, ex-president of AIUS, Director VR Services CFS, Professor Radhika Tandon ma'am, Chief RPC AIMS, for coming to this place. Dr. J.G. Agrawal was little indisposed, so he has left. Dr. Satyajit, who has always been there with us in whatever we are doing at Bihar, Ranjana, and the dignitaries who have come across the country, Dr. Santosh Sanova sir, Secretary IUS. I think you started your coming to this place by one video so back in, I think, 2006 or 8, yeah. Professor Rajesh Sinha sir, always there for us, Kirti ma'am, Dr. Subhadra Jalali ma'am, and all the dignitaries who have come to this place. Head of the Department of Ophthalmology from AIMS, Dr. Ramit, Dr. Asif, Dr. Vidya, all the head of the department of different departments from institute. So on behalf of Regional Institute of Ophthalmology team, I welcome you all as we embark upon our journey in fourth decade by celebrating the 30th RIO Foundation Day. It is important to remember and pay gratitude to the important contributors. Without this, whole concept of Regional Institute of Family couldn't have survived. So 1995, Sri A.N.P. Sinha was Senior IAS and Health Secretary who brought Regional Institute of Ophthalmology to IGIMS, and he took the courageous decision because there were 5 faculties who have joined there as a young fellow. So those 5 faculties were Dr. Sunil Kumar Singh, Dr. Nagendra Prasad, Dr. Subhas Prasad, Dr. Mrinal Anand, and Dr. Sudhir Kumar. So they were the founding figures of this Regional Institute of Ophthalmology. Later on, this team was joined by faculties like Dr. Bhavna Chawla, and the team was also assisted by senior residents such as Dr. Anil, Dr. Vibhuti Bhushan, who's at Jamshedpur, Nilesh Sir, Ranjan Rai, Sivendra Shahai. Many people were there. At that time, PG was not there. They all had one thing in common. That was burning desire to succeed and also serve the patients of Bihar. So in fact, they changed the face of Bihar. I'm sure for that. I was fortunate to work with them and learn also from them. From 1995 to 2000, they created a center of excellence, and they created many firsts. I'll not going to go into that. One thing was LASIK also, first time in Bihar. On lighter note, LASIK taught us many things apart from refractive surgery. I don't know how much refractive surgery we learned, but it taught us many things. So 2002 to 2007, RIO was not only at a standstill, but whole of IGMS was at a standstill. Nobody was ready to sign even for a needle. That was the situation. So rebuild phase came. So I want to pay my gratitude here to one of the IAS who taught me how to read financial rules. So Dr. Sri Arvind Singh, he gave me Bihar financial rule and said कि पहले इसको पढ़ लो तब कुछ काम करना. So that is how I started training into procurement, another thing. And then the director, Dr. Arun Kumar, had faith in me. So we started with the maintenance and repair of all the old equipments. And then we started procuring newer equipments like OCT and newer laser at that point of time. In between, we started feeling crunch of faculties. So we started recruitment also. Dr. Gyan joined. नीलेश सर के घर पे जा करके फॉर्म भरवा करके बुलाया गया. Rakhi joined, Anita joined, Ali joined, and we had our first success in establishing this institute. Dr. Deepak Mishra was the first DNB candidate at that point of time. He was working like a faculty here, so उसकी training वहीं पर complete हो गई थी सर. Faculty की भी training हम लोगों ने करा दिए थे. So this program, DNB program, ran successfully till 2020. 2020 we graduated to MS program. In 2012 we started feeling crunch of space as well as desire was there to grow. So I wrote down the first project that was worth 45 crore. The project was delivered to the Union Health Minister at that point of time, Dr. Sri Ashwini Chaubey at airport by me and Dr. Arun Kumar. And this project was revised from 2012 to 2017. Every 6 months it used to get revised. Every 6 months we used to get hope and then a despair that what we are doing, we are wasting simply our time. So golden phase came again in 2014. Dr. N.R. Biswas joined. I'm sure you all people must be enjoying this story because this is story of success of RIO. So N.R. Biswas joined from RPC AIMS itself. I still remember he wanted to talk to me from Delhi itself. Before talking to him, I had a talk with Rajesh Sinha sir. And he said, this is your golden chance to progress. तुम्हारे पास डायरेक्टर वैसे हैं जो कि ऑप्थेल्मोलॉजी से हैं of not only at an administrative edge but also created a goodwill among the masses, including the officials of government of Bihar, that they want to work. So that is how we started going. 2017 Sri Mangal Pandey became health minister and late Sushil Modi ji was there. who was working on organ donation, and I was there also. So we got the approval of this project in 2017 at airport again. In the airport lounge, fortunately, Nadda Sahab was there, Sushil ji was there, Mangal ji was there, and even Ashwini Chaubey was there. And I was also moving to Delhi for some work. तो मुझे तीनों चारों दिखाई पड़े तो मुझे लगा कि आज तो पकड़ लो. तो मैं गया अंदर जाकर के, and then I said कि सर if अगर आज होगा इस पे हाँ या ना तो ठीक है, अदरवाइज तो फिर तो अब टाइम वेस्ट हो रहा है. And fortunately, Nadda Sahab agreed to this proposal, and within 2 days we got the letter. So that is how this project, and the project which was written for 45 crore became 187 crore. Now, 3 legendary figures who inspired and gave direction to this project also. Dr. Professor R.V. Azad, Mangal Dogra sir, and J.S. Tityal sir, they were advisors to this project. And their fine tuning of the project had made all the differences, what you can see here. So the fine tune was like a master teacher, what you say, they tuned the whole project for benefit of the society as well as institute. Binde Kumar sir has extended faith in me and my team. RPC AIMS was always instrumental for us. जब भी कोई प्रॉब्लम होता है, we always look towards them. आज अगर आई बैंक को अगर मीडिया मिलता रहा है तो that is because of RPC. कोई ट्रेनिंग करना है RPC, कोई बैकअप लेना है, that we go back to RPC, and we are fortunate that they are helping us like we are one of their arms. So thank you everyone. Our present director Binde sir has extended his faith in me and my team for the project and virtually given blank check. So whatever I propose, usually it get through nearly 99.99% without any discussion. So that's the kind of faith they have given into me, and that is how we are working. So the story is quite long. In fact, a struggle of nearly 3 decades that can't be summarized in few paras or few slides. I'm fortunate that the God gave me the role of pivot. Now future, now we are 16 faculties. So here we are, 16 faculties, 7 senior and rest 9 new faculties who have joined, and they are full of energy. This program, this show is, they are organizing basically. So that is from their energy is coming. They are running the 5 sub-speciality services, and current patient load, which was earlier 350 to 400, has now grown up to 550 to 600 in a span of 6 to 7 months from the time we shifted to this place. Cornea and refractive, more than 1,000 transplants they have already performed, and they are doing a wonderful job. Dr. Nilesh Mohan sir is doing a great job in leading the cornea services. Dr. Rakhi, who is doing tremendous work as a teacher, as a researcher, as a contributor to the department, and now she is also into the administrative role as AMS also for the RIO, and she is looking after the academics also. So I don't know what she'll do with lot of burden in coming days. Now they have been joined with Ankita and Pallavi. They are going to join hand with these 2 seniors, and they'll give their best for the services. Retina and uvea services is being looked after by Abhishek Anand and Shivani, who is working here. And here I want to thank Dr. Abhishek Gupta, who is now faculty at AIMS Kalyani. He came way back in 2000, I think 14 or 15. He joined as a senior resident. So I said, ki, look, salary to tumko senior resident ki milegi. We'll give you opportunity to grow as like a faculty. So he was given free hand to establish the Vitreoretina services, which was re-established. Earlier it used to get done, but there in between there were no surgeons. So Abhishek Gupta worked, and this team of Abhishek Anand, Shivani Sinha, and Pratik Nishants are there giving right now the services. Glaucoma, me, Rashmi, Ravi, and Pinky, they are giving the services, and this department is already equipped with USG, with UBM, HFA, OCTA, electrophysiology, SLT, cyclogy for transscleral diode therapy, YAG lasers, and everything. Oculoplasty services is being led by Dr. Nigyan Bhaskar. Lab services is being led by Dr. Ravi and Department of Micro, and our scientists Dr. Lalan and Dr. Pankaj. Lalan is there? Dr. Lalan? So they are working very hard to establish the ocular lab for, in fact, identification of organisms to doing various research works. And the result has already started coming in, and that is how we are moving. Emergency services has already been established, and it is now running 24 hours with a full dedicated operation theaters and everything. Outreach program is being run under the heading that is Roshni, that is we are running with RPC AIMS. So right now we are running, I think, 3 projects with RPC. Roshni is one. Another one is on ocular oncology, retinoblastoma. We are going to start with Dr. Bhavna ma'am, and third one, 3 projects are running. Research and other things Dr. Rakhi will deal with. So what is future for RIO? In coming days, we are going to install and commission 9 modular operation theaters on the top floor. It is under, nearly it is being done in next 2 to 3 months. Establishment of proteomics and genomics lab for research work. PG right now we have 4 PGs per year. Next 10 PGs are, what we have got information that 10 PGs next year are going to join. We hope that we'll get 14 seats. We have ample patient load as well as faculties to train them. Simulation lab in the last board we have already got, and simulation lab we are going to set for the training of the students. Femto procedures, strengthening of VR services, and developing the key proposal of ROP Center for Excellence at RIO. So we are trying to create under the guidance of Ajad sir and Dr. Abhishek and Dr. Sivani are really working hard to develop a kind of a center of excellence for ROP that will get attached with the different sub-centers from the district hospitals and different district PICU, PICU and NICUs for giving the services, starting PDCC courses in all sub-specialities. So nothing is possible without the support and dedication of team. All the success till now belongs to RIO. Gyanji, Nileshji, Raki, Anita, Ali, Abhishek, my nursing team, technician team, administration of IGMS, accounts and store. At the end, want to quote one of the person whom I admire, whom I think one person whom I love also, President Kalam. His quote was there on my first page of this project also. The dream is not which you see while sleeping. It is something that does not let you sleep. So it is a dedication. It is we all are dedicated to President Kalam wordings, and let's dream of achieving excellence, and let's take the journey forward by taking small baby steps. Thank you everyone for coming to this place.
Thank you, Dr. Vibhuti. Now we move forward with the academic achievements by RIO by Dr. Rakhi Kusumesh.
Very brief. Good afternoon, everyone. Today in this presentation, I'll be briefly introduce the academic activities of the department and the achievement made during the period of 2022 to 2025. So as you all know, that RIO has always been a prestigious institute of the state, and it was established in 1995 with the aim providing a state of art for teaching, optimizing healthcare, reducing the number of outside referrals, promoting research activity in the state, and conducting community-based survey to know the exact or prevalence of ocular morbidity. And with the dedication of past and present respected directors, HODs, faculty, staff, and of course alumni, RIO has now grown to a center for excellence. So currently RIO runs 2 degree programs, a master in surgery in ophthalmology and bachelor's in optometry. We have senior residency program, and frequently we conduct short-term training programs as eye bank training. In patient care, RIO provides all subspecialty care, glaucoma, retina, oculoplasty, cataract, cornea, ocular surface, refractive surgery, eye banking, neuro-ophthalm, low vision aid services, contact lens services, and recently pediatric ophthalmology is added in this list. In clinical trial and research project, as you all know that the RIO has always focused towards the research and innovation. So our faculties and residents, they are working many extramural and intramural projects. Some of the projects are completed and published, and few are in pipeline and in process. There are some multi-centered projects also. Our postgraduate students are actively participating their thesis to bring out something new and beneficial to the patients. Over the years, RIO has become more focused toward the research, and in last 3 years, it's a good news for us that we have significantly improved the number of publications in many reputed international, national and state journals. I would like to name few of them like Cornea, British Journal of Ophthalmology, American Journal of Ophthalmology, and our own Indian Journal of Ophthalmology and MIAZO, and so on. Residents are not behind, they are also publishing their articles in the PubMed index journals and the non-index journals. Apart from these research activity and the teaching, our esteemed faculties and residents have been awarded with prestigious award in the field of research and the patient care. So these are few awards documented here. And this is the result of their dedication, sincere work, and definitely the name of RIO, because RIO is growing a lot. Yes, you know. So this was all about the academic activity of last 3 years, and we hope to extend the list in the achievement and the milestones in coming years under the leadership of our HOD and the support of all faculties and staff. Thank you.
Thank you, Rocky, for being brief and elaborating the research activities of RIO. Now is the time we move on. I would request our Chief RIO and DDIGMS, Dr. Vibhuti Sinha, to felicitate our Chief Guest, Professor R.V. Azad sir, who has been our mentor, guide and teacher since early days. I request Dr. Vibhuti to felicitate our director, Dr. Binde Kumar sir, who has been so always cooperative, supportive and trusted us in all our activities since his joining as a director and being as a faculty over here also. May I now request Dr. Gyan Bhaskar to felicitate our guest of honor, Dr. Om Kumar sir. Dr. Om Kumar is a known personality in IGMS, as Dr. Vibhuti earlier said, a sports person and the Dean of IGMS also.
May I request Dr. Nilesh Mohan sir for felicitating a special invitee, Dr. Lalit Verma sir. May I request Dr. Nilesh Mohan sir also to felicitate Dr. Professor Radhika Tandon ma'am.
Now, I would request for Dr. Aniket for a book release on genetics and genomics in ophthalmology by our faculty of RIO. He is a faculty of RIO. So since RIO is growing now and the future activities will be on research, primarily apart from the patient care, so genetics and genomics, these are a very important aspect in ophthalmology, which will lead us in the future direction. Thank you. There is also a book release from our chief guest, Professor Azad sir, named, he'll name it himself. Sir, aap hi bolenge. Named Sone Ka Haar. I want Haath. Sone Ka Haath.
Make a small introduction to this book. That very title, Sone Ka Haath. I was in Kuwait. So obviously I went for retinal surgery there. There was a guy, Arabic. And I saw him. I said, you have got retinal detachment, so we'll operate. So I went, came back to my house and told sister to prepare. In the meantime, that patient, he called the local eye doctor. And he said that I don't want to be operated by the Indian doctor. I want to be operated by you. And that local doctor said that I will not be able to operate on you. He will only operate because we have called him from Delhi only for this. So I operated on him. He's a big, I still remember, he had a, nasal side, a very nasty, horseshoe tear and a big detachment. So I operated, he became all right. 10th day when he came for follow-up, I said, your vision has improved. तुम्हारा आँख बिल्कुल ठीक है, सब कुछ ठीक है, रेटिना तुम्हारा बैठ गया, सब कुछ ठीक है, तो सही है. He said, doctor, can I say something? I said, yes, please do. He said, doctor, you have a golden hand. So that is how it is a golden hand. And I said that मैं कुछ नहीं करता हूँ, ऊपर अल्लाह है, भगवान है, वो कह देता है हम कर देते हैं, जिसका अच्छा उसी का, अगर बुरा तो भी उसी का, मेरा कुछ नहीं है.
Thank you so much, sir, for sharing your experiences. I would request Gyan Bhaskar to felicitate the most important personality of Bihar Ophthalmological Society, who has been kind enough in organizing this. Dr. Satyajit Sinha, Secretary of Bihar Ophthalmological Society. And may I request Chief RIO to felicitate our Chairman Scientific Committee of BOS, Dr. Gyan Bhaskar. Sir. खत्म लास्ट हम लोग रहेंगे. I request our chief guest to felicitate the chief and DDO of RGMS, Professor Vibhuti Sinha, for his tiring efforts. I have been personally seeing his meticulousness and his efforts which he has done. Definitely the support has been there for all corners, but his dedication and his support is beyond explanation. Thank you so much, sir. And with this, now I invite Professor Dr. Lalit Verma, sir, for his address.
Professor Azad, my mentor and my teacher, guest of honor, Dr. Binde Kumar, and Chief Representative Dr. Radhika, then Dean Dr. Om Kumar, and all the dignitaries, Satyajit, my dear friend. You see, at this occasion, I just want to emphasize 2 or 3 things only. One is, I've seen the progress of Bihar, Bihar not politically, politically Bihar is doing very well, but the academics which has not only, especially for the ophthalmology, I have seen RIO rising very high, the Bihar Ophthalmic Society rising very high, and also Dr. Ajit is here, even AJEH is doing a wonderful job there. So these 3 things I've seen very well, you know. They are so-called unsung heroes. You have to visit AJEH to see what wonderful job they have done. And as far as RIO is concerned, you have heard the success story of RIO right from for last 1995 se leke ab tak, for 3 decades, how everything happened at airport. Everything Vibhuti said happened at airport. But believe me, it's not one-man effort. It's you know, generational effort, right from Sudhir, Nagendra, and so many other people. Subhash, they have worked very hard. Previously, when I used to come to Bihar, it was only Subhash Prasad har jagah naam hota tha. But now you see, so many people are doing such great job, and you see what this RIO stands today is a total transformation. The initial visit when we had come is a total transformation, and it's a living example of what I call what hard work can actually, you know, result in. This is a total dedication of a lot of people, but I still salute the efforts of Vibhuti and Nilesh. They have done so much hard work, and I wish them all the best. With couple of advices which I am fond of giving every time, is that in the you know, once you are doing service component very good, you are jumped from 300 to 600, maybe very soon to 1000. But do not forget the PG teaching program, because they are the backbone of any organization. And Radhika was telling so much advice about you know, how she has learned and she has made others learn also. And second thing is international collaborations should always be there, so that this RIO remains in the limelight always, not only in Bihar, nationally and internationally also. You should also have a RIO alumnus body, so that they, you know, like we have in Harvard, everywhere, they are permanently attached here, and some scroll of honor, so that future mein kuch chahiye, they also become donors also. You know, Harvard, yeah, everyone progresses like this only. And the future of RIO, I think, is bright, and I just wish that this energetic team keeps working very hard, and pays a lot of attention to what was being presented by Raki about the publications. Do not forget about this. You see, hota kya hai ki you should keep half day off. You should have regular faculty meetings so that attention is on the research and publications. So half day meeting in office of Vibhuti will tone everybody up so that they can keep pursuing this path of research, service and publications. What LP Agarwal did for RP Center, and I wish Vibhuti will do for RIO also. Thank you very much.
Thank you so much, sir, for your encouraging words. May I now request Professor Radhika ma'am to address us for thanks.
Respected Director, Dean, Dr. Bibhuti, Dr. Sinha, everybody on the dais, and of course Professor Azad. It's been a wonderful morning, having seen this great achievement which the RIO has sort of dedicated, I would say, to the state, and very nicely put how it's been a journey which involved a lot of personal intervention and what is the, you can say, dabang. It required that dabang attitude ki you have to get it done and you have to somehow go a little bit out of the box. So that has definitely made a huge difference in getting things done. The other important thing is that this can be a role model for so many other institutes who are starting their journey, that it's often one cannot go totally by the book. You have to have that personal drive and conviction, and you have to have a certain rapport with the policy makers, because often that can make things very complicated. You have to have that kind of thing कि मुझे ये करना ही है, किसी तरह करना ही है. It's for a good cause. It's not that you're doing something which is bad. It's just that you have to do it for a good cause and you have to push for it so that they understand the need of the hour and then they support you at every step. So firstly, it's really remarkable that at this young age you've achieved so much, because earlier when things were not available, then somebody achieved something, it was, like there was not that much of competition. But in this day and age, to have achieved so much so fast, with, general tendency is ki kyun kare, kya kare, and, rehne do. So that kind of thing you have overcome. I would really give you heartiest congratulations and really hope that you go ahead very fast. Thank you.
Thank you so much, ma'am. And now I request our Dean IGMS, Professor Om Kumar, to address the gathering.
Respected Professor R.B. Azad, sir. Respected our Director, Professor Binde Kumar ji, Professor Radhika, Professor Lalit Verma, Dr. Satyajit, Gyan Prakash, Dr. Vibhuti, Dr. Nilesh, all other dignitaries, they are present in the hall. I have listened Dr. Vibhuti narrating the journey of RIO. Fortunately, I was also in this institute since 1996. So I have seen how RIO has grown from one table and few chairs to this magnitude. And as we do eye care, sight care in RIO, I have witnessed a leadership with vision and foresight can bring a great change in any sphere of medical institute. So as Dr. Vibhuti was saying that Mr. A.N.P. Sinha visualized the idea of RIO, and then subsequently Dr. N.R. Vishwas, and now Dr. Binde Kumar is shaping the growth of RIO. As a nephrologist, I am a nephrologist. I am only concerned with presence of NPDR, DPR, clinically significant macular edema, VEGF treatment, and they are sending patient for reference for nephrological clearance, whether they should be given dye for FFA or not. Later on, when Professor R.B. Azad came to Patna, then I heard about ROP. what is ROP. And now, with so many good friends in RIO, I am also learning so many things, what is happening in RIO. So, we all have witnessed the tremendous growth of RIO, and I congratulate the organizing team of RIO for having such a meeting of such magnitude. And whenever anything succeeds, everyone tries to, that I am also associated with this successful model of the thing. And as a dean, I can say that I am, with my honorable director, I am also involved in selecting the faculty members for RIO. And I am sure that Dr. Vibhuti and all the experts who have come from outside, they have witnessed that we have done a good job by selecting very good people who can bring laurels to this RIO Institute. So I give congratulations to all the faculty members who have joined recently RIO, and I wish them all success in life. With these few words, I thank you all for coming here. Thank you.
Thank you so much, Om sir. You have been a witness to this RIO journey from its nascent step. So now is the time for the felicitation of our guest faculty. I would request our chief guest, Professor Azad, to felicitate our guest faculties. I would request Dr. Arvind Jaiswal, who is a senior ophthalmologist of Patna. Please kindly come up, sir. He has been a past president of Bihar Ophthalmic Society and a guiding force in every sphere, picking up talents, and president of Eastern India Zonal Ophthalmic Congress, IZOC also. So we are really humbled for your presence over here. Thank you so much for being here. Professor Kirti Singh, ma'am. She has been an ex-director of GNEC and treasurer of DOS Society. Thank you so much, ma'am, for being here. Dr. Subhadra Jalali, ma'am, you have taken pains to come up here. Thank you so much, ma'am. Where is the cordless mic? Cordless mic कहाँ है? बोल रहे हैं तब से. लो. दे दिया. दो. Dr. Santosh Honavar, sir, who is the secretary of AIOS. Welcome you, sir. You have also been here with us since past days. आगे. आजाद sir को. Thank you so much for your presence, sir. You have always been here as a teacher to our residents also in previous programs. Welcome you, sir. Thank you so much for coming. May I now request Professor Rajesh Sinha to be here. This is a face known to all the residents and all the faculties over here. He has been with us in each and every moment, right from RIO's, this building's inception, and help at all corners, be it an installation of machine, helping in training, at a personal level. It's not only on a CME level.
So thank you, Rajesh. Now I request Dr. Deepak Mishra. He was our first DNB from our institute, now a professor at IMS BHU. Now it's a privilege to see this kind of a journey when you see your students growing up to that stage, and he has owned up this institute. He doesn't feel that he is in another institute. He fights for this institute when he's outside. So thank you, Dr. Deepak, for this. For being so possessive about this institute. So it's for the betterment. It will always be for the good, and you're doing fantastic over there. Now, may I now request our director, Dr. Binde Kumar sir. He has left. Acha, sir, sahi kara. May I now request Dr. Manish Singh, a smiley figure from Kolkata. Thank you for being here and being a part of our Foundation Day. Dr. Love, he's taken. Dr. Amitabh, where is he? Dr. Amitabh and Dr. Manish. These two are persons, I mean, they come up to our place at a very short notice. Thank you for so much for being here. May I now request Dr. Binde Kumar sir to come forward and felicitate Dr. Shahid Alam. Thank you, Dr. Shahid, for being a part of our journey. Thank you so much for being here. Dr. Lalit Agrawal. It was nice to see your talk, and please, thank you so much for being here. Yeah. Acha, wow, that's an additional thing. Your work in ROP is definitely will be inspiring for many of the future residents. Thank you so much for being here. Dr. Vivek Singh. Vivek Singh, another alumni of this place. He was a DNB from our institute, and it's really a pleasure to see your students working nicely and bringing laurels to institute in a good way. So thank you, Dr. Vivek, for the good work which you are continuing, and welcome you here. May I now request Dr. Lalit Verma sir, please, to felicitate our residents of RIO for their, this is a part which we definitely always look forward to appreciate the good work. Dr. Neha Kumari. Dr. Neha is here? Yeah. Neha, a very dedicated senior resident. She has just finished off her senior residency and a frontline worker in all aspects academically, being the strategic work of RIO. She will be an asset to the institute wherever she is. So, thank you. Dr. Nisha Jha. She is also working as a senior resident RIO. She is actively involved in training the junior residents, as well as I know when she completes a senior residency, she would be again an asset to that institution wherever she is. So, Dr. Nisha. Dr. Manish Karn, again is working as a senior resident at RIO, doing wonderful surgeries and actively involved in teaching and training. And she's actively doing vitreoretinal surgeries, and this faculty is being strengthened by his presence. Dr. Abhishek Kumar, very soft-spoken, silent worker, and a very good surgeon with clean hands, popular among junior residents and training them. Now, there are two junior residents who have done exemplary performance. Dr. Akansha Sinha. Akansha Sinha. She's a final year student. What was that award? iFocus. Recently, she's very good in academics, and I think she will do very good in her future. Dr. Drishti. The duo of these two residents, they are doing exemplary good work. Thank you, Lalitha. May I now request our guest of honor, Dr. Binde Kumar sir, for his concluding address.
Dignity on the dais, the doyen of Ophthalmic Society, Ophthalmology, not in India, internationally, Professor Rajvardhan sir, Azad sir, the Radhika Tandon ma'am, Chief of RIO, RP Center, Delhi, Professor Om Kumar ji, Dean Academics, Professor Lalit, Professor Satyajit Singh, Professor Gyan Bhaskar, and my friends sitting in the audience, Dr. Rajesh Sinha, Dr. Kirti, Dr. Nagendra, and all the participants. The 30 years of serving humanity, the 30 years of giving eye care, vision to the needy population, and for the 30 years for being a beacon of hope in the field of ophthalmology in Bihar. RIO, in his 30th birthday, deserves a warm clapping. The 30 years just not only reminds us what the contribution the predecessors have done and how these things have been taken off. Dr. Bibhuti Prasad Sinha has just given a glimpse of that. Important is that where we are standing today, from here to where to go, from innovation to the cutting edge surgical technology, we are bound to have everything at RIO. The simulation lab is in the offing, and I think in the 3 to 4 month time, a simulation lab will be there, where every trainee will have the needed exercise to get the practice done before shifting to the original patients. And that is one great achievement we are going to have. All the modern gadgets, wherever and whatever available, anywhere in the country or outside country, we are just confident, and we are promised ourselves to bring it in RIO so that it will always be a leading from front in the field of eye, not only in the state of Bihar, but also in the country. This is my way of looking the things. I appreciate, and I must congratulate the whole team which is sitting on the dais and off the dais, and all the dignitaries who have come on this occasion, grace this occasion, and bless this beautiful place, RIO, in field of ophthalmology. What they are doing, we are very much proud of you. I congratulate again, and I pray that God will give more courage and more efforts so that we can give the needing population of Bihari population, not only Bihar, the whole eastern region population, a hope that their eye will be taken care of. Thank you very much.
Thank you so much, sir. May I now request our chief guest, Professor Rajvardhan Azad sir, to address our gathering.
You know what, I talked to him because I had made a presentation, so I thought that, you know, because it's already getting late and Radhika has to go somewhere, I don't want to disclose. So the director of IGIMS, Dr. Binde, मेरा एक प्रॉब्लम है, मेरा प्रॉब्लम ये है कि जहाँ भी हम जाते हैं तो I have the advantage of calling everybody by name. But others don't call me by name. If somebody would have called me like Santosh, like Soni, like Subhadra, like Pranav Ranjan ji, like Arvind, ये इधर बैठे हैं हमारे विभूति, नीलेश, राधिका, डॉक्टर बिंदे, डॉक्टर ओम कुमार, ललित, सत्यजीत और ज्ञान भास्कर, और ये दुलरुआ जो ये है क्या बोलते हैं फैकल्टी है बनारस का, ये दीपक और राजेश, कीर्ति, नगेंद्र, सुभाष, जितने लोग हैं यहाँ पे, तो इतने हमको ये एडवांटेज है. दूसरी बात, मैं वहाँ बैठा सोच रहा था कि ये चीफ गेस्ट को हमेशा बाद में क्यों बोलना होता है, लास्ट में क्यों बोलना होता है. बड़ा प्रॉब्लम है. प्रॉब्लम ये है कि जब सब कुछ सब बोल ही लेता है तो चीफ गेस्ट के लिए बचता क्या है. No, it was very nice to hear the journey of RIO, and Dr. Om Kumar said, that ROP first workshop was held here. And I used to carry video indirect. And with that video indirect, first time I showed that ROP hota hai. And not only here, I did it in HV Desai Hospital in Pune. Pune, there we demonstrated it, and many other places. And then we also had a training of trainer workshop here. This was by the Ministry of Health, Government of India. And I think Dr. Radhika was here, I was here, and then Dr. Dada was here, Vimla Menon was here. So, I mean, it was a subspecialty kind of, training which was imparted here. About DNB, ये है ना first उसका beneficiary. DNB, when I became the president of National Board of Examination, that time बिहार में कोई भी इंस्टीट्यूट नहीं था जिसमें DNB था. तो it came to my mind कि बिहार में इतना पोटेंशियल है यार, इतना बड़ा हमारा IGI-MS है, तो इसमें तो होना चाहिए. इन्होंने मांगा नहीं मुझसे, I called them. मैंने कहा भाई आप आइए और DNB लीजिए, and I gave them. The another center which was here was Mahavir Cancer Center. Mahavir Cancer Center, Dr. Jitendra was there. I call him. I said कि जितेंद्र जी आप इतना अच्छा काम कर रहे हैं कैंसर के बारे में, तो आप DNB लीजिए, आइए भेजिए. उसी तरह से ये कार्डियोलॉजी का इंस्टीट्यूट था, इंदिरा, हाँ, उसको उस समय डॉक्टर अशोक ठाकुर थे उसमें, ही वॉज द डायरेक्टर. मैंने कहा आप आइए लीजिए. मैंने अखोरी का जो हॉस्पिटल था वहाँ कंकड़बाग में, दृष्टि, उसको कहने का मेरा मतलब ये है कि आई वॉन्टेड दैट बिहार शुड ग्रो, एंड इट हैज ग्रोन लाइक एनीथिंग, एंड क्रेडिट गोज टू दिस गाय फॉर RIO. एक बात आप जान लीजिए, हम तो यूनिवर्सिटी सर्विस कमीशन में चेयरमैन भी थे यहाँ पे. बिहार में कोई चीज शुरू करना, उसके बारे में सोचना, और उसके बाद में शुरू करना, और उसके बाद में धरातल पर उतारना बहुत मुश्किल काम है, बहुत मुश्किल काम है. ये वैसे लार्जली होल ऑफ इंडिया में है, लेकिन हमारे राज्य में कुछ ज्यादा है. आई हैव नो this thing grudge or I have no hesitation in saying that this is like this. If it is like this, this is like this. And we are only responsible for this. No one else is responsible. So anyway, the RIO has come up to this stage, and whatever my contribution is needed, Dr. Binde was sitting next to me and we talked many things. We talked about the optometry course also. The nomenclature has been changed. Optometry from BSc Ophthalmic and many other. I think this is the, the national body where I was there, one of the person who was involved in the optometry program, curriculum development, and the nomenclature and many other things. So that has not been established, and that is now being followed in Bihar also, and credit goes to Dr. Binde. And many other things are happening here. The way this, the institute has been, thought of, and has been established. See the labs, today the labs were there, ocular pathology, ocular pharmacology, ocular microbiology, radiology, anesthesiology, ये सारा जो है यहाँ ये CT स्कैन कर रहे हैं. CT स्कैन जब हम चीफ बने तब मैंने RP सेंटर में किया. वो शर्मा, संजय शर्मा is the head of the radiology, ocular radiology department. So when I became chief, I got the CT scan there. What I'm saying is that now, because good thing is that the way it has been conceptualized, this is for coming 20, 30 years. They have a lot of space. He used to come to me initial period, when they were thinking of this institute. And I had told him कि विभूति ऐसा करो कि बैठने का खूब जगह हो, ताकि पेशेंट जो आने वाले 10 साल 20 साल में पेशेंट को दिक्कत नहीं हो. एंड दैट इज व्हाट ही डिड. अब देखिए ये जो है ऑडिटोरियम आपका, दिस वन ऑफ द फाइनेस्ट ऑडिटोरियम. एंड लाइक दैट वाइज likewise one library is there. When I became chief of RP center, we started e-library. हम तुमको कहेंगे e-library शुरू करो यहाँ पे. So you can start the e-library here. You can start the skill development workshop here, like we have in RP center, skill development. वहाँ पे जो है वो कमरा खाली पड़ा हुआ था, उसमें कुछ instruments वगैरह पड़ा हुआ था. So I want to disclose one thing here, that the Alcon people came to me and they said कि सर हम इसमें आपको इंस्ट्रूमेंट दे देते हैं, हम लोग यहाँ लैब कर लें सर. तो मैंने कहा ठीक है. तो उसने प्रपोजल दे दिया, सारा कुछ बन गया. अब मैंने एडमिनिस्ट्रेशन से बात किया कि भाई ऐसे ऐसे है, वो कमरा पड़ा हुआ है, इसमें हम यहाँ पे वर्कशॉप शुरू करेंगे, स्किल ट्रेनिंग, नेशनल स्किल ट्रेनिंग सेंटर हम करेंगे इसमें. अब उसमें लोगों ने मुझे, एडमिनिस्ट्रेशन ने कहा कि अरे ये तो डायरेक्टर के पास जाएगा, फिर डायरेक्टर देखेगा, फिर वहाँ से जाएगा मिनिस्टर के पास, तब मिनिस्टर अप्रूव करेगा. हम क्या काहे का यार, अरे हम कोई अपने बेनिफिट के लिए कर रहे हैं. हम तो जो तमाम लोग हैं बाहर के, हिंदुस्तान के जितने ऑप्थेल्मोलॉजिस्ट हैं वो आएंगे, वो यहाँ ट्रेनिंग लेंगे. मैंने उसको वहाँ कर दिया और वो आज अच्छा चल रहा है. मेरे कहने का मतलब ये है कि अगर अच्छा काम करना है आपको तो किससे घबराने की जरूरत है, क्यों घबराने की जरूरत है, हमको करना ही करना है, बस सिंपल. तो ये एटीट्यूड हम चाहते हैं कि सब कोई ऐसा करे और आप करिएगा. हम ये नहीं कहते कि भाई गवर्नमेंट रूल्स को उसको बेंड कर दो या तोड़ दो, बट विद इन गवर्नमेंट रूल्स देयर आर लॉट ऑफ ग्रे एरियाज आर देयर, एंड इन दैट ग्रे एरिया यू कैन वर्क एंड यू कैन गेट मेनी थिंग्स डन. आई डोंट वांट टू टेक योर मोर मच टाइम, क्योंकि आई एम वेरी कॉन्शियस अबाउट टाइम, कि जब भी कहीं हमको अपॉइंटमेंट होता है 15 मिनट हम पहले ही पहुंच जाते हैं. तो इसलिए मैं ज़्यादा वक्त नहीं लूँगा. और मैं जितने बच्चे बैठे हुए हैं यहाँ पर, देखो बेटा एक चीज़ ध्यान में रखना, काम करोगे तो ही फल मिलेगा. हमारे गीता में लिखा है ना, कर्मण्य ध्येय वादिकारस्ते माँ फलेषु कदाचन. फल की चिंता मत करो. मैंने फल की चिंता नहीं की. मैं PMCS से उठ के गया वहाँ RP सेंटर में, और RP सेंटर से उठ के गया तो मैं क्या बताऊं, कोई वर्ल्ड का कोई कंट्री नहीं बचा होगा जहां मैंने लेक्चर नहीं दिया. तो आप भी ऐसा कर सकते हो, आप में क्षमता है, यू हैव द कैपेबिलिटी, बट ओनली थिंग इज यू हैव टू हैव द डिटर्मिनेशन. सो दैट्स ऑल आई वांट टू से, एंड इट्स वेरी गुड एंड वेरी नाइस, एंड सी अ ब्राइट फ्यूचर फॉर RIO हियर. थैंक्स टू विभूति, नीलेश, राखी, और ये नया लड़का है, ये शिवानी है, ये कहाँ गया अभिषेक, यहाँ बैठा हुआ है, मेरी बात सुनता नहीं है ये. तो और जितने तमाम लोग हैं यहाँ पे, तो आई एम वेरी हैप्पी विथ ऑल ऑफ यू. यू आर डूइंग वेरी गुड वर्क. प्लीज कंटिन्यू इट. थैंक यू वेरी मच.
Thank you so much for your encouraging words from the bottom of our heart, sir. Thank you so much. May I now request Dr. Abhishek Anand to give the vote of thanks. Dr. भूल गए थे. दिमाग से ही उतर गया था.
विभूति जी ने हिस्ट्री की बात की, तो मैं उसके पहले की बात करता हूँ कि जब PMCS से RIO यहाँ आया IGMS में, डॉक्टर ये मिस्टर एनपी सिन्हा थे एंड डॉक्टर यादव यहाँ पर डायरेक्टर उस समय हुआ करते थे। तो मैं और प्रोफेसर पीसी गुप्ता की काफ़ी मीटिंग यहाँ होती थी एनपी सिन्हा के साथ में और यादव जी के साथ में भी। और फैकल्टी का जो भी मैंने क्राइटेरिया हमने 2 जगह से मंगाया था, एक अहमदाबाद से और एक चेन्नई से RIO का। उसी हिसाब से फैकल्टी पोस्ट का पहले प्रोफेसर गुप्ता और सब लोगों ने मिल करके ये चीज़ किया गया था। तो ये है नींव के पहले की बात, नींव के पत्थर की बात। धन्यवाद।
So how is the Joes guys? Marathon inauguration session.
So this time, as Dr. Vibhuti said, the young brigades, we have just assisted the young brigades in organizing this. So he is the chief organizing secretary of this Foundation Day celebrations, and he'll be giving the word of thanks. Huh? And where are the two organizing secretaries? Ankita and Dr. Shivani.
Yes. आइए, मेरे right and left hands, please. So around 6 weeks back, विभूति सर passed me the baton कि भाई अब कुछ करना है 30th RIO Foundation Day में। और I think कि I will thank Dr. Rakhi ma'am for coming up with the idea कि pediatric eye करते हैं. It will converge, this small eye will converge all the different specialties of ophthalmology. So thank you for that. Thank you everyone for being a great sport, coming all the way from all the parts of India. Subhadra ma'am has come at 7 a.m. Ma'am, I was sure about you that you'll come at 7 a.m. Start the session at 10 a.m. So thank you everybody. Thank you all the national faculties. Deepak sir, you traveled from the road. Thank you sir. Thank you all the state faculties. Thank you for great orations, Lalit sir and Radhika Tandon ma'am. So thank you all. Thank you AV team. Thank you all the faculties, our Maya Coordinator. Thank you residents and juniors. And I think we are running late and we should go on with the show. Thank you. Thank you everyone. Have enjoyed. The lunch is open and we'll continue with the scientific deliberations.
With this we come to the end of the inaugural session, and we'll continue with the, before we continue with the next session, let's stand up for the national anthem.
पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मांगे गावे तब जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you everyone. With this we come to the end of the inaugural ceremony, and very quickly we'll start the ocular surface disease, the next session, because Professor Rajesh Sinha will be delivering the keynote address right now, because they have to move after delivering the deliberation. So please, the moderator of this session, Dr. Pallavi, please continue.
Good afternoon everyone. Now we'll move to our next session, cornea and ocular surface disorder disease. I would like to call our chairperson, Dr. Nilesh Mohan sir, to take over the dais. Dr. Chandrasekhar Prasad sir, Dr. Randhir Jha sir, Dr. Amit Raj, Dr. Rakhi Kusumesh ma'am, and Dr. Priyanka. I would like to call upon our panelists, Dr. Abhishek Ranjan, Dr. Rashmika Singla ma'am, Dr. Ashish Kumar, Dr. Vandana Tiwari ma'am, Dr. Vandana Prasho, and Dr. Ujjwal Prakash sir.
I request those who are interested to cornea, they must stay. There are few very good speakers here during this session. So everyone please be seated.
Dr. Nilesh Mohan sir, Dr. Chandrasekhar sir, Dr. Randhir Jha, Dr. Amit Raj sir, and Dr. Rakhi Kushumesh ma'am and Dr. Priyanka ma'am to take over the dais.
लेना ये ऐसे लोगों को भूख लगी हुई थी हम मालूम है नहीं ओपन होगा तो भागे गए इसलिए ओपन नहीं कर रहे थे ये तुम्हारा वाला लगा हुआ ना
I'll introduce Dr. Rajesh Sinha sir. Sir is working as a professor of ophthalmology in the cornea, cataract and refractive department at Dr. Rajendra Prasad Center for Ophthalmic Sciences, AIMS, New Delhi. He has done his specialty training at RP Center, AIMS, and that time he was awarded as a best resident in 2002. He has done DNB, FICO, FIACLE and FRCS. He has done fellowship at the University of Washington, USA. He is currently the president of DOS. He has also worked as a general secretary of DOS during 2013 to 15. Sir is also working as general secretary of SCARIS. Now, he has more than 131 indexed international and national publication. Over to you, sir.
Thank you very much. And I guess most of us who are sitting here might be hungry, or some might have had their lunch and they have come back. So, well, before I start, I would just like to congratulate Team RIO and whole of Team RIO, including Dr. Vibhuti, Dr. Nilesh, Dr. Rakhi, Anita, and all the new young brigade as well, for having this wonderful, can you just dim this light, please? For having this wonderful place to work, because it always gives you a lot of a very good feeling when you are working at a place wherein you have all these facilities available. You have such a huge area wherein you can that gives you a feel-good factor as well. And I would like to congratulate you, wish you a very good, a very nice foundation day, and again I would like to thank you for having me here. So this is my first opportunity to actually do a formal presentation in this hall, although I had discussed with a few faculty members earlier in this hall when this was being constructed. So I'll be talking about pediatric, as Rakhi has kept the theme of pediatrics. So this was pediatric cataract that I was asked to speak on. So I'll be talking about pediatric traumatic cataract. Now, children are prone to develop trauma. It can be blunt trauma, it can be penetrating trauma, it can be any other trauma. So when you have a pediatric traumatic cataract, the classical picture is this rosette-shaped appearance, but you can have a total cataract, you can have a subluxated cataract, you can have a partially absorbed membranous cataract. Wait. एक मिनट. Okay, sorry. Take. It can be a partially absorbed membranous cataract. It can be there can be anterior capsular defect with floc-length material in the anterior chamber. There can be associated trauma to the cornea and uvea. There can be prolonged self-healing kind of a wound with a adherent glaucoma with a traumatic cataract. So all these kinds of presentations can be there. The key to all this is doing aspiration of the lens matter and implantation of IOL so as to provide visual rehabilitation, and also to do additional procedures for associated pathology. It also depends on the time of presentation. Somebody who has a traumatic cataract but having a corneal perforation as well, so you would like to repair the corneal perforation at that time and do a cataract surgery later. Why? Because if you do the cataract surgery, put an IOL at that time, there is risk of fibrinous AC reaction with pupillary membrane, and because of this trauma there will be corneal edema, the visibility will be poor, there will be chance of inaccurate IOL power calculation. So all these factors are there. But if there are flocculent lens matter in the anterior chamber, you would like to aspirate it, leave the patient aphakic, plan for a secondary IOL later, remove all this suture and see how the keratometry stabilizes, and then you will have an accurate IOL power calculation. You can have varied type of presentation when we talk about traumatic cataract. You can have a simple kind of a traumatic cataract wherein you don't have a damage to iris, don't have a damage to cornea, no damage to the capsule. It's just like any other routine pediatric cataract. So in such a case, what you would like to do, you would like to do an anterior rhexis first, and then aspirate the lens matter, completely, thoroughly clean the cortical fibers. And if the child is less than 8 years of age, then do a posterior capsular rhexis as well, and then put an IOL in the capsular bag. So this is how it goes. But this kind of a scenario is seen in very less number of cases. You can have very different kind of presentations which are more complicated. You can have a partially absorbed cataract wherein the what happens that there is a micro perforation in somewhere in the capsule, and that results in absorption of the cortical fibers. That results in even sometimes calcification of the cortical fibers, and wherein you have to feed in the cortical fibers into the aspiration probe. Then you can have this posterior capsular plaque. Because of the absorption of the cortical fibers, sometimes you do get posterior capsular plaque. So what to do in such a case? You try to create a cleavage plane between the plaque and the capsule, and if you can create a cleavage plane, then you can remove the plaque completely. If you are not able to create a cleavage plane, then you may have to do a central capsulotomy in order to make a opening, clear the visual axis. So once you create a cleavage plane, you can lift it up with a forceps, and then you can put the IOL. If you have a membranous cataract like this, you can just do a membranectomy central and put a multi-piece IOL in the sulcus. Sometimes due to trauma, you can have a pre-existing posterior capsular defect. I just stopped here because I just want to emphasize two things in such a case. When will you suspect that there is a pre-existing posterior capsular defect? When the cataract progresses very fast and it becomes total cataract very soon. Then this means that there is some breach in the capsule and there is fluid that has been imbibed into the lens, and that is why it has become total cataract very fast. And second, if you are suspecting such a thing, you can obviously use some instruments like Cassia, etc., some other instruments, UBM, to see whether there is any lens matter in the anterior vitreous cavity. And then if you have that doubt, then wait for a couple of months, so that this margin, whatever damage has happened, this fibroses. And once it is fibrosed, then it will not extend when you are removing the lens matter, and the lens matter will not fall behind. And when you are implanting the lens into the bag, you can put it into the bag. You can see here it is fibrosed, it is not enlarging, because we waited for a couple of months for it to fibrose. And then you can implant the IOL in the bag, and once it's in the bag, you can see it has not enlarged again. And when you have implanted, one haptic is in the bag, you don't dial it. Just simply gently nudge it underneath the anterior capsule so that you don't manipulate too much, and this is how you can manage in a pre-existing posterior capsular defect. Sometimes you can have an intralenticular foreign body that can be present here, Now, if you have, as you can see here, there is a damage in the iris here. From here it has gone, and there is a foreign body situated here. It was a chisel and hammer injury. The boy was standing somewhere near that when somebody was working, and it went into the eye. So in such a case, again, I would like to send two messages. One, you have to do a capsular excess and do the cataract surgery. Now, if the opening is in the center, you include that in the capsular excess. But if it's outside that center, then you exclude that, make the excess inside. So you make it inside. The second thing I would like to emphasize here is that when you are doing a hydro procedure, do a very gentle hydro procedure so that this foreign body does not move. And you don't remove it with the forceps by pushing the forceps inside, otherwise you will push the foreign body inside. So you just debulk the nucleus little bit, just debulk it so that you create space. Once you have created a space, leave the remaining lens matter, hold the foreign body, see to it that the foreign body doesn't move inside the lens, otherwise it will damage the posterior capsule, it will go posteriorly. Once you have held it like this, you can take it out and then remove the cortical fibers and then put the IOL in the bag. Another scenario I would like to tell you, there can be two such scenarios when you have a traumatic cataract with iridodialysis. Now, this is a membranous cataract, absorbed cataract with an iridodialysis. You have to do iridodialysis repair, you have to clear the visual axis, you have to put the IOL. What will you do first? The first, in such cases, you will do iridodialysis repair, because here you have to do a membranectomy. And if you do membranectomy and put an IOL first and then do this repair, then there can be pigment release which can go posteriorly, there can be inflammatory mediator release that can go posteriorly, and it can cause CME. So in such a case, you should do a iridodialysis repair first. Now, second thing is, when you are doing iridodialysis repair, what happens that the iris sometimes gets folded. So you have to stretch, keep stretching the iris tissue. You have to keep stretching the iris tissue so that you don't get a notching while you are doing passing the suture. So that you pass the suture at the edge of this iridodialysis, and as you pass it, it gets pulled on one side. So you use a forceps to stretch it, and as you keep stretching, you can see these lines, hyperpigmented lines, they will appear. And these are the lines wherein iris was folded like this. So you have to keep stretching and keep repairing, and then you do a membranectomy and put the IOL in the bag, in the sulcus, a multi-piece IOL, and that is it. So this is how it looks like. There's hardly any stretch. The idea is that there will be a little bit of notching here, but it should not cross the margin of the IOL. That is the most important thing. Another scenario of iridodialysis repair wherein you have a swollen cataract. In such a case, you remove the cataract first and then create a space. So I'll just move fast because of paucity of time. So you do the cataract surgery, put endocapsular ring, then put the IOL, and then after that you do the repair, because your anterior segment and the posterior segment are separate. There's no breach in between. So you can do the repair, and also you have created space after removing the swollen lens matter. And then once you do that, this is how it looks like. Mostly if there's a corneal scar, in the central scar, you put a monofocal spherical lens. But in cases wherein you have a peripheral scar, you can go ahead with a toric lens as well. I'll just move on. And this is the last scenario which I'm showing. If you have, this is a repaired perforation, lens fallen behind, which is removed later by a vitreoretinal surgeon, vitrectomy done, and there's no iris. So in such cases, the patient was improving with refraction to 6/6 partial, but the patient could not open her eyes in sunlight or in bright light. In such cases, you use a aniridic IOL. So aniridic IOL is not a foldable lens, so you have to create a 9mm incision for that. This is an aniridic IOL with a central 4mm cylinder and pigmented flange. And then you go ahead and you tie it with a suture. You put one knot on one side and second on the other side, titrate the centration, and then go ahead and put the suture, and that is the end of the procedure. So this is how it looks like. Subluxated cataract, it's a whole chapter actually, a whole presentation, so I won't go into details. Just like to mention that up to 120 degrees you can use endocapsular ring. Up to nearly 240 to 270 degrees you can fix the bag with Sione's ring, and beyond that you do a lens removal and do a FIOL. If you have a central corneal scar, you can just do a small sphincterotomy while doing the cataract surgery so as to create an adjacent pupil. And if you have a scar like this, then in such cases, even after putting the IOL, the child will not have good visual improvement. In such cases, use of RGP contact lens over the scar is very, very helpful. So in conclusion, traumatic cataract is a tricky situation, and we have to manage each case differently, and meticulous planning is very essential. Thank you very much. And just a couple of minutes I would like to bring to your kind attention about something which we don't bother these days, but yes, we have to think about, and that is drug master file. What is our concern? When we treat a patient, our concern is that we should make a right diagnosis and correct medication. The patient should have good compliance, and there shouldn't be any adverse reaction. And the drug should be safe. That is what we want. But these days, what survey has noticed that there are some drugs which are substandard that are being manufactured in India. So that is why drug master file is important. It is a confidential document submitted to the FDA which covers all comprehensive, accurate and precise information about active pharmaceutical ingredient. And it is the basic idea is that it gives you the idea about manufacturing, it gives you the idea about packaging materials, stability, materials used to prepare drugs, drug substance, and most importantly, purity and impurity. And impurity is something which we don't want in a drug, because impurity can cause harmful effect, it can cause TAS, it can cause adverse drug reaction, and that is why we need to have a control, a check on this as far as the purity of drug is concerned. And that is what is DMF, drug master file, wherein in this it is a way to check the purity of the drug. It is assurance of a superior quality of the drug, and this is very essential in order to have a good outcome when we are treating somebody with any drug. Something like recently, I have no financial interest, but Mankind Pharma has come up with its moxifloxacin 0.5% Mahaflox, which has a purity of 99.95%. So that is something which, if that is there, in such drugs can be used intracamerally also without the risk of any TAS, and that is very important. So DMF is something which we do require in India, because we just for the sake of generics, a lot of drugs with impurities are being manufactured, so it is very important. And if the drug has a DMF stamping, this means that the drug has a very good purity. Thank you very much.
Sir, would like to ask you one question. In cases of pediatric traumatic cataract associated with corneal injury, how would you decide whether to do cataract extraction with IOL implantation in a single stage or a stage surgery?
It should be avoided in a single stage. The first stage should be a corneal perforation repair. And if there are flocculent lens, if there's no flocculent lens matter in anterior chamber, just do the repair, leave it like that, remove the suture, eye becomes quiet, then you will have a stable keratometry, you will get a accurate IOL power, and then do the cataract surgery. So do it secondarily. Sometimes you can have flocculent lens matter coming into anterior chamber. So you do the corneal perforation repair, remove the lens matter, and then leave the patient aphakic. Okay. And then after that, subsequently, when you remove the suture, you wait for a couple of weeks for the corneal keratometry to stabilize, and then you do biometry, and then put a secondary IOL.
Thank you, sir. Now I'd like to call Dr. Nilesh Mohan sir to felicitate Dr. Rajesh Sinha sir. Now I will introduce Professor M. Vanati ma'am. She is working as Professor of Ophthalmology at AIIMS New Delhi at Cornea, Cataract and Refractive Services. She graduated from Madras Medical College, Chennai and pursued her ophthalmology residency at AIIMS New Delhi. Her contribution to the field of ophthalmology are well recognized with over 130 international index publications. She has received her several prestigious awards, including AIIMS Research Excellence Award in 2019, Best IGO Award in 2021, IGO Silver Award in 2022. So over to you, ma'am.
Are my slides visible and am I audible?
Yes, ma'am.
Yeah, I'm audible. Okay. Thank you. And at the outset, I wish to apologize for not being there in person. And many congratulations to the entire team at RIO Patna on your Foundation Day celebrations. I think it's an apt subject, and I really miss all the excellent academic interactions which have been happening since morning. Over the next 10 minutes, I will talk to you on pediatric keratoconus, keeping in line with the theme of your CME today. The presentation, prevention and management would largely keep it more to the practical aspects of the disease. And this might not be an exhaustive list, but I will try to cover as much as possible in the next 10 minutes. No financial interests here. So when you look at pediatric keratoconus, how is it different, or what are the salient features one needs to understand in comparison to adult keratoconus? First and foremost, the progression is very rapid in pediatric cases, and those which show rapid progression early on in life almost need corneal transplant 7 times as much as in the normal ones. The association of VKC with atopy is strongly established ones, and those with atopy and ocular allergy show a more rapid progression. About 88% of all pediatric keratoconus patients have been noted to be progressive. Hence, the need for offering collagen cross-linking on the first visit or for any pediatric keratoconus patients stays justified in the current consensus. The particular risk factors which would aid or which would predict progression in pediatric cases is when your pachymetry, when you're seeing them early on, it's less than 450, an average keratometry exceeding 50 diopters here, and your posterior corneal elevation going far beyond the range of 50 microns here. So these are all proven factors here, and what's also worrying is that most of the pediatric keratoconus tend to present at a very advanced stage compared to that what you would see in adult cases here. So that's to tabulate it again and to reiterate for the residents. For the residents, the diagnosis is more advanced when you look at pediatric keratoconus. The severity is more advanced when you diagnose a pediatric keratoconus case here. The progression is much more rapid than you would see in adult cases here. And it is commonly tends to be associated with systemic and other ocular comorbidities. About 40% of them would be associated with ocular allergy here. So eye rubbing is a significant risk factor for the progression of these cases. And very advanced keratoconus usually have poor prognosis for keratoplasty. So that's how the onset of the disease and the profile of the disease in pediatric keratoconic corneas occurs. When you look at the need for collagen cross-linking in pediatric age group, what I told you foremost is imaging is a particular difficulty in these patients here. So when you're finding a very steep K in cases and those associated with allergy, you are justified in offering collagen cross-linking as on the first line of visit rather than having to wait for a documentation over 3 to 6 months for progression. So that's something which is currently a consensus in management of pediatric keratoconus, especially advanced cases here, so that you can cross-link them when their corneal thickness is or affords or allows a collagen cross-linking here. So progression is one thing which we probably will not wait for when you're offering collagen cross-linking in pediatric keratoconus. The second concern is what type of collagen cross-linking would you like to do, whether it's epi-on or whether it's going to be epi-off. Most of the studies tell you the efficacies of epi-on collagen cross-linking is best, and again, a conventional versus accelerated, though the results have been found to be equivocal. Again, what we have in published literature is that conventional results are more favorable in cases of pediatric keratoconus. Yeah. But remember, this is not to be taken frivolously. This is an interventional procedure. So in pediatric cases, sterile keratitis, infectious keratitis, post-collagen cross-linking haze is all a reality, and this is much more if when the surface is associated with ocular allergy. So containing the ocular allergy or bringing the ocular allergy to the lowest possible ebb, the inflammation to the lowest possible ebb is imperative before you would offer collagen cross-linking for your patients there. A few case examples here on management of pediatric keratoconus. This was a 10-year-old child who had reported to me on the right eye with an advanced stage of keratoconus. The left had undergone collagen cross-linking here, and the refraction, as you can see, the left is minimal and the right is about -8 with a -2.5 cylinder. The K1 and K2 is as steep as 71 and 80 with a Kmax of 89 and a 323. So here you know this is at a risk for perforation. Even if you take it up for DALK, it's beyond the stage of collagen cross-linking, the thinning here. And this child is successfully managed with rose K2 lenses on continual follow-up, giving him a good useful vision which allows him to do his schooling here. So that's how you need a good supportive optometry team with you, a low vision services team with you which can help to fit collagen, fit all these advanced corneas with the various advanced systems of contact lenses here. So these are again pictures of the same child here, and I wish to acknowledge Sneha, our team lead optom in contact lens and low vision services, who helps to manage such cases here. This is another 13-year-old child with advanced keratoconus in the right, the left having undergone collagen cross-linking and subsequently needed a DALK because of progressive thinning here. And the visual acuity is as good as 636 improving to 618, and you can see the maps here of advanced keratoconus in this particular patient. Again, amenable to contact lens fitting with a Keracare contact lens here. This is a scleral contact lens, and again this child has useful vision which allows him to attend school regularly. So these are certain management protocols which are possible even in pediatric cases, but the chair time, the teaching protocols, and the parental cooperation all need to be top line and are very imperative in successful management of these cases to ward off surgical interventions here. Again, collagen cross-linking recommended protocol, I would reiterate, it is a standard epithelium off protocol for these patients. Control the inflammation associated with ocular allergy before you would take them for collagen cross-linking. And again, remember, collagen cross-linking cover stays for about 4 to 5 years following the linking. And you might want to relook at these eyes to see if there is a progression. And sometimes the procedure is not effective, and following 6 to 12 months later, you might find a steepening in these patients as well. Another risk assessment score system given for patients with keratoconus associated with eye rubbing, associated with ocular allergy, depending upon the age, the eye rubbing, the atopy disease, frequency of glass changes. You could categorize the risk for progression into as high risk, mild risk, moderate risks here, and depending on these score systems, it helps you to categorize these children who are going to be under the various category of risk factors here. Eye drops is a particular reality in pediatric keratoconus, especially advanced ectasias, as the inner layers gives way, and these patients, these eyes tend to present with corneal edema here. What's new in the management of corneal eye drops is the adoption of a combination of procedures here, and you would like to probably consider the modified way of compression sutures along with intracameral air and contact lens management in these cases, which gives you early rehabilitation for these patients. Again, remember that use of gas has to be done cautiously when you are using even non-expansile intracameral gas for management of keratoconus. This was one such patient a young boy for whom I had done intracameral gas injection, and the patient landed up with a malignant glaucoma and needed intervention in form of a lens aspiration and anterior vitrectomy before we could effectively save the eye. And of course, now he sees 6/12 with a subsequent secondary IOL and deep anterior lamellar keratoplasty. But that's a word of caution for all of those who do take intracameral gas injections in pediatric keratoconus patients. Yeah. When you look at the profile of pediatric keratoconus associations, VKC stands atop. In most of the cases, over almost 40% of the keratoconus patients having an association with a varied amount of severity of the allergic eye disease, which could range from just the palpable type, the limbal type, the mixed type associated limbal stems deficiencies, and blinding corneal disease as well. So these need prompt management in terms of surface steroids here, and the continued anti-allergic medications, interventions such as amniotic membrane transplantations to heal the surface, and early visual rehabilitation for these cases here. I think this is a video of corneal eye drops management. I'll just skip this in the interest of time here, but then when done properly in eye drops, it does help you in early visual rehabilitation of these patients and moves the patient on for good effective rehabilitation with contact lens fitting of these cases here. These are again cases which need deep anterior lamellar keratoplasties, or patients which need penetrating keratoplasties whenever you have a full thickness scarring, and when your internal rupture of the Descemet's membrane is large with intense scarring, then it's a full thickness keratoplasty for visual rehabilitation of these cases. When it's just an apical scarring, and a deep anterior lamellar keratoplasty works well here. But eyes such as this, you do have the allergy recurring, and you have the allergy causing rapid suture loosening of these cases, and you probably will have to deal with the additional problems which can occur because of these cases here. Again, pediatric DALCs is not free of rejections, and watching them closely in the postoperative phase to catch on an early rejection is important in reversing the rejection so that the visual acuity can be restored for these patients. So that's a particular concern in patients. This is another case of a 12-year-old child who presented to us with bilateral keratoconus. As you could see here, a vision of 636 in the right and 1/60 in the left here. A patient went on to have a DALC in his left eye here, and those are postoperative pictures of the same to show that it's effective here. And before I close, then I would run you through, I think no presentation of pediatric keratoconus or keratoconus is complete without seeing deep anterior lamellar keratoplasty, the Descemet's bearing big bubble DALC here, and that's the wow factor. When you see it on the IOCT, you can see the Descemet's falling back as you are breaking the roof of the big bubble chamber, and the DALC is completed effectively. And that's pretty much how the surgery goes on when you're doing a successful Descemet's membrane bearing deep anterior lamellar keratoplasty. Then we have more videos, and we do move on to do manual DALCs even on cases which have ruptured eye drops and healed eye drops here. But remember, you will have to leave behind the Descemet's, the pre-Descematics Duas layer in these cases here. But still, the Descemet's rupture allows seepage of the fluid through the Duas layer, and you might land up seeing a double chamber in the postoperative phase of these patients here. That's called a weeping posterior stroma in these patients, even when you do an uneventful DALC in manual DALCs when you are managing cases of healed eye drops here. So this made us think and caught us into doing lenticule addition keratoplasties, moving away from tissue replacement keratoplasties for those cases of pediatric keratoconus, or those cases of keratoconus associated with ocular allergy, where you would probably, which are thin enough and not suitable for doing conventional collagen cross-linking. We combine these cases with doing an intrastromal laser dissection, as you can see here, and this is completed. And then the host cornea anterior epithelium we use the anterior Bowman's and the anterior stroma lenticule, which is harvested using the automated microkeratome. go back to the host cornea, open up the laser microkeratome created lamellar dissection, and this stromal lenticule comprising of Bowman's and anterior stroma is placed on the surface, and we continue with the accelerated cross-linking for these corneas. So this was done in a group of progressive keratoconus cases, particularly associated with ocular allergy, whose thinness was not making them eligible for the conventional procedures. Now we have a follow-up of close to 2 years of these patients, which is now going to hit publications very shortly. And this is as effective in controlling progression of these cases, but the quality of vision is perhaps not as good as what you would see in deep anterior lamellar keratoplasties. Yeah. This is a good review article which I would like to refer you all to read up to make it more, to make your understanding more comprehensive. Another case here, we just saw this one last week. A patient of a 14-year-old boy reported after missing follow-ups for over a year, stopped his medications as he was feeling fine, and this is what he looked like when he came back to me, with both eyes showing a variable amount of recurrences of giant papillae, the right more than the left here, and his keratoconus had also progressed, as you could see in these maps, in the right eye for this particular patient. So now it begins. Now it's a journey of beginning the battle all over again to control the surface inflammation and to control his progression and manage his progression. So that's a journey in which when you have to reiterate to these patients that compliance to follow-up, compliance to medication is probably imperative to keep the disease under good control and manage them effectively here. One other result which I would like to share in managing keratoconus in association with ocular allergy is a study on tear levels when it is applied over the lid in many of these patients with chronic allergy, especially with particular lid disease here, and children who do not allow ocular surface installation of tacrolimus. This helps in effectively controlling the allergy and less eye rubbing for these patients when they are associated with keratoconus. So that's particularly something which I think we find is effective even when you apply it over the lid and gets absorbed, and the tear concentrations are good enough to cause the resolution of the upper tarsal conjunctival inflammation in these eyes, and they're really helpful in pediatric cases of severe ocular allergy associated with keratoconus, alleviating the need for any other interventional procedures for the lid here. So when you now, so to close your profile of pediatric keratoconus, continued eye rubbing is a reality and is a very significant confounding factor in causing continued progression of pediatric keratoconus. You have particular imaging difficulties in these children because they do not usually cooperate well. You get a lot of variable readings here. So the consensus is to offer collagen cross-linking on the first go when you do see these patients for particular management of progression in these patients. Ocular allergy is a particular, is significantly associated in pediatric cases, and many of these cases, when they are in early keratoconus, tend to get misdiagnosed as amblyopia cases. So don't miss out doing a keratometry on these early cases, especially when you're not able to refract them to 6966 here. And you would find it's not amblyopia. You have an associated myopia along with curvature disease in these patients here. Ocular comorbidities is a particular reality here. Most of them suffer secondary morbidities because of steroid-induced cataracts and steroid-induced glaucoma. And that also completes the profile which needs to be managed in pediatric keratoconus. I would refer to students to postgraduate ophthalmology textbook for more reading on these patients. And I welcome your wonderful research for submission into the Indian Journal of Ophthalmology. Thank you again, the entire team at RIO, for the patient listening.
Thank you so much, ma'am, and I would request you to stay back during the whole session to give your input. And one question to ma'am, what should be the optimal time interval after achieving the control of VKC and performing the C3R in cases of pediatric keratoconus to reduce the risk of post-operative complications?
Most of the time when you're taking up pediatric keratoconus for collagen cross-linking, the severity of the ocular allergic disease is important to decide how quiescent is going to get over the period of time. So sometimes you could get the lesions to be quiescent in about 3 weeks. Sometimes it's going to be needing as much as 3 months here. So that's you're going to wait on a case-to-case basis, but you will need to be able to bring the ocular surface inflammation to the lowest possible ebb before you're going to offer collagen cross-linking. Besides this, you're also going to look at epithelium of thinnest pachymetry of 400 microns if you're going to use an isoosmolar, or you would use a hypoosmolar. So you should also see if the pachymetry is affording that, and that will help you to decide what the time interval can be.
Questions from panelists?
Thank you, ma'am, for such an elaborated presentation. I'm Rashmika from Patna. Ma'am, I just wanted to know your insight on the challenges faced when we do a PK in a pediatric patient, tissue being more elastic and the size of the graft, maybe 3 to 4 salient points. Thank you, ma'am.
Okay. So, as we do in all pediatric keratoplasties, we usually look for the donor tissue to be perhaps around 40-45 years of age, and as least death retrieval time as possible in these cases here. And I always look at the postoperative myopia of these cases here. So if they have an axial length, and if your postoperative myopia is going to be over -6.5, then you would do good in doing a same-sized graft-host disparity in these cases. So that's something before you take on that I think surgeons are well versed in good suturing, because when you're doing a nil graft-host disparity, meaning same-size grafts, the way you tackle the host cornea is very important, because it's not going to be forgiving, and you will have to, you should avoid any unwanted cutting or undue wrong cutting over the surface when you're managing the host tissue here. Suturing needs to be optimal in these cases, otherwise go with the 0.25 oversizing here. And again, the apt size of the graft, look at the type of cone you're looking at. Is it a nipple cone? It's a large cone. It's an eccentric cone. What you need to restore is a central surface, which will give you a best refracting surface here. So you don't have to get away with the entire cone in most of the times. Hence, you would also see a residual astigmatism in your post-keratoconus PK tends to be higher than the astigmatism you would get for a simpler corneal opacity, or you would get for a dystrophy. That's something you need to understand. And most of these patients would have a higher quotient of post-PK astigmatism, which will need some form of other optical interventions for management. And again, watch these patients. If they have an ocular allergy, you need to watch them closely for containing the ocular allergy. Many of them might have a missed secondary glaucoma associated with them, and always do not miss looking at the discs of all your patients of pediatric keratoconus. That's something which is imperative. And when you are putting them on steroids for their associated ocular allergy, please tell them to come back to you for management of for follow-up of their IOPs and their disc monitoring.
Thank you, ma'am.
Thank you for the talk, ma'am. I'm Dr. Ujjwal, and I have a query regarding some recent cases that we have seen. And these are generally 5 to 6 year old young children who have presented with high astigmatism of up to even -4 diopters, or ranging from -3 to -4 diopters. So I wanted to know your experience and your take on how these children are likely to progress into how they are likely to progress into keratoconus, or what is the likelihood of such cases?
How young are these children?
Ma'am, generally around -5 to 6 years old.
5 to 6 years, and
as young as 4-year-old.
You're seeing them for what complaint?
Ma'am, they have reported with diminution of vision and just a routine refraction revealed astigmatism of around -3.5 to -4. And the pentacam has been, obviously the indices have been ranging from 45 to 50 diopters as well. So I wanted to know your experience with such cases and how you would monitor these cases.
See, a child, if you're seeing around 4 to 5 years of age, is never going to have 6/6 vision. Most of these children attain 6/6 only beyond 8 years of age. So when you see 4 or 5, they would probably only be reading around 6/12. Even when they are having a normal globe and normal corneas here. Okay, and once you are able to document on your pentacam either the anterior or posterior surface crossing 47.2, then your diagnosis of keratoconus, it's not a suspicion, it's almost a reality. The ones is when you're looking at a subclinical keratoconus is when you're going to ask them to refrain from eye rubbing and you're going to watch for allergic disease. But you do also have a subset of disease where it's just simple compound myopic astigmatism with steep corneas, or simple compound myopic astigmatism with thin corneas who do not tend to progress. And some of them, as they grow, the steepening might flatten a bit here. So we as ophthalmologists will need to observe and follow up these children to see which category they are going to fall into. And if they have a sibling of keratoconus, then you know this is a subclinical keratoconus, it's going to be a matter of time. And what you need to tell them is watch their ocular allergy, keep it under control, avoid eye rubbing. And this is most important so that you do not allow them to progress very fast. And if you do find that there is a significant progression, or if you are able to document an amount of thinning, then take them early on for collagen first.
Thank you, ma'am.
Yeah.
Now I would like to call upon Dr. Rakhi Kusumesh ma'am for talking on the topic clinical approach to the pediatric corneal diseases.
Thank you so much. So, good afternoon, everyone. I'll be talking on a clinical approach to corneal diseases in children. So, if you look at the corneal disorders in children, you'll find that there is a diverse clinical condition that affects the children across the world. But in our country, or particularly in our state, I have seen that the trauma, the infectious keratitis, chemical injury, the nutritional deficiency induced corneal diseases, and of course the congenital and acquired corneal opacities are quite common. And their pattern and frequency are also different from the adult. Not only pattern and frequency, but also the course and the disease prognosis are also different from the adults. So in any condition, despite this wide spectrum of disease, if a child comes to you, he has usually one of these kind of presentation, either red eyes or whiteness of cornea or denervation of vision. So whenever a child comes to a cornea clinic, I always try to fit them into one of these category, if possible, based on their major presentation. So if the patient has red eye, then definitely it makes my approach much simpler to think about history and examination. So if the patient has red eye, definitely I would see whether it is unilateral or bilateral, and depending upon the indication, I would go for the history and examination. And if the patient has whiteness of cornea, then I'll see whether it is congenital or it is acquired, because it definitely going to affect the visual rehabilitation of the patient. And diminution of vision, the most common cause of refractive error even in the younger kids. But if the refractive error is progressive and there are other signs on the cornea, then definitely we look for the keratoconus in certain conditions. Now, the history in pediatric cases is little different from the adult. The onset, severity, the occurrence, they all are same as adult, but here the history will be given by the parents, mother especially, or by any caregivers. So here, apart from routine history, we also take the history of family history, history of the siblings. And if the kid is very young, less than 2 years or 1 year, then we will like to ask about the pregnancy and eventful pregnancy, or overall general health of the patient and development. So as far examination is concerned, if the patient is very young, I would like to start with pen light examination, because it gives you the overall view of the ocular health. You can examine the corneal light reflex, you can see the conjunctiva, you can see the lid opening, you can see the swelling, growth, anything you can find with just a pen light examination. And if the child can sit on the slit lamp and is comfortable, then younger kid, you can ask them to kneel down, and as per this, kneeling actually helps a lot. The child can manage the height along with the slit lamp. The older kids can easily sit on the slit lamp, they can communicate, they can give history also. But always remember that in kids, start the examination from the affected eye, not with the normal eye, because they are not going to stable for 4 or 5 minutes. They will be there just for 1 or 2 minutes, and you have to examine the eyes in that time only. So nowadays I have started taking the ophthalmic images with the smartphones, and this helps me a lot, because whenever we sedate the child, we take a picture and zoom in those pictures, and you can see the finer detail also that you cannot see when the child is awake and the patient is very uncooperative. Now, in certain situation, despite best effort, you can't examine a child. In most uncooperative child, you can't do that. So, and in certain condition, like when you want to take some sample, you want to do scraping, you want to take some documentation, you want to do some recording, or you want to do some surgical planning before taking the patient to OR. Then you can definitely do the examination under anesthesia, and here you can do all the tests apart from the slit lamp examination. You can do some specialized tests, like you can do the fluorescent staining, you can take the sample, you can remove the sutures, you can replace the suture, you can take IOP, fundus examination, refraction, everything you can do in the UAs. But one thing to remember, that you need to take a consent for these patients, and whenever a UA that is planned must be used as a single opportunity to do a comprehensive evaluation, because this child are going under anesthesia, and you need to do all the things. Rather performing a single test, you need to do a complete evaluation of these eyes. Or if you want to do any other test or minor intervention, then you can do that. So this is a case of keratitis where we need to do the scraping, and there was a thinning in the center. So in the same sitting, we evaluated the keratitis. We see the depth of ulcer, surrounding area, AC, and we did the scraping. We gave intrastomal voriconazole and applied glue BCL in the thinning area, and we got a very good response after this. So UA not only allows you complete evaluation, but it also gives you chance to treat in the same sitting. So in that way, the timely intervention will definitely lead to a very good results. In post-keratoplasty patient, examination under anesthesia or documentation is of utmost importance, and here you can document the graft clarity, the AC detail, the graft host junction, suture, the epithelial defect, everything you can note down and just make a sketch, so that even after this examination, anybody can see this patient and get the information prior to the UA. Here it is also important, because the biggest concern in pediatric keratoplasty is graft rejection. And here in our paper, we documented that the graft rejection rate is 12.1%, while the reversibility was very less, that is only 25%, and it was because of delayed presentation and delayed initiation of therapy. Here comes the role of frequent UAs, regular interviews, UAs, where you can detect the graft rejection at a very early stage. You can initiate the therapy in a very early stage. You can control the IOP. You can give the visual rehabilitation to the child, either in form of glasses or contact lenses, or you can perform suture removal or replacement whenever required. So these UAs are really important for all the pediatric cases, especially if you have done a keratoplasty. Now, what are the tools required for these examination? The portable slit lamp is a wonderful tool you can use in OT, and you can see all the depth of the corneal opacity, foreign body, and everything you can get to know with this. There is a new attachment is coming with the smartphone, that is a slit attachment, and here you can see also, and you can document also in the same setting. The calipers, really important. Everybody knows, every corneal surgeon knows that calipers is very important for the keratoplasty, and tonometers for IOP measurement, because these patients usually get a lot of steroids after the surgery. Fluorescent strip is one of the very important tool for all corneal examination, and microbiological kit. In older children, you can use the ASOCT to get the proper depth and for your surgical planning, and OPSCAN, definitely topographers are useful to rule out any ectatic disorders. Now I just want to show you this case of pediatric keratitis, where this patient was brought to us by mother, and she was 3 months old girl with bilateral severe keratitis with marked conjunctival xerosis, and she was bottle fed. She had also history of diarrhea for off and on for 2 months. So in the same day we ordered the CBC, the complete blood profile, the serum retinol, while seeing these eyes are very dry, and a pediatric consultation was done to rule out any other systemic disease, just like vitamin A deficiency is very common in the intrahepatic, the neonatal cholestasis. So these has to be ruled out prior taking to the UAs or any surgical intervention. And the swab culture sensitivity was sent to rule out any microorganism involvement. Hang over here. So in this case, we took this case for so after 15 days, patient came back to us, and the other eye has early anterior staphylomas, and the right eye was perforated with flat AC with the presence of few vessels in the periphery. So we took this case for examination under anesthesia, and in the same sitting we performed the pediatric keratoplasty. And after 3 years, now she is 3-year-old and she can walk and she can do all the work. So this case actually reminds us that systemic history is also very important, and systemic workup is also very important in the pediatric cases. We cannot skip this while managing these cases. So these are the few history which are really important in the younger kids, like low birth weight, premature delivery, bottle fed babies, improper immunization. And in the older kids, definitely trauma is most common cause. Other ocular diseases like VKC, systemic diseases, these are very common things which need to rule out before starting the management. And these are few kids where we did the timely intervention and saved the eyes. So to conclude, pediatric corneal diseases are not just the smaller version of adult problems. With the right approach and close coordination with the parents, outcome can be improved significantly, and we can preserve the vision for the life. Thank you.
So thank you, ma'am, for such a wonderful presentation. I would like to ask you one question, ma'am. Like, how prevalent is still vitamin A deficient in our state, and what are the clinical features?
Yeah, vitamin A deficiency definitely, the incidence and prevalence definitely reduced from the before, but still we are getting patients of vitamin A deficiency, especially keratomalacia, probably because of just one cause. I said, like the neonatal, cholestasis is one of the very common cause, and here we need to do LFT in all the patients. And other than that, patients usually they are bottle fed rather being on breastfeeding, and immunization status is still the documentation showed that every child is vaccinated, but if you see really on the ground, then there are many kids still without vaccination in the peripheral area, and these patients actually develop these kind of picture. And in the periphery, or you can say the people who are not aware of treating this disease, they start antibiotics and keep on them just antibiotic, and patient finally perforates and turns into anterior staphylomas.
Thank you, ma'am. Panelists, you want to ask?
One thing I want to elaborate, very nicely presented, Raki ma'am, that many SRs are here. So as ma'am said, EUA, examination under anesthesia, this is a golden chance when child is in front of you. So never forget to dilate the child, because whenever you do a transplant or after that, there is maybe a total cupping or whatever is there. So you need to know when the child is in EUA.
This talk was supposed to take by Dr. Shrikant Sahu, but just because of any some medical issues, he is not here. So Dr. Pallavi will brief the chemical injury and its consequences.
Thank you, ma'am. I'll just brief about chemical injuries in children. So it's an ophthalmic emergency because it's very critical in pediatric cases, as it faces the communication challenge and developmental vulnerability. So ocular burn represents 7 to 18% of the total eye injuries. 84% of the ocular burns are chemical burns, and in which chuna, that is lime, it is the most common cause for the chemical injuries, especially in the rural areas where the lime in the form of chuna, which is edible, they mostly consume with the tobacco, and this chuna comes in small packet, polythene packet, which even squeezed lightly, it can spill into the eyes and cause severe chemical injuries. And chuna used in the whitewash also can cause to chemical injury. Recently, I had a children in my this OPD. She had total epithelial defect and conjunctival ischemia. And I was thinking what could be the cause. They then, after examining, I thought it's looking like a acute chemical injury. Then I saw on the child had bandage in her hand. She had history of fall and application of this plaster of Paris. So while application, it might have fallen into her eyes, which led to the acute chemical injury. So it's very common in rural part because of this chuna. Another cause is the toilet cleaner used in household. So there are two types, alkalis and acids. Alkali are more common than the acid, and it penetrates more deeply. So most common are ammonia, sodium hydroxide, and lime. Common acids are sulfuric acid. It can damage any structure, from lids to conjunctiva, cornea, anterior chamber, and ciliary body. So why do we need classification? To prognosticate better and to have a better prognosis in cases of ocular surface injury, it depends mainly on the type of chemicals which has caused the injury and what structure it has damaged, whether conjunctiva, cornea, and whole structure, and whether it was immediately treatment was given or not. So every factors depends to prognosticate to better prognosis of the patient. So we have two classification, Roper-Howler and Duas classification. It was an earlier classification which has 4 grades based on the involvement of cornea and limbal ischemia, and it has excellent, good, and guarded prognosis. So in this picture we can see the first one, it has mild epithelial defect, but there is no limbal ischemia, and we can see the iris detail. But in this picture, grade 2, so there is a hazy cornea, but iris detail still visible. In this grade 3, there is more of total corneal epithelial defect, which further hinders the details of iris. And in grade 4, we have total opaque cornea. So why do we need Duas classification? In some cases of grade 4 injuries where it says poor prognosis, and it was in the era before the invention of limbal stem cell transplantation, it has grade 4 carried the poor prognosis. But in Duas classification, if the patient has grade 4 injury, still the patient can have a guarded prognosis after the implantation of limbal stem cells. So in chronic cases, it can affect cornea, which leads to conjunctivalization, neovascularization, and chronic inflammation. And for the conjunctival, it can lead to goblet cell damage and further formation of symblepharon and scarring of the eyelids. So what should be done in emergency? Copious irrigation with the normal saline or ringer lactate. It should be done immediately. Double eversion of the upper lid, very important to remove the hidden particles which are stuck there, and debridement of all the necrotic tissue and loose corneal epithelium. Remove any residual chemical particulate matter, and we have to do the pH monitoring, because most common cases of chemical injury is alkali, and which has a higher pH. So we have to monitor the pH after irrigating it with the normal saline or ringer lactate. And we can use the topical anesthetics to facilitate more examination, and we have to monitor. Further treatment can be given like cycloplasics, and the role of corticosteroid is very important, which promotes faster healing and reduces the inflammation. So our aim is to reduce the inflammation, promote epithelial healing, and further to decrease any corneal ulceration. In chronic cases, we can do claw, which was first given by Kenyan and Sang in 1989. Then came leaving-related conjunctival limbal allograft, and in 2012, by Dr. Sangwan came the simple limbal epithelial transplantation. I'll just brief about what is claw and sled. In claw, after removing all the pannus tissue and doing peritomy and hooking all the muscles, we can put the amniotic membrane and we have to construct the lid to remove all the symblepharon after removing. And we can suture amniotic membrane by biting, and this two limbal lenticulae of 3 to 6 clock hours are harvested from the upper and lower limbus, and it is sutured to the recipient eye using suture or putting the glue also, whatever suits. And in slit, what we do is, like, we don't take the 2 limbal lenticule which is larger, we just take 2 into 2 mm limbus or 4 into 4 mm limbus, and which is cut into 8 to 10 pieces. It is cut into 8 to 10 pieces and it's glued over the amniotic membrane, and BCL is applied. So these are some of the photos pre-op and 6 months post-slit. Pre-op and 6 months post-slit and 6 months post-claw. So after limbal stem cell transplantation, we can rehabilitate the patients, and it can really change their life. Thank you. Now I would like to call Dr. Ankita Singh for talking on a topic, this from playground to emergency room, a case series on pediatric eye injuries. Any questions from me?
Very nice cover up by Pallavi. SLET is a wonderful surgery. We all know that by Dr. Sangwan et al. From LV Prasad. So this has changed the overall scenario of chemical injuries. So in case when one eye is totally this complete limbal stem cell deficiency, you can take from the other eye. So the health of the other eye is very important. In case of bilateral cases, you can go for a donor graft, but in that case, you have to go for immunosuppressive therapy for a long.
And so it's a stage procedure also.
Yeah, it's a stage procedure. Yeah, nice.
Thank you, ma'am. Now I would like to call upon Dr. Ankita Singh.
Thank you, Pallavi ma'am. Now today we will be discussing few cases. I won't take much time. That is from playground, how the patient lies to emergency room. This is the first case of 11-year-old male child where he had a history of trauma with bangle of sibling in right eye 2 days back. On slit lamp examination, you can see there is a U-shaped tear with iris plugged and AC was formed, but on a forced CDIL, it was positive. So what to decide, how to decide that whether it should be repaired or not? It should be definitely repaired because it is a 11-year-old child and there is a forced CDIL test so it should be repaired. So the basic principle of repair is to make a site put first, to release the adhesion from the corneal tear site, and then to put a suture of 90% depth and close the all the tear margin and to form the AC. The post-operative medication used are moxifloxacin, tobramycin, topine, CMC, HPMC, systemic, antibiotic and painkillers. This is the pre-operative and post-operative pic of the same patient. The second case is 5-year-old male child with alleged history of trauma with goat's horn in right eye while playing in the ground 3 days back. On slit lamp examination, there was a cruciate type of a tear. You can see there was a lot of tissue melt with query lens prolapse, query vitreous in the wound, AC was shallow, and there was a cruciate type of tear from 12 to 8 and 4 o'clock. This is a short video as following the principle. First the site put, the necrotic tissue was cut and the site put was made. This was the type of the tear which was seen. Then the viscoelastic substance were put and the adhesion were released. First the scleral sutures are given, then the limbal sutures are given, then the cruciate V-shaped suture is put, then the flat end is sutured, and finally the gape sutures are given and AC is formed. In case at the last of the surgery you need to put ringal lactate or any solution to check for the AC leak. If there is a leak, you need to put more suture. If there is still leak, then you can apply glue or BCL for the same. You can see the many sutures, crochet type of sutures were put and the AC was formed. This is the pre-operative and post-operative pictures of the same patient. The case 3 is the 2 months old baby, very small baby, came with a chief complaint of Lyme injuries 2 days back in eye. When we had done the examination, there was query foreign body in the cornea, but that was not foreign body, that was the Lyme which was almost the full depth of the cornea. So this Lyme was removed under general anesthesia, layer by layer, as you can see. This was removed, keeping in mind that it may perforate, but when you can see in this video, it was removed easily, but at the end of when we had, I had reached up to the descemet membrane. After that, when removal was done, it was perforated, and finally the glue BCL was applied. The same patient was taken under EUA after 26 days, and the glue and BCL was removed. And this is the pre and post-operative picture. The case 4. It 8-year-old female child came with alleged history of fall of Lyme in right eye 2 days back. On slit lamp examination, there was deposition of Lyme over eyelid, conjunctiva, cornea, sclera. You can see in this picture there is a scleral melt with deposition of Lyme in a supero-medial part, and it was around 5 to 6 mm. There was a corneal opacification. There was 360 LSAD. First, the medical management was done. Eye wash was given with 1 liter of RL solution. Removal of Lyme was done as much as possible because we were doing in LA and the patient was very small, and patient was started on medical management with prednisolone 1%, moxifloxacin, CMC, topine, vitamin C, doxycycline, and systemic steroid. The plan was to remove the Lyme with scleral patch graft with EMT under general anesthesia. This is a short video. First, all Lyme were removed from the conjunctiva, sclera, keeping in mind not to excise all of the conjunctival tissue. So the tenon's tissue was preserved, all the Lyme were removed, there was a scleral thinning observed, and partial excision of the donor sclera was done, and the patch graft was applied. The scleral patch was secured with the help of the glue and the sutures both. As you can see, the glue was put and it was secured, and finally it was more secured with the help of the sutures. And the main thing which I preserved was the tenons. The tenons was lastly secured on the scleral patch graft with the help of the glue. And the amniotic membrane was placed and conjunctiva was closed. This is the same photo of preoperative, intraoperative, and postoperative pic of the same patient. Thank you.
Thank you, Ankita, for such a wonderful talk. I would like to ask you one question. What are the principles for corneal suturing? Can you explain?
Yeah, principle for corneal suturing first you need to explore the wound, the very important. Second point is make a site port, put the viscoelastic substance, make the adhesion free, the site free of the adhesions, and then put the suture. If there is a corneoscleral suture, then sclera should be sutured first, then the limbal suture should be applied, then the corneal suture should be put. And the corneal suturing depth is 90% from both the sides.
One thing I would like to point out in these pediatric cases, corneal perforation cases, usually these are done by the residents, or if the faculty is there, okay. These are the patients where you need to take care, utmost care, because your one repair at that point of time, he has to live longer years of life, and instrumentation, needles, sutures, those things should be new, holdable forceps, those things should be in place. Yes. Compromised things should not be utilized in those, at least in those pediatric patients.
True, sir.
Because rather than doing good, you are doing harm in that situation. So
True,
this was a subtle point which I wanted to point out.
Sterilization is very important.
Here comes the end of cornea and ocular surface session. Now I would like to call Dr. Abhishek for the cornea cues.
Thank you, ma'am. Good afternoon, all. coming to the quiz.
चॉकलेट दे दो.
Acha. First question is Salmon patches are seen in options are hemorrhage in the cornea, B is interstitial keratitis, C correct.
Answer क्या है?
B is the correct answer.
बी कौन पहले बोला है? बी गलत है. आंसर सही क्या है जी?
बी है सर.
तो बी बोल रहे हो?
हाँ सर.
चार आदमी हाथ उठाए हुए.
हाँ सर. पहले सर.
अजय भारद्वाज.
Coming to the next question, oil droplet reflex in keratoconus is also known as A. Munson. A is wrong. B is right. पीछे अंशुमन. अच्छा. यस सर.
सबसे पहले इसे उठा के बी बोला. नीला प्राइज.
हाँ.
Yes, yes.
No, faculties are not eligible.
Faculty is not eligible.
Coming to the next question. Most important prognostic factor in a case of Lyme injury, A is extent of conjunctival. B is right, sir.
ये आवाज इधर से आई है.
Yes, sir.
मिल चुका है. एक मिल चुका है. Faculty not allowed.
Thank you, everyone.
Okay, 3 questions.
Now we'll felicitate our panelist and chairperson. I would like to call Subhadra Jalali ma'am to come on the dais, please, ma'am. Dr. Rakhi ma'am, please come.
Lights on. Hari, light.
Now I would like to call Dr. Kirti Singh ma'am to felicitate Dr. Ankita.
नहीं कीर्ति मैम अगले 2 को देंगी. अगला बोला अगला नहीं अगला कीर्ति मैम को बुलाओ.
साथ में बुलाएगा.
चलो.
Next.
Next हो गया.
Now we call upon Kirti ma'am.
Now we call upon Kirti ma'am to felicitate Dr. Pallavi for moderating a very nice session. Now I would like to call Dr. Abhishek, who is moderator. सबको ऐसे ही दिया है. Now we can gather for a group photograph quickly.
The session.
Session.
Speakers and the chairpersons of the session. Ankita specified.
हाँ क्या?
Speakers and chairpersons
Yeah.
of this session. Please have
Speakers and chairperson for the cornea session, please. We can have on stage for a photograph.
Be quick, be quick.
I would like to call Dr. Ashish sir to please join us on dais.
Now we'll continue with the oculoplasty session because Santosh sir has a flight to catch. So I would like to say a few lines for Dr. Santosh sir. Please bear with me for just 5 minutes. Santosh sir has 36 years plus experience with ophthalmology in the field of tumors of ocular surface, eyelid, eye orbit, and especially retinoblastoma, eye plasty, and eye prosthesis. He is presently Director Medical Services, Honorary General Secretary IOS. Now Santosh sir has many publications, peer review journals. He is on advisory board on International Council of Ophthalmology, Secretary of Oculoplasty Association of India, and Vice President of Asia Pacific Society of Ocular Onco and Patho. Now he had many awards and recognition. Major awards and honors on his credit include Pfizer National Award, Medallion Colonel Rangachari Gold Medal by AIOS, Ziegler International Fellowship by Orbis International USA, Dr. Shiva Reddy International Award by AIOS, and Senior Achievement Award by AAO, and the prestigious Shanti Swaroop Bhatnagar Award by Government of India. Sir, what we need to say about you? It is already well known, everybody knows you. You are a pioneer in the field of oculoplasty and leading authority on eyelid orbit and surface tumors. Your contribution have shaped our field and inspired countless ophthalmologists across the globe. You are a true inspiration. Your dedication, innovation, and academic contribution have touched the life of around the world. We are truly privileged to have you with us today, and I consider a great honor and a great privilege to introduce you to the gathering. So I would like to invite Santosh sir to give a talk on retinoblastoma. I would like to request chairperson and panel for the session, Dr. Ravi Ranjan sir, Dr. Ranjan Rai sir, Dr. Gyan Bhaskar sir, Dr. Naveen Jha sir, Dr. Gautam sir, Dr. Ali sir, Dr. Nilesh sir, Dr. Raghuvansh sir, Dr. Kunal sir, Dr. Suvesh sir, and Dr. Prerna.
Time up 15 minutes.
Cornea is a kind of plastic surgery, man. Yes.
Corneoplasty. Good afternoon. I appreciate this invitation and congratulations to RIO for its 30 years in work. I'll be speaking about retinoblastoma current practice in India. Why should we know about retinoblastoma? Because it is the most common primary intraocular malignant tumor in children. Not just that, it is highly lethal, up to 50% mortality if it is not treated early, if it is not recognized appropriately or treated early. We are in a privileged position to get these children as the first point of recognition. Pediatricians often refer a child with squint or white reflex to ophthalmologists, and we can recognize these children very easily. And more importantly, it is completely curable if it is detected early. Nearly 98% life salvage is currently possible. The most common presenting symptom as well as sign is leukocoria, unilateral or bilateral. Squint follows, either esotropia or exotropia depending on the age of onset, and reduced vision. Inability to recognize faces is one of the symptoms in children with bilateral retinoblastoma, especially macular tumor. Redness is a sign of advanced retinoblastoma. When a child already has secondary glaucoma, neovascularization of the iris, and anterior segment infiltration, you find inflammation and redness. Proptosis signifying orbital tumor is rare currently. That's the clinical spectrum of retinoblastoma. If you were to pick a child when the child is about 3 or 4 months old, it's almost always in the posterior pole. As the child ages, the tumor starts moving towards the periphery, in the sense that if a child were to present to you at 1 year of age with retinoblastoma, it's possibly anterior to the arcades and so on and so forth. So finally, in an older child, you would find a peripheral retinal tumor. The most important tool to diagnose retinoblastoma is indirect ophthalmoscopy. A good examination under anesthesia is the way to diagnose retinoblastoma. Ultrasound B scan helps you confirm intralesional calcification, especially when the media is hazy. Otherwise, you can measure the diameter of the tumor and the height of the tumor using ultrasound. CT scan is useful only to know if there is intraocular calcification if you're trying to differentiate it from simulating conditions. Otherwise, CT is relatively contraindicated because of the radiation exposure that it produces in retinoblastoma. Most important diagnostic tool beyond clinical evaluation is MRI, because MRI will tell you things that you cannot see clinically. That is, optic nerve invasion here could not have been predicted without MRI because this child has no proptosis at all. That's a major optic nerve invasion that the child had in the absence of proptosis. And this choroidal invasion actually is a contraindication for intraarterial chemotherapy. So you can know the prognostic factors very well on a well-done MRI scan. There are 4 types of tumors: endophytic, exophytic, diffuse infiltrative, especially in older children, and the mixed configuration. Now, the recent advances are regarding classification. Some advances in chemotherapy, management of vitreous seeds has drastically changed. We also have a protocol for high-risk retinoblastoma and orbital retinoblastoma. About the classification, grouping always prognosticates eye salvage. It is organ salvage classification. Staging prognosticates life salvage. Now for grouping, we have a simple international grouping of intraocular retinoblastoma, which is a kindergarten classification. A is for small tumors. B is for bigger tumors, tumor more than 3 millimeter, macular in location, close to the optic nerve and fovea, and also tumors with subretinal fluid go to group B. C is for contained or confined subretinal seeds as in exophytic retinoblastoma or vitreous seeds as in endophytic retinoblastoma. D, remember, as diffuse. Diffuse subretinal seeds, diffuse vitreous seeds make the tumor group D, and E are potentially enucleolized with a tumor infiltrating the anterior segment with blood in the anterior chamber or vitreous or any sort of infiltration. The international staging system, IRSS, prognosticates life. Here stage 0 is the child has been conservatively managed without enucleation. Stage 1 is when enucleation has been done and the tumor is completely resected. There lies the role of the pathologist. Pathologist has to tell you that the tumor is completely resected without any microscopic residual tumor, which will make it stage 2. And if there is orbital and regional lymph node extension, that is stage 3. Up to stage 3, you can salvage life up to 95%, but beyond stage 3, it is less than 5% life salvage. So there is a definite shift in prognosis the moment child crosses from stage 3 to stage 4. When the child has metastasis, it is almost incurable. About new in classification, we have TNM classification, tumor node metastasis. The 4th alphabet has been added only for retinoblastoma, that is H. H stands for heritability, signifying that genetics plays a major role in retinoblastoma. About focal therapy, we are very familiar with cryotherapy and photocoagulation. Cryo is typically done for peripheral retinal tumor. Cryo is very effective, more than 90% is the cure rate, but the complications are there in the sense that the tumor, if you begin with a tumor of this size, the size of the scar that is ultimately produced is much larger because cryo is very heavy. Triple freeze thaw cryotherapy, which will have an overrun mechanism in the sense that the adjoining retina will also get damaged. Multiple attempts at cryotherapy in the same location will produce atrophic retinal breaks, resulting in rhegmatogenous retinal detachment. So cryo is good, but it is not innocuous. If a tumor were to be somewhere around the equator, say anterior to the equator on the temporal side, and if you were to attempt heavy cryotherapy, what we used to call cutting cryo earlier, then there's a risk of dragging of the macula fovea and epiretinal membrane formation, precluding good vision. Photocoagulation is typically not performed in retinoblastoma currently because it has many complications. Photocoagulation means anemization of the tumor or cutting off its blood supply by applying 2 rows of large diameter burns around the tumor, making a small tumor into a large scar. So look at the size of the tumor and look at the scar that we have produced, and the blood vessels that pass through this area are typically photocoagulated and get blocked. So this is not a good modality to treat. But if the tumor were to be lying in the, say, juxtapapillary area, superior, then you would end up producing an inferior arcuate scotoma. So photocoagulation is mentioned only to be condemned. It is no longer used in the management of retinoblastoma. And the way to manage retinoblastoma focally is transpupillary thermotherapy. Thermotherapy is done directly on top of the tumor. So scar is not going to be larger than the size of the tumor that you began with, and the blood vessels that pass through this area are typically patent, and the scar is very crisp, does not produce desmoplastic activity because you're not photocoagulating. You're only inducing tumor cell apoptosis by heating the tumor to about 55 to 60 degrees centigrade. Now, newer advance in TTT is photodynamic effect of ICG. When TTT is combined with indocyanine green infusion, you can treat tumors which are on a amelanotic background. Like this patient has a scar with choroidal atrophy in that area. On top of that, there is a tumor recurrence, and that can easily be treated with ICG enhanced TTT. Otherwise, it's a very difficult proposition to treat such a tumor. Plaque brachytherapy is not new, but the designs of plaque have improved significantly to make us use this in situations where chemotherapy may be contraindicated. Like this child with thalassemia major could be treated without chemotherapy with plaque brachytherapy. And look at the healthy optic nerve, because we used a notch plaque here which sits around the optic nerve and treats the rest of the tumor without giving dose that is damaging to the optic nerve. Make in India plaque by BARC is also new. It reduces the cost of the plaque by less than 5%. Chemotherapy, when it was introduced in 1996, brought about a paradigm change in the management of retinoblastoma 30 years ago. But it is still the workhorse. It is still the standard of care for the management of retinoblastoma in India. It's called intravenous chemotherapy. It reduces the tumor size so much that it takes you back in time. If you begin with a tumor of say 20 millimeter in diameter, you can make it 8 or 10 millimeter before you start treating with focal therapy. Example is here where you have a tumor here and a tumor there. And finally, when you look at the scar size is much smaller than the tumor that you began with. It's not possible with any other modality except chemotherapy, where you can actually shrink the tumor before you treat the residual tumor with transpupillary thermotherapy. Advantage, of course, is vision. The second principle by which chemotherapy works is that the tumor always hangs on to its source of major blood supply. Most of the posterior polar tumors derive blood supply from one of the arcades. Here is a situation where the tumor was abutting on the macula fovea at the primary presentation. After one cycle of chemotherapy, it has moved away from the fovea, and this is the blood supply supratemporal arcade. After 3 cycles, it's completely moved away from the healthy macula fovea, thus exposing the child to good visual prognosis. So that's the advantage of intravenous or intraarterial chemotherapy. It does remain the standard of care in India, despite all the disadvantages that it has in terms of hematogenic complications, because it is easily affordable. What we have new are these new forms of chemotherapy. We have intraarterial, periocular, and intraocular chemotherapy. For intraarterial chemotherapy, the drug of choice is melphalan, but we use 3 drugs to reduce the number of cycles. Here, the interventional neuroradiologist gives us access to the ophthalmic artery by cannulizing with a 400 micron catheter. Then we take over and inject these 3 drugs right into the ophthalmic artery while monitoring the perfusion. This is very important to monitor because we don't want to have spasm of the ophthalmic artery, or we don't want to have any injury to the ophthalmic artery resulting in stenosis, thus compromising on vision. So perfusion has to be maintained all through, and these are the kind of results that you would get with intraarterial chemotherapy. It is very pronounced, very quick, and significant reduction of tumor that you get. This is total retinal detachment. After a couple of injections, you can see tumor completely calcified. Again, a similar situation where the child is exposed to good vision here because macula and optic nerve are fine. One more large tumor completely resolved after 3 injections of intraarterial chemotherapy. So intraarterial chemotherapy is extremely good, but it is expensive, so that limits its use routinely in all patients. Does it really help? Of course it does. In group D tumors, it gives about 10% more eye salvage than intravenous chemotherapy. In group E eyes, it gives about 15% more eye salvage than intravenous chemotherapy. So you have the additional advantage of saving more eyes. As far as life is concerned, it is the same. In fact, intravenous chemotherapy is preferred in children with high-risk retinoblastoma. So intraarterial chemotherapy has allowed us to save more eyes than earlier. Now what about vitreous seeds? Now vitreous seeds is a term that is old. Currently we use the term intraocular seeds. Intraocular seeds are further classified as classic vitreous seeds, and depending on the location we have prehyaloid, subhyaloid, epiretinal, intraretinal and subretinal seeds, and intracameral seeds can be depository which swim through the zonules and come into the anterior chamber. Those are actually vitreous seeds which have moved into the anterior chamber. Those are depository. Their enucleation is really not necessary. But infiltrative seeds are the ones which invade the ciliary body and iris and come into the anterior chamber, where that's a high risk factor. For intravitreal chemotherapy, we use melphalan or topotecan. Melphalan is a very powerful drug. As you see here, all these seeds went away with one injection, but melphalan has a lot of complications in pigmented Asian Indian eyes such as ours, where there could be loss of RP. RP changes are very pronounced, and there is also retinal toxicity. So here in India, we use intravitreal topotecan, which is a very gentle drug, has no retinal toxicity, and couple of injections are required 3 weekly to take away the vitreous seeds. Examples of intravitreal topotecan, you can see pronounced reduction in the vitreous seeds after 2 injections, complete calcification of the vitreous seeds after a couple of injections. These are some of the long-term studies that we have published. Now, intraocular chemotherapy extended indications are for the management of anterior chamber seeds. Like this patient was treated with intravitreal topotecan for both combined intravitreal as well as anterior chamber seeds. And this child was treated only with intracameral chemotherapy for the anterior chamber seeds. This child did not have any vitreous seeds at all. So it can be used in anterior chamber, it can be used in posterior chamber, bicameral injection, and intravitreally without any significant corneal or retinal toxic effects. One more extended indication is for the management of epiretinal or intraretinal seeds, where earlier we would do transpupillary thermotherapy, which invariably would cause a lot of retinal scarring. Now that can be completely avoided by injecting the drug intravitreally, and that actually takes care of the seeds as well, intraretinal and epiretinal seeds. Now about enucleation, we all realize that enucleation is a very good modality for advanced retinoblastoma, but the length of the optic nerve is very important. You should not depend on the textbook description of 10 millimeter, which would have still left some tumor behind in this patient. But having an optic nerve length of about 20 millimeter, if it is possible, or at least 15 millimeter, which is easily possible, is very important when you enucleate a child with retinoblastoma. Following enucleation, you should look for histopathological high risk factors, which are present in at least half the children that you enucleate in India. Why are these important? Because if you don't take care of the histopathological risk factors with adjuvant therapy, then 1/4 of children that you enucleate die because of metastasis. If you take care of the high risk factors by adjuvant therapy, you can reduce mortality to 4%. So clearly, just by this simple measure, you have 20% more survival in retinoblastoma when you enucleate. It's a very simple measure, calls for just 6 cycles of intravenous chemotherapy. So enucleation is not the end, it is the beginning in the management of retinoblastoma. In orbital RB, we have moved away from exentration to conservation. Primary orbital retinoblastoma, clinically or radiologically detected, used to have 70% mortality with exentration. Now we begin with high dose intravenous chemotherapy, which can take away the orbital component. Then once the eye gets into a comfortable phthisis, you do a enucleation with long optic nerve stump, treat the residual, microscopic residual with stereotactic radiation, and add adjuvant chemotherapy as well. So 1 year long treatment takes care of optic nerve extension, takes care of intracranial extension to the cavernous sinus, you can see nicely resolved. And the most important benefit to the child is cosmesis. You don't have to exentrate, so the child can use a good cosmetic custom-made prosthesis. Even the eyelid infiltration, as you see here, has completely been resolved with multimodal treatment without need for orbital exentration. With all this put together in 2025, we have overall 98% life salvage, which mirrors what is seen in the West. About 20% eyes still need primary enucleation. Where chemotherapy is given, 90% have eye salvage, 95% have some vision depending on the location of the scar, and 50% have vision more than 20/40 when the children are old enough to measure these. These children, despite having a macular scar, are still able to manage the vision well, whatever residual vision that they have. They are able to draw, behave like normal children, and grow up like normal children. This child has a macular scar, other eye enucleated, but she is very good at music. So these children actually grow up very well, and thus is the implication of early management and conservative treatment. Thank you so much.
Thank you so much, sir, for the talk on retinoblastoma. And so will you continue with the second talk?
Shahid can do and I'll do the...
Okay,
there could be a break from the monotony. Yeah.
Sir, actually, we are treating these patients here, and we do not give the high-dose chemotherapy for the risk of this myelosuppression.
Yeah.
We don't have the backup of bone marrow transplant. So they we have adopted the policy of giving the chemotherapy at 3 weekly intervals, the standard dose only.
Okay.
And that also is working well, sir, I think, in our observations. So what's your thought?
Stand dose works very well. High dose is mainly for orbital retinoblastoma. So when you have a child with orbital RB, if you give standard dose, it doesn't work as well as high dose. So you have to obviously have GCSF backup and a good pediatrician to take care of these children. They will invariably have bone marrow suppression, at least one blood transfusion or platelet transfusion would be required in these children in every 6 cycles. So that backup is required. If you have it, and I'm sure in an institute like IGMS, you would have good pediatrics backup. So you can shift to high dose in indications where it is really necessary.
Thank you, sir.
Next talk is by Dr. Mohammad Shahid Alam sir on management of pediatric epiphora. Sir is currently the director of the Department of Orbit Oculoplasty, Reconstructive and Aesthetic Services at the Kolkata branch of the Shankara Netralaya, and is currently heading the department. He is an avid researcher and has published several art publications to his credit.
Good evening, everyone. So at the outset, I'd like to thank the organizing committee for having me here. So pediatric epiphora, anything less than 16 is pediatric, and obviously pediatric patients are not miniaturized adults, so whatever causes of epiphora you see in adults might not be true in pediatric cases. And then pediatric epiphora is not akin to congenital nasolacrimal duct obstruction as most of us believe. So having these facts in mind, I'll begin my talk on pediatric epiphora. I am Dr. Shahid Alam. I work in Shankara Netralaya, Kolkata. So I'd like to just share this case with you. It's a 6-year-old male child who presented with complaints of watering and photophobia since birth. He was diagnosed at CNLDO, advised DCR elsewhere. And as you can see the picture here, it's a dull and irregular corneal reflex, corneal surface with loss of light reflex, as you can see in this oblique beam illumination of a slit lamp. And what do you see on retroillumination here? You see that complete absence of iris. So it's a case of congenital aniridia which has been misdiagnosed. The child had a similar picture in the other eye but didn't have much complaint because the aniridia was partial in that eye. So look for the cause. It can be because of hypersecretion, and then it can be outflow obstruction. So what are the causes of hypersecretions? It can start from eyelid abnormalities and range up to from go till ocular surface and involve some other causes like glaucoma. So in eyelid, you have to look carefully for the lashes. There can be trichiasis or an extra row of lashes as in seen in cases of dystrichiasis. Many of these patients have a family history and can have congenital lymphedema also. So in congenital dystrichiasis, you have to excise whole of the lid margin and do a cryotherapy so that there is no recurrence. So these patients also will present with watering. Congenital epiblepharon and intropion, they look similar, but they are different both on the basis of etiology and pathology. You see extra fold of skin in epiblepharon, which is not seen in intropion, but these children also will present with watering to you, and management is different in both epiblepharon and intropion. Then coming to congenital ectropion, where there is anterior lamellar shortening of both the upper and lower eyelid, leading to incomplete closure and watering. Then there is euryblepharon, where there is widening of the horizontal fissure width, leading to excessive exposure of the eye, and then again these children present with watering. Leg of ophthalmos, though not that common, but many of these patients have congenital facial nerve palsy and will complain of watering, and this sign, it can often be missed in your busy OPD. So don't forget to ask the child to blink, to close the eye, so you can assess leg of ophthalmos. And then ulcerative blepharitis. So this is a severe case of blepharitis. Many of these patients can have simple meibomitis and then can present with watering to you. So these causes also need to be kept in mind and have to assess thoroughly. Then fornicial pathologies, they are quite often mislooked, especially when they are in the superior fornix. A small foreign body sitting there. This is a small pyogenic granuloma which has been lying there and causing irritation and watering the child. Coming to ocular surface abnormalities, so there are different varieties of ocular surface problems where the children can present with epiphora. Ophthalmia neonatorum generally presents in the first month of life, and it's a sexually transmitted infection which has gone into the surface of the baby, and the patient presents with watering and excessive discharge. This is an emergency. Then conjunctivitis, both allergic and infective, has to be ruled out because many of these patients will present only with the sole complaints of watering to you. Then you have to look carefully to find out whether there is itching, whether there are subtle signs of papilla or that Horn-Tranta spot seen in the child, to exclude an allergic cause or an infective cause in other cases. A small corneal foreign bodies. So it's very difficult in a child to rule out foreign body. These patients, they will present with watering, irritation, but then since they don't allow examination, so many a times you will need examination under anesthesia, and you will find this foreign body lying there, and which is the culprit and causing watering and irritation in the child. Recurrent corneal erosions, especially after fingernail injury, is very common in children, and again these patients present with pain and watering. Keratitis, especially viral keratitis, can present with watering in children, and then you have to stain these kids with fluorescein and with cobalt blue filter. You have to look carefully about viral keratitis and other causes of keratitis in children. Again, ophthalmos has a present with a classical triad of watering and lacrimation and photophobia, and these patients again present with watering, and then you have to be careful to rule out ophthalmos in all children who present with photophobia and watering. Now coming to lacrimal outflow abnormalities, which are more common than the causes that I have described now. So there can be proximal and distal lacrimal obstructions. So there can be punctal and canalicular agenesis. So you have to look carefully on the slit lamp to rule out punctal and canalicular agenesis. Another cause which is very often mislooked is IPC, incomplete punctal canalization, where there is a small membrane of orbicularis which covers the puncta completely, and it looks like punctal stenosis or punctal agenesis. But if we look carefully on higher magnification, we will be able to find that membrane lying over the puncta. It's a congenital abnormality, and it just needs to be ruptured on slit lamp. Then congenital lacrimal fistula, there can be lacrimal valvular dysfunctions. And then last but not the least, congenital nasolacrimal duct obstruction, which is one of the common causes of watering in children. So coming on to CNLDO, so you have to assess the lacrimal outflow obstruction by observation and inspection. You have to look for the TR meniscus height, which will be raised in these cases, look for discharge, matting of lashes, and then since these children won't allow you to do a RO+ or a lacrimal sac irrigation, you have to do a fluorescein dye disappearance test to look for whether there is any outflow obstruction or not. CNLDO can have different spectrum. This is an amniontocele, a child where the amniotic fluid has been entrapped in the sac because of the obstruction. Then they can present with orbital cellulitis. This is a case of a lacrimal sac diverticula in the case of CNLDO, and then a lacrimal sac abscess in a case of congenital nasolacrimal duct obstruction. So what should be the approach? So ask for onset, how frequent it is, what are the associated complaints, ask for any systemic history, whether it is unilateral or bilateral, because they give important clue towards the diagnosis. Say allergic conjunctivitis, they are more oftenly bilateral. CNLDO also can be bilateral, but sometimes if the parents say that it has resolved in one eye but it's persisting in the other eye. Seasonal variation of symptom is very important. Patients with lacrimal outflow obstruction, they have symptoms more severe in winters, while in allergic conjunctivitis they are more severe in summers and during the spring. Then history of discharge again is very important. If the patient presents with watering, ask for discharge, ask for self-RO+ by the mother, whether there is any fluid or discharge coming out when they press over the lacrimal sac, and then history of acute dacryocystitis. Birth history, because preterm babies, they have more chances of having CNLDO, which often resolves in most of the cases. Then ask for history of trauma, and then family history, because in some cases these punctal agenesis or canalicular agenesis can have family history. Then coming on to management, as I said, treat the cause, look for the cause and treat the cause. In more than 90% of cases, CNLDO, they resolve spontaneously within 1 year. So you need to advise lacrimal sac massage in them, topical and systemic antibiotics as required, drainage of lacrimal sac abscess if it is there, and then probing and syringing, and finally DCR if it doesn't resolve. So I'll just like to share one video of endoscopy guided probing and syringing, where we do probing, syringing, but it's not blind. We find the probe inside the nose by the endoscope and see whether the probe is buried, whether it has opened correctly in the inferior meatus or not, and whether the system is patent or not. So here the puncta is dilated with the nettle ship dilator. Then a Bowman's probe is passed. We feel the heart stop, and then the probe is guided downwards, backward and laterally in the direction of nasolacrimal duct. This is how it is guided. Then, so that is the point where I have ruptured the membranous block in the nasolacrimal duct. So some people, they do this metal to metal touch to confirm that they have reached the inferior meatus. So that's what I am doing. So after that, you insert the endoscope here, lift the inferior turbinate or do an infracture of the inferior turbinate, and there you can see the probe here, nicely you see here. The probe has nicely come out, and then you generally gradually enlarge that opening which you have made here by just rupturing that wall, that membranous block, and then when you press over the sac after this, you will see this discharge egressing out from that opening that has been created, and this is syringing with the fluorescent dye, which as you see it is patent. So this is a small video of endoscopic guided probing and syringing. So to conclude, look for the cause of watering a child with watery eyes and don't label them immediately with a diagnosis. Thank you.
Thank you, sir.
Nowadays, most common cause of epiphora in clinical
Mobile.
practice is mobile, smartphone vision syndrome. The childs are continuously staring at mobile screen or laptop screen, especially after COVID era. And it is very difficult to get rid of that addiction. Even parents are not supporting for their treatment. Parents are also addicted for the same.
Thank you, sir. Dr. Santosh Unawar sir will continue with his talk on when to treat congenital ptosis, clinical decision making.
We'll be talking about the management of congenital ptosis. Whenever a child with congenital ptosis has been sitting in front of you, you have to ask and answer certain questions. What is the severity of ptosis? Are there any complicating factors such as synkinesis? What surgery would I perform? Is the surgery I'm going to perform safe for the child, or am I going to produce any complications? And what is the expected outcome? Am I going to fully correct ptosis? Am I going to leave it a little undercorrected? All this will be evaluated, and based on that, you counsel the parents. When to operate is always a question. If this child were to be brought to you just after birth, you won't obviously want to operate until the child is old enough to sit with support and you assess the amount of ptosis and is there any head posture, is there any frontalis overaction, what is the pupillary clearance, then you would like to operate, not immediately after birth. There is no harm in observing these children until they are about 3 to 6 months of age, prognosticate them and then operate. But if it's a unilateral severe ptosis, then surgery is mandatory as soon as possible, otherwise they will go into deep amblyopia. This child has unilateral ptosis. When she is attentive, she is able to clear some of the pupil, but when she is not attentive, there is near complete ptosis. This is an indication for immediate surgery. So what kind of surgery do we do in these children? It has to be reversible without any residual effect. So a suture sling is ideal. Ethibond is an ideal suture with which ptosis can be corrected to the extent that the pupil is completely exposed and the head posture is immediately alleviated. The child does not have to use the frontalis so much. So this is a very simple technique, a triangular sling, which is completely reversible when the child is old enough, and then you can do a permanent procedure. In older children, what surgery would you do? We have a range of surgeries starting from mullerectomy to frontalis suspension. like in this young lady with mild ptosis, 2 millimeter ptosis, what surgery would you do? It depends on phenylephrine test. If phenylephrine test is positive, you can definitely consider her for mullerectomy. Even if it is negative, you can still do mullerectomy. But the other option would be to do Fassler-Savart procedure. The indication for Fassler-Savart procedure is 2 millimeter ptosis and levator action should be more than 10 millimeter. And the standard thumb rule is that for every millimeter of ptosis, you resect 2 millimeter of the tarsus and tarsal conjunctiva. One more criteria that needs to be fulfilled is that the child should have at least 8 millimeter of vertical tarsal height, because you're supposed to leave behind at least 4 millimeter of the residual tarsus for the stability of the eyelid and for prevention of dry eye. Surgery is very simple. In children, of course, we have to use general anesthesia. In older children and adults, we can do under frontal block. So lid is everted and sutures are passed through the tarsus centrally in the pupillary axis, and 2/3 from the central suture and again on the lateral side. Second set of sutures is passed from the fornix to come out just short of the lid margin. Then you measure the amount of tarsus that needs to be excised, excise that particular amount of tarsus and the tarsal conjunctiva, pass the 6-0 plain catgut suture from the skin side and tie it back on the skin side. You can see that the suture has started from the skin side. We have taken the needle internally, and then the suture is run buried all across the conjunctiva, and the suture is brought out again and tied on the skin surface. I'll skip the video for the lack of time, but the effects are very good. It's a surgery where there is nearly 100% prediction. Whatever you measure, you get in Fassler-Savart procedure. One more example of the Fassler-Savart, where you can actually symmetrize the lid crease as well without actually having not done anything for refixation of the eyelid. Contraindications would be if a child were to have lash ptosis. If a child already has lash ptosis of this sort, any posterior approach ptosis procedure is contraindicated. Even some amount of lash ptosis, if the lashes are horizontal or pointing down, then Fassler-Savart should not be done. Lashes should be pointing up and forward for Fassler-Savart to be done. Otherwise, you will induce lash ptosis. Complications, of course, are there. In levator surgery, we have all these variants. Levator reattachment is mainly for acquired ptosis. In congenital ptosis, we can do levator plication, levator resection, and Whitnell sling. Levator excision is done mainly for synkinetic ptosis. In levator resection, the indications are ptosis more than 2 millimeter and levator action at least 4 millimeter. Can of course extend these indications, and there is conjunctival approach as well as skin approach. A child with 2 millimeter of ptosis, 7 millimeter of levator action, and has a lid crease already can easily be approached by the conjunctival approach. Whereas if the ptosis is more severe, there is no lid crease, about 4 to 5 millimeter levator action, this is an ideal candidate for the skin approach. How much to resect is always a question. This really does not work. How much you resect really does not work. You cannot measure and resect. But what works is the placement of the sutures. In typical case, we always place the suture right under the Whitnell's ligament and tighten the sutures to get intraoperative correction. Above the Whitnell's would be supramaximal resection. Through the Whitnell's will be a Whitnell sling. The rules are Berkey's rules. Basically, we apply the Berkey's rule as a beginner surgeon, and you nearly get good correction in almost about 80 to 90% of patients. The rule is very simple. If the levator action is 6 to 7 millimeter, you leave the lid exactly where you want it to be postoperatively, because such lids neither droop nor fall postoperatively. If the levator action is worse, you have to overcorrect on the table, because such lids actually droop postoperatively. If the levator action is better, you undercorrect slightly, because such lids actually rise postoperatively. So depending on the levator action, after having placed the sutures right under the Whitnell's ligament, you tighten the suture to the extent that you get the intraoperative correction of your choice. This is applicable for both for general anesthesia and local anesthesia, where you have used a sensory block such as frontal block. Let's quickly look at the video. Surgery starts with eyelid crease incision, which is symmetrical to the contralateral eyelid. Then you can optionally use these marginal traction sutures, which is good for a beginner surgeon. Then gentle incision just through the skin and partial thickness orbicularis. Don't go full thickness orbicularis right at the first go. Then lift the skin and undermine the orbicularis. This is called suborbicularis dissection till there is change in color. Change in color always indicates change in plane. Pink to yellow indicates that you are looking at the septum. Similar suborbicularis dissection has to be done on the tarsal side as well to expose the central 4 millimeter of the tarsus. So basically you pass your sutures in the middle of the tarsus, and that area needs to be exposed by this dissection. Then you flip the lid over the Demers lid retractor and inject subconjunctival xylocaine to create a plane of cleavage between conjunctiva molars and the levator aponeurosis. This is a good step for a beginner surgeon, because then your chance of having a buttonhole in the conjunctiva would almost be zero. Once you've done this, pass a set of 3 sutures through the levator aponeurosis. These are 4-0 silk sutures. Lamellar through the levator aponeurosis, not full thickness, so that you can tent up the levator. So once you pass these 3 sutures and hold them vertically, you actually can create a vertical pull on the levator aponeurosis like that. So there is a slope which have to make perpendicular. Now you can see that once I am disinserting, the slopes becomes a perpendicular. That means that you have disinserted levator to the full extent. Then all that you have left is molars and conjunctiva. The color changes. That pinkish structure is molars. You go back a little bit and then simply peel the levator of the conjunctiva. So this way you will be avoiding all the complications of posterior dissection. You come back to the anterior surface, open the orbital septum, release that pad of fat and go under the pad of fat. Once you release this pad of fat by cutting the septum, you retract this, go under it, and Whitnell's ligament is right there. You identify the Whitnell's ligament and pass your sutures just around the Whitnell's ligament, not through it. Cut the horns perhaps a little gently and then pass the sutures just under the Whitnell's ligament and tie the sutures to enough tightness so that you get the intraoperative correction that you have chosen. These are some of the results of levator resection. Works beautifully well. Not in all patients. Some of these patients, about 10% of patients may need a redo when the child grows up into an adult. In Whitnell's sling, you pass the sutures right through the Whitnell's ligament and the results are very good. It works like sling. But when the child looks down, there is a huge amount of downgaze lid lag and also lag of thalamus. Primary position correction is very good in Whitnell's sling. For much severe ptosis, bilateral or unilateral, we use tarsofrontal sling. Facial ETA was the gold standard. It has been replaced by silicone. Silicone has all the qualities of an ideal sling. It is not biointegrable, so it is completely reversible. Silicone sling can be completely reversed. It can be adjusted even after several decades following primary surgery. I'll skip the video. There's an example of unilateral silicone tarsofrontal sling in a child. This is again a unilateral sling. So these patients don't really have to use their frontalis to keep the lid elevated. Silicone has a good amount of flexibility, so it gives much better cosmesis, and also downgaze lid lag and lag of thalamus are much less. Special situations, of course, we deal with in a different way. Complications are plenty with ptosis surgery. This is not to scare you, but to be aware of these complications so that we can preempt them by taking care of avoiding these by having a good preoperative workup. So in conclusion, ptosis surgery is totally dependent on assessment. Initial assessment is very important. Then you set a goal for a patient. Perfection is an unreasonable goal in ptosis surgery. It is impossible to achieve perfection in all 3 cases. You can achieve perfection perhaps in the primary position. Looking up is okay, but when the child or any patient looks down, there is going to be some amount of downgaze lid lag which is going to cause asymmetry. Explain and demonstrate this on the child until the child and the parents understand completely. If they don't understand, perhaps you will have to defer the surgery. Always follow a thumb rule, and if at all you have an unexpected overcorrection or undercorrection, don't hesitate to adjust the sutures in the first postoperative week itself. Tincture of time does not help in ptosis surgery. If it is undercorrected, it will remain undercorrected. So don't take that risk at all. You can easily adjust the sutures in the first week postoperatively. That's all I had to say. Thank you so much.
Thank you, sir. Question is Marcus jaw winking phenomena.
Yeah, if Marcus jaw winking is mild and ptosis is severe, you deal with it exactly like you deal with any other ptosis. If Marcus gun is severe and ptosis is moderate or severe, then you have to excise LPS and do a tarsofrontal sling or a frontalis flap.
Thank you, sir.
Thank you so much, sir, for your inciting talk. Next, our speaker is Dr. Vivek Singh. He is currently working as assistant consultant in Shankar Nethralaya, and he has done his fellowship from Shankar Nethralaya in orbit, oculoplasty, reconstructive and aesthetic. Now he'll be, and the best part is he is our RIO alumni, and he has done his DNB from RIO Patna only. So Vivek, we welcome you. He will be giving talk on reconstruction of post-traumatic canalicular and eyelid lacerations.
Good afternoon, everyone. Thank you, RIO, for giving me such opportunity. So I will be talking about the pediatric eyelid laceration, especially the complex one. So we just start with few case scenarios which we came across in our emergency, like simply from just a skin tear to involving only canaliculars to going up to the complex lid tear where nothing can be clearly visualized with which part is there and which part is gone where. So all of these things include in complex pediatric canalicular laceration, eyelid tear laceration. So when we go through some literatures which were published in entire Western journal and Indian journal, the common point which they conclude is that that the most common cause of these tears are in children is dog bite while playing in motor vehicle accidents and their sporting activities. In Indian scenario, Blausic injury in the pediatric patient is also evident, where the most common lid involved is the upper eyelid followed by the lower eyelid. In such cases, complex tear, most of the articles reported that around 20 to 50% of cases having upper canalicular involvement also. So the principle which we follow in these cases are the same principle which follow in every eyelid tear, that wound should be thoroughly cleaned and foreign body should be removed. Healthy tissue to be preserved, we do not have to debride any tissue. And the most important point which we follow is the alignment of anatomical landmarks. That means that anatomy of the eyelid should be clearly remembered and it should be followed nicely. Then layered repair should be done, should be started from the deeper layer, and margins should be non-overlapping, everted and minimal tension. But in case of pediatric, we will need a backup of general anesthesia. And then we go through this video where this patient presented to us with a complex eyelid tear where we doesn't find anything, which part of lid is there and which part of lid is not there. So first, after wound toileting, we found a foreign body that has been removed. After that, the basic principle to align the anatomical landmarks. So we just search for the anatomy which we find. So first we have aligned, just take a cardinal suture at the lid margin, so that the some anatomy should be, alignment of anatomy will be there and we can recognize different structures which is there. So these are taking the suture at the lid margin. After that, the remaining portion, tarsal plate alignment has been done. We just take a cardinal suture so that the different structures of lid get aligned, and then we start repairing from deeper to anterior part of the eyelid tear. So the tarsal plate is recognized and just a cardinal suture has taken on the tarsal plate, and then we recognize the tear in the fornix. So the first fornix is reconstructed. After the fornicial reconstruction, we just go through the reconstruction of all the areas of fornix so that there should not be any gap there. And then proper appositioning of tarsal plate should be done, as cardinal suture was placed initially, but we have to appose nicely. And taking care that the suture should be a partial thickness, it not go behind the conjunctiva to irritate the ocular surface also. After that, we find there is also a tear in the periosteum and periorbital laterally that has to be repaired. All these deep layers repairs should be done first. And then step by step this repairs has to be followed in each and every case of eyelid repair. With lateral canthus was also tear here, so lateral canthus crux was also repaired initially to form the eyelid margin also. And then the prolapse fat is there, that was also repositioned. And after repositioning all these internal structures, skin is sutured. So then finally the lid margin sutures are done with their end to be kept long so that it doesn't go and interfere with the ocular surface, and inferior lid tear, a small skin tear was also repaired. And after that what we get, and finally the lateral canthus was formed. So these are the post-operative result of this patient. Now coming to the canalicular tear repair, we also searched a lot of journal which they also supported that the common finding which we found in these cases is that the canalicular laceration should be repaired, must be tried in each and every cases, and all the case reports or various retrospective and prospective studies suggested that most of the cases they got anatomical and functional success rate ranging from 85% to 95%. The factors which influence this successful outcome is the type of injury, whether it is a sharp cut or lacerated injury. Whenever the proximal canalicular is involved, the repair success rate is very high, and timing should be as earliest as possible. There is not a hard and fast rule that it should be done immediately. Other factors has to be taken care of. Ideally it should be repaired within 48 to 72 hours, but whenever the patient comes, if it is late, we should try the canalicular repair. They said various type of stents are available, but all the study says the specific role of a specific stent is not too much in successful. Any stent which is available, which can be used and which the surgeon is comfortable with. So for identification of the canalicular torn end, which is the most important point, various signs and various techniques has been described. So coming to the video repair, where just we saw what we should be doing. Sorry. So first, identification of the torn end of the canaliculus is important. Then various type of stents which are available in the market, which can be used, like monocanalicular and bicanalicular stents are there. And these are the stents which are easily available in India. This is our stent, no financial interest, but it makes our job very easy. So initially in the video, we see what we have to do in a punctal canalicular tear. Punctal dilatation has to be done after identification of the torn end. And in this video, this monocanalicular stent is used, where we have to pass through the proximal and then we have to pass through the digital canalicular end, which is the most difficult part in such tear repair. But thankfully, we are able to pass in this case. And we have to pass it nicely. This is the first most important step in any repair of canalicular tear. After passing, the second most important step is the proper appositioning of the canalicular ends. That is important because if they are not apposed properly, then stenosis will occur and all these things will fail. So we have to do a pericanalicular suturing, or some says that canalicular suturing can be done, direct canalicular suturing. So this way we have to suture the canaliculus so that we have to take care that proper appositioning of end-to-end tear of the canaliculus should be done. And we can pass 2 to 3 sutures, which how much as possible to take the sutures. After that, we can repair the subcutaneous tissue and skin repair as possible. So these are the precautions that we have to take, and so that we can get a successful canalicular tear repair. So coming to conclusion, eyelid tear is not an acute emergency, but each and every case thorough history and systemic assessment is important because these are traumatic patients. Maybe systemic illness will be there. That should be prioritized before repairing the eyelid. If any ocular tissue is involved, then ocular injury repair is must before repairing the eyelid. Primary repair is always superior, and canalicular tear repair should be attempted in all cases and to give the best possible and functional cosmetic outcome. Thank you.
Thank you so much, Vivek. Any questions? So with this, we will just take a break with glaucoma and oculoplasty. We'll merge the session. So I would like to call Gyan Bhaskar sir and Vibhuti sir to felicitate Santosh Honavar sir. भास्कर सर दो सर्टिफिकेट नहीं पैनल नहीं होता. Chairperson and panelists, please be seated. The same set will be continued. It's a great honor that Santosh sir has given us time and he's here. Now I would like to call Shahid Alam sir. Sir, फटाफट Vibhuti sir, please. Vivek. I would like to call Dr. Vivek. Now we'll start with the talk with Manish sir. Kirti ma'am. Okay, we'll start with talk of Kirti ma'am. Dr. Pinky, please take.
Thank you, Dr. Ankita. Good afternoon, everyone. Chairperson. So, due to paucity of time, we have started to do glaucoma talk in this session. Among chairpersons, I would like to invite Dr. Vibhuti sir to come on the desk, Dr. Pranav Ranjan sir to come on the desk, Dr. Sanjeev sir, please sir come, Dr. Asif sir, Dr. Bhavesh sir. Among panelists, I would like to request Kumari Shweta ma'am, Dr. Himanshu sir, Dr. Vidya Bhushan sir, please come. Now to start the session with Dr. Kirti ma'am, it's my pleasure to introduce Dr. Kirti Singh ma'am, who is the Director Professor in Department of Ophthalmology in Guru Nanak Eye Center, Maulana Azad Medical College and Associated Hospitals, New Delhi. She has received several awards of the Commonwealth Fellowship in 1999, 2000 and WHO Fellowship in 2009. She has more than 100 indexed and peer-reviewed publications. She has published and authored 4 textbooks in contact lens and glaucoma. She has delivered over the 800 educational lectures at the various CME at the local, state and international level meets. She has also received the 3 prestigious orations, that is the Dr. B.N. Khanna in 2019, Dr. S.N. Mitra 2020, Dr. Hari Mohan 2021 at the DOS. So welcome you ma'am. It's my honor to request ma'am.
Thank you very much. It's an honor to be here at this lovely RIO. Thank you, Dr. Vibhuti. Thank you, Dr. Abhishek and Nilesh and the team. It's the fag end. सबको नींद आ रही है? कितने लोगों को नींद आ रही है? मेरे को आ रही है. अभिषेक तेरे को तो अभी नहीं आएगी. अभिषेक खाली को नहीं आ रही, बाकी सबको आ रही है. I mean, I do this very frequently, but it helps me in my classes. Just stand up and do like this. ऐसे करो. ऐसे खड़े होके ना ऐसे. So, see, we teach 250 students, so you can imagine. So, I'll be running through my slides because of the time constraints, but it's something which is very important, and all of you sitting behind and in front and us are responsible for this disease. So therefore, we must wake up. I'll just tell you a very brief story. When I presented this slide of mine way back 10 years ago in a conference of Delhi Ophthalmic Society, the person who was loading my slide, he says, "Madam, ye picture kyun dikha rahe? No financial interest otherwise." I said, because at that time, this was the most common drug used. It was very, very economical. He says, "ये दवाई मेरे गांव में मेरी माँ शेल्फ पे रखती है, जब कभी लाली होती है आँख में, हमारे बच्चों को डालती हैं." He could recognize this medicine, and he was an audiovisual person in the Delhi Ophthalmic Society. So this is a true story I'm telling you. How common is this medicine of any steroid? This is one, there are many of them. It's a preventable disease, therefore it's all the more important for us to understand this. The story started way back in 1950s, and now it's almost 75 years and we still haven't waken up that IOP does increase after both systemic and local cortisone, and we are more bothered with the local one. I won't go on the theory that you have in the textbook, but the definition as per the current is that IOP increase of more than 10 millimeters mercury with clinical significance is defined as SIG or steroid-induced glaucoma. Steroid challenges were given, it was proven. Normal population may it is less, it is moderate response and high response, whereas their super responders are very few. But in open angle glaucoma patients and in their siblings, the response is much more. It's as if that steroid-induced glaucoma unmasks the open angle glaucoma cases. These patients are actually the ones who will develop glaucoma even later on in life. It's a bimodal one. We are more concerned because today the topic is children, and actually it is much more in younger children. It's more common in connective tissue disorders and in uveitic studies with JRA, high myopia, 88% are high responders. Post LASIK surgery, the IOP anyway is masked because it is reduced due to ocular rigidity, thin cornea and fluid interface. Cause we all know about the MacLean's theory of the biological edema and the altered phagocytosis. What is new is that it is TGF-beta2 signaling at the metalloproteinases, and there's something called as CLANs. Cross-linked actin networks are being formed, and the cytosolic alpha isomer of the GC receptor, the glucocorticoid receptor, has a transformational change. So things have really shown us how the glucocorticoid receptors changes the trabecular meshwork cytoskeleton, which is the other medicine which acts on the trabecular meshwork cytoskeleton. A new drug. Come on. Sir, you are not eligible to speak. Rokinase inhibitors. Thank you. So if you are all of you are awake, so this is basically new imaging things are coming at the molecular level to see what is happening. We also have many genes identified. Still the pathway is not clear, but we are getting there. Now in whom to anticipate? We've all talked about VKC, Dr. Vanathi talked about VKC and keratoconus. VKC anyway is a problem in India. And we always have to give steroids in that. The topical one causes the more problems. Other things are uveitis, nephrotic syndrome and asthma or the other issues. What is the actual magnitude? Huge. Okay. 2.2% of the 4,000 cases of VKC had steroid-induced glaucoma. Chitrakoot study 3.3% of the 1400 cases. West India study 4.7% of the patients. North India 24% of the acquired childhood glaucomas. This is a huge amount. It's a volcano there which we are ignoring. 1/5 of these patients who have steroids, 1/5 of these young children who were just given steroids for itchy eyes require trabeculectomy. That is sad, really sad. As I said, this drug, because it is not only this, there are many other drugs, because it is easily over the counter available and the sale in India is much more. Do you know why Mucor happened in India? COVID was a pandemic. USA, Italy, Australia, Japan में Mucor क्यों नहीं हुआ? Because of rampant steroid use, because we are responsible for the irrational therapy, and this also is a disease of our making. So this is a very beautiful study if you want to read about it, that 36% patients who came to this center in Chitrakoot because of vernal conjunctivitis, misuse of steroids, were blind. And we all know that it also causes cataract, but glaucoma is the more important problem because it's irreversible. Depot steroids, retina people use it very frequently, intravitreal, and they have an earlier response, 4 to 8 weeks. Risk is much more if the baseline IOP is high. Therefore, always the retina people just measure the IOP before you're giving the depots. We used to give posterior subclenons very frequently. Now we're very wary of it because 1/4 of those patients will land up into steroid-induced glaucoma. This is a small video just to show you. This is a PST with SIG. It had to be operated. We tried to wait out all the 6 months and see whether it would come out or not. And this child already had that PST there. So this is the frilled suturing which we do, and this is the PST which was present there, which we are removing. Now the studies are saying that if you have to inject PST, do it in the infranasal quadrant, leave the superior quadrant for the glaucoma people to operate on. Post-surgical squint patients, very common, especially super responders, complicated cataract, PK. Now all these patients have the other causes of glaucoma also. The glaucoma could be because tight muscles, because of the band, because of the silicone oil. Therefore, you have to differentiate steroid-induced glaucoma from the other complications. What is the normal time? 3 to 6 weeks post-steroid use. Again, unless the patients are high responders. The dose and duration is proportionate. The propensity is more with the more anti-inflammatory potency like betamethasone, dexa, prednisolone, and less with the fluorometholone and others. Duration of use, longer the duration, and the formulations. 4.57 minutes are left, sir. What has happened? Why are you putting these? The systemic steroids. Now we all think it is topical only. Systemic steroids also are there, and there are very recent studies which talk about systemic steroids with the odds ratio being much more with the potency of the steroids and the duration of the treatment. In our hospital, we did a study on nephrotic syndrome, and we tried, because these children are dependent on steroids, and we tried to find out what was their steroid responsiveness. We had more than 100 children who were studied. Oral corticosteroids of 12 weeks was given in them, only then they were taken up. People on topical steroids were excluded. 88% were steroid sensitive, means these are the nephrotic type who require more steroids. Out of these children, 4 children had PSC over 12 weeks of steroids. They had this posterior subcapsular cataract just over 12 weeks of treatment. They were not visually significant, vision was not affected, but gradually it would be. And 5.9% had high IOP. This was a statistical significant response which we found, and the mean steroid dosage was 7,049 milligrams, and the duration was 86 weeks. So we could titrate, and what the worst part was that none of the pediatricians who were treating, none of the parents who were being treated realized that ocular side effects of steroids are so much. This questionnaire answered that question for us. Uveitis, juvenile idiopathic arthritis, has a high incidence of SIG, 1/3 of the pediatric patients of USA. Now it is vision saving, but you have to just see what the steroid responsiveness is like that. Again, it's a diagnostic dilemma in uveitis because of trabeculitis and the other aspects. Inhalational, we are lot of asthma is being treated with steroids. It is the mainstay. However, till now, a very good study called as the iCurve study from the UK General Practice Database and other studies said that inhalational probably has no relevance till now. Same for skin application, unless you have application on the upper eyelid of the skin. There the absorption is more. This we had a patient who came to us with depression, this boy, because he had feminizing features, and we just found because his vision was blurred. He had secondary glaucoma because of endogenous steroids. Now the problem in children was that child is unaware. The problem is in diagnosing because of pachymetry, IOP, and the PSC associated. You have to have a high dose indication, high suspicion rate. First of all, stop the steroids, reduce and replace with tacrolimus, cyclosporin. Tacrolimus is a lifesaver because it really helps control the VKC. Replace with the steroids which have low propensity like fluorometholone and lotiprol. Add second anti-glaucoma drugs, beta blockers, carbonic anhydrase. Avoid alpha agonists in children younger than 6 to 9 years, and prostaglandins, not because of hyperemia, they also cause the pro-inflammatories. Trabeculectomy, you may have to do, as we just discussed, more than 1/4 of the patient required it. You stagger to the nasal side because these children will end up requiring a second trabeculectomy. You have a lot of dry eyes, so you do cyclosporin. Failure is common and patients will still rub the eye. Latestly, you have this tissue plasmid activator and gene therapy which is coming up, still not there. I'll just show you 2 videos. This is a child of VKC in which we had the cataract. We did the releasable sutures. Incidentally, try to do releasable sutures in all the trabs of especially children. This was an older child, so this releasable we could remove later on. So we did this releasable. For the children who are younger, we do a surrogate releasable. Do not operate with active VKC. Do not do a combined surgery. Stagger it. This was an inflammation done long ago because of the combined surgery. And it required a lot of steroids and to get to this stage. Limbal follow-up VKC. What you do here? You have to wait for a trap. Don't operate. You have to titrate till with anti-glaucoma medications or with Dimox also. You may try MIGS procedure in these patients. Antifibrotic use is must. Poor conjunctival healing is there. You may do tenonectomy. Cataract is often associated, will progress. Take the prognosis. Tell the patients that parents that this child will have cataract requirement later on. In these type of deadly types of cobblestone, you may use an intralesional steroid and a Dimox cover. Yeah, thank you. I'll just finish in 2 minutes now.
Thank you, ma'am, for your valuable insights on topic.
She's sleeping.
Sorry.
Intralesional. Just have to give 1 more minute. I'll just show you something called. So good.
Sorry,
yeah.
ma'am.
So
Sorry
good.
to interrupt you, ma'am.
So what are the measures you can do to prevent? First is all of they gave a topic like this to me that cover up steroid-induced glaucoma, and you saw that the pediatricians and the caregivers were not aware. Do you know how many children are prescribed steroids by quacks and how many children are prescribed steroids by doctors? Can I have the slides on? How many? Any guesses? All these studies are quoted right now. 90% of the steroids were prescribed by doctors, not by quacks. It is not that this irrational therapy is by the people who are not educated. It is by the people who are educated. Surrogate releasable is something which we do because these children very often can't cooperate for releasable. So we use 6-Vicryl as releasable, which will get absorbed over time. And you screen these patients. What I do whenever I give steroids to a VKC patient, I will, audio please, I tell the mother or the person that this is you, I'm writing your name because make them accountable, that Abhi, we are giving these steroids for 2 weeks, 3 weeks, don't keep on using it, don't get it from a chemist, come back and show me because this can cause blindness. And the other thing we do is, this was another patient who had Duchenne muscle dystrophy. He had blindness in one eye. The father had an OAG. So I was just telling you, it unmasks OAG. This is a sibling. This is the child of a first patient with OAG who had steroid responsiveness. We wrote on this thing that do a steroid sparing drug for Duchenne's. They did not. This child came with cataract and glaucoma. What we do is we have these physician of the first contact is the MBBS student. We empower them during glaucoma week about steroid-induced glaucoma. We have these videos where we teach the parents and the patients in the OPD about how to manage Nukkad Natak and how to manage glaucoma and how not to use steroids. Okay. So this is to conclude that magnitude of blindness and magnitude of blindness due to steroid-induced glaucoma is immense. Look at these figures. Therefore, we have to reduce this Make in India complication and exorcise this from our system. Thank you very much.
Thank you, ma'am. Such a wonderful presentation, ma'am. Next,
thank you, Kirti ma'am. Thank you, Kirti ma'am, for eye-opening deliberation on steroid-induced glaucoma, and very well explained. I mean, one of the things which is very important to me, what I was just discussing, that a lot of pediatrician, lot of doctors use oral steroid on children and all. So for them, the awareness factor is very, very important, so that they are made aware of the fact that every child who gets a steroid oral, topical or whatever way, should be examined for intraocular pressure at least once after a month.
That's exactly what I said, sir. That
so
nephrotic
that
syndrome.
awareness
Now,
among
after that study, sir, now the pediatricians sent to us कि आप एक बार इसको देख लीजिए. So that was an eye opener for us also.
Ma'am, a wonderful talk. Just want to ask something about steroid challenge. So any patient, any child who is likely to be prescribed steroid, should we give some kind of challenge before once they have to shift it to subtenon injections or something like that? So should they be given kind of steroid challenge, and is it like a perfect way to move ahead? Steroid challenge in form of drops to see what happens to the IOP, and then actually proceeding on before giving the injections.
So very, very nice question. Actually, that was how it was diagnosed by Amelie and Becker. They gave a steroid challenge to diagnose the responders, and this patient which we reported, the endogenous steroid one, we were not sure what we were dealing with. We did give a steroid challenge, but nowadays it is not ethical to give a steroid challenge because you don't know how many would respond. So you use more a rational therapy of steroids and monitor. If you have to give a PST, then you monitor. If you have to give it intravitreal, you monitor rather than doing a challenge and then saying ki hum de ki nahi de, because giving of steroids is also vision saving. So the glaucoma, when it happens, you can treat it if you are vigilant and the patient is vigilant. So we have done steroid challenge historically also, but now it is not ethical to do that, sir.
So, ma'am has such a elaborate discussion on, and it's very required, highly required in our segments basically. Do you suggest that whenever we get such kind of steroid-induced, people, the people who are responder, we should write prominently on the prescription as an steroid responder, number one. Also, to educate the parent to not to take steroids or warn the physicians to write regarding the steroids for those, because it really works.
So can I shake your hand, sir? I was doing the same thing, exactly boy. Because on that prescription, I was writing, and the prescription I was writing कि ये दवाई दे रहे हैं, इससे काला मोतिया बन सकता है, so that even if they tear the prescription, that thing, visual impact will work. And for that patient with Duchenne and the others in which we find it, we do write that this patient is a steroid responder, please do not. There was a patient of LASIK surgery who came to us with glaucoma in one eye which was undiagnosed, and we did write that do not repeat the same thing, he's a steroid responder. So we do write it, sir, and we do tell the parent, बच्चा तो छोटा होता है, माँ को या बाप को जो भी साथ में है कि ये दवाई आपको लंबा नहीं देनी है. We don't want the steroid responders to get the medicine, but that the steroid response may occur, so just stop it short of that, this thing. And as I said, tacrolimus and the other cyclosporin things, they're very, very useful, and we can start using them instead of just giving steroids.
Definitely, it's really helped. Thank you, ma'am.
So it's my pleasure to introduce Dr.
May I ask one question? As you said that trabeculectomy, the success rate of trabeculectomy in VKC is not great as in other cases, but still there are many cases of VKC when the VKC is quiet, there is no active VKC and patients are on immunomodulator, but still if these patients has 0.9 or 0.8 cup and require the surgical intervention, what are the ways to improve the success rate in trabeculectomy in these cases?
Make it quiescent, make it quiet, only then don't operate on an angry eye. Maybe you have to give Dimox for at least 2-3 weeks and meanwhile get the VKC quiet before you operate. Stagger towards the nasal side. Always use mitomycin C, which normally also do. Always use releasable sutures. I do a little bit of tenonectomy also in children because the tenons is the problem. These children are rubbers. उनको आदत है आँख मलने की. So there is a bleb dehiscence also very commonly with them. Although touchwood, I haven't seen one, but it is known. So tight suturing and releasable suture. Post-op, what happens is I'm little afraid, although it doesn't happen, ki they can respond to steroids. You are giving steroids and then you can respond to that also, although the pathway is there. So I try to give oral steroids in addition to topical steroids and give a dose of oral steroids for 5-6 days, because oral have a less propensity to cause the responsiveness, and topical I finish off in 2 to 3 weeks and then go into fluoromethalon et al. And VKC के लिए I call the patient again after 3-4 months, suture removal सब कुछ हो गया, 3-4 months के बाद, and I evert the lid to see कि उसका VKC कितना active है, and then tacrolimus etc. and lubricants.
And do you recommend the frequent bleb needling with fluorouracil in VKC patients more than other patients?
Actually, there is no such control study I have that VKC vis-a-vis the other primary congenital glaucoma children which we do, but needling anyway is part of our repository. We will do it, and whether I don't normally like 5-FU, I prefer mitomycin C because 5-FU doesn't really work. But if you find early fibrosis, what I am doing now is just doing a saline needling within 4 weeks. उससे आप early जो fibrosis आप तोड़ देंगे अगर, and mitomycin C you can use later on, because the early bleb fibrosis can tear only with the needling with the saline itself. So monitoring has to be very vigilant just for any glaucoma, but these conjunctivas are not very good, so their healing is also bad.
Thank you so much, ma'am.
Yeah.
Okay, thank you, ma'am. Now I'd like to
कितने एज तक दे सकते हैं, कितने एज तक के बच्चे को
tacrolimus किसी भी एज तक दे सकते हैं. स्किन वाला if you give it over the eyelid. But the other one is the oros, the tacrolimus ointment भी आती है जो ocular होती है. Ocular वाली you give it like that, just place it like that twice a day or once a day. And in addition, sometimes I use orosporin, 2% cyclosporin, and of course FML in between. This is for the VKC, especially जब spring आएगा, जब वो allergic season आएगा, तब वो बच्चा ज़्यादा rub करेगा. Now we remember VKC rubbing से keratoconus भी हो जाता है. So one cause of blindness is glaucoma, one cause of blindness is the corneal curvature change. तो उसको भी हमें रोकना है. So therefore you start giving this, and also look for any allergen outside. अगर कोई allergen जैसे dogs या cats हैं उनके पास, pets है, तो avoid that or change the climate, so that allergic cut come ho, because most of these children outgrow them when they are 12 to 13 years old. So till that time aapko ye sab, you have to play with tacrolimus, with orosporin, with NSAIDs, with lubricants and all those things.
Thank you.
So any other questions? Thank you, ma'am. So I would like to request Dr. Manish sir. He is a senior glaucoma consultant and executive director of Netralam Super Specialty Eye Care Center, Kolkata. He is delivering on a talk on the management of pediatric glaucoma. Yes, sir.
Thank you so much for having me, and it's a vast topic, pediatric glaucoma. I'll try to cover in 10 minutes. In fact, I was supposed to speak after Dr. Ajit, so he would have made my work easier. Now I have to do the other way around. But because of the, I think, flight issues, there is a slight change in schedule. So I'll skip the diagnosis part, which I'm sure Ajit will discuss in detail. But to make things simpler, we generally classify them as true congenital glaucoma, infantile and juvenile. The earlier the patient present, the more severe is the disease and bad is the prognosis. So classifying them helps you understand how aggressive you need to be in managing these patients, because it's a blinding disease if not managed early and properly. The diagnosis part I'm skipping for Ajit. And one important thing I'd like to share, there are a lot of interesting charts, like this particular chart is from Becker-Sheffer. I always keep in my OT, because in pediatric eye, the pressure at different age group and what should be the normal corneal diameter, this is something which is difficult for us to remember. So based on this, you can understand, for example, say at 1 year age, anything more than 12 millimeter corneal diameter is indication of glaucoma. So you can use this chart if you are to serious pediatric glaucoma practice. It will be very helpful when you are evaluating this patient under anesthesia. Now this is the main focus of my presentation. What is the management of pediatric glaucoma? It's primarily surgical, but when you're waiting for surgery or else you have a failed surgery, also in secondary glaucoma, there is a role of medical management. The main drugs are beta blocker and carbonic anhydrase inhibitors. In beta blocker, you have to check with the family whether the baby is having any heart disease, any lung problem. And after starting the drop, you should ask the mother that after starting drop whether the baby is having any coughing or not. That's also an evidence the patient may not be able to tolerate beta blocker. Brimonidine, we all know, not to be used less than 7 years age because it causes CNS depression. Prostaglandin and pilocarpine can be used, but they are less effective because angle at this stage is still not well developed. Always teach nasolacrimal duct obstruction to reduce the systemic absorption. ROCK inhibitor, I think we all are using, we want to use in pediatric glaucoma also, but the data about ROCK inhibitor in pediatric glaucoma is quite variable. There are some studies like this particular have shown almost 8 millimeter IOP reduction, while other studies have shown that the patient effect is minimal. So you can try in your patient. Some of the patient may respond, but not all of them. They are definitely not the first line drug. Now coming to the surgical part. So if I get a patient with pediatric glaucoma, congenital glaucoma, where I want to go for surgery and the cornea is clear, my first option will be to go for a goniotomy. If the cornea is hazy, I'm not able to see the angle properly, then I'll go for a trabeculotomy. Trabeculotomy with trabeculectomy is generally reserved for patients who present late or maybe the corneal diameter is more than 40 millimeter mercury. And glaucoma shunts and ciliary ablation we reserve for patients where we have failed surgery or sometime in cases of secondary glaucoma, and we'll discuss it. Goniotomy, as students or as practitioners, we have always thought that goniotomy is not a good option in India, right? Because most of the patients of ours present late, and when they present, a lot of them do have corneal edema. But there are now a lot of studies, and this is a very interesting study from the PGI group in 2021, where they have shown that a lot of patients do present early where you can do goniotomy, and they've shown a result of as high as 80% over first year, and even as a secondary procedure they have found a 70% success over a first year period. So in 1 year you can get a good success with goniotomy. You can have a bit of corneal haze, but you can, using an MVR knife, you can cut open this Sclems canal, remove that Barkan membrane, and you will see the falling of the iris backward to see that the angle is opening up. But this is the most preferred surgery in India. The trabeculotomy, this is similar to trabeculotomy, but there are slight modifications. So you are doing a conjunctival dissection, then you create a triangular flap. This is the way we are doing it. Once you have done the flap, the most important thing is the dissection of Sclems canal. So you need to give vertical incision at the junction of the gray and the white zone where you get these Sclems canal. And once you see this little bit of ooze coming, now you know that the Sclems canal is opened up. If there is a sudden gush, then probably you have pressed a bit too much and you have entered into the entry chamber. Once it's there, you use the Ham's trabeculotome, the left side and then right side. So basically what you're doing, you are entering into the Sclems canal, turning centrally to, you are creating a communication directly from the entry chamber to the Sclems canal, sort of removing that Barkan's membrane, removing that membrane which is obstructing the outflow. Where are the cases where we do trabeculotomy? With trabeculotomy, cases which are presenting slightly late with larger corneal diameter. First, here we do a trabeculotomy, right side and then left side. Once we have done it, then underneath the scleral flap, you are now converting into a trabeculectomy. So you are entering the anterior chamber and then you are using a punch to create the opening, and then a routine peripheral iridotomy, and then you complete the trabeculotomy with trabeculectomy. Overall, with trabeculotomy and combined surgery, over a 1 year period, more than 90% success have been reported, and Dr. Mandal, as you all know, has done a lot of work on this area. Dr. Mandal now has popularizing a new surgery. There are not enough data on that, but this is called what he calls as the impact surgery. It is illuminated microcatheter passage assisted circumferential trabeculotomy with a trabeculectomy. So instead of doing a harm trabeculotomy, he is using this catheter entering into the Sclems canal 360 degree, and you are doing a 360 degree trabeculotomy, and once you have done that, now you do with the routine trabeculectomy. Now what are the role of glaucoma shunts? They are mainly reserved for cases where the trabs have failed, you don't want to do repeat trab, or in cases of secondary glaucoma like aphakic glaucoma, pseudophakic glaucoma, Sturge where overall the success of trab is poor, you can even go for a primary shunt surgery. Like share this case, this is a patient who was a case of axonfil anomaly. You can see already there is a failed bleb here, the pressures are almost 30 millimeter mercury on 4 medication, it's one-eyed boy, you want to go for a definitive surgery. In this case, you can't go for a direct cyclophotocoagulation. Axonfil anomaly anyway has a slightly poorer rate of trabeculectomy and even poorer rate of resurgery. So in this case, glaucoma shunt like Ahmed glaucoma valve can be a very good option. Basic surgery we all know, I'm not going to detail of it, but when you're operating a pediatric eye or young eye, you need to know that you need to keep the tube slightly longer, because you know, as the baby increases in size, as the child increases in size, the eye is also growing, but your tube will not increase in size. So there is a retraction of tube. So always keep the tube slightly longer. So in routine cases, if you're keeping 2 millimeter, maybe 4 millimeter, you can keep the tube and keep it as away from cornea as possible. Even if you are touching the iris, it will not cause much harm, because as the eye will grow, there is a tendency for the tube to straighten up and move anteriorly. So keep it as away as possible, because in the long term, the most common complication which we have seen, one is the corneal decompensation. Even if the tube is not touching, with the blinking of eye or when the child is rubbing the eye, there is always some movement of the tube, and that can lead to this corneal decompensation. Plus there is also theory that there is a reverse flow of aqueous from the subtenon space back to the entry chamber, which contains toxin, and that is why you always often have these type of localized corneal edema. So that is why whenever we operate pediatric eye, we always try to keep the tube as away from cornea as possible. This is a patient who already had a failed trap with a complicated cataract, a 4-year-old boy. In these cases, you can go with the Ahmed glaucoma valve. You can see we are using the pediatric version, the smaller version. First, you have to secure the plate, because once you have done the cataract surgery, done a vitrectomy, eye will become very soft. Then securing the plate becomes difficult. So you first secure the plate, then you go for the routine cataract surgery, implant the lens, do vitrectomy, implant the lens, and then you complete your tube surgery. Again the same, slightly keep the tube longer and as away from cornea as possible. So as we know, pediatric shunts are also available. So if the eye is very small, you think the FP7 version is too big, you can go for a FP8 smaller version. Now I'll talk about some other options like the aqueous drainage implant, the RD. The RD is a non-valved implant. There the post-operative hypotony is more, but the advantage is it's very, very cost effective. It just costs 5,000 rupees compared to 28,000 for a Ahmed glaucoma valve. There have been a lot of head-to-head trial comparing the RD with Ahmed glauc. This is a very nice study from LVPI, where they found that RD actually gives you slightly better IP control at 1 year compared to Ahmed valve. But yes, there is a bit of risk of hypotony. So if the patient is local, you can do a proper follow-up, and slightly adult eyes, slightly older child, you can do RD. But Ahmed glaucoma valve is safer if you think the post-operative follow-up will be difficult, because every time taking the patient for examination and anesthesia might be difficult. This is another surgery which we are using now currently, a lot of patients. This is another boy who was a post-retinal surgery. We did a Ahmed clear path. The reason we are using it, because in this case you don't need to do muscle dissection, which you have to do with the RD. Since it's a non-valved implant, so what we need to do, we need to ligate the tube, so that in initial 4 to 6 weeks, you can see this is the implant. We need to totally ligate, make sure there is no aqueous flow for 4 to 6 weeks using the Vicryl. And we are putting some slits which will help in some oozing of aqueous, so that initial 4 weeks there will be some control of pressure. This is a very soft implant. You need to do only 4 to 5 millimeter of dissection, and you can fold the implant and put it inside. So a very small incision is enough to put this. This is what we call as the taco technique of insertion of Ahmed clear path. And since you're not doing muscle dissection, it's a very fast surgery compared to an RD implant. There is also RD250 available, which gives you less hypotony. Here you can use this ripcord, similar to what we have been using in Ahmed clear path. Only disadvantage here is in RD, you have to still go for a muscle dissection. I'll skip the video. This is a ripcord which we are telling. So in these cases, you have to place a ripcord. Post-operative, the pressures are high. You can just simply pull it even on a slit lamp to increase the flow. I'll just conclude by just share the MIGS, because MIGS is coming in a big way in adult glaucoma. We know about the bank surgery, where we use a 26 gauge needle to open the Schlemm's canal by cutting the trabecular meshwork. The bank surgery has now also been used for pediatric eyes. If you're not very comfortable with a goniotomy, you can do a bank surgery even for pediatric eye. You can use an MVR blade to open the Schlemm's canal, and you can use a 26 gauge needle, or another option is you can just use a Sinskey dialer and tear open the Schlemm's canal. You can see this iris processes, and you can see the groove being created. And there is a study from PGI where they have compared the bang with goniotomy, and they found interestingly both give you similar IOP control. So if you're comfortable with goniotomy, great. If you're not, even you can go for a bang surgery in pediatric glaucoma. Even better is the suture GAT. where you open the Sclems canal and then you are using a 5-0-proline, cannulating it from inside, and 360-degree after cannulation, when the suture appears, you just pull the suture, 360-degree whole of Sclems canal will be opened up. And there is a study from AIMS just in 2025 published where they've shown it gives you 50% IOP reduction, which is probably the highest in any mixed surgery for pediatric glaucoma. These are reserved for failed cases, and I think secondary glaucoma madam has already discussed. I'll just share 2 cases before I end my presentation. One is this year of ubium. Like this patient of pediatric glaucoma we planned for AC wash. We thought there is a hyphema. But when we did it, because the baby was not aligned to examine, it was just 3-year-old child. When we did a ubium, we found there was hardly any hyphema. It was actually corneal staining. It was appearing like a hyphema. So sometimes ubium can be a very important thing when you can't see the anterior chamber details. Another patient where you're planning for a surgery, when you do a ubium, you realize there is a iris touching here. So it's a Peters anomaly. So if you have a corneal opacity, you're not able to see the anterior chamber properly, consider doing ubium on table before the surgery. Treatment of amblyopia again is very, very important. Always have a cornea consultant with you because pediatric glaucoma, a lot of them will require a corneal surgery. So it's a multidisciplinary approach. You also need a retinal surgeon because a lot of them are prone for retinal tears. So pediatric glaucoma overall has to have a multidisciplinary approach in a setup like RIO, where you have the cornea consultant, glaucoma consultant, retina consultant, all need to pitch in, and also a pediatric ophthalmologist. Thank you so much.
Thank you, sir, for insightful presentation. Any questions?
So yes, actually it's such an elaborate as usual by Dr. Manish.
Very nice presentation, Dr. Manish, as usual.
Yes, sir. And
But,
it's a
but you only covered the surgical part. What about the medical management initially when you examine, when you see and diagnose a patient of congenital glaucoma?
So examinations have intentionally skipped because I think Ajit will be discussing examination.
No, after you have
regarding the medical management, as I showed in one of my slides, the primary drugs are beta blockers and carbonic anhydrase inhibitors. The second line drug will be prostaglandins, oral diamox.
So these 2 drugs are very important. Beta blockers
and carbonic anhydrase
inhibitors. They are the first line of treatment.
But do you agree that actually the treatment of primary congenital glaucoma is surgical?
Definitely, definitely. It has to be surgical because the primary problem is in the angle. The angle has not developed, the iris is not receded back, and there are remnant tissue over the trabecular meshwork which are not letting the aqueous go out. So unless you remove it, you cannot totally control just by giving aqueous suppressants. So you have to remove the membrane, you have to create an outflow channel. So surgical management definitely is important, and the first surgery is the most important surgery. So definitely all of those who are doing pediatric glaucoma surgery should have done at least 50-100 adult trabs so that you are comfortable with trab, because the handling of tissue is also different. You will feel like you are cutting butter. The tissues are so soft. So and first surgery, try to go slow, try to properly dissect the Sclems canal, or if you are doing goniotomy, properly dissect, because first surgery, if it is successful, will get the best results.
Also, there is very little space because the cornea is very large.
Definitely little space. And also a big problem is, like in adult, we have lot of post-op management. Post-operative, you can give 5-FU, you can do massage, you can use releasable suture, you can do suture lysis. But in pediatric glaucoma, whatever you are doing on table is final. Or else every time you have to take the baby again to the OT to do the massage.
How frequent you do the EUA in a
What we are following now, after surgery, we examine the patient in the OPD. 1 month after surgery, we take the baby again for evaluation. If we find everything is okay, then after 3 months and then 6 monthly, we do the evaluation.
Definitely, sir. It will help the protocol too. Thank you. Thank
sir, excuse me. Sir, what is your preferred resurgery if initial trab and trab fail in the primary congenital glaucoma? Whether you go for again trab and trab or you go for the glaucoma shunt surgery?
If the first surgery has failed, initially we start with medical management again to buy some time, because in less than 3 years, a big problem with these shunts is that the complication rate is high and a lot of babies will rub their eyes. So we do get a lot of tube erosions. So generally less than 3 years, we try to avoid doing shunt as much as possible. If the trab has failed, we'll start with medical management. If we see there is a lot of healthy conjunctiva left, we can still give a try with a trabeculectomy. Mostly if the kids are more than 3 years, we go for a Ahmed glaucoma valve.
Any other questions? So thank you, sir. Now I would like to invite Dr. Bhibhuti sir to felicitate Dr. Kirti Singh ma'am.
Pranav sir, please
Pranav
come.
sir, please sir, come. I like to request Bhibhuti sir to felicitate Dr. Manish Singh sir.
सर एक्चुअली जो अभी आपने देखा ना उनकी स्टडी जो थी काफ़ी सेंटर से टियर लेवल्स विद एक्रोलिमस बीकेसी में तो दे हैव डन कि एक्रोलिमस पर से
Sorry.
जो स्किन वाला है 10 years वाला वो पहला सा डॉक्टर है यहाँ कि दिन में एक बार
Next, I'd like to request Dr. Ajit sir, who is the director of Rajendra Nagar Super Specialty Ophthalmic Science Center, Bihar. He is the founder Sada Eye Dental Hospital, Patna. He is a chairman Scientific Committee of POS and editor proceeding of Bihar Ophthalmological Society. He is delivering on the topic of the assessment of pediatric glaucoma, tips and tricks. So please.
So thank you, Dr. Pinky, for nice introduction, and congratulations the whole of the RIO team under leadership of Vibhuti sir for the 30th for RIO Foundation Day. And actually this talk should have been earlier than the Dr. Manish, but moving forward, there is nil financial interest. And I am coming directly to the pediatric eye evaluation, as Dr. Ravi will talk about the classification and other things. But I would like to reprimand few things. There is a child glaucoma research network classification for the pediatric glaucoma, and we all should go through that one, and it gives a very useful classification system where keeping that in our mind, we can go for the comprehensive eye examination in pediatric glaucoma, which is usually completed in multiple sitting with compassionate family touch, because the parents are very much careful, very much apprehensive regarding the pediatric system. So childhood glaucoma in India, there are 3 categories: primary glaucoma 23% and secondary glaucoma 36%, and out of all those, diagnosed glaucoma, primary congenital glaucoma is most common, 32%. So this chart we have to remember for the pediatric glaucoma, where if there are out of 5 criteria, if we found 2 or at least 2, we can classify it as a glaucoma. IOP more than 21 millimeter of mercury, optic disc cupping, which should be progressive or asymmetric. And if we find half stria and corneal diameter, as per Dr. Manish has already shown that chart, we all have to keep there. And there should be in older children, after 5 or 7 years, there should be a reproducible glaucomatous visual field defect without any other reason. But the another point is, if we have only one criteria, what we should do is that patient is marked as a glaucoma suspect, and that needs follow-up in every 3 to 4 months, and he may turn to the another group. So coming to the primary childhood glaucoma, it has 2 types: primary congenital glaucoma and juvenile open-angle glaucoma. And this primary congenital glaucoma is an important one because it has the isolated angle anomalies, and here the increase in ocular size is there, because eyes grows till 2 years of age. So sub-classification based on age of onset is there: neonatal onset, infant onset, and juvenile onset, while juvenile open-angle glaucoma can be treated as a primary open-angle glaucoma where there is no ocular enlargement. So coming to the clinical evaluation and diagnosis, we must have a sheet ready beforehand for the every case. And whenever this happens, when you go inside OT for the evaluation, you don't have any sheet and you don't know the protocol, and you are in a haste of anesthetics being urgent and everything. So always have a seat and try to fill it right from the OPD to the evaluation under anesthesia. Which I take as a measure, I make it a two-step evaluation. Fundus evaluation under sedation in OPD, because we can't do gonioscopy if our children are dilated, and we can't even with a anesthetic agent there is some dilatation after anesthesia, and the glaucoma evaluation under anesthesia inside OT. We must be clear, we were talking about in a cornea that evaluation under anesthesia should be there. So we must know why we are taking the child to the for the evaluation. If it is glaucoma, we have to keep that in our mind, and definitely USG and AS scan, if it is there, it will be very much useful. So history is very important in pediatric glaucoma. Many information are collected during history itself. Always ascertain and document to whom you are talking. You should document it. Prefer mother and father together for its onset, siblings, make a pedigree where it is, ask about co-sanguinity in a manner which can reveal that one, and always prioritize their symptom address, observe the child during the examination. So this is a brief decision tree to guide categorization according to Childhood Glaucoma Research Network. Details will be shared by Dr. Ravi. And during comprehensive eye examination, we have to check if the child is young, we have to check the fixation as well. Fixation, if it is followed or not. Many a time child are unable to open the eyes itself. But in older children, we can go for the retinal refraction, and we can document that one. Always look for the facial symmetry, like in this and developmental milestones are achieved or not. There is a port wine stain or hemangioma or dental anomalies. Always look for the dental features if it is there, and upper lower body ratio. So like in this child, if you see, this child has a port wine stain on over a half of the face, but also there is slight elongation of this side, this signifying the Sturge-Weber syndrome. So intraocular pressure in children are very important, but believe me, we can take the intraocular pressure inside in a OPD setup as well. Like, and if you are making the child to sit in a mother's lap, and I was able to take the IOP even in 3 years old children, like this case. And always use, we should use the Perkins eye care tonometer, a boon for the glaucoma practitioner nowadays. Even CO's tonometer, it should not be discarded. It's less preferred but useful inside the OT. Normal IOP is 10 to 20 millimeter of mercury, and primary congenital it may reach more than 30 to 40 millimeter of mercury. If we have seen the half stria, which is a horizontal scar in the cornea and a posterior aspect, so it is usually, it's a hallmark of the pediatric glaucoma. And calipers and slit beam width, even in our older children, helps to measure the horizontal corneal diameter. Any corneal diameter more than 12 millimeter is strongly indicative of primary congenital glaucoma. In considerable edema and long-standing glaucoma, there may be a posterior stromal involvement signifying prolonged increased IOP. Like in this systemic evaluation, we should not underestimate, and in each and every case, like in this case, pediatricians are consulted, and even the neurologists are consulted for the associated syndrome. Homocystinuria is a very common association. We should rule it out, and there is maybe a congenital malformation. Associated epilepsy and port wine stain require imaging, especially MRI, to rule out the cerebral hemangioma and other specific things as well. Like and how to document. When we have a battery of information, we have to see, like in this case, the previous case has an anemia, abnormal EEG showing epileptiform changes, and there is a normal homocysteine level, and the neurologist has added, based on this report, the sodium valproate before we take the patient for the evaluation under anesthesia inside the OT. Fundus examination is necessary. I usually try to complete it in a OPD itself under sedation, and optic disc is recorded because many a time after treatment there is a reversible cupping in early cases. So Axial length is very important in neonates, and always remember, 1 minute. Axial length is very important, which is 16 to 18 mm, growing about 22 mm by age 2. And if any time it's greater than 20 mm at birth, it can have a congenital glaucoma. Like here specifically when we are prescribing for the glaucoma, we have to prescribe that mark the axial length there at itself. So cycloplegic refraction is very important. It also helps in the amblyopia management, like in this case where the later on contact lens was prescribed for this particular child, so that there should not be a longer. Traditional imaging can be done, but there is a non-availability of population-based data, but raw data is very important in these children. Gonioscopy can be done, should be done inside the OT. I prefer inside the OT with a Swan-Jacob gonio lens like this, where you can have a very clear, very easily the pictures come there, and we can record it as well. And like see, there is a classic triad of epiphobia, photophobia and blepharospasm. Usually it is told that it's a pediatric glaucoma, but there can be NLDO, conjunctivitis, corneal abrasion, uveitis, and also here see what Dr. Manish has conveyed, that there is a, this child was operated with a AGV, and after, during the suture removal, we have seen that there is a spot on a cornea, corneal haze is there, and this haze was because of the tube was touching in the cornea. So we have to take the case very next week for the evaluation, and we have to trim the tube so that the cornea can be preserved in a longer way. So can we avoid inhalational anesthesia? There are alternatives for general anesthesia in such cases. Triclophos, very common. Pedicloryl is the common brand name, nilphenol interest, and dexmedetomidine, which is used intranasally. And the doses are like that. We can, dependingly, we can increase the dose as well. So there should be a 2 separate consent form for these cases. UA for, there should be a separate consent form. There should be a separate consent form for the glaucoma surgery, marking which surgery you are going to do. So still there is a foot for thing and challenges ahead. This child is a 9-year-old child, moved from clinic to tertiary care, but still parents are undecided about the its surgery being done. One eye has been lost. So to summarize with, evaluation cyst must be ready beforehand for each child. Multiple sittings are required to complete the examination. Choose cooperative anesthesia colleague during EUA and surgery. Never try to empower child, rather play to get information collected. Be clear and supportive to parents, and need for lifelong care discussed every visit. So to take home, flexible but scientific examination approach can save blindness in children with glaucoma. Gynecologists and pediatricians should be awake about early surgical treatment along with parents. Make collective multidisciplinary team for care. So this is our glaucoma initiative. I would like to thank Haaswala Foundation for supporting us. We have completed around 10 pediatric glaucoma surgery with support of them, which needs no it becomes financially nil for them. So thank you very much for the patient listening.
Thank you, sir, for insightful presentation. Any questions among panelists?
Which anesthetic agent generally you use in sedation in OPD examination?
Yeah, definitely. Even the triclophos is usually very much useful. We can increase the dose depending upon the body weight of the child. Okay. First one, and if we need intranasal dexmedetomidine, but I think it's debatable, because many a times children are not that much sleepy to allow you for the examination.
Effect of IOP of the using this anesthetic?
Definitely. That's why I have mentioned whenever there is a column of remarks. So whenever you are using any agent, mark the agent, and also do the first test when inside the OT for the IOP. But it's saying is very easy, but it's very difficult to do. If you are doing the IOP first, then you are unable to see the gonio. So you have to be a little bit dicey. So think about the comprehensive collection of the data. Once the CT is complete, decide about the fit. So never ever go for the proceed for surgery, I will say. But if it is diagnosed, parents' consents are taken, we can go ahead with the surgery. But it's usually not a rule. So collect the data first and then diagnose and then move with the consent of the patient.
Is there same kind of target IOP if people are setting up for the pediatric glaucoma as in the adult one? Or target IOP consent is not there in pediatric?
It's not practical basically. We can talk about a lot regarding the because the target IOP in such cases, how can we ascertain? There should be reversible cupping first of all. So it's not possible in early children. And if a child is more than 7 years of age, it can be treated as adult glaucoma.
When do you say that your glaucoma surgery has failed? What are the criteria for failed glaucoma surgery that need a second surgical intervention?
Definitely.
IOP is not a consideration.
The IOP is a consideration, but the target IOP is a range. So we cannot strictly follow the adult guidelines. But like in my case, once we did one case with the trabeculotomy only. So it was well-controlled IOP with ICT on different occasions for 1 year.
What do you mean by well-controlled IOP?
No, that's why I'm saying it's a 10, anything between 10 to 20 is acceptable.
Sir,
but it definitely.
Sir,
No. Yes. Yes.
So there is, as rightly said by the Dr. Jeet, there is no target IOP for a child because you want it as low as possible. The second problem with the child is sir, scleral rigidity and the corneal biomechanics are very different from that of an adult. Plus, when we are doing a surgery, we have altered the biomechanics more. Plus, this child invariably had corneal edema पहले. So, the measurement जो है आपका, उसका baseline ही हिला हुआ है. Therefore, what you go by, sir, is not really so-called target IOP. You go by, there is a reversal of the corneal edema. The photo, जो आँख बच्चा खोल नहीं रहा था, वो आँख खोल रहा है, पढ़ रहा है, चल रहा है, जो normal milestones होते हैं बच्चे के. Then, refraction में myopia बढ़ तो नहीं रहा है. If the tension is controlled, if the myopia is increasing, very often, sir, अगर limbal stretching हो रही होती है, तो IOP will in fact go lower. But the glaucoma is progressing because of the scleral biomechanics. Therefore, खाली IOP का criteria बच्चे में कभी नहीं होता. IOP, symptoms, myopia, refraction, axial length wherever possible, and EUAs बहुत frequent नहीं कर पाओगे, feasible नहीं होता है. It's very easy saying 3 months, 6 months वो नहीं कर पाते. आधा टाइम तो बच्चे का रनिंग नोज होता है या कुछ और होता है. एनेस्थेटिस्ट, आई डोंट नो आप लोगों की लड़ाई होती कि नहीं होती, हमारी तो होती रहती लड़ाई. वो दे कैंसल द केस. ठीक है. And how frequently can a child get an EUA? So what we trust on, sir, is digital tonometry, eye care tonometry, no financial these things, but something which is easily done. Dilated refraction, वो बच्चा आपका आराम से करा लेगा बिना बेहोशी के. एंड वेयर एवर पॉसिबल एक्सिल लेंथ. अगर मायोपिया बढ़ रहा है, इट्स अ वार्निंग साइन. देन डू एन EUA डेफिनेटली एंड चेक फॉर द ब्लेब एंड एवरीथिंग. नहीं सर मायोपिया नहीं. दिस इज नॉर्मली जो हम PCG कर रहे होते हैं सर, दैट्स द एज ऑफ 1 or 2 years. दैट इज द हाइपरोपिक एज. मायोपिक एज 5 साल के बाद आती है सर. हम मोस्टली जो सारे बच्चे हैं हमारे 2 साल 3 साल 1 साल के हैं, उसमें मायोपिया नहीं होता, हाइपरोपिया होता है. सो इफ द इंक्रीजिंग मायोपिया इज देयर एट द प्रेशर मे बी नॉर्मल, इट्स अ रेड साइन. व्हाट आई एम सेइंग, ऑब्वियसली आप खाली मायोपिया में नहीं जाओगे, आप डिस्क भी देखेंगे, पर डिस्क कई बार बच्चा नहीं दिखा पाता है, उसके लिए यू मे नीड एन EUA. सो इट इज़ ऑलवेज बहुत मन लगा के बच्चे को देखना होता है. एंड इट हैज़ टू बी, दैट इज व्हाई इट सेज इंस्टीट्यूशनल प्रैक्टिस इज रिक्वायर्ड टू लुक फॉर कंजेनिटल ग्लाकोमा, बिकॉज यू नीड अ लॉट ऑफ एफर्ट ऑन बोथ द पेरेंट्स पार्ट एंड द डॉक्टर्स पार्ट. वन क्वेश्चन आई हैड फॉर यू इज, जो anesthetic drugs you can do for sedation, do you have it available here in RIO? Because again there was a study from PGI, they are using it, but आप कर रहे हैं.
I'm doing in our practice, and it's we are doing.
It's, one more thing adding to what Madam was saying, EUA is difficult at times. So sometimes what we tell our patient, to the mother and father, कि बच्चा को थोड़ा सुबह जल्दी उठा दीजिए, रात को कम सुलाइए, bring the baby early morning, say 9-10 बजे जब OPD start होता है, and try to make the baby sleep in the OPD. So using that time, we can put a drop of Paracaine and do a tonopen. That time it is possible. So at least you can get an idea about the pressure if the baby is sleeping. And if the baby is dilated, you can see the disc also. So sometime by doing that, we can skip a UA. But then obviously if you want to see CCT, want to see the bleb, sometime cut the suture, see everything in detail, then obviously we'll need UA. But this is something which have worked for us. Even we have used syrup pedichloril to sedate the patient. That time we try to check the baby is not having any respiratory problem. We make sure some physician or anesthetist is in the hospital because all these drugs have some side effect. CCT, if the baby is sedated, you can do CCT also. Ultrasonic CCT कर सकते हैं. पर जैसे मैंने कहा अगर आपको proper detail evaluation करना है, X-ray lens, CCT everything, then तक UA करना है. पर sometime देखिए 3 month 4 month में baby आया, बच्चा सोया हुआ है, you can just see the disc on indirect ophthalmoscopy and just check the pressure. You know कि okay, that patient is doing okay.
Definitely, even indirect ophthalmoscopy is very good in evaluating the disc in children, I think, many a time.
See, most children, when you're doing UA, you are anyway you indirect only. Yes. That is what you're using to see the disc.
Sir, which one is preferred, whether rebound tonometer or tonopen, in case of early?
Preferred is Perkins tonometer, if you can use it. No, if you don't have, then rebound and tonopen both have their fallacies. In our hospital, we have tonopen. But if you want, you can use rebound also.
The most important part is how you are doing. We cannot do it on a supine position. So you have to do in a left lateral position or either child sitting in a lap of the patient. So that's very important.
Manish sir, what is the role of CCT in childhood glaucoma?
So sorry to interrupt you, sir, due to paucity of time.
I think CCT in pediatric glaucoma has limited role, but gives you some idea about corneal pathology also. So like 2 eyes, one eye is having very high CCT, other eye is normal. There is an associated corneal edema also. So the CCT correction which we use for adult glaucoma, that is not recommended for pediatric glaucoma. It is more to understand whether there is corneal edema or not. Second, differentiating a CHED from pediatric congenital glaucoma, that is CCT also very useful. So you have a diffuse corneal edema, you are not sure, you do a CCT, it is more than 1000, you know probably you are dealing with a CHED and not a pediatric glaucoma. So this type of CCT helps.
The whole gamut of investigations, IOP, angle, disc, axial length, refraction and the CCT, ये जो 5-6 चीज़ें होती हैं सर, इनको हर बार ही नहीं करना होता है. Initial EUA में आपको चाहिए for the decision. Then some of us will do suture removal or titrate the suture or do a needling or check the first EUA after 4 to 6 weeks. That time you can repeat and see what was the result of your first surgery. उसके बाद हर बार ही ये सब CCT वगैरह करने की ज़रूरत नहीं. Your refraction and your IOP can suffice. Perkins wherever possible, and I would say either tonopen, like we have rebound, they have tonopen. So we use that. However, most of these have an overestimation. क्योंकि बच्चे के ऊपर overestimation होती है. So I don't know about the people here. I still rely on digital tonometry a lot. It will give you a very good example of a very good guesstimate of how much is the pressure control.
In children, I think the digital tonometry is very much giving a good idea.
Good evening, respected Vibhuti sir, panelists and the national and state dignitaries. I'm Dr. Ravi Kumar, and now we are going to open the Pandora box in the childhood glaucoma. So I have no financial interest to disclose. Pediatric glaucoma. It's a heterogeneous group of disorder associated with elevated intraocular pressure. It has various presentation and etiologies that damage the optic nerve and up to the age of 4 years the cornea and the other structures. And the prevalence in Western population it's 1 in 10,000, whereas in India it's higher, it's 1 in 3,300. So let's go to the definition of the pediatric glaucoma. IOP related damage to the eye, and at least 2 of the following criteria should be present to tell that the patient is having glaucoma. The first thing is the IOP more than 21 mmHg, then the optic disc cupping which shows progressive increase in the cup disc ratio, and cup disc ratio asymmetry of more than 0.2 between the 2 eyes when the optic disc sizes are similar or focal rim thinning is present. Then cornea which shows the hypstria, and the diameter is in newborn more than 11 mm, in infants more than 12 mm, and at 10 years it's more than 13 mm. So visual fields should show reproducible visual field defect consistent with the glaucomatous optic neuropathy with no other observable reason, and there should be progressive myopia with myopic shift or an increase in ocular dimension inconsistent with normal growth. Then what is pediatric glaucoma suspect? When there is no IOP related damages are present, or at least one of the following criteria is there to diagnose the glaucoma suspect. If IOP is more than 21 mmHg on 2 separate occasions, optic disc appearance suggestive of glaucoma, that is increased cup disc ratio for size of optic disc and increased corneal diameter or axial length in eyes with normal IOP, or visual field suggestive of glaucoma. So now we discuss the modified CGRN classification. This is the algorithm which we discussed just right now. If there is only one criteria is present, then we will tell that the patient is glaucoma suspect. If there is more than, if glaucoma is there and there is history of cataract surgery, then we'll tell the patient that this is because of glaucoma following cataract surgery. If there is no history of cataract surgery previously, then we'll check for congenital eye anomalies or systemic syndromes, and it is whether associated with systemic involvement or not. If it is associated with the systemic involvement, then we will tell that the glaucoma is associated with the non-acquired systemic disease or syndrome, and if it is not, then glaucoma associated non-acquired ocular anomalies, that is the Peter anomaly or the Axenfeld rigor. If there is no any congenital eye anomaly present, then we'll ask the history of trauma, uveitis, steroid use or tumor or ROP in past. If it is present, then glaucoma associated with acquired condition, and if it is not present, then we'll check for ophthalmos, and if ophthalmos is present, then PCG is diagnosed, or if it is not present, then we can think of JOAG. So let's come to the primary pediatric glaucoma. It is divided into neonatal onset, infantile onset, late onset, or later recognized. PCG accounts for most primary glaucoma cases. Newborn PCG accounts for approximately 25% of the cases. PCG is bilateral, and 70% of cases and diagnosed within the first year of life in 75% of cases. More in males than females, and most cases occur sporadically. Up to 40% of cases are inherited in autosomal recessive pattern, pathogenic variants in cytochrome P1B1 with the GLC3A locus, and less commonly LDPP2 is associated. Presents with megalocornea, microspherophakia, ectopia lentis, and Will-Marchesani syndrome. Then one more gene is there, ANGPT1 and TK within GLC3, which are inherited in autosomal dominant pattern, are associated with Schlemm's canal dysgenesis. So this is the flowchart showing the genesis of the childhood glaucoma. Cytochrome P1B1 is encodes for P450 oxygenate, which converts the retinol into retinoic acid, which is important for anterior segment genesis and aqueous outflow. Presents with the PCG presents with the classes of classical triad of epiphora, photophobia, and blepharospasm. Elevated IOP causes cornea to stretch, leading to ophthalmos, and corneal stretching leads to Descemet membrane breaks, that is called hypstria. Child is irritable and photophobic, and after the age of 3 to 4 years, the cornea ceases to enlarge further. So PCG has a better visual prognosis than most secondary pediatric glaucoma. A poorer prognosis is associated with newborn PCG, PCG diagnosed after 1 year of age, and corneal diameter of more than 14 mm. The prognosis is best for patient diagnosed between 3 to 12 months of age. Now come to the JOAG. Generally it presents from the age of 4 to 40 years. Elevated IOP and normal appearing angles are present. It is generally autosomal dominant, inherited, and many family will be aware of it, leading to early screening. No corneal involvement due to later age of onset, and however progressive myopia may result until 10 years of age. Now comes to the secondary pediatric glaucoma. The secondary pediatric glaucoma is further classified into glaucoma associated with non-acquired ocular anomalies, which is classified into Axenfeld-Rieger syndrome, Peters anomaly, aniridia, and Sturge-Weber syndrome. Let's discuss the Axenfeld-Rieger syndrome. It's a spectrum of disorder characterized by anomalous development of the neural crest-derived anterior segment structures, including the angle, iris, and trabecular meshwork. It is generally bilateral, autosomal dominant, and the gene associated is FOXC1 and PTX2. The classic manifestation is the posterior embryotoxin, iris adhesion to the Solbase line, and iris changes, that is hypoplasia, correctopia, and ectropia in UVA. Next is the Peters anomaly. It's a rare condition with an annular corneal opacity in the central visual axis. It is autosomal dominant. The gene associated is the PTX2, FOXC1, PAX6, and cytochrome P1B1. The iris strands adhere to the corneal opacity. Sometimes lens may be adhere to the posterior layers of the cornea, and the patients with corneolenticular adhesions have an increased likelihood of systemic abnormality, heart, genitourinary system, and ear, palate, and spine abnormalities. The third is the aniridia. It is a panocular bilateral disorder with iris hypoplasia associated with microcornea, anterior polar cataract, optic nerve, and foveal hypoplasia with pendular nystagmus and reduced vision. The gene is PAX6, and it is generally associated with two syndromes, that is Weiser syndrome and the Gillespie syndrome. Then the Sturge-Weber syndrome, it is also known as encephalofacial angiomatosis. It presents with ipsilateral choroidal cavernous hemangioma, cerebral calcification, seizures, focal neurological deficits, and it is sporadic, usually unilateral. Glaucoma is most common ocular complication, and due to elevated episcleral venous pressure, there is a glaucoma. Now the next classification is the glaucoma associated with non-acquired systemic disease or syndrome, under which there is neurofibromatosis, Snell-Patella syndrome, Stickler syndrome, or osteogenesis imperfecta. Then the glaucoma associated with acquired condition. In this spectrum, there is trauma, which is accounting for 36%, and the next one is the steroid-induced, 27%. Then the lens-associated disorder, that is 10%, and others are 27%, under which comes the uveitis, tumors, and posterior segment disorders, and topiramate-induced angle closure. Now the last is the steroid-induced glaucoma. Children are more steroid responsive than adults. Steroids should not be used as first line for VKC. Conservative therapy should be tried, or tacrolimus should be tried, and steroid use in children should be closely monitored. And if you can't monitor IOP and fundus, then please do not prescribe the steroids. Then last is the glaucoma following cataract surgery. The prevalence of this is 6 to 26%. Generally, it is open angle type, and cataract surgery in first year of life is small corneal diameter postoperative complication. The risk remains same. The risk remains same with aphakia and whether receive IOL. Lifelong follow-up is required in such patients, maybe due to surgically induced inflammation, or the tube stent is preferred in case of aphakia. So follow-up of children after cataract surgery every 3 months first year of from first post-op year, and 6 monthly till next 10 years, and then after annually. So the take-home message is that childhood glaucoma are unusual but serious group of disorder that only partially overlap with glaucoma of adult onset. Recognizing the features of glaucoma unique to early childhood is critical to rapid diagnosis and effective treatment of PCG. Use of international classification of childhood glaucoma allows better communication among those who are for these children and is recommended for all clinicians. And successful care of pediatric glaucoma patients require a team approach, including the ophthalmologist, family, and members of the school and community for vocational rehabilitation. Thank you.
So thank you, Dr. Ravi, for the great presentation. Next, I would like to invite Dr. Rasmi ma'am, who is the Assistant Professor of the RIO IJMS Patna. She is delivering on the implication of genetic testing in families with childhood glaucoma.
So good evening all. So after the enlightening talk of Dr. Ravi, who has opened the Pandora's box, you must have been knowing that childhood glaucoma is presents heterogeneically, not only phenotype, but it is the genetic composition which is responsible for this varied phenotypic presentations. So in the last 1 month, I encountered 2 children with similar history, similar diagnosis, operated by a same surgeon with similar expertise, but different story. While this first child is fixating well and is smiling, getting his picture clicked in every gauge. The second one, I took wasted 20 clicks to get this child eyes photographed, and then still this child is frowning and was taken for reassessment. These are, as discussed previously, these are signs that all is not well with this child, and this child may need re-evaluation and re-surgery. So what we are thinking at this aspect, was my diagnosis correct? Both children were of PCG, or is the treatment offered was appropriate? And what next? Is the response to re-surgery, which I will be doing, predictable? And by the time we are thinking so, what is the patient's perspective? They are thinking, what went wrong? Why is it gender-based? My boy child is affected while my girl child is normal. What is the prognosis of my child? And what will be the next pregnancy be affected? And by the time this child grows up and he is already aware of his sufferings, the questions which will come into his mind will, how can I prevent sufferings in my offsprings? Will antenatal testing or marriage counseling work, or is any gene therapy possible? And while we are busy with this, our researchers would be busy in thinking, is there any new gene involved? Or are there any variants or mutants of the identified gene? Can apply genetics for artificial intelligence for risk prediction? Or is there any pharmacogenomics possible for the glaucoma treatment? Is any population-based genetic screening programs possible? So I mean to say that the implications of any test depends upon your perspective. So whatever be the query, the answer converges to one thing, that is genetic testing. So as far as childhood glaucoma is concerned, there are numerous genes with definite changes with all inheritance patterns that have been associated with childhood glaucoma, and understanding the most common genes as well as potential genotype and phenotype correlation is mandate if we want to excel the management part. There are n number of genes involved, but most commonly 7 to 8 genes have been identified, but difference of inherent pattern, which implies that if the autosomal recessive genes are responsible, then the chance of getting a next pregnancy will be 25%, while if autosomal dominant genes are responsible, the next child to be affected is 50-50. So considerable genetic and phenotypic heterogeneity can result in significant challenges in attributing a particular phenotype presentation to a gene without molecular diagnosis. So what next? So being a physician of first contact, careful examination along with analysis of pedigree can help to identify a specific gene and assess individual risk. Carrier testing to identify at-risk couples can be discussed in the case of autosomal recessive inheritance based on consanguinity, ancestry, population-based carrier rates when known. So this is called strategy of predictive genetic testing, when whole of the family need not be put under the microscope, but there has to be segregated on the basis of the genetic abnormality of the proband. So it ensures efficient and cost-effective glaucoma management. It means individual with high genomic risk can take a proactive approach to the eye health, making informed decisions and avoid unnecessary examinations for those who did not inherit the familial variant. So a team approach is always recommended. Being the physician of contact, pediatric ophthalmologist often find these patients, and they have to ascertain a diagnosis based on their clinical acumen and categorize the glaucoma subtype. But it is the clinical geneticist who are responsible who are specially trained to use modern cytogenetic, molecular, radiological, and biochemical testing to assist in specialized diagnostic evaluation and implement needed therapeutic interventions and provide genetic counseling. So if a genotype is known, is typical of a typical phenotype, then one orders for a targeted gene panel. But if non-specific phenotype and unsure clinically, then whole exome or whole genome sequencing is preferred. Once a variant in the proband is found, then use Sanger sequencing for segregation and risk assessment in the family. So what does it has any implication on the management? So most PCG cases are sporadic or autosomal recessive, but incompletely mutant autosomal dominant genes have recently been recognized like TEC1 gene, and surgeries targeting this Helms canal may not be effective in TEC-associated PCG. And this could be the explanation in our child why one responded while the other failed. So this could be one of the possibilities. This is not sure unless we test, but this could be the answer to our questions with which we began. genetic studies have revealed molecular basis of JOAG, and at least 3 genes are responsible. Amongst these, myelin-associated glaucoma with JOAG are found to have responded with minimally invasive glaucoma surgeries. Again, a newer gene LTBP2 has been found to be associated with PCG, but there is a biallelic variant of LTBP2 which is responsible for PCG mimicking phenotype, and the picture changes when it is the variant of LTBP2 in management, because the management is drastically different. Early lensectomy can prevent secondary glaucoma, while timely identification and treatment of peripheral retinal pathology can reduce the risk of sight-threatening complication in these so-called PCG patients who are not actually PCGs. So here the gene assessment again helps us in searching for our management. So this can be applied for emerging gene therapy, though sounds theoretical, but this is going to be future of glaucoma management as well as future of all inherited ocular diseases. There has been discovery of topical ocular treatment with phenylbutyrate or CRISPR-mediated genome editing that reduces IOP, and angiopoietin mimetic protein has been able to reduce the IOP in animal models. So soon that they will be tested for human also, and this is the future of what I said. So these discoveries highlight potential future role of personalized medicine in childhood glaucoma. So what implication does it has on reproduction? In the absence of any genetic identification, what the patients are left with? They have either not to have any child, or go for adoption, or go for IVF with donor eggs or sperm. But if the molecular diagnosis is available, then additional options what we can offer is prenatal diagnostic testing or pre-implantation genetic testing using IVF. Though these are all theoretical, still a long way to go, but this is what we can see. Now again, family planning is not should not be generalized for every patient, and that should be specifically depend upon specific diagnosis, severity of the condition, age of onset, religious and cultural belief, personal preferences, cost and time constraints as well. So there are definitely different barriers. Affordability. We don't have in-house genetic testing. There are certain private labs, but it costs, certainly it has some cost. Accessibilities and ethical issues. Setting up in-house is not easy. You need to have a space, you need to have infrastructure for which you need fund, and above all, you need accreditations from regulatory bodies. So the flip side of these genetic testing is that genetic results may alter the original diagnosis and reveal possible comorbidities, some of which can be life-threatening. Then it becomes very ethical whether to divulge this information to the patient party or not. हम लोग कुछ ढूंढने गए थे आँख में, निकल गया कुछ life-threatening disease. Then what should be done? It can affect patients' plan to have children, can create sense of anxiety or guilt, and can even perturb the patient's relationship with other family members. So it has lots of psychological constraints as well. So for these, there is a AO guideline for sailing us through these complications that offer testing for Mendelian disorders, ensure referral to experts and counseling from certified gene counselors, utilize certified laboratories, provide patient copies of results, discourage direct-to-consumer testing, avoid unnecessary parallel testing, delay testing for complex disorders unless treatment or surveillance strategies based on genetic information have proven beneficial, and avoid testing asymptomatic minors. So to conclude, when used appropriately, or I must say judiciously, genetic testing can transform glaucoma care by improving diagnosis and prognosis, detecting unsuspected syndromic glaucoma, reduce disease risk in families, and aid in personalized medicine. But that definitely should be complemented with counseling part to potentially impact on reproductive plans, emotional well-being, and family relationship. So as I said, there is a long way to go, but RIO has taken its baby step in the first step being allocating a space for this research lab. This area will be designated for genomics and proteomics, as was announced in the inauguration ceremony as well by our HOD sir. So thank you so much.
Thank you everyone for insightful presentation. Due to paucity of time, we will have to take last two oculoplastic talk in this session. So I like to request Dr. Kirti Singh. I like to request Dr. Ruchi ma'am, who is the Associate Professor in Department of Radiology, IJMS, Patna. She is delivering on the cross-section imaging, that is the tips and tricks in diagnosing the orbital pathologies. Please, Ruchi ma'am.
So by the time ma'am is just preparing, so can I have a question from ma'am, Kriti ma'am, regarding the this genetic testing? So how we are here at this moment?
Genetic testing would be a big boon because, as she said very rightly, the ones which failed, if we can identify that gene, our prognosis would be different. We all know consanguinity is an issue, and until and unless that belief or the cultural thing changes, it's not going to, you're not going to reduce consanguinity. Having said that, if you have one child affected, we can definitely tell the parents that the risk is much higher. They can consider not having a second child. Vis-a-vis doing a testing for everybody in a country like India, very few centers, you are lucky that you have a setup here. Not many people have that luxury. And even if they have that luxury, would you tell them, as she very rightly said, would you tell them not to have a child based on that? That may not be feasible. So I am unsure of where it is going. We'll still have to see, but definitely it is opening up things for us कि जो हमें समझ नहीं आ रही थी अब समझ आ रही है. So let's wait and watch for a couple of years before we talk on that. नहीं बिल्कुल, because now if we can go and do amniocentesis and modify, well and good, unless and until we do that. But ये step forward तो है ही, ये तो नहीं कि हम आँख बंद करके कि पता नहीं है तो, but how it is going to impact, I will not be able to give an answer. Yeah, not even that. All the experimental targets, vector targeting, gene therapy targets are being developed. पर वो कितना feasible हो पाएगा, because this is usually an autosomal recessive issue, and then how consanguinity will be reduced is the main thing.
Okay, before starting my topic, I would like to convey that we are doing prenatal testing in our department. So if RIO is doing genetics, so please you can send patients to me for prenatal testing. Okay, so the topic, I was told to keep it as simple as possible, that is cross-sectional imaging, tips and tricks in diagnosing orbital pathologies. So what we want as a radiologist are the complete history and the examination findings from the clinician. Regarding skull X-ray, we all know the only practical implication nowadays is the radiopaque foreign body in the eye. Regarding ultrasound, as all of you are already doing, we know that this is a first-line modality easily available in our clinic. So most commonly it is done for intraocular lesions, focal lesions in the orbit like abscesses, optic nerve, and any intraocular and retroorbital masses, and especially for the vascular lesions also. We can see, and especially the flow in the vein, like if it is carotico-cavernous fistula, the arterialization of flow in superior ophthalmic vein, we can easily document in ultrasound. So where to use cross-sectional imaging? Now the question comes when to use it. So the most common indication, as we know, is the trauma, and followed by foreign body. It can be easily done like non-contrast CT in optic nerve head drusen to look for infarcts if there is cortical blindness, evaluation of orbital infections because we can do CT paranasal sinuses. Then if like we want to look at the muscles, so evaluation of the muscles can be done to look for calcification on tumors. But remember, there is radiation dose associated with it, but it is fast, it is easily available. And when MRI not to be done. So when it is not to be done, when it is a metallic foreign body. So whenever there is a foreign body in the eye, better to go ahead with CT and not MRI because it is contraindicated. And obviously in patients with CKD, we cannot give contrast. So better go ahead and do plain studies. So little bit about the anatomy on CT. This is a plain CT. We all know this is the axial section where this is a globe. And I would like to just convey that it appears totally black on CT. because it allows all the CT waves to pass through. So it will appear black, while bone will reflect back all the rays and will be detected by the detector. So it will appear bright on CT. While, just a moment, arrow options. And the soft tissue will appear like a midweight 20 to 30 Hounsfield unit or 50 to 60 Hounsfield unit will be the density. Then will come the fat, which will appear hypo-intense, and then the air. So this is the central is the optic nerve, and the two sides will be the muscles, which is the medial is the medial rectus and the lateral rectus muscle. Remember, the medial wall of the orbit we can very well see on CT, which is formed by the lamina pepratia, and here the lateral wall of the orbit, which is formed by the greater wing of sphenoid bone. So any bony lesions, any infections of the orbit, any bony pathology we are suspecting, so in that case CT will be the modality of choice. And coronal sections are the mainstay, where this is the globe which we have seen, and these are the muscles which we are seeing here, and rest of it what we are seeing is the orbital fat. And here what we are able to see on coronal section, not only the medial and lateral walls, but also the inferior wall and superior wall. The inferior wall is formed by the superior wall of maxillary sinus, while inferior wall, the roof is formed by the inferior wall of the anterior cranial fossa. And this is the inferior orbital nerve, which is seen in the floor of the orbit. Now regarding the MRI, T1 weighted images are the mainstay for the MRI, and coronal images are the must. So remember, water appears dark on T1, that is very, and fat appears bright on T1. So what we are seeing, globe appears hypo, so it is a T1 weighted image, and fat appears bright, so this is a T1 weighted image. The muscles are seen all around, and what is seen surrounding is the orbital fat. And here as we go more posteriorly, optic nerve has come into picture, and this whole thing, this fat is giving us good contrast. So any lesion of the muscle or the optic nerve, any lesion is seen very well against the background of this hyper intense fat. Regarding T2 weighted images, as I have told, water appears bright on T2. So vitreous will appear bright on T2, fat will also appear bright on T2. So these are the T2 weighted images, while if we suppress fat, then it becomes T2 fat set. So T2 fat set images are very important because they help in early detection of pathologies. So if there is any infection or anything, so any early fats trending we can easily see on T2 fat set images. And coronal images are the mainstay, as I have told. This is the optic nerve, and this is the perioptic CSF spaces which we are seeing, and the whole fat has been suppressed because it is a fat set sequence. And to look at for the nerves, we always advise heavily T2 weighted sequences, which is the Fiesta sequence. So whenever there is any nerve pathology, any cisternal segment, always advise this sequence, which is the Fiesta sequence. To look at the proptosis in the axial sections, what we do, we draw a line from the anterior aspect of the lateral walls of the orbit, and we see whether the posterior wall of the orbit, if it is more than 6 mm, it is normal. So anything which is less than 6 mm will become grade 1 proptosis. If it is more than that, reaching up to optic nerve head, then it is grade 2, and more than that will become grade 3. That we can grade on both CT as well as on MRI. So these are various indications of MRI. I will not go into details. So just remember, for the trauma in the foreign body, I have already spoken about the NCCT brain and orbit as the investigation of choice. Here, because we can see on 3D reconstruction, the fracture lines we can see very clearly. And if there is any, bony fragment which is impinging on the posterior optic foramina, like in this this fissure or the optic nerve impingement, this we can see very well on NCCT. So what are the indications of MRI? MRI indications, we all know it is related to nerves. So any nerve pathology, optic neuropathy, any complaints of diplopia, field effects, and orbital masses as well. So why MRI? Because it has high resolution imaging. So that is why we prefer MRI, and for demyelinating pathologies, always advise spine screening. That is very important. So demyelinating optic neuritis, what test to advise? You will always advise MRI orbit with brain, and with contrast study and spine screening. Spine screening is just the T2 sagittal sequences. In this sequence we can easily see the spinal cord, and any hyperintensity in the spinal cord we can detect. So remember, for demyelination, no role of CT. So in this, what we can see is the early T2 hyperintensity within the optic nerves that we can see within the optic chiasma, even within the optic tracts that we can see on this sequence. So even early MS plaques that we can diagnose on T2 weighted and the FLAIR images. Neuromyelitis optica spectrum or MOG antibody disorders, we can very well see the optic nerves and any lesions, any plaques in the brain we can diagnose on the imaging. So these are the differences. I will not go into detail. And then infiltrative optic neuropathy, again no role of CT. Remember, MRI brain plus orbit and contrast is the investigation of choice. If you want to look for calcifications, you can add on plain CT, but don't advise contrast CT in these patients. That is, if contrast has to be done, it has to be MRI. So retinoblastoma, to look for calcification, plain CT, contrast only with MRI. So why MRI? Why are we emphasizing MRI? Because obvious lesion we can see both on CT and MRI. But what is not obvious? Look at this, the opposite globe. What we are seeing is a subtle lesion at the optic nerve head that we can detect on MRI, but we can easily miss it on CT. Like in this leukemic infiltration of the optic nerve. So here right side it is very obviously seen, but subtle optic nerve head involvement that we can easily see on MRI, and plus the cranial nerve infiltration also we can see it on MRI. Uveal melanoma, investigation of choice is MRI, because melanoma appears bright on T1 weighted image and they enhance brightly on contrast. So melanoma, MRI is the investigation of choice. Regarding tumors, any optic nerve, sheath, optic tract tumors, investigation of choice is MRI. So any optic tract glioma, in this is a patient of NF and had right-sided vision loss. There was no intraocular pathology, but where was the pathology? It was involving the right-sided optic tract. Again, optic nerve sheath meningioma. Here we are seeing the enhancing balls of the optic nerve. So why can we do CT in this case? Yes, we can do. Plain CT can be done to look for calcifications, because calcifications will further increase the confidence of diagnosis of meningioma, but contrast has to be done with MRI. For thyroid ophthalmopathy, whatever is available you can do. If CT is available in house, you can go for plain CT. If MRI is available, you can go for MRI orbit. No need for contrast. So what we see, remember, Graves' disease, it is a bilateral disease, so the involvement will be seen bilaterally. The muscle enlargement will be seen bilateral. What if the disease is unilateral? So when the disease is unilateral, then MRI has to be done with MRI brain. Why? Because the diffusion weighted images can help to differentiate whether this is lymphoma or not. So further, biopsy confirmed this case as orbital lymphoma. So unilateral disease, muscle enlargement, go for MRI with MRI brain. Then vascular orbital lesions, most of the cases we advise MRI. So when is CT done? CT is specifically done when it is intermittent proptosis, when it is orbital varix. In this case, we do CT in two positions, one in resting position, one in prone position. Why we do prone? Because we increase the orbital pressure, and that will, the varix will come out, which was not seen in resting phase. In all cases, you go ahead and do MRI, contrast MRI. And angiography we have to supplement if it is carotico-cavernous fistula and AVM. So aneurysm or carotico-cavernous fistula, contrast MRA, that is this angiography. It is an investigation of choice. So this is venolymphatic malformation, easily diagnosed on MRI, no need of CT. Then this is the cavernous angioma, easily diagnosed on MRI, no need of CT. So remember, if MRI is available, go for MRI. If in-house CT is available, yes, you can go ahead and do contrast CT, but better to go for MRI. Compressive optic neuropathy, again go for MRI. Only for sinus involvement, we can go ahead and do CT sinuses. So like any case of large, this is a case of aspergilloma compressing on bilateral optic foramina or cavernous involvement. So plain CT can be supplemented with later contrast MRI. Then fungal sinusitis, which is invading the orbit. In this, first CT should be done and then followed by MRI. This is another case of invasive fungal sinusitis in a diabetic patient with loss of vision on left side. So plain CT followed by MRI with contrast. Nerve palsies, we all know, no need of CT, only MRI brain with contrast has to be done. I have removed this. And orbital apex syndrome, only MRI to be done with contrast. For Tolosa-Hunt syndrome, again MRI, because it will give us the intensity of the tissue. If it is T2 hypointense soft tissue, then it will be seen on MRI, and we can say that yes, it could be a part of like pseudotumor or Tolosa-Hunt syndrome. Inflammatory pseudotumor, very well seen on MRI, not on CT. The lacrimal gland involvement, which is appearing hypointense. That is very important characteristic feature of pseudotumor, and its extension along the muscle into the orbital apex. So inflammatory pseudotumor, better modality would be MRI. So I would like to conclude, in majority of orbital indications, MRI is suggested. But for trauma, foreign body in eye, calcification in masses, infection, orbital varix, or to look for phleboliths in veno-lymphatic malformation, plain CT is sufficient. For varix, we have to go for contrast CT. So thank you for your kind attention. Thank you.
Thank you, ma'am, for your valuable insights on topics.
No, sir, we can't differentiate. It will look same. Just Tolosa-Hunt syndrome will be more posteriorly and pseudotumor will be more anteriorly in the orbit. The imaging features will remain same. Otherwise, like cavernous sinus involvement is seen more in Tolosa-Hunt, less in pseudotumor. Like some is less, some is more. But imaging features, otherwise, it will remain more or less same.
And
yes, sir. So first ultrasound.
First ultrasound.
We will look for the Doppler of the superior ophthalmic vein.
Because yes, definitely we always suspect with a raised episcleral venous pressure or raised episcleral veins. So what should after ultrasound?
We'll go with the MRI brain with contrast angiography. If that shows the fistula, we'll go ahead with DSA.
Okay. DSA means?
That digital subtraction angiography. Okay. That will be the final diagnostic last, and intervention can also be done under DSA.
And in cases of orbital cellulitis?
Orbital cellulitis, CT orbit is enough.
Okay.
CT orbit is enough.
Thank you, ma'am. Now move to the next speaker, Dr. M.S. Ali, sir, who is the additional professor at the RIO HMS Patna. He is delivering on the orbital cellulitis. Please, sir.
Good evening, everyone. So, I'm talking on the topic of orbital cellulitis. Dr. Ruchi has made my job easier because it is mostly about imaging. First of all, we can see this diagram of the orbit. This is sagittal section showing the septum and the structures anterior to the septum and the posterior to the septum. That part is important to identify the orbital septum with preseptal or postseptal. Then we should also have knowledge about the medial wall of the orbit, which is the formed mostly by the ethmoid sinus, and that is the lamina papracia, which is a thin bone. So what is it? It is a just infection of the soft tissues of eye socket behind the orbital septum. So it is important to identify whether it is preseptal or postseptal. Preseptal is innocuous and very easily kind of treatable, but the postseptal orbital cellulitis is sight-threatening. So the causes are the extension from the periorbital structures, that is adjacent ethmoid or frontal sinus, by the trauma, foreign bodies or post-surgical causes, spread from the bloodstream like the bacteremia or fish septic emboli. Intraorbital causes can be there due to endophthalmitis and dichlorhydinitis. So there is a classification given by Chandler that is classified into 5 groups. That is a preseptal orbital cellulitis, subperiosteal abscess, orbital abscess, and the cavernous sinus thrombosis. So what is important to know is that in children younger than 10 years of age, the most common cause is the spread from the ethmoid sinus, and this infection can spread very easily to the cavernous sinus because there are the walls of the orbit are vessels of the venous system is without valves. So this is a risk factor. The risk factors in children are usually the recent upper respiratory illnesses, acute or chronic bacterial sinusitis, trauma, or periocular infections. The most common organisms are the gram-positive streptococci and staphylococci. In children, usually younger than 9 years of age, there is a monomicrobial infection, but in children older than 9 years or adults, it is usually polymicrobial, involving aerobic and anaerobic bacteria. Gram-negative infection can be seen in trauma in the neonates and immunosuppressed patients. So fungal infections are seen with the immunocompromised and the uncontrolled diabetic patients. So the diagnosis is basically clinical. We should always look for the signs and symptoms. The most important signs are the proptosis, chemosis. There is a pain with eye movements, ophthalmoplegia, and optic nerve involvement. There can be rhinorrhea, headache, or tenderness. So CT is the most important investigation to identify whether the infection is preseptal or postseptal. So these are some of the images, photographs showing the different spectrum of the disease, right from the acute dacryocystitis to total ophthalmoplegia with proptosis. The most we've seen a lot of cases of rhino-orbital mucormycosis, the fungal orbital cellulitis, and these are the different spectrum. What should be the workup? The workup is essentially the same as we do in other cases. The best corrected visual acuity, color vision, the proptosis measurement, visual field assessment, the pupillary reaction, ocular motility is the important examination, and slit lamp examination, fundus examination, and we should also do the ENT consultation to rule out the sinusitis part. Differentials are also important because sometimes we get patients who are actually not infectious but non-infectious kind of orbital cellulitis, like the idiopathic inflammations, orbital pseudotumor, psychodosis. We all see lots of patients with retinoblastoma who present with the sterile orbital cellulitis. Can be lymphangioma, hemangioma, leukemia, rhabdomyosarcoma. See, so there are various causes of non-infectious orbital swellings also. So the primary prevention is always identify the patients early and treat effectively. Any kind of preseptal skin infections or sinusitis should be treated as early as possible. If the patient present with orbital cellulitis, then we have to hospitalize the patient. Start with the broad spectrum antibiotics, intravenous antibiotics. Routine blood investigations are done. And in infants or young children, we can start with the third generation cephalosporin and a penicillinase resistant penicillin like the amoxicillin. In older children and adults, we have to add the anaerobic coverage with the clindamycin and metronidazole. So systemic corticosteroids has also a role because it takes control of the inflammation and residual scarring can be reduced. So always it is a case involving a multidisciplinary approach with involvement of pediatrician, ENT surgeons, ophthalmologists, and infectious disease specialists. Surgical management is indicated when there is subperiosteal abscess or the orbital abscess, so usually in the younger than 9 years of age, it responds to the IV antibiotics, but if the age is more or the abscess is large, we have to drain it. Sinus surgery should also be done if there is sinusitis, extensive sinusitis. There are various complications leading from starting from the exposure keratopathy to optic neuritis to this loss of vision, and it can lead to cavernous sinus thrombosis, meningitis, and brain abscess. So the take-home message is that early treatment of sinusitis and skin and soft tissue infections is to be taken care, and high index of clinical suspicion. You should not confuse it with acute conjunctivitis just and leave the patient, and early identification and prompt management is vision and life saving. Thank you all for your patient hearing.
Thank you, sir.
Sir. Steroids, sir, I think we should give IV antibiotics for 2 days, then we can start the steroids. And it should be very low dose, approximately 0.5 milligram per kg per case. So we should not give a full 1 milligram dose, we should give 0.5 milligram per kg. हाँ sir, steroids देना है sir.
Okay, sir. Thank you, sir. Now it's time for the quiz session. I would like to, Dr. Neha, please coordinate the oculoplastic quiz session.
Hello. Welcome to the today's oculoplastic quiz. Think of this quiz like ptosis. It will lift your spirit once corrected. A 5-year-old child presents with bilateral proptosis and chemosis. There is pallor and petechia over the skin. CBC reveals pancytopenia. Most likely cause of orbital signs. Answer is B, sir. B.
आपको भी मिल चुका है सर, मिल चुका है सर.
Coming to the next question. A 6-year-old girl presents with painless progressive visual loss in the left eye and mild proptosis. Fundus shows optic disc pallor, MRI brain and orbit shows fusiform enlargement.
दृष्टि आ जाओ दृष्टि का है वो.
No, chal. Now I'll call upon the Dr. Surbi for the glaucoma case.
अब बन गया. What is the main mechanism of next? हाँ दे दीजिए मैम. Coming to next question, please let me complete the question first. Mutation seen in this condition. What is the name of this condition first? What condition is this? सर सी था, सही था सर.
कंडीशन भी मिलेगा.
नहीं सर सी बोला था, सुने.
कंडीशन बताओ.
सर सी आंसर है इसका. हाँ कंडीशन का नाम बताओ. अरे एक्सेंटफील्ड. ठीक है. Find the odd one out.
B.
Answer is B. Answer is B. B. Answer is B. Yes sir, B है. आकांक्षा बोलिए सबसे पहले.
So, thank you Dr. Surbi and Dr. Neha. Now I'd like to request Vibhuti sir to felicitate Dr. Ajit Kumar Dwivedi sir. So I'd also request Dr. Vibhuti sir to facilitate Dr. Rasmi ma'am. So I request Dr. Vibhuti sir to facilitate on Dr. Ruchi ma'am.
Sir, आग लगाना is not allowed.
I'd like to request Dr. Vibhuti sir to facilitate or MS Ali sir. I'd like to request Dr. Vibhuti sir to facilitate Dr. Rabi.
I request Dr. Vibhuti sir to felicitate Dr. Pinky for her moderation.
So the quiz moderators, Dr. Surbi and Dr. Neha.
So I'd like to Dr. Vibhuti sir to facilitate Dr. Neha for coordinating the quiz.
एक और कुछ बाकी है ना, एक और कुछ बाकी है। रवि भी नहीं लिया। ठीक है, हाँ लास्ट कर रहा हूँ। अच्छा।
So we move on to last session. Call Dr. Ranjan Rai. Dr. Ajit Podar.
Hot seat.
Dr. Navneet. नवनीत हैं? तो कॉर्पोरेट कौन है? Who is corporate among us? हाँ, आइए।
कॉर्पोरेट का यही है कि टाइम का वेस्ट मत करो, जाओ पेशेंट बैठा हुआ है। पहला लेसन ये है।
रोशन इज रिप्रेजेंटिंग काइंड ऑफ कॉर्पोरेट, आ जाओ। दृष्टिपुंज। So the topic is like beyond PG open mic PG session. So open mic session है basically. कुछ presentation है आपका?
थोड़ा सा एक वीडियो है सिनेमा।
ठीक है। तो so what we are going to talk is like what is the future for beyond post graduation. So we'll have few different kind of opinions, different experiences being shared by. So Ranjan Rai is basically presenting solo or group practice. So why we should go ahead with a solo or group practice after doing post graduation.
So hi, good evening. यहाँ कितने लोग ग्रुप
ये ग्रुप प्रैक्टिस में एक बटन दबाने वाला भी कोई चाहिए होता है.
Solo means solo. There are advantage and disadvantage of solo. Autonomy is there, and most of the group practice, even in corporate, it is interpersonal conflict which leads to failure, and your freedom is not there. So people opt for solo practice, and since very beginning in first year we have a dream that I should have a chamber, I should have my patient, I should have my medical staff, and this dream we used to live throughout our life. Even in group practice also, we used to carry these thoughts in our subconscious mind. So for autonomy and for personalized care, of course, in group practice today, a patient X come to Dr. A, and if he is not satisfied, he can go to Dr. B under the same roof. While in solo, this personalized benefit of clinician as well as to the patient is there. So flexibility is always there. I am telling my story in short. During COVID, before COVID, I used to work till 10 p.m. Morning shift, afternoon OT, and evening shift. During COVID, I learned that no, my time is also important. So I confined my OPD consultation hour from 11 a.m. to 4 p.m. And after 4 p.m., I have to go to the OT, and evening I used to keep free for my family and social life. So this flexibility is not there in group practice. And lower overhead cost is there because minimum staff, minimum salary. So पैसा ही पैसा होगा बॉस. एंड सीधी बात, नो बकवास, ये बीमारी है, ये इलाज मैं ऑफर कर सकता हूं, इसमें ये क्योर रेट होगा. जितना भी प्रेजेंटेशन आपने देखा, टोसिस से लेके ग्लूकोमा से फिल्ट्रेशन सर्जरी तक, सोलो में एक्सप्लेन करना इजी है. ग्रुप में अगर हम एक्सप्लेन करेंगे ग्लूकोमा का तो द्विवेदी जी कहेंगे नहीं, आई विल गिव बेटर रिजल्ट. सो भाई कंपाउंडर भी इधर उधर पेशेंट कर देता है. कंपाउंडर जो है इधर उधर पेशेंट कर देता है. पेशेंट का इंश्योरेंस है, कुछ है तो पेशेंट राइट लेफ्ट होता है. एंड दिस इज वन ऑफ द इंपॉर्टेंट रीजन इन आवर पार्ट फॉर ब्रेकिंग अ एस्टेब्लिश्ड ग्रुप. डिसएडवांटेज इज देयर, वर्कलोड इज देयर, देयर इज वर्न आउट. आर्थिक स्थिति सुधारने के लिए हॉस्पिटल ड्यूटी की थी, अपनी मानसिक स्थिति खराब तो हो ही जाती है शाम होते होते, जैसे अभी हो गई है सबकी. सो यू हैव टू डू क्लिनिकल, नॉन क्लिनिकल, एडमिनिस्ट्रेटिव, सिविल सर्जन के यहाँ से रिन्यूअल लेना है, फायर का लेना है. दिस ऑल बर्डन्स आर देयर इन सोलो प्रैक्टिस. Limited resource, of course, you are alone, so resource is limited. And because resource is limited, no? so you can't move ahead with the n number of equipments. Burnt out risk is always there. So fatigue, burnt out. My colleague used to ask कि तुम एक एक महीना गायब क्यों हो जाते हो? भैया थक जाते हैं मेंटली, तो हिमालय पर जाना जरूरी हो जाता है रिचार्ज होने के लिए. एंड लिमिटेड स्पेशलिटी केयर. आज के डेट में बेटा आरडी हमसे ना हो पाएगा, बाल द्विवेदी जी लगाएंगे. तो दीज आर द डिसएडवांटेज. अगर द्विवेदी जी ईमानदार हैं तो पेशेंट को कहेंगे डॉक्टर साहब बढ़िया आदमी है, हम कर दिए हैं, जाके वहां दिखा लीजिए. नहीं तो पेशेंट को पुल कर लेंगे. These are the practical disadvantage in solo practice. Now come to the other disadvantage. Administrative burden is there. You have to do everything. जब भी हम क्लिनिक खत्म करते हैं तो मेरा स्टाफ आता है कि सर
OPD टाइम खत्म.
OPD टाइम खत्म. खत्म बढ़ाओ. और ग्रुप में है कि हेल्थ केयर सेटअप विद 2 or more providers working together can range from small clinics to large multi-specialty organization. Resources are shared, staffs are shared, and responsibility among members are shared. So it is financially it is more stable. No large investment is required, and operating cost is low. Better resource and technology is there. साथ आने से ताकत बढ़ जाती है. Can invest in advanced diagnostic tools, EMR, specialized equipment, wider range of service, etc. Inbuilt referral is the most important advantage in group practice. Retina, cornea, glaucoma, pediatric, neuro-opthal, among cornea, endothelial specialist, stroma specialist, epithelium specialist, right eye specialist, left eye specialist. So definitely yes, advantage is there. Internal referral grow patient base, cross specialty collaboration ensures full care, and less need for external marketing to attract the patient. Peer support is most important part, most important advantage in group practice. And coverage during leave ensures uninterrupted care. अब आज हम यहाँ हैं तो मेरा दुकान बंद है, आज मंडे को रहता तो 2 दिन का घाटा होता. तो ये चीजें हैं. Less administrative burden is there. डिसएडवांटेज है कि 4 आदमी है तो 4 ओपिनियन है, तो मेरा अपना ओन कंट्रोल कम है. चारों का एक कॉमन थॉट होगा तब हम आगे बढ़ेंगे. Productivity pressure is always there. I had been in one of the nearby multi-speciality hospital. One of my friend is working there. A guy was sitting outside his chamber and he was counting number of patient entering into his chamber and how much time Dr. Saab has given. 9:15 entry, 9:20 coming out. So these kind of pressure is always there in so-called corporate hospital. I have seen that. So and more so आज लोग हम लोगों पे उंगली उठाते हैं कि unnecessary investigation कराते हैं. तो we solo practitioner usually avoid unnecessary investigation while in corporate setup and group, you know. So स्टाफ अगर शेयर करते हैं तो पेशेंट इधर से उधर तो करता है भाई. मेरे पास माँ है, मेरे पास पेशेंट है. पेशेंट एट्रिशन आई मीन इधर उधर पेशेंट करना. एंड वेरिएबल पेशेंट एक्सपीरियंस इज देयर. कुछ भी हो सकता है. सो इन कंपेरिजन it is all your personality. You have to decide your goal in your life. Solo, group, corporate, academic, teaching institution, corporate with teaching institution. You have to decide when you have entered in PG first year. You have to set a goal. And accordingly, you can choose your path for your growth. So many things simultaneously can affect your family condition, your financial condition. You have to consider all these things during practice. So solo, you are having full autonomy, flexible scheduling, direct patient care, personalized service, independent practice. In group, shared decision making, it is a structured scheduling, collaborative care, comprehensive services, and it is team-based practice. So as your personality suits, you can choose the path. From here for the PG, if people are doing PG, after that you might be planning for senior residency, fellowship. After that, Nowadays, ophthalmology is needs huge investment. So for that, you have to work with someone. वो एक फायदा है ग्रुप प्रैक्टिस में कि आपको एक मेंटर मिल जाता है, एक सीनियर मिल जाता है जो आपको अच्छे से सिखा लेता है. So finally, both solo and group practice offer unique benefit and challenges. Solo practice provides autonomy, flexibility, and personalized care. Group practice offers stability, resources, and peer collaboration. The best choice depends on personality, career goal, finance, and preferred lifestyle. The best choice depends on personality, career goals, finance, and preferred lifestyle. Align your choice with what matters most to you as a healthcare provider. कोई भी perfect नहीं होता, इसलिए pencil में eraser होते हैं. It is your choice.
ना, तुम लोग का नाम नहीं.
एक बार फिर से देखिए ना मुर्चंद भाई.
अरे भाई तुम लोग का नाम लिस्ट में नहीं है.
तो ये फाइनली हमारा हाल है. At the end of the day,
सर एक बार फिर से सुना दीजिए सर. नहीं नहीं पूरा नाम नहीं है. ना, तुम लोग का नाम नहीं है.
एक बार फिर से देखिए ना मुर्चंद भाई.
अरे भाई तुम लोग का नाम लिस्ट में नहीं है.
फाइनली यही हाल है. So it is your personal.
So
thank you very much.
बहुत अच्छा टॉक था. So we'll go to the charitable and semi charitable option. ये जो सेशन है ये ओपन सेशन है, तो इसमें 2-3 मिनट में विल ट्राई टू कंक्लूड और फिर ओपन किया जाएगा ताकि उस पे लोगों के व्यू पॉइंट आए, चीज के मन में क्या थॉट है उस पे हम लोग काम करें. तो व्हाई शुड आई, मैं पोस्ट ग्रेजुएट हूं, मुझे क्यों चैरिटेबल ज्वाइन करना चाहिए या फिर सेमी चैरिटेबल ऑर्गेनाइजेशन ज्वाइन करना चाहिए. इस पर अजीत पुदार साहब, हु इज डायरेक्टर ऑफ मस्तीचक अखंड ज्योति आई हॉस्पिटल, अ बिग सेंटर.
थैंक यू सर. थैंक यू सर. सबसे पहले तो I would like to start with my own experience, because after doing my post-graduation, I have not joined any fellowship program or something like that. I was in the Muzaffarpur Eye Hospital. I was a medical officer. I learned the surgery over there. I started my own practice. I had a very decent practice in one of the district town of Bihar. I had a group practice with the Professor Dr. Rajan Anand, Purnia. He was one of the #1 surgeon in Purnia district. I was in a Katihar Medical College as assistant professor. I had also joined a primary health center as a medical officer. So I had done a various experiment with my things. Why? Finally, I am right now, I am in leading the clinical things at Akhand Jyoti Hospital, the largest eye care provider. So why? Why did I share it with you? The first thing is that whatever you do solo, you do group, you do the corporate, whatever, you should know the thing. You should have a proper skill. So, and before that, you should have a proper career plan. Whatever you should choose what you want. You should have a 5-year career plan. You should have a 10-year career plan. What do you want to do with your life? Second thing is that it also depends on your learning ability. If teachers are ready, if the students are ready, the teachers appears. It's the statement of Lao Tzu, the philosopher of the Chinese philosopher. But if the students are truly ready, then teacher disappears. एकलव्य भी सीखा था, अर्जुन भी सीखा था, द्रोणाचार्य एकलव्य को नहीं मिला था. चौथी बात चैरिटेबल के साथ क्या है कि आपको सबसे पहले तो जितना भी एक स्टडी है रेसिडेंसी में, ड्यूरिंग योर रेसिडेंसी, यूजुअली योर केस इट डिपेंड्स ऑन द हैंड्स ऑन. सो हैंड्स ऑन वेरीज फ्रॉम 1 to 96 केसेज ड्यूरिंग योर एंटायर रेसिडेंसी प्रोग्राम. दिस इज अ स्टडी इन सम जर्नल. So the number of surgery that you are given, though you are provided. So the most important thing is to gaining the skill. And where will you get the skill? No private practitioner will you provide you the case. No corporate will let you touch the case. So it's the only charitable hospital. But the disadvantage with the charitable hospital is that there is a lot of misconception, misnomer, a lot of mushrooming of the charitable hospital. Arvind is also a charitable hospital. Chitrakoot is also, LVPI is also a charitable hospital. But there are so many charitable hospitals across in every nook and the corner. So be very particular about choosing the charitable hospital. What are the facilities they have? Whether they have a number of patients, footfall of the patients, the equipments, the mentors, the faculty, the collaborating, the environment of the research, environment of the academics, everything. And it will give you the overall development. And moreover, if you choose an organization like Akhan Jyoti, for example, I'm not advocating. So, like you can even lead some department. You can develop your leadership skill as well. So that's the importance of the charitable hospital. And just I will conclude. Beyond career, what do you like most? What satisfies you most beyond career? Because career is not everything. There is something beyond career. And at this age, we feel that there is something beyond career. So keep in mind what makes you happy, what gives you the quench your thirst, inner thirst, because that will also determine which career do you bring. So I'm leaving it up to you, and I'm open to question. Thank you.
The last one to represent is corporate choice. Dr. Roshan is working with Drishti Punj. Semi-corporate kind of, it is a kind of group, large group practice, becoming kind of corporate also. So why did you choose that corporate practice?
Actually, I didn't choose. लाइफ में कई बार जो है कि आपको प्लान ए जब नहीं मिलता है तो प्लान बी भी आपको रखना पड़ता है. तो मैं अपनी बहुत ज़्यादा तो मेरा एक्सपीरियंस पोस्ट पीजी नहीं रहा है. 2019 में मैंने अपना पीजी कंप्लीट किया. यहाँ पर काफ़ी सारे पीजी बैठे हुए हैं. तो पीजी के मन में काफ़ी कन्फ्यूज़न रहता है. जैसे पीजी ख़त्म करते हैं तो कहाँ जाएं, कॉरपोरेट सेटअप में जाएं, मेडिकल कॉलेज में जाएं, चैरिटेबल हॉस्पिटल में जाएं, अपना प्राइवेट प्रैक्टिस खोलें. तो एक्चुअली मैं ये कहना चाहूँगा इन सारे कन्फ्यूज़न को अगर आप अपना स्किल डेवलप करते हैं अच्छे से, और अगर आप में लैक ऑफ आप ये वैलिडेशन की ज़रूरत आपको नहीं होनी चाहिए. हमेशा लोग वैलिडेशन के पीछे भागते रहते हैं कि हमको कोई बोल दे कि हाँ तुमने बहुत अच्छा काम किया तो हम बहुत खुश हो जाएंगे. तो सबसे पहला चीज़ मैं सारे पीजी को ये बोलना चाहूँगा कि वैलिडेशन सीख करने की ज़रूरत नहीं है. पहला फर्स्ट नंबर 1. सेकंड, इनसिक्योरिटी आप में नहीं होनी चाहिए. आप जो भी हैं अपने स्किल को डेवलप करते जाइएगा, आपकी इनसिक्योरिटी कम होती जाएगी. एंड थर्ड, इंडिविजुअलाइज एंड कस्टमाइज योर केस. आपको खुद को जज करना पड़ेगा कि आपके लिए कौन सा फॉर्मेट सबसे ज़्यादा अच्छा है. और हमेशा कई बार आप एनालाइज कर भी लेते हैं कि हाँ मुझे तो मेडिकल कॉलेज में जाना है या मुझे ये करना है वो करना है, लेकिन कई बार आपको वो चीज़ नहीं मिल पाती है. तो आपको हमेशा ऑलवेज बी रेडी विथ प्लान बी एंड ऑल्सो समटाइम्स प्लान सी ऑल्सो, इजंट इट. तो ग्रेजुअली अपने स्किल को डेवलप करते जाइए. और अगर जो मैंने बताया कि आपको अगर वैलिडेशन सीख करने की हैबिट नहीं है, इनसिक्योरिटी आपकी ख़त्म है, आपने वो ख़त्म कर दिया है और अपने केस को इंडिविजुअलाइज कर दिया है, तो मेरा मानना है कि आप किसी भी फॉर्मेट में जाइए, एनी फॉर्मेट, तो आप वहाँ पर बूम करिएगा, आपको कभी दिक्कत नहीं होगी लाइफ में. तो इसीलिए अभी फ़िलहाल मैं जिस सेटअप में हूँ, आई एम कंसल्टेंट एट दृष्टि पुंज आई हॉस्पिटल. ये हार्डकोर कॉर्पोरेट सेटअप नहीं है, मे बी एक्सटेंडेड ग्रुप प्रैक्टिस एज सर टोल्ड. तो मेरा प्लान ए हमेशा ही था किसी मेडिकल कॉलेज में. अभी रेटिना का तो एम्स पटना में और IGIMS पटना में ये सेटअप है, तो यहाँ था. तो अभी वो वैकेंसी वगैरह उतनी नहीं है, तो फिर मैं वहाँ पर ज्वाइन कर लिया हूँ. तो मैं वहाँ भी एक्सेल कर रहा हूँ, काम सीख रहा हूँ, सीनियर्स लोग हैं वहाँ पर. तो कोई भी प्रॉब्लम नहीं है। जितना मैंने बताया अभी, जितने भी पीजी लोग हैं, इस चीज़ को ध्यान दीजिएगा आप लोग हमेशा कि अगर आप ये सारी चीज़ों पर वर्क करिएगा तो आप किसी भी सेटअप में जाइए, यू विल ऑलवेज बी हैप्पी। थैंक यू सो मच।
Thank you, Roshan. A very honest kind of submission. And finally, I'll be speaking on academics and government opportunities. So, once you complete your PG, what you have, जो एक 5-year 10-year plan की बात कर रहे थे पोदार साहब, that is very important. कि आपके plans आपको पता है, आपको किस direction में जाना है वो आपको देखना है, आपको practice oriented है। हमारे सामने हर एक तरह के examples हैं। चंद्रशेखर हैं, डॉक्टर चंद्रशेखर हैं, जब आए थे सीनियर रेजिडेंसी करके कॉर्निया में आरपी सेंटर से, तो उनको हम लोगों ने खुला छूट दिया था कि भाई तू आजा हम लोग के साथ में। भारद्वाज सर हैं, इनको भी बोला गया था। दे वेर लाइक वहाँ से ही वो मिसाइल चला था कि आपको जा कर करके ग्रुप प्रैक्टिस करना है, तो वो दे हैड वेरी क्लियर माइंड कि मुझे क्या करना है। बट दोज हु आर कंफ्यूज्ड कि मुझे क्या करना है अगर हम प्रैक्टिस में नहीं जाना चाहते, देन आई थिंक कि गवर्नमेंट सेक्टर आपको ऑप्शंस बहुत सारे देता है। while doing senior residency from a good institute gives you a lot of opportunity to learn also, to hone your skill also. It gives you a little bit of time also to think of कि where you want to go, in which specialization you want to go. ये एक तरीके से आपको guidance देता है। वहाँ पर दो questions आते हैं उस समय, हमको लगता है ये क्वेश्चन का जवाब देना बहुत ज़रूरी है कि if I get senior residency and if I get a fellowship program, where I should go. तो I would like to have opinion of house also on this point कि अगर मुझे senior residency मिल रही है और मुझे fellowship program भी मिल रहा है तो मुझे क्या करना चाहिए। रंजन साहब,
पहले मुझे क्लियर करिए कि फेलोशिप से फेलोशिप का वैल्यू है क्या गवर्नमेंट एकेडमिक इंस्टीट्यूशन में? इट इज़ हैविंग नो एकेडमिक वैल्यू। सो आफ्टर क्लियरिंग योर पीजी, पासिंग योर पीजी, यू हैव टू डिसाइड, दैट इज़ द जंक्चर वेयर यू हैव टू डिसाइड कि आपको एकेडमिक्स में जाना है या फिर कॉरपोरेट में जाना है या फिर प्रैक्टिस में जाना है, ये आपको डिसाइड करना है। तो पहला डिसीजन तो यही लेना है कि सीनियर एजेंसी अगर आईजीएमएस में मिल रहा है, कहीं भी मिल जा रहा है, एकेडमिक्स में जाना है, एक ठीक ठाक लाइफ लीड करना है तो आप सीनियर एजेंसी करिए। अगर आपको मन है कि फ्यूचर में मेरा क्लिनिकल प्रैक्टिस अपना हो या ग्रुप में जाए, देन गो फॉर फेलोशिप। एंड नाउ इट इज़ फेलोशिप एग्जाम इज़ ऑल्सो नॉट अ वेरी ईजी एग्जाम। लॉट्स ऑफ पीपल आर इन क्यू फॉर फेलोशिप। मेरा अपना मानना है डॉक्टर विभूति कि इट इज़ 20-20-20 रूल इन मेडिकल साइंस। 20 साल में आप एंट्रेंस क्लियर करते हो, बाय द एज ऑफ 40 आप फेलोशिप सीनियर एजेंसी करके आप उस काबिल होते हो कि एक प्रिस्क्रिप्शन बना लो, पेशेंट आपके नाम से आना शुरू होता है। अब बाय द एज ऑफ 60 स्टेंट लग जाता है, अर्थराइटिस हो जाता है। सो यू हैव टू डिसाइड योर PQLI, फिजिकल क्वालिटी ऑफ लाइफ इंडेक्स। यू हैव टू डिसाइड, यू हैव टू थिंक अबाउट कि which type of life you are planning to lead.
Nilesh sir also want to contribute.
फीडबैक लेंगे। हाँ, नहीं, it's very true that the decision making has to be done at this juncture, but very few people are the guided missile kind of a thing who are very determined कि मैं PG के बाद सीधा अपने जगह पे जाके वहाँ प्रैक्टिस करूँगा। Most of the PGs usually depend upon the opportunities what they have at that point of time. That is what we have observed. Senior residency, they want the best of both worlds. Most of the clinicians hang around the best of both worlds. अभी decide नहीं कर पाया हूँ कि academics की तरफ अगर यहाँ मिल गया तो चले जाएं. But every field graduates you. If you get a senior residency and at that point of time you are not decided with academics, maybe when you have completed your senior residency, your inclination changes. But at this juncture, at least you have to balance that your options, if you are doing fellowship and going that side, your academic part is closed. Because to get into a faculty position, you require mandatory senior residency. So doing a senior residency from XYZ place will only benefit you if you want to go into the, if you want to open the doors of institutional area. But if you are inclined to go towards practice and all, whatever opportunity you get, the fellowship you get, that's the best thing, what Dr. Ranjan said. So decision making stepwise, jo mile. Individual practice is a definitely very high investment plan, so very few people will do that. So the first thing यही दिमाग में होता है ना, next opening जहाँ मिलेगी वहाँ जाएंगे. तो अभी opening क्या मिल सकती है? Government वाली limited है, corporate मिलेगी. Corporate में मिली तब तक government की मिल गई, वहाँ चले गए. This is the scenario of the PGs. I want to know what runs in your mind. Then we can answer point wise. Anybody can volunteer what goes in mind.
This is your chance.
Sir, I have a question actually, but it is slightly different from what sir is saying. So my question is that sir, we are glorifying this sort of workaholic culture and people who work tirelessly without taking breaks, with ignoring their personal life and their health issues. So what I'm trying to ask is that 10 years down the line, if you're trying to become like you, where you are at your life, at the juncture you are right now, so can we become like you without the journey and the grind taking a toll on our physical and mental health and our personal life? Or is no sir, no sir, no.
No, we seriously want to know what are the physical relentless life that you are leading and the mental anguish.
Yes.
Because that is a disconnect that we are having.
Yes. And taking that work-life balance thing also.
वो पार्ट पे बोलेंगे हम कि देखो as we matured, we started learning how to divide our time between family, work and academics and everything. It was not there earlier on in the early part of age, and that's why we faced some of the difficulties. We पहले diabetes हो गया, बहुत कुछ हुआ. So it happens. So earlier you understand the nitty-gritty of that part. Better it is, number one. Number two, it is not required, actually not required, कि मतलब lot of time is not required, I want to say. 8 hours working, but dedicated 8 hours of working. That is more important than 12 hours of working. Fixed, मेरा 8 hours का काम है, मुझे 8 hours के काम में ये वर्क करना है, ये चैप्टर खत्म करना है, ये इतने नंबर ऑफ केसेस देखने, इतने नंबर ऑफ सर्जरीज करना है. वो आपका जो शेड्यूलिंग होता है वो कितना इंपॉर्टेंट है आपके लाइफ में, वहां पर उसका रोल प्ले होता है. दैट वी लर्न लिटिल लेट. लेकिन एज ए यंग फेलो यू नीड टू लर्न हाउ टू अरेंज योर डे. इफ यू कैन अरेंज योर डे बिफोर हैंड, मॉर्निंग में जब उठते हैं तो आपका अरेंज अगर हो चुका है मेंटली, तो मोस्ट प्रोबेबली आपको ये सारा प्रेशर नहीं आने वाला है. लेकिन इफ इट इज अनअरेंज्ड, और गवर्नमेंट सेक्टर का यहां पर एक रोल आ जाता है कि गवर्नमेंट सेक्टर में एक्सेप्ट यू एवरीवन इज मेकिंग डिसीजंस फॉर यू. आप नहीं डिसीजन मेक करते हैं, एवरीवन इज मेकिंग डिसीजन फॉर यू, एंड दैट इज द ओनली पार्ट जो कि आपको डिस्टर्ब करता है. लेकिन अदरवाइज गवर्नमेंट डिसीजन डिफरेंट है. लेकिन अगर उसमें भी इफ यू कैन अरेंज योर सेल्फ योर डे, तो इट द थिंग्स बिकम लिटिल इजियर फॉर एवरीवन.
No, संतोषम परम सुखम. जो हाँ, इनिशियल डेज till
whether you want to be grilled for these initial 5-6 years,
no
to have a satisfied life later on.
till the age of 40 you have to work hard. Till this is my experience. Till the age of 40-45 you can say you have to work hard, but don't be in rat race. Don't be unethical. Never compromise with your morality.
हमारे ग्रिलिंग का मतलब पीजी तो नहीं है ना, पीजी स्कोर से तो नहीं है. पोस्ट पीजी की बात कर रहे हो तो we will talk.
And regarding as Dr. Poddar said, all over India, there are 4 organizations in group practice which are doing really well. One is Shankar Group, one is LVP, one is Arvinda, and in North it is Disha. Other groups used to be pure business group. I'm not going to take name. Few of my colleagues are working with the Disha. They are having very good handsome salary. They are enjoying their life. They are having 3 foreign tour plan every day sponsored by that Disha. And they are a stakeholder in that group. 0.5% share, 1% share, 1.5% share, as you are having the kind of skill you are having. So this is the best way to run a corporate kind of thing, जहाँ कि आपके डॉक्टर आए तो आपके साथ रहे, छोड़ के नहीं जाए. बाकी जगह क्या होता है ना कि लोग आए, साल 2 साल 3 साल रहे और फिर निकल लिए. हाँ, ownership. Similarly, one of my colleagues practicing in Patna recently he has joined a big group, and he joined on the term that he is getting 1.5% of a stake in that particular group. Now he is very loyal and working very hard for that group. Even when he was in PP, he was not working so hard because he wants to be a royal and loyal life. So staff अंदर लाना easy है, स्टाफ को या डॉक्टर को या क्लिनिशियन को अपने साथ जुड़े रखना मुश्किल होता है. तो जब तक आप प्रॉफिट शेयरिंग नहीं करेंगे एंड नॉलेज शेयरिंग नहीं करेंगे, स्किल शेयरिंग नहीं करेंगे, आई एम नॉट गोइंग टू स्टे विथ यू. अगर मैं कह रहा हूँ कि मैं रहूँगा सर 5 साल, तो आप मान के चलिए कि डॉक्टर रंजन राय झूठ बोल रहे हैं. ये 5 साल नहीं रहेंगे, 6 महीना में निकल जाएंगे. तो
Sir, I am recently passed out from this institute. I am sir, it's an open question. So, as a PG, like other specialties, they are offering MCH programs, and the faculties are pushing them to pursue for MCH, like in medicine, surgery. So, why the government and faculties are not pushing their students for MCH program, and why government is not working on increasing the seat for MCH, and why institutes are not working for
so MCH program in ophthalmology, you want to say?
Why there are limited seats, and why we are not working on that?
So can I answer?
Yes.
So basically right now there is only one place which is offering MCH, that is PGI Chandigarh. I think in coming days MCH program will be increasing in other institutions also, but at the same time other institutes are moving also towards. So let me take you back to some of the practices which has happened. Earlier 3 तरह की practice चलती थी. One was medical college जो कि पढ़ाता था, one was private sector जिसमें private practice होती थी, जहाँ पे surgeries होती थी and financial transactions and ये होता था, and third was charitable जो कि pure charity करता था. In last 20 years ये जो demarcation है धीरे धीरे तीनों में घटते जा रहा है. So medical college पढ़ाई कम करा दिया, प्रैक्टिस ज़्यादा हो गया वहाँ के टीचर्स का. जो प्राइवेट वाले थे उनको लगा कि अब तो मेरा क्या होगा, तो सेकेंड हाफ में वो पढ़ाने लगे, वेबिनार और सेमिनार करने लगे. और जो ग्रुप जो ये हैं चैरिटेबल हॉस्पिटल्स है, दे ऑल्सो बिकम इंटरेस्टेड इनटू टीचिंग. सो ग्रेजुअली ये पूरा का पूरा जो पैनोरामा है वो धीरे धीरे मर्ज करते जा रहा है. तो हमको नहीं लगता कि अगले 10 years में ऐसा कोई इंस्टीट्यूशन बचेगा जो कि पढ़ा नहीं रहा होगा, और ऐसा कोई इंस्टीट्यूशन बचेगा जो प्राइवेट प्रैक्टिस नहीं कर रहा होगा, और ऐसा कोई ये बचेगा कि जो चैरिटी नहीं कर रहा होगा. तो एवरीवन विल बी डूइंग एवरीथिंग. बट एट द सेम टाइम उसी समय अपॉर्चुनिटीज बढ़ भी रही होंगी. आपके लिए जितनी भी पोस्ट ग्रेजुएट्स हैं उनके लिए अपॉर्चुनिटीज बढ़ रही होंगी. उसी के दौरान बहुत सारे जो अब इंस्टीट्यूशंस हैं उनके लिए FNB जिन्होंने ओपन अप किया, FNB इन विट्रो रेटिना, it is also going to come. The number of seats are going to increase in coming days. Maybe अभी नहीं है, हो सकता है आने वाले दिनों में. Similarly, PDCC courses are going to get introduced at many places, even at our institute also, where we are trying to introduce senior residency में 1 year of senior residency, and post 1 year, if you are selected, you will be continuing with the PDCC course also. So at the end of 3rd year, what you get is license to become assistant professor, number 1, fellowship program of 1 subspecialty, which can take you to the private practice, which can take you to the group practice, or which can take you to any where you want to go. So this is the way ophthalmology is moving right now. Let's hope for the best.
This is the best thing.
Any other question? Open. तुम्ही लोग के लिए है.
Good evening, sir. I am second year PG at RIO as UMS. I just want to know, sir, what is the ideal time to start our private practice, sir? There is, in one hand, I can think I gained complete skill just doing the fellowship program, and then I start private practice, or I gain a partial of the skill and start my private practice. Alongside practice, I keep on learning and growing. So what will be the best?
Let me ask to what? हाँ, अभिषेक. लेकिन तुम तो गवर्नमेंट प्रैक्टिस में हो ना.
So प्राइवेट प्रैक्टिस का एक बहुत पुराना डिक्टम था, द अर्ली द बेटर, सिंपल डिक्टम था, बट नाउ द सिनेरियो हैज चेंज्ड. नाउ यू हैव टू सी विच प्लेस यू वांट टू सेटल. फर्स्ट ऑफ ऑल, वेयर यू वांट टू सेटल. आप पूर्णिया में जा रहे हैं या उसके बियॉन्ड जा रहे हैं, यू कैन स्टार्ट जस्ट आफ्टर पोस्ट MS. यू हैव स्टार्ट सम अमाउंट ऑफ स्किल्स, यू कैन लर्न. सी लर्न. Let me just. Dr. Navneet, he never went into any senior agency. He just went to a corporate hospital and evolved into one of the best phaco surgeons in Patna. He never did anything, didn't got trained with anybody. So learning under a trained program is a myth that you have to first of all think. That yes, structured learning is always welcome. Now, at that point in time, which was we are talking is 12 years back. Now the point is something else. You are also want referral practice also. So if you want to acquire skills, you have to go for fellowship. If you want to acquire a comprehensive ophthalmologist, where do you want to? Patna is a high saturation place. You just can't jump into any place and think that after PG you can just start practice. So you have to be very clear about where you want to start a practice and what you want to, and what is your, pivot, where do you want to put yourself. You also want to have academic satisfaction, or you want to pursue some particular subject.
So we'll take last 2-3 questions. Gyan want to say
सर
something.
इसी का सर एक पार्ट में, वैसे एक पार्ट तो डॉक्टर अभिषेक बोल दिए कि आपको क्या स्किल है जो आप करना चाहते हैं. दूसरा पार्ट सबसे इम्पोर्टेंट पार्ट है कि फाइनेंशियल कंडीशन आपकी क्या है जो आप प्रैक्टिस शुरू करना चाहते हैं. क्योंकि अगर फील्ड ऑफ ऑप्थेल्मोलॉजी में देखें तो बिग ह्यूज इन्वेस्टमेंट करना पड़ेगा. जैसे अगर सिंपल RIO में देखिए, इतना इन्वेस्टमेंट के बावजूद भी लगता है कि कुछ लैकिंग है. तो इस चीज़ को भी हमें सोचना पड़ेगा कि आपका फाइनेंशियल कंडीशन कितना है. और अभी के समय में है, चाहे वो प्राइवेट सेक्टर हो और गवर्नमेंट सेक्टर हो या चैरिटेबल सेक्टर हो, जो दिखता वही बिकता है. सिंपल सी बात है. क्योंकि जो भी आएगा पेशेंट आपके यहाँ ट्रीटमेंट कराने के लिए, तो ये पूछता है कि आपके पास फैसिलिटी कितनी है. यानी कि अगर हम लोग जो भी, अगर डॉक्टर VN प्रसाद सर के यहाँ सर हम लोग एज ए PG के बाद काम करने गए थे, तो एज ए PG के बाद वहाँ स्टार्ट किए, तो सर सोचे कि सर ये 2001 की बात है. तो उन्होंने कहा कि अगर आप प्रैक्टिस में आ रहे हो तो तुम्हें 5 चीज़ चाहिए. उस 5 में से अगर कहीं पे भी कोई लैकिंग होगा तो बस खाने का मारमर हो जाएगा, आप अप टू मार्क नहीं जाएंगे. उस 5 में से पहला चीज़ था कि आपका इंफ्रास्ट्रक्चर जो आप बनाए हैं कैसा है. दूसरा चीज़ है कि आपके साथ जो अटेंडेंट, यानी कि वहाँ पे जिसके वेलकम के लिए या रजिस्ट्रेशन के लिए रखे हैं, वो कैसा आदमी है. तीसरा चीज़ पे आ जा रहा है कि वो जो वहाँ के इक्विपमेंट जो आप इसके साथ में जो आप इंस्ट्रूमेंट बनाए हैं उसके साथ में क्या है. चौथे पोजीशन पे आता है कि आप जो पेशेंट आपके साथ आया, आप उसके साथ कैसा बिहेव कर रहे हैं. लास्ट पोर्शन आता था आपका ट्रीटमेंट स्किल, कि आप उसका जो लास्ट पोर्शन था वो आपका ट्रीटमेंट स्किल था. अगर इस 5 में से कहीं पे भी लैकिंग होगा तो आप उसको प्रॉपर ग्रो नहीं कर पाएंगे. तो मेरा यही मानना है कि आप अपने आप को एसेस कर लो कि 5 में से आपका कहाँ पे है, किसमें गैप है. उस गैप को अगर फील कर रहे हो तब कहीं भी जाओ नंबर 1 पे होगे. मेरा यही कहना है सर.
नट सेल आपके पास जब कॉन्फिडेंस आ जाए, कोई एक सर्जरी, टोसिस, कैटरेक्ट, आरडी, मैकुलर हॉल ग्लोकोमा, कोई एक सर्जरी में आपको लगता है कि यू कैन compete with the top practitioner of the city, now you are eligible to go into private practice. Number one. Number two, I am sharing my experience. I have started my private practice with the Appa phaco machine, Appa microscope, then Topcon microscope, chota wala, then Otley, then shifted to top model microscope machine and microscope. Now I had a regret. I should start my practice from the top, not from the bottom. But it was demand of time. I don't have so much capital. I have to start with the lower end. So whenever you are planning for private practice, start with the top model, top microscope and top machine to reduce your complication rate. There are n number of people in your right side, in your left side, and they are going to compete with you. So first thing, कोई एक सर्जरी में मास्टरी होनी चाहिए, and you have to think you are in top slot for that particular surgery. And आप by the age of 40, आपके पास इतना accumulate हो जाएगा कि you can go for the top class machine.
So last question.
खाली जोड़ेंगे.
Any last question?
अब बस अभिषेक जो बोले कि आप पटना सैचुरेटेड है, हमारे ये बात मत सोचिएगा किसी को भी. नो प्लेस इज सैचुरेटेड. और कितना भी बड़ा ऑर्गेनाइजेशन हो, छपरा में एसके पांडे की प्रैक्टिस चली ही अखंड ज्योति खुलने के बाद. बता देते हैं हम. आईजीएमएस के सामने जो डॉक्टर का प्रैक्टिस चलता है, जो जैसे सुभाष प्रसाद हों या जो भी सर लोग हों, तो आईजीएमएस के सामने उनके प्रैक्टिस. अरविंद हॉस्पिटल के सामने सबसे बड़ा प्राइवेट क्लिनिशियन है. तो मंडी में बाजार है, मतलब आपके कहने का मतलब मंडी में ही बाजार है. तो आप
So last question. First year. Anyone wants to ask? Huh? Or we close. So रघु कुछ बोलो भाई. अरे कुछ सजेशन दो. रघु 0 ईयर में रहता है. हाँ ठीक. So basically thing is, finally let's come to the conclusion. आपको देखना है कि what is your interest zone. आपको देखना है कि what is your financial support system. Where do you want to settle, or in which field you want to settle. आपको एजुकेशनल बैकग्राउंड में जाना है, आपको प्रैक्टिस के बैकग्राउंड में जाना है. जब प्रैक्टिस के बैकग्राउंड में जाइएगा तो आगे के आने वाले दिनों में आपको लगेगा कि थोड़ा पढ़ा लिए होते तो अच्छा रहता. एजुकेशनल बैकग्राउंड में जाइएगा तो आपको लगेगा कि प्रैक्टिस में चले गए होते तो मेरा रंजन बाबू के जैसा ये होता, बैंक अकाउंट हो जाता. तो देयर आर रिग्रेट्स एवरीवेयर. But you have to choose and you have to get satisfied with whatever you want to have. ये सिंपल सी सीधी लाइन है.
I am in front of many one because why I am adding this point, because I have also an experience in a charitable organization for 2 years, in educational institute from Arvind for 2 years and 2 months, a small training, and then worked in a Lions hospitals in a Rajasthan, and in a charitable hospital which are outstation work in Odisha, Sambalpur, and with a long I think association with Akhand Jyoti Eye Hospital as an administrator, I think at that time, and in academics as well, and also in a government setup working at right now, and I have established my own private practice with a chain of hospitals around 4 centers. So why I am we have started on a very strong note that this we are for here for the people what they are going to choose. So definitely it's a mindset. In a leadership it is always said So you need to have your 5-year plan ready, as sir has told. And you need to have a mindset, what you are going to do for another 5 years. Okay? You have a perspective for your life, what you want to do for the 5 years. Because it's very difficult to say in a first year PG or a third year PG to choose where I will go. So 5-year plan should be ready for you. And whatever suits your plan, there you stand. That's it.
दिल्ली वाले लोग दिल्ली पहुंच गए, हम लोग यहीं पर हैं. So let's close this program now. Thank you पुदार जी, thank you रोशन.
तुम लोग का नाम नहीं.
Just few.
एक बार फिर से देखे ना भूषण भाई.
अरे भाई तुम लोग का नाम लिस्ट में नहीं है.
I request जिसका नाम है वही आए. ले आओ, मेरे पास लाओ ना, हम दे. अरे वही मेरा बार बार ले आकर के घुमा घुमा के दे रहा है लोग. लो भाई, अलग अलग है. क्योंकि डिनर तो अभिषेक डिनर क्या है, रेंज क्या?
I would request everyone to wait for 5 more minutes.
For trade.
Yes, yes. So no conference is possible without an active participation of our partners. They have supported us in every ways. Thank you. And this is the very small thing that we can do to appreciate their efforts. So thank you. I would like to first invite our platinum sponsors, NRI Vision, Narendra ji, always there, always present, always there with कि भाई हो जाएगा, टेंशन मत लो, NRI है. Thank you, Narendra.
What's up,
Thank you. And none other than Sun Pharma, RIO के साथ 10 की टीम लेके खड़े हैं, कल से खड़े हैं. सन फार्मा, प्लीज राजकुमार जी आइए प्लीज. Thank you for becoming the platinum sponsor for our RIO team. And Intas Pharma, Amit ji, anybody from Intas Pharma? They have already left. वो लोग भी चले गए वापस दिल्ली लगता है. Now to our gold sponsor, His Highness. Any representative from His Highness? They have already gone. मिश्रा जी कहाँ चले गए? हमेशा रहते पर रहते नहीं अभी. अजंता फार्मा, प्रभात जी प्लीज. थैंक यू अजंता फार्मा.
Just bounce with this.
Mankind Pharma. Any representatives from Mankind Pharma? And Sumit ji from Mera I take. Santosh ji from Joja Pharmaceuticals. Representatives from Carl Zeiss India Limited. देखिए लेट हो चुका है. They have also. मिश्रा जी from His Highness, please come. Thank you for becoming our gold sponsor. है समोसा है, भजिया है, केक है, सब है, चाय है. And any representative from Tosobro Medicals? Yes, Injamam ji from Tosobro. भाई तालियां बने, इनके कारण ही सब कुछ हो रहा है. And every small contribution is big. So appreciating our silver sponsors, Lipin Pharmaceuticals. Anybody from Lipin Pharmaceuticals? पंकज जी सो गए, बोले कि हमको तो लास्ट में है। Thank you, Pankaj ji. We need bigger participation from you. Nikhil from Sipla, please come. Clear कर देना भाई. And last but not the least, AV Pharmaceuticals. Please come. नहीं इसका क्लियर हो जाएगा. कोई बता नहीं. So big cheers to all the industry. Thank you.
Thank you all the trade people for participating, but let me just let you know that you will get the requisitions for the upcoming Bihar Ophthalmological Society conference, MOSCON, which is shouldered upon me. So now onwards I'll be after you. So yeah.
Finally, want to say, अंकिता आ जाओ. अंकिता, हम लोगों में सबसे सीनियर बूढ़े आदमी यही हैं, तो इन्हीं से करवा दिया जाए. अंकिता, for lot of hard work you people have done with team, of course, but since you were leading this time, so we appreciate that. Shivani, ever smiling. अरे वो क्यों ले जा रहे हो? अच्छा वो भी देना है. उस पे हमारी नजर है. ये पौधा कोई टच नहीं करेगा. So everyone have tried their level best. लेकिन ये 2-3 लोग बहुत ज्यादा काम किए हैं, इन्होंने लीड किया है, तो that's why. And finally अभिषेक के लिए स्टैंडिंग ओवेशन. इस बार पहली बार और अटेंडेंस रजिस्टर मेरे चेंबर में है. सो गुड नाइट एवरीवन, एंजॉय 30th एनिवर्सरी. कल से फिर रूटीन वर्क. थैंक यू एवरीवन फॉर पार्टिसिपेटिंग. हाँ, ग्रुप फोटोग्राफ सारे आ जाओ इधर.